A very good morning to all of you present here, all delegates, our esteemed faculty. It's really an overwhelming and a very, very joyous moment to find all of you here. More so, I was thrilled to see my schoolmate, Dr. Mona from UNICEF here today. So again, a very warm welcome to all the esteemed delegates who walked that extra mile to be with here today. And this is Bihar Neocon 2023. And the theme that has been dedicated to this conference is Intact Newborn Survival. So by intact, we do mean that we come up with typical children having no neurodevelopmental delays. And for this, we have a wide range of faculty, ranging from Mr. Chaitanya, to Dr. Mittal, to Dr. Kea, who's come all the way from Bengal, and we have so many other people from UNICEF, which we would be seeing gradually as the day unfolds. So yesterday was a very enriching day for us with the pre-conference workshops of Bihar Neocon, one happening at NMCH under the convenership of Dr. Saroj, which was on neonatal ventilation, and the other was NRP, which took place in PMCH under the convenership of Dr. Rakesh Kumar. They were all extremely successful workshops, and I'm sure we would be moving a step towards our theme, that is intact newborn survival. So once again, from the whole organizing team, we are overwhelmed to have all of you here and to have the day rolling, because we have a number of sessions lined up which would really satisfy the same need. I would request Dr. Sushil to welcome the first person who is a geneticist and the best start to this conference possible. Dr. Sushil Kumar Pathak to take over.
Thank you, ma'am. Good morning, everyone. So to start with this first session, we have Dr. Chaitanya Datta. Is a well-known figure. So he will be speaking on approach to metabolic disorders in neonates. So to chair this session, I request Dr. Vijay Kumar Singh sir, Dr. Ashok Kumar Singh sir from Hajipur, who is the President IP Vaishali, Dr. Rashmi Agarwal madam, who is Assistant Professor at Nalanda Medical College, Pediatrics Department, and Dr. PP Mishra sir, who is Assistant Professor at Patna Medical College, Pediatrics Department. So I request all the chairpersons to kindly come on dais and introduce our speaker, Dr. Chaitanya Datta. And since we have a very long session with the inaugural on time in the evening, so I request chairperson to, it's my humble request to be on time so that we can finish our program on time. Thank you.
Now to have the day rolling, we have our first speaker, Dr. Chaitanya Datta, who is the person in genetics and in born errors of metabolism. Dr. Datta, who is the director of the Sujanan Hospitals, is here with us today to introduce us to this topic. And he's also the chairperson of the Indian Academy of Pediatrics Medical Genetics. And sir is the authority on inborn errors of metabolism also. So with that, I welcome you all. Welcome, sir. And you may please begin with your deliberation.
Very good morning to everyone. Thank you, respected chairpersons, for the introduction. And I would like to thank the Neonatology Bihar team for this opportunity. So without much ado, I'll start with the talk wherein we'll discuss about the incidence. We'll discuss about clinical clues based on which we would suspect an IEM. We'll search for biochemical cues, various presentations like seizures, hypoxia, etc. How do we sample in critical cases, and the newborn screening? I'll touch upon newborn screening and its importance, and genetics in IEM. So if you look at the incidence, it's quite common. So if you look at a combined incidence of all IEMs together, it's close to around 1 in 2,000 is what is expected. It's highly underdiagnosed. So essentially, if you look at a high-risk screening, some studies have been carried out wherein high-risk neonates have been screened, especially in the ICUs. And there the incidence has been as high as 1 in 14. That higher incidence is there for IEMs, but many of these are unfortunately undiagnosed. The reason being they present with a myriad of symptoms. It can be sepsis, it can be an encephalopathy, hepatopathy, etc. Or they can be just derangements like acidosis, hypoglycemia, and most of this are labeled as sepsis, asphyxia, and therefore they're not investigated. So therefore, with the theme of the conference, that is intact survival, we now need also to pick up these children so that we have good outcomes in the future. So how do you suspect an IEM? Any acutely ill child in the NICU, PICU, you have to suspect an IEM. Seizures, they could have encephalopathy. The child could be irritable with excessive crying. There could be tone abnormalities, altered sensorium, poor feeding, respiratory distress, failure to thrive, any intractable condition, intractable acidosis, intractable hypoglycemia, you should suspect. Also look at the history. When there's a previous history of sudden deaths or consanguinity between the parents, also is an important clue to pick up an IEM. What is the variable presentation? You can see the same disorder, citrullinemia. In the first case, 3rd degree consanguinity, baby was well till 2 days, crashed and died on day of life 3, 4. So that's the case of arginemia. See, the citrulline levels were 1436. Second case, non-consanguineous, early developmental milestones were normal. When the child was started on complementary feeds, had an episode of encephalopathy, but he could recover from that and see the citrulline. In the last case, this lady had normal childhood, normal schooling. She got married, and post-marriage, she had a postpartum psychosis and altered sensorium, and she was diagnosed to have a same condition called citrullinemia. So they can manifest at any age. So essentially, a basic blood screen should include this GLAC, glucose, electrolytes, lactate, ABG, ammonia, and ketones. So these are basic things which are available in most of the basic centers or the NICUs. But at the same time, you should also look at the hemogram, the liver function, kidney function, and urine reducing substances. Based on this, you're going to diagnose many conditions. But at the same time, you must utilize the TMS and GCMS also as measures to diagnose a definitive IEM. Just based on acidosis, you can suspect an IEM, but for a definitive diagnosis, you require TMS. It's called tandem mass spectrometry. It can be done on a small blood spot, and it picks up almost about 10-15 amino acids and about 40 other disorders which are common. So you're looking at various amino acids, acylcarnitines, even chain and odd chain. Even chain would indicate organic acidemias, while the odd chains would be organic acidemias, even chain would be fatty acid oxidation defects. And if you couple it with a GCMS, it can be done, it picks up many more conditions as well. So a TMS GCMS combination, especially in sick babies, helps in picking up these IEMs quite well. CSF studies may be rarely required, especially in GLUT1 deficiency, or sometimes for mitochondrial disorders, a raised lactate or glycine in a child with intractable seizures. You can look at CSF glycine. Enzyme studies are not that commonly required, but biotinidase enzyme study is one of them. Now, based on this cartoon, which is given by Haberly et al., you can just, based on the basic metabolites, you can classify various IEMs into various categories, and you can come to a logical possible diagnosis in these cases. So how will the patients present in a biochemical way? So we saw how the patients would present clinically. Now we'll see how they would present biochemically. It could be hypoglycemia, hyperammonemia, acidosis, ketosis, or sometimes everything can be normal. I'll show you that case scenario also. So if it's a hypoglycemia, though it's a very big cartoon, you just have to focus on 2-3 metabolites: sugars, ketones, lactates, ammonia, and if you have available the amino acids and organic acids. So any hypoglycemic child, you're ruling out a diabetes, you're ruling out perinatal issues, sepsis, etc., and collect critical samples for 2 things. One is endocrine, second is metabolic. Endocrine, you're doing insulin, cortisol, growth hormone, thyroid. And for metabolic, you're doing your basic GLAC, as you call that, along with TMS and GCMS. So this will help pick up most of the IEMs. Now we'll see 2 presentations. In the first case, the baby both had intractable hypoglycemia, wherein the first case, normal thyroid, normal 17-hydroxyprogesterone, but low cortisol. Low cortisol in a dark child, it indicates that it could be a familial glucocorticoid deficiency. And this is usually diagnosed based on a genetic study, wherein you're doing an exome sequencing and picking up the mutation. A very well-treated disorder if you pick it up in time. Similarly, in the other case, it was a large-sized baby of 4.3 kilos, a large placenta with hyperinsulinemia. You can see the sugars were 15, insulin was 34. So at a sugar of 15, insulin should be non-detectable. So it was 34. And this showed an autosomal recessive type of a congenital hyperinsulinemia picked up on genetics. Again, a well-treated disorder if you pick it up on time. So you need to evaluate both these aspects, not only metabolic, but also endocrine. Now, going to simple 2 tests, which are going to help us in picking up galactosemia. We do a non-glucose reducing substances and plasma galactose. Plasma galactose should be done when the child is on milk feeds. It should not be when you stop milk feeds. It should be done earlier. Now, if there's high galactose levels with a low GALT enzyme, that is case of galactosemia. Sometimes what happens in the Indian scenario, the patients are fed with sugar, water, or sometimes honey, and they can present with this hereditary fructose intolerance, which is essentially because of the fructose ingestion during the early period. They're fed sugar, water. So that history is crucial, and they'll be associated with severe vomiting. They'll have overall lethargy, seizures, etc., and additional findings in the electrolytes you'll find. So now we'll take two case scenarios. The first one, there were no perinatal issues. There was difficulty in breastfeeding, and there was day 3 hypoglycemia with a BSL of 29. So obviously, you're going to think of other causes as well. But see the other case. There was failure to thrive on day 13 associated with hypoglycemia with direct hyperbilirubinemia and a firm hepatomegaly. So which case you suspect IEM more? The right side, because there is direct hyperbilirubinemia associated with all these issues, and that indeed turns out to be a galactosemia. So galactosemia should always be confirmed by increased blood galactose and GALT enzyme. Never label the child as galactosemia just based on the urine reducing substances, because most of these cases turn out to be normal. Now, how do they present? They can present with poor feeding, lethargy, vomiting, hypoglycemia. Cataracts may not be detected at early stage. The simple treatment is exclude dietary galactose. Now, this is very, very crucial in the first year of life only, beyond which most of the cases, the amount of galactose coming in from other feeds is also significant. So that much stringent restriction is not required later. Now, in this case, similar case of neonatal hypoglycemia, but see the history. There was one history of IUD, life-threatening cardiac event on day of life 3, and with lethargy and essentially. So in this case, so when you have hypoglycemia, when it's a floppy baby, you have lethargy, cardiomyopathy, hepatopathy, failure to thrive with a history of sudden deaths, you always think of fatty acid oxidation defects. So fatty acid oxidation defects are of 3 kinds, the VLCAD, MCAD, and SCAD. Very well treated conditions. Simple treatment is avoid fasting is the only treatment. Uncooked cornstarch, high carbohydrates, avoiding excess fat. Very simple treatment, but you have to pick these up on time. MCT oil is only used for VLCAD deficiency. So now this particular baby essentially presented with lethargy, hepatomegaly, and a cardiomyopathy. He used to have early morning episodes of hypoglycemia. The free carnitine levels were low, so suspected to be a primary systemic carnitine deficiency, but on further evaluation, see what is important when you're evaluating the reports, you have to look at each point. Now the free carnitine was low. So first step is to supplement carnitine. And then you're relooking at the profile and you find it's a VLCAD deficiency, not a primary systemic carnitine deficiency. So reading the profile well is also very, very crucial. Now, sometimes you can save babies if you give some antenatal treatment. Now, the older child is my case of VLCAD deficiency. They had a neonatal death in the second case. Fatty acid oxidation defects can lead to sudden neonatal deaths. So the third case, they came antenatally and we found that the baby had a VLCAD deficiency, but they very much wanted to continue with the pregnancy. So in this case, what we did, we started the mother on carnitine and an MCT diet. And now postnatally on a newborn screening, she did show a VLCAD deficiency, but overall, now the child is almost 1 year old. He's doing absolutely fine. So even if a child is affected with an IEM, we can sometimes give antenatal treatment and save these babies. You should never forget neonatal diabetes. It is a real case scenario wherein you have some diabetes are permanent diabetes. Some of them are transient neonatal diabetes, and they can be picked up on genetic studies. So any baby presenting with diabetes under 9 months of age should be investigated for a genetic cause of neonatal diabetes. Next scenario is hyperammonemia. You have a symptomatic newborn. Wherever the ammonia is on the higher side, say more than 150, you're trying to look at glucose and acids. So any child who has normoglycemia and no acidosis, you should suspect a urea cycle defect. So usually urea cycle defect, any child, ammonia you should check in any baby who has unexplained change of consciousness, unusual or unexplained neurological illness, liver failure, or intoxication-like features. Any ammonia, if it is normal in a symptomatic baby, it rules out a urea cycle defect, and any respiratory alkalosis in the newborn should be investigated for a urea cycle defect. So remember, any respiratory alkalosis in the newborn, ammonia between up to 200 in a neonate, if it's otherwise neonate is well, is normal. If a neonate, anything beyond 150, if the neonate is symptomatic, you have to consider investigation and treat them. Now, I'll just take a case wherein this baby was on day of life 16, had a very severe encephalopathy episode, admitted to the NICU, pupils were sluggish. We did an MRI, which was suggestive of bilateral infarcts. This is day of life 16. What we find is that there is acidosis, there is deranged LFT, ammonia was high, and it turned out to be a case of citrullinemia. So essentially what we did is now critical management is very important. So here what we are doing, you're stopping the proteins, you're giving dextrose. If there is hyperglycemia, you're adding insulin to the drip. You don't want to reduce the dextrose in this case. You're giving intralipid for calories. You're giving sodium benzoate and other medications and supportive medications. Sometimes you need to give peritoneal dialysis to these babies to save them. And this child required almost a 1 month NICU stay, and the MRI was bad. So essentially we counseled them that the outcomes are not going to be that great. But ultimately the patient, they persisted with the treatment. And what we found is essentially, this is a child now at around 7 years of age. The same baby who was brought out of the NICU, had severe encephalopathy with proper management, a proper neonatal and infancy management with medications and diet. She's doing well. Now she's almost 10 years of age. So this is how good outcomes can be achieved if you give optimal treatment. Now, if you have acidosis in a child, typically, again, as I mentioned, you require 2 tests, TMS and GCMS. So if you couple them, you're reasonably good enough to reach a conclusive diagnosis. So you're doing a TMS as a first step. Along with that, you do a GCMS, and it gives you a diagnosis. So the typical presentation, how it will come to you, wherein a neonate is well to day of life 3, crashes suddenly, hypoglycemia, then hyperammonemia with low platelets and neutropenia. So essentially TMS, GCMS was done, but always in these cases, it is crucial to collect some critical samples. Now, critical samples, how do you collect? You collect 2 ml of heparin blood, 5 ml of urine sample, or some blood spots, and you just keep them aside in case you're starting any treatment. Because once you start your treatment, all these metabolites will get washed up, and that can lead to problems. So essentially, it's very crucial to collect these samples on time. And it indeed turns out to be a case of a propionic acidemia based on the TMS, which shows a C3 elevation, and GCMS, which shows a profile of abnormal organic acid. So it turns out to be a GCMS. You have acute and chronic management. In the acute stage, you're looking at hydration properly. You need to correct electrolyte and acid imbalances. Ringal lactate is usually not used in IEMs. Glycemic control is very, very crucial, for which, if required, you can add insulin. Correct hyperammonemia. Stopping proteins is always advised for a brief period, that is only 24 to 48 hours, after which you can give precursor-free amino acids, which are now easily available and not that expensive anymore. Earlier, we had to order them from outside, but now they're very, very easily available and quite an affordable cost to the patients. So gut antibiotics, supplements, etc. will be required. What is crucial also, as the case I showed you, a chronic follow-up, a long-term follow-up is very crucial, wherein you're giving them oral medications, you're giving them a proper diet, you're giving them a well-day sick day plan, explaining the emergency measures so that they have normal outcomes in future. Some cases you will not have any derangements like a glycine encephalopathy. Everything is going to be normal. Your pH is going to be normal, TMS normal, GCMS normal, and will be picked up only when you do a CSF to plasma glycine ratio. That's the only test. So usually children which are presenting with an unexplained seizure disorder, glycine encephalopathy is one of the conditions which you need to pick up, but the only way to diagnose is a CSF studies. Mitochondrial disorders are a huge class of disorders which can present in the neonatal period. So here what would happen, you can, if it's available, you can go for a lactate and pyruvate testing, but usually many cases, scenarios, the pyruvate is not available. So any child is acidotic, and when you find most of the things are normal, you can go for genetic studies. These are the typical mitochondrial or metabolic cocktail medications in the doses which are given. Now these are variable in various scenarios, but this is a general medications or the schema that should be considered for IEMs in most of the cases. In majority cases, for a case of mitochondriopathy, you have to rely on genetics. Now, in this particular case, the baby was normal, had vomiting, excessive crying, abnormal movements with seizures, with hypoglycemia, with raised lactates, etc. And the diagnosis was based on genetics. So when a metabolic testing doesn't give you an answer, you should elevate and consider exome sequencing to have a definitive diagnosis. So this was a mitochondrial DNA depletion syndrome. The other aspect which troubles neonatologists is neonatal seizures. So usually 3 types: biotin dependent, pyridoxine dependent, and folinic acid dependent are quite fairly common. So always give them in high doses. So biotin in 10 to 40 milligram per day, pyridoxine in 100 to 200 milligram per day, IV preferably, but watch for apneas, and folinic acid at 10 to 30 milligram. Now all these preparations are now easily available across the pharmacies. So any abnormal EEG sometimes just normalizes, and that gives you a hint that we are dealing with one of the common seizures. Now, this is how a biotinidase deficiency classically can present with a hair loss or rashes, but in the neonatal period, they can just present with seizures alone. You have to be aware that there could be seizures other than these also. Now, this particular baby with high fever, generalized seizures from 15-day with altered sensorium, and baby suddenly crashed and died because of a cardiac arrest. Later, when investigations were done in the parents, we found it was a simple case of hypomagnesemia with secondary hypocalcemia. So hypocalcemia had not manifested till then, but magnesium was not checked. So if it was perhaps supplement, so very low magnesium and hypocalcemia is the hallmark of this particular condition. We have to be aware of HI mimics, which are metabolic conditions, MTHFR deficiency, which is because of hyperhomocystinemia, a molybdenum cofactor deficiency, or fatty acid oxidation and urea cycle defects are crucial. Then my last part, when you're talking about newborn screening, a 4-point newborn screening is crucial, wherein we are doing a physical screen for anomalies, we are doing a cardiac screen, hearing screen, and a biochemical newborn screening. NNF has given a very good tier system wherein we can investigate these newborns. So all newborns should ideally be investigated for hypothyroidism, adrenal hyperplasia, G6PD deficiency, and galactosemia. Any sick baby who is in the ICU should always undergo an advanced newborn screening, which should include a TMS. And resource available situations wherein it's available, the patient can afford, they can always go for category C, wherein the entire thing can be considered. So how do you collect the samples? It should ideally be 48 to 72 hours after initiation of breastfeeds. It should be before discharge. Any preterm baby, as soon as the baby is reaching term, you can get the testing done. If the baby is critically ill, you can do it at any point in time. So how do you collect? It's a simple way wherein you're going to collect a filter paper spots. In case you're collecting blood for some other conditions, you can always spot the same blood sample on the filter paper. That gives you very good spots as such. So how does it help? Congenital hypothyroidism, the best example wherein you're treating or you're preventing irreversible mental retardation. Similarly, in this case, this child had, this particular case is a case of homocystinuria, was diagnosed much later, has academic issues, ophthalmic issues, and essentially the sister was also born with a similar disorder. We did a newborn screening, and at 7 years, she's absolutely normal. So she would have had the same fate as this child if you wouldn't have done a newborn screening. The other case which highlights the importance of NBS is glutaric acidemia, very common disorder to come with. Essentially, the babies are absolutely normal. Sometimes they present as macrocephaly, but one episode of an encephalopathy or a fever at at any age between say 1 to 6 years, they can become completely dystonic and abnormal. This child had an older sister who had similar issues, but we treated him from day 3rd of life once we diagnosed, and this child is almost about now 8 years old. And he goes to a school, he's absolutely normal. And in glutaric acidemia, usually the importance of diet decreases as the age advances. So now he's almost being put on a normal diet and he's doing fantastically well. So you can prevent many intellectual disabilities and morbidities if you have a definitive this thing. Now, role of genetics, remember all metabolic conditions are genetic conditions. So in case the couple wants a future pregnancy and they have a child with an IEM, you need to have a genetic testing. Like, for example, we know that this is a case of a propionic acidemia, wherein the last couple of slides, please. Yeah. So two babies have died. They have a diagnosis, a clinical diagnosis of propionic acidemia, but I can't help the parents in the future pregnancy unless I have a genetic diagnosis. So for all such babies, we need to have a genetic diagnosis for which we can always collect some critical samples. So collect one EDTA blood and store DNA. In case the patient is not affording, keep the DNA aside and you can always store and do a testing at a later date. So my message would be to consider newborn screening in all cases as much as possible. Have a high index of suspicion. Inborn errors is not the last DD, but it should be included much earlier in case you want to have an intact survival. Always do investigations on a critical sample, store samples appropriately before initiating treatment, and molecular confirmation is required. So this is how you collect a critical sample sample, few drops on filter paper. You can collect one EDTA vial, you can collect a cheek swab, or even a cord sample in case the baby is very, very critical, can help us in this. Now, we have come up with the Indian Society for Inborn Errors of Metabolism has come up with this protocol book on IEMs. And it's a very handy book which we have edited, and almost about 14, 15 common IEMs have been included in this particular book. And it's a very good reference, and it is available on our website, and should become a member of the Indian Society for IEMs, and wherein we give support as regards to the medications, diet, etc. And through my clinic also, essentially we can help out in case someone wants, or someone is stuck up with certain issues pertaining to an IEM. We have I have a metabolic dietitian working with me as well, so that helps in sometimes in remote areas also patients can connect online, and it does help a lot in improving the outcomes in these cases. Thank you so much.
Thank you, Dr. Chaitanya.
Yeah,
it was a very nice presentation.
Thank you.
Yeah, it was a very nice presentation on neonatal metabolic disorders and approach to them. And as you have correctly emphasized on newborn screening, so I also, like all of the members who are here, we should advocate newborn screening in all the babies. And it's a little costly, but I think it's a genuine expenditure. Thank you.
Thank you.
Thank you, sir. As you have explained that metabolic disorders are not so rare. Individually, they may be there, but collectively, they are common entity, and one should always suspect when newborn is normal and suddenly deteriorates, and when you find no cause, then one should suspect IEM. Other things are that the presentation of this IEM is not specific. There are many non-specific signs like vomiting, lethargy, refusal of heat, vomiting, hypotonia, seizures. So when and then we diagnose it as sepsis. So when we find non-specific signs and the cause is not sepsis, we should suspect IEM, and we should diagnose these cases early, that we can refer and we can reduce mortality and morbidity. Thanks.
Just I wanted to comment. We have a big hospital in Ranchi, almost 225 bedded hospital.
Right.
And on an average, we diagnosed 4 to 5 IEMs every month, you can imagine. And my simple approach is, if baby is sick, your septic screen is negative, you have severe metabolic acidosis, your lactate is normal, please suspect IEM. Send ammonia and do blood urine for ketones.
TMS and GCMS.
Then if it is positive, then you go for your TMS and GCMS. And the simple test, a blood gas, urine, ammonia, that's all. This is good enough. And whenever you cannot explain the illness by anything, you have to suspect IEM. On an average 4 to 5 every month we pick up.
That's very nice.
So thank you, Dr. Chaitanya, for your nice, excellent presentation. And thank you, chairpersons, for chairing the session.
I request the chairpersons and the speaker to kindly step on the smaller dais for the memento presentation. Now to move on with the next session, that would be a session by UNICEF people, Dr. Sarita and Dr. Reddy, on quality improvement for social behavioral changes and status of newborn health in Bihar. For this, I invite the chairpersons, Dr. Arun Kumar Shah, sir. Dr. Arun Shah, sir, please. Dr. Chandra Mohan from AIMS Patna. Dr. Sushil Kumar Pathak, who's the assistant professor in MCH, and Dr. Salim from Darbhanga.
Dr. Reddy will be first speaker.
Dr. Reddy would be speaking the first. So I welcome you, Dr. Reddy, to enlighten us on this issue. Could I request Dr. Om Prakash, sir, instead of Dr. Salim, since he's not here? Dr. Om Prakash, sir.
So good morning, everyone. So this is going to be an exciting session because the UNICEF representative to the state of Bihar, Dr. Siddharth Shankar Reddy, will be speaking on the topic. We all know Dr. Reddy, but for the benefit of audience, I introduce him. He is a native from Odisha and completed MBBS and MD in community medicine from MKCG Medical College, Ganjam, Odisha. He is currently working as a health specialist with UNICEF, and he has over 16 years of work experience in Orissa, Andhra Pradesh, and Bihar. Initially, he worked as a public servant in Orissa government, and then later joined as assistant professor in a medical college. But since 2011, he has been working for the UNICEF Bihar, and it's a fortune of Bihar that a dedicated person like Dr. Reddy is working for us. And recently, he has presented a paper on COVID-19 vaccination, and he has an excellent field work in the field of public health as well as pediatrics. So child survival is one of the key areas of his interest. So I welcome Dr. Reddy for his lecture.
Thank you, sir, for this nice introduction. Respected dignitaries on the dais and of the dais, all seniors, delegates from Bihar and out of Bihar, my colleagues, friends and media. I would like to thank NNF Bihar chapter for organizing this Neocon 2023 with the theme of intact newborn survival, a better future, which is very much aligned with our principles, mandate, and also priorities, not only UNICEF, but also the health department's mandate, principle, and priorities. So also I would like to thank the organizers for giving UNICEF this opportunity to present on newborn survival. Thank you very much. So I am here with my colleague, Dr. Sarita and Mona. I will be present on the newborn health scenario of Bihar. Then they will be present on one of our key successful pilot, which we are doing in Purnia. So thank you very much. So I know all of you aware about the current newborn health scenario of the state, even the child health scenario of the state, most of you aware. But I will be highlight here some key points that is very concerning for the newborn survival and also beyond the survival for children of Bihar. So you know that if in the trend of under 5 mortality, infant mortality, newborn mortality, and also early newborn mortality, then the upper two lines actually you see that there is a flat decline, the sharp decline is happening since last 4 or 5 years. But that which is actually under 5 mortality, that is 30 per Bihar, and neonatal mortality, that is 27 per Bihar. That are actually, if you compare to the national average, we are faring better in terms of under 5 mortality and infant mortality. But if you will go for the neonatal mortality and in early neonatal mortality, actually we are very much actually challenging, facing a lot of challenges to reduce further to contribute the overall newborn survival of the state. So every year, actually, around 69,000 newborns die in Bihar, and around 89,000 infants and around 99,000 under 5 mortality happen in Bihar, and which is actually contributing around 12% of the burden of the country. And if you see the neonatal mortality, it is more than 77% of the infant mortality of Bihar. So now our focus should be more on the newborn mortality, because if you see the annual reduction rate for the last 5 years data, So annual reduction rate for infant mortality and under 5 mortality is very much well achieved, which is 7.21% and 6.49%. But the neonatal mortality, the rate of reduction is only 4.08%, which is a cause of concern. And if you will go through this pace, then we will be not able to achieve the target set for 2030, that is SDG target less than 12, or the India Newborn Action Plan target of achieving single digit newborn mortality by 2030. So we have to work more strictly on newborn mortality, and especially I request NNF, IAP, and government to, and also partners to work tandemly to achieve the results. Sir. So if you compare to the national data with other states, actually Bihar is on the sixth position, though our neonatal mortality is 1 point higher than India, but we are at the sixth position. But if you go to the absolute number, we are just behind the UP. That means our contribution in terms of absolute number is very huge. And if Bihar and UP were not achieving the result, then the India cannot be achieve the result. So my request here would to be focus on the newborn mortality, especially in the underprivileged districts and also in the vulnerable groups. So we have actually two key priority programs at the health department. One is a facility-based newborn care program, and another is community-based newborn care program. And also there is a program for linking the facility and community. And I will be here give some glimpses of the current situation of the current facility and new community-based newborn program. So you know that in Bihar there are actually 43 essentials are functional, and if you see the admission rate, every year around 50,000 admissions are happening, and with a bed occupancy rate of 85%. But and also if you see the data where from the newborns are coming, then you see that 40% newborns are coming from the health facility itself, means the health facility where the newborn essential is available. So that means another 60% are coming from the outside of the health facility, that is from either the block health facility or community, but it is actually very less. If you see the institutional delivery status, only around 20% of institutional deliveries are happened at the district hospitals and also in the medical colleges. But here the admission is 40%. That means most of the admissions are happening from the district hospital and medical colleges, not from the periphery. So we have to focus there. And also one challenge is that, as you know, that as per the life expectancy, birth at life for the female child, it is around 40% of the newborn should be female, and they should be at the same proportion they should suffer from any illness and should be joined at the SNCU. But only 37% of female girls are, Sikh girls are joining the SNCU. So there are also a lot of challenges and discrimination there in gender admission in the SNCUs. Also, the successful discharge rate is only 65%, which is also very challenging for the state. If you see that mortality, actually that average mortality should be around 5% to 10%, but it is high for Bihar. And also referral, you see 15% referrals are happening. That means one SNCU is referring to other SNCU, and that is burdening to the medical colleges, where actually we are providing these critical care services. So if you will strengthen our SNCUs at the peripheral level, then these challenges can be averted. Similarly, NBSU, 41 NBSU are here available in Bihar, and the admission is only 5,000 per year. If you will see the average length of stay in SNCU, it is 4 to 7 days, but in the NBSU, it is hardly one day or 12 hours. So at the pace of admission rate and bed availability and also average length of stay, at least around 40 to 60,000 admissions should be happen in NBSUs, but that is not happening. Why I am saying this is 40 to 60,000? Because our birth cohort in Bihar is 33 lakhs. And if in that birth cohort you will calculate how many babies will be suffer any illness, severe illness, then it will be coming around 1,20,000 to 1,50,000. That means if 50,000 babies are coming to SNCU, then another 70,000 babies, at least they should be admitted in the NBSU, but that is not happening at all. But in terms of management, we are doing better in the NBSUs, that 70% to 71% is successful discharge, and referral 28% is happening, that is OBBS. And the death and LAMA rates are very less. That is a good sign of our management system. So NBCC, I know that in 2019, we had established around 700 NBCs, But after 2019, there is no movement at all. Now only 713 NBCs are available, and that admission is also very poor. You see, there are around 13 lakh admissions are happening out of the 33 lakh birth cohorts. So that means we are lacking NBCCs as per the requirement. At least we are requiring around 2,400 NBCCs. That also in the periphery facilities like health and wellness centers, and where we are conducting deliveries, but we don't have NBCs, sufficient NBCs, and also we are not catering all the babies. Those are actually needing care at the essential newborn care at the NBCCs. So we, from the data, we can see that around 3% babies are needing resuscitation services, and that is 0.2% in the admitted NBC admitted babies, and referral is 1.1%, which is very fine as per the requirement. There are other facility-based services also available, like KMC Kangaroo Mother Care Units are there. Around 43 Kangaroo Mother Care Units are there in Bihar, and NRCs, around 41 NRCs are there in Bihar. But here also we are facing a lot of challenges in terms of admission of sick newborn babies and children, sick children. Coming to the home-based newborn care, there is a very well laid program, that is home-based newborn care is available for the state. It is a national partnership program, and here we are providing at least 6 to 7 visits to the newborn, whether that born baby delivered at a health facility, private, government, or community, or home delivery, wherever it is happened, we are providing 6 to 7 home visits. But you see, only few children are actually provided the full visits. That is around 13 lakh children are provided full visits out of the 21 lakh children enrolled in the system. That is 61%, or that all 6 visits. So that means we are again missing around 20 lakh children per provisioning of essential newborn care at home. So similarly, one new program is home-based young child care has been launched by Government of India since 2018, and we have started training. This program is very in initial stage, but gradually we are picking on this. Now we are just capacity building the healthcare providers capacity on home-based young child care. Then we will gradually start this program along with the health department. So to achieve this newborn mortality 12 by 2030 as per the SDG, or single digit by 2030 as per the Indian Newborn Action Plan, how these changes can be achieved. So if you will see where actually newborns die and how this can be prevented in the life cycle of a newborn, that if you will provide a proper pre-conception and antenatal care, then around 5 to 10% of neonatal mortalities can be reduced to. If you provide a skilled care at birth, that means during the time of delivery and within 24 hours, then around 41% of newborn can be saved. If you can provide care at the essentials, sick newborn care, then around 30% newborns could be saved. And also in the community follow-up, I was saying about the home-based newborn care and HUIC, home-based young child care. So if you will provide the services at the community, then another 25 to 30% newborn can be saved. So if the numbers, if you see, around 69,000 newborns are dying in Bihar, out of which actually the pre-conception and antenatal care period, if you will provide quality care and adequate care, then around 3,500 children's life can be saved, newborns' life can be saved. And if you provide proper care at the time of delivery, the institutional delivery and essential newborn care, then another 27,600 newborns can be saved, lives can be saved. If you provide essential sick newborn care at the essentials and the kangaroo mother care services, then another 20,700 deaths can be averted. Similarly, proper community follow-up and with facility linkage can also save around 25 to 30%. That is coming around 17,250 newborn deaths. So all these deaths are very much preventable and can be abated if you will focus both at community facility and also linking the community facility services. So there are a lot of strategies, well-laid strategies are there from Government of India. That is India Newborn Action Plan. There are 6 new pillars. 6 pillars are there in the India Newborn Action Plan that has been launched in 2014. So that focused from the day of conception, that focused from the day of conception to beyond survival. Here the 6 pillars are like pre-conception and antenatal care, care during labor and childbirth, immediate newborn care, that is essential newborn care, that is home-based care and care at NBCC, and care of healthy newborns, that is actually mostly home-based care and care of small sick newborns. That is care at SNSU and kangaroo mother care units and care beyond survival. That means beyond 28 days, what care we are providing. So if all the cares are ensured, the 6 pillars are ensured, then we can avoid 100% of neonatal mortality, not only neonatal mortality, that another 23% of infant mortality and another 30% of under 5 mortality can be also abated if we follow all the principles. We also have a very well program, that is Indian Action Plan for Pneumonia and Diarrhea, IAPPD. Here also there are very much strategic targets and guidelines are there, and what are the activities, what are the principles of management that should be followed are also there. If we will follow at the community and facility, we here also we can avoid the survival, especially beyond the 28 days newborns. That means children under 5. So what are the opportunities actually available? If you see, there are a lot of key flagship programs are available at national level, at the state level, like the facility-based newborn care, which we are discussing. So essential online system and tracking system that is available. Kangaroo mother care system is there. Now it's KMC. Immediate. Then early initiation of breastfeeding, home-based newborn care, vitamin K injection, antenatal corticosteroid, gentamicin at the community, all are actually very well programs. Then also flagship programs to improve health facilities like Lakshya, Sans, Muskan, labor room strengthening. These programs are also there. So here also we can focus on the labor rooms and newborn care units to strengthen the newborn care program. So my request to here to the NNF delegates and dignitaries, actually the government is actually Bihar is facing a lot of challenges in improving newborn survival, ensuring newborn survival. No doubt you were very much actually pioneer on this, and you are also helping to the health department very much since the beginning. I know that actually many of you were actually part of the guidelines that are policies developed for the newborn survival. You were part of these programs, but still I would request here, actually you know that quality of healthcare is a biggest challenge in Bihar, and there is no adequate of SNSUs or NBSUs or NBCCs as per the requirement of the newborns, sick newborns or normal newborns. So definitely government of Bihar is strengthening the healthcare facilities and improving the infrastructure, but simultaneously private institutions are coming forward. They are also strengthening their capacity in terms of management of newborn. But challenge is that actually private facilities are not reporting any newborn mortality or newborn admission, which is a biggest concern. Because why I am saying here, you know that around 20 to 25% newborns actually they die at the community. So we managing newborns at the SNSU of our private health facility, but after discharge there is no system at all to follow them. If you enroll them in the system, then we have a very well program, that is SNSU tracking of the sick newborns. So we can track them up to 15 months of life. So we can save their lives. At least 20 to 25% of newborns can be saved. There is also Ayushman Bharat program where you can also enroll your health facilities. You can empanel these health facilities so that all these sick newborns can be provided free of cost, and government will be reimburse all the cost that has been spent for the newborn. So whatever amount that is coming, that will be borne by the government. So Ayushman Bharat program, if you can enroll your facilities under Ayushman Bharat, then you can provide all newborns free of cost so that the poor people can also get benefit. Then awareness is a very big concern, though we have SNSUs at the district hospital, SNSUs at the medical college, but the hard to reach at the outreach area people, they don't know about SNSU and NBSU and what are the services provisioned there and free of cost services provisions there. So awareness generation is also very much essential, and I request you, whenever you are coming in contact with any newborn with their parents, please guide them and please make them aware on not only coming to SNSU but on the antenatal care, internatal care, nutrition, breastfeeding and postnatal care. Please guide them. And also I request here, you actually NNF Bihar and medical colleges, they were pioneer in establishing this facility-based newborn care model in Bihar, and initially they provided a lot of mentoring and handholding supports. But after this COVID, now I think there is a gap between the facility-based services and linking with the NNF experts and also medical colleges. So you should come forward to support the health department and the partners for mentoring and handholding support to the health facilities, not only private, but also not only government, but also the private health facilities. And also please help on auditing the deaths, newborn death that is happening at the SNCs in the labor rooms, so that we can also find the cause of that death, and we can will try to change or improve the causes or the scenario of the management. Similarly, new programs are like vitamin K, is there antenatal corticosteroid program, is there exclusive breastfeeding, kangaroo mother care is there. But I observed that few private hospitals, they are actually initiating this formula fed milks, and also they are not following this antenatal corticosteroid or vitamin K guidelines. So I think if you will intervene here, then we can change the scenario of newborn of the state. So thank you very much for giving UNICEF this opportunity. So thank you for your patience listening. So I am available here for any question is there on this newborn survival. Thank you very much.
So thank you, Dr. Reddy, for your talk. You have given a lot of information, and you have given lots of programs running, and we're happy that we are part of that program, and we are seeing a lot of changes. And what is my personal, that we have achieved a lot, but we have to achieve a lot more.
Yes.
So we are having lots of NRP programs initially. Every year, I think 2-3 programs. So we are taking care of that. We will try to improve. Thank you.
Thank you very much.
So thank you, Dr. Reddy, for enlightening us, and the take-home messages, 2-3 messages. Still 69,000 newborns are dying in the state of Bihar. So this is a matter of concern for all of us, and we must take note of it, and we have our resolve to bring it down as far as practicable. And the second point, you told Bihar is at number 6. I will not say it's in the number 6 from bottom, and we are the one who are pulling the national average down.
Yes.
We are not ahead of the curve, we are behind the curve. So these are the 2 take-home messages from my side. I will request everyone to please take note that we come out of this shame. Thank you.
Thank you.
I am proud that I was attached with Dr. Reddy and all the persons of the UNICEF, and we started SNCU before the NIP came in the, and UNICEF give lot of support, and due to NNF and UNICEF, I was training in Madhya Pradesh, which is the most aspirant state, and Chhattisgarh. So thank you, UNICEF, for giving us, supporting Bihar in cut down the neonatal mortality. We have to, as an NNF member, I have request to each of the NNF member to just associate with this, our ambitious program. Though we are on 6th, but Kerala has 4 and we have 21. So this is a large gap, and we can fill with few simple measures. So I thanks Dr. Reddy. We gave up support from UNICEF. Thank you very much.
Thank you very much, sir.
Thank you so much, Dr. Reddy. And now for the next speaker from UNICEF, Dr. Sarita, who would be introduced by the chairpersons. And I would like to request Madam Mona Sinha also to join Dr. Sarita when she finishes. I'd really like to hear from her, because she's also an expert in her own field. So over to Dr. Sarita.
It is my proud privilege to introduce Dr. Sarita Verma. Dr. Sarita Verma is the health officer with UNICEF Bihar. And I know before he joined the Bihar, he was in Madhya Pradesh, and he have the opportunity to attach to the other well-developed states. But she chose Bihar. She is a public health professional for more than 13 years of experience in the field of newborn and child health. She has experience working in the 2 big high burden states, Madhya Pradesh and Bihar, and he had done a lot of for Bihar. We have done a lot of quantity work, but after Sarita, we are working for the quality. He is a quality champion and led several quality improvement initiatives, essential of the Madhya Pradesh and Bihar. So let us hear from Dr. Sarita how we can do more.
Thank you, sir. So before starting with my presentation, I would like to show a video of this particular project that we are doing in Purnia district, which is also UNICEF programming district. So let's see this video. You will get to know something about the project, and then I'll talk about the methodology and the recommendations that came out of that project.
एक अभिनव परियोजना नवजात शिशु की सुरक्षा एवं देखभाल हेतु सामाजिक एवं व्यवहार परिवर्तन गुणवत्ता सुधार का परिणाम है। गर्भवती महिलाएं ही आवश्यक 4 प्रसव पूर्व जांच के लिए जाती हैं। नतीजन इसका असर सीधा प्रजनन स्वास्थ्य एवं नवजात स्वास्थ्य पर पड़ता है। इस परियोजना को शुरू होने के मात्र 4 महीने के अंदर ही लखना पंचायत में इसके आंकड़े काफी बेहतर हुए हैं। इन प्रयासों के सकारात्मक परिणाम आने लगे और अब गर्भवती माताएं स्वतः ही प्रसव पूर्व जांच के लिए आने लगी।
कार्यकर्ताओं ने स्वयं ही इस बात को तय किया कि चूंकि उनके यहाँ अधिकतर गर्भवती एनीमिया से ग्रसित होती है, अतः उन्होंने अपना लक्ष्य चुना। सभी गर्भवती माताओं को आयरन और फॉलिक एसिड गोलियों का नियमित सेवन करने के लिए जागरूक करना, ताकि स्वस्थ नवजात शिशु का जन्म हो और मां भी स्वस्थ रहे। जब लोगों ने आयरन और फॉलिक एसिड की गोली के नियमित सेवन के फायदों के बारे में जाना, तो न केवल गर्भवती महिलाएं परंतु उनकी सास तथा पति भी इस बात के लिए नजर रखने लगे कि उनके घर की गर्भवती महिलाएं नियमित रूप से गोली खा रही हैं अथवा नहीं।
आज यहाँ शायद ही कोई प्रसव घर पर होता है। रिकॉर्ड समय में संस्थागत प्रसव को बढ़ावा देना इतना आसान भी नहीं था। ये एक चुनौतीपूर्ण काम था। अगर हम इसकी सफलता यात्रा को देखें तो पाएंगे कि यूनिसेफ बिहार एवं जिला स्वास्थ्य और सहयोगी विभागों की 4 महीने की कड़ी मेहनत और लगन ने इसे संभव बनाया है। आशा करते हैं कि यूनिसेफ बिहार की इस पहल से वो दिन दूर नहीं जब राज्य में कोई भी प्रसव घर पर नहीं बल्कि स्वास्थ्य संस्थान में होगा।
नवजात को स्तनपान कराना बच्चे के लिए अमृत के समान है और मां का पहला पीला गाढ़ा दूध नवजात के लिए पहले प्राकृतिक टीके की तरह काम करता है। यदि ऐसा नहीं होता है तो बच्चों में कई प्रकार के संक्रमण होने का खतरा बढ़ जाता है। अतः शिशु को जन्म के तुरंत बाद जितना जल्दी हो सके मां का पहला पीला गाढ़ा दूध दिया जाना अत्यंत आवश्यक होता है और उसे 6 महीने तक सिर्फ मां का दूध ही दिया जाना चाहिए। कार्यकर्ताओं ने महिलाओं को बताया कि प्रथम 3 दिनों तक मां के स्तन से निकलने वाला गाढ़ा पीला दूध नवजात के लिए बहुत उपयोगी होता है। इसमें पोषक पदार्थों की प्रचुर मात्रा के अलावा शिशु को रोगों से बचाने वाले तत्व भी शामिल होते हैं। साथ ही स्तनपान से मां व बच्चे के बीच मधुर संबंध भी स्थापित होते हैं।
शिशु एवं बाल मृत्यु दर में कमी लाना यूनिसेफ के आधारभूत परिकल्पनाओं का एक महत्वपूर्ण हिस्सा है। बिहार के पूर्णिया जिले के कस्बा प्रखंड में शुरू की गई अभिनव परियोजना नवजात शिशु की सुरक्षा एवं देखभाल हेतु सामाजिक एवं व्यवहार परिवर्तन गुणवत्ता सुधार, इसी परिकल्पना को मूर्त रूप देने की दिशा में उठाया जाने वाला एक प्रयोग है। संस्थागत प्रसव की संख्या में वृद्धि होने के बावजूद प्रसव के बाद घर में होने वाली नवजात शिशु की मृत्यु अभी भी काफी बड़ा अनुपात है। इसलिए नवजात शिशु की घर में देखभाल की व्यवस्था करना महत्वपूर्ण हो जाता है। इस उद्देश्य से परियोजना के अंतर्गत कस्बा प्रखंड के गुरही पंचायत को गृह आधारित नवजात शिशु की देखभाल या होम बेस्ड न्यूबॉर्न केयर HBNC सुनिश्चित करने के लिए चयनित किया गया।
जन्म दर को कम करने और जनसंख्या वृद्धि दर को धीमा करने के लक्ष्य के साथ भारत परिवार नियोजन कार्यक्रम शुरू करने वाला दुनिया का पहला देश बना। बनौली पंचायत में जब इस परियोजना की शुरुआत हुई तो परिवार नियोजन वहां की एक गंभीर समस्या के रूप में टीम द्वारा चिन्हित की गई और कार्यकर्ताओं ने परिवार नियोजन साधन के इस्तेमाल को बढ़ाने के उद्देश्य से काम करना शुरू किया। इस समस्या पर बातचीत किया जाने लगा। टीम के सदस्य अपने दैनिक कार्य योजना के अनुसार गृह भ्रमण कर लक्षित दंपतियों से बच्चों में 3 साल के अंतर के महत्व और ऐसा करने के लिए तमाम उपलब्ध विकल्पों की जानकारी उन्हें देने लगे। साथ ही हर 10 दिनों पर टीम के द्वारा किए जा रहे समीक्षा बैठकों के आयोजन से भी इस प्रयास को काफी सफलता मिली है।
So maybe after watching this video, you got to understand the idea behind this project, that we wanted to focus on quality improvement, part of routine interventions that are already existing. So this basically this project started when social behavior change strategy for newborn survival was launched in 2018. And in continuum to this particular strategy, this project was envisaged, and there's already a Tarang module, which was basically focused on improving immunization services using SBC approach. So we used that module, and we included quality improvement approaches in this particular Tarang module, where we have focused on frontline workers and in building on their skills of providing quality counselings and also finding out local solutions. So for that, UNICEF has supported with creation of 50 district level resource persons and also the trainings of FLWs in 8 Gram Panchayats. We have started small, but with the support from district administration of Purnia, now we are extending that project to whole Purnia district. And there's also continuous monitoring and support from state level and district level teams to roll out this particular projects. So basically we followed 3 key mantras for this project, that we want to do the same thing differently rather than doing the things, doing the different thing. So we are not doing anything new, but we are just finding a way of doing the same thing in a innovative way, in a new way that will help bring out the change. And sustainability was also one of the main mantra for this project. And last but not the least is system strengthening approach that we are using here. So the main objective of this quality improvement for social behavioral change project was to increase demand and also to ensure that there's an equitable access to maternal and newborn and reproductive services. And we are also focusing that ASHAs and other frontline workers, they are able to deliver the quality counseling to the community. And besides that, we have also focused on improving preventive and protective behaviors such as breastfeeding, maternal nutrition, ANCs, family planning, institutional delivery. This project has also focused on improving male involvement, because since many years we have been seeing that only we have been focusing on women beneficiaries, and we are counseling them, we are bringing them to the VHSND session, but involvement of male was very limited. But now this project is specifically focusing on male involvement and using them as a influencer and positive deviant for other male members of the community. And we are also focusing on bridging the divide between community and frontline workers. So this particular project is following this socio-ecological model, where we focus on creating the enabling environment by strengthening the structures and policies around the health system. And we also focus on social change by focusing on institutional strengthening, and also community by building social networks and social capitals and addressing the cultural norms. And the focus, but ultimately our focus is to do the behavior change, which is basically at the interpersonal level and the individual level. So this particular project is focusing on social change and behavior change part of this socio-ecological model. So for this, we have been using these strategies. So first of all, there's a team of AAA, ASHA, Anganwadi, and A&M, and we have also included Jivika Didis in this project. We have been using different advocacy events to bring this quality improvement agenda at the core. And under this project, we have focused on doing the system strengthening. We have partnered with Alive and Thrive and also with District Civil Surgeon Purnia and also the District Administration, and DDC Purnia is on the top of this project, and she's following it up almost on a weekly basis. And the main strategy was community mobilization. That even in primary healthcare, we know that the main pillar is community engagement. So engaging with the community will bring the change when they are participating in decisions related to their own health. And under this project, we have been trapping conventional as well as the unconventional networks like religious leaders and elders in the community, male members of the community. And it was a convergent effort between different departments, ICDS, health, Jivika, and there's a focus on building social capital. And also interpersonal counseling is a main important component, because like if you see all the strategies, the strategy which brings behavior change, it is IPC, interpersonal communication. So the counseling is very important part of this particular project. Six main problem that we focused in these different project area. First was family planning, and the second was improving ANC visits, IFA supplementation, there was issue of high home delivery, home-based visit, and also improving breastfeeding. So we had this 8 project areas. These are 8 Gram Panchayat where we focused. So this was the QI model that we have been using. It's a standard QI model from point of care quality improvement module of WHO. So we have been training workers on using these steps to identify their own change ideas and implementing those change idea in the community and sustaining these improvements. So the same that we have been doing at the facility level in SNCUs and labor rooms. Now we have successfully demonstrated this particular model at the community level, and I think this is the first of its kind of project which has been done at the community level. So workers have done this kind of problem analysis using different tools. So this fishbone was basically done by Ashas, Anganwadis, ANMs, and Jivikas sitting together, and they came forward what are the different root causes of low coverage of home-based newborn care visits. Then they also developed their own aim statement for each of the projects. So I'm not going I'm not discussing this particular slide in full, but all the Ashas and ANMs, they were aware where they want to achieve and who is going to help them with data collection, what will be the frequency, when they will be meeting. They had all that planned well in advance. And once the project was successful, there were certain solutions that they came forward. Like in an ANC project, we know that in ANC, ANMs play a very critical role. But here in this project, we have been focusing on in improving the role of Ashas. So they can play a proactive role in reaching out to pregnant women to come for ANC, and also use that opportunity when they visit the home to counsel the pregnant lady about the benefits of ANC, why they should be coming to VHSND for doing the ANC. And also this project has also focused on providing quality counseling to these pregnant women, and also telling them why they are required to register their pregnancy within first trimester. And thirdly, again sending reminders to pregnant women to come to VHSND session, using mothers meeting platform to provide information about ANC. And the similarly for IFA supplementation, there were refresher trainings for FLWs for IFA supplementation. Workers divided pregnant women, they adopted 5 to 6 pregnant women, and then they followed them up over the period, and they counseled the families along with the pregnant women. And they were also promoting local solutions for preventing pneumonia. They also use the method of checking whether pregnant woman is taking iron supplementation or not by checking the strips, whether it is used or not, and also checking their thalis, whether they are eating properly or not. And different platforms have been used to communicate information about IFA supplementation. So in each project, we have like different kind of need-based solution or change ideas. But collectively, in all the projects that we did the right line listing of right holders, refresher trainings on thematic areas have been done, and all the family members were included in the counseling session. And these counseling sessions were especially designed to be planned on the time when the whole family is available, basically in evening when husband is also available at home. So workers were doing this based on availability of all the family members. So we also have some formats to record the data. One thing that is in the system, but Ashas were not doing it, was developing an Asha diary. That means keeping track of each and every day's activity, what is the plan, next day's plan. So in this project, they have been focusing on doing that as well. And we have those diaries, and we can see because of that diary, now they are using one single visit. If it is for home-based newborn care visit, they are using that particular visit to deliver other interventions as well. Like they are doing family planning counseling, they are also motivating them for ANC. So it's not only the one thing which is improving, but it is affecting all the other things. So spillover effect we have been observing in this project. And there was clear division of work among Ashas and Anganwadis during the joint visit. Regular team meetings to discuss the progress, and also there was one WhatsApp group to share the information and progress and the progress. And there were many counseling tools that were already existing with Ashas and Anganwadis and Jivikas. So this project has also revived the uses of those counseling tools. So this is some of the data from our project that when we started in June, the counseling was it was almost for counseling, it was not happening. And in December, it was around 86% of pregnant women were counseled for ANC. And second, you can see the improvement in second ANC. It was previously it was 78%, now it is 96%. And same is the story for the fourth ANC. And in home delivery project area, there's a drastic change. Previously, 80% of deliveries were home delivery. Now there's no home delivery. All the deliveries are happening in institution. And although HBNC was showing better data compared to other projects, but the quality was main issue in these HBNC visits, and specifically the visits beyond 14th day of birth. So they focused on 21st day of visit, which was only 50%, and now it is 83%. And similar was the story for IFA supplementation. It was very poor, like hemoglobin levels were very poor among pregnant women, which have improved over the period. And also the counseling part in breastfeeding project. And we also saw like there are studies showing that family planning, you cannot change the behavior related to family planning in a very short term period. But this project has demonstrated that it is possible. So we can see that temporary method was only 17.4% in first fortnight of June. Now it is 64%. And permanent method has also increased by around 3% in the same duration. So now there are some recommendation and way forward that came out of this project. So before going with the recommendation, we know that there are certain challenges also. We accept that because it was a new way of working. So everybody was thinking why we want to do this. They were thinking that this was additional work, and there were many apprehensions. So by continuous handholding and providing them support through our teams in the field, we were able to address this challenge. And there was also issue of supply chain and logistics. for IFA, even for HBNC forms and ANC related materials, and interdepartmental convergence that we have been envisaging since many years, and even primary healthcare is based on multi-sectoral policies and action. But it is easier said than done. It was very difficult. It was easier to bring Ashas, Anganwadis, Jivikas and other workers together, but it was very difficult to do that higher level interdepartmental convergence. So still it remains as a challenge. And FLWs also felt that they should have some resource allocation. So we asked them to use the existing platform of VHSNC, where fund is already there and they can utilize that platform. So we are also doing capacity building of VHSNC teams. And also the sustaining 2 minutes. So also the sustaining and maintaining the quality of projects, especially the ANC, because quality of ANC matters. We need to focus on numbers, but also on the quality. So this project has potential, a lot of potential for scale up because resource pool is available. We have trainers available, and the confidence that workers are having, it is immense, and we can use this as an opportunity to build counseling skills among FLWs. And because project was designed by FLWs, so the ownership was very high. And this module can be easily divided into incremental learning module, which can be delivered on monthly basis. And at the end of 3 months, we will be having a 1 QI project. Because there is a scope for mid-course correction, so it makes it easier to scale up and to test the different change ideas. And so it will not be monotonous. And now the recommendation that came out of this project is that we need to converge at the district level and also at the state level, and if possible at the country level. We will be supporting creation of pools of trainer. Monitoring is a very important component of this project, because without monitoring, any good project will fail. So robust monitoring component will be required. And here the Dr. Reddy also said that HMIS, in HMIS currently we are having government data, but we are missing out on private data from private providers. They are in private sectors, there are ANCs happening, there are deliveries happening, there are PNC visits happening, but we don't have that data. So we need to broaden the scope, and we felt the need that we need to institutionalize QI for SBC curriculum, because it's not possible for UNICEF to keep on supporting Ashas and Anganwadis or other FLW trainings. So if it is inbuilt in the curriculum, it will be much easier to roll out over the years. And we also need to document these local solutions. And most important is that streamlining logistics and supply, because quality will not come if there is no supply. So that is more important. This is the integrated map. And
thank you, Dr. Sarita.
I'll just take 2 minutes, because
we are already a bit late, and you have dealt the subject quite well.
Yeah.
And I believe. Okay, so you can go ahead. Otherwise, as a timekeeper, it's my responsibility.
It's okay. So, yeah. So just very short term and long term, some actions for some of us. That UNICEF will be supporting these refresher trainings of master trainers and creating pool of master trainers. But because you all are here, so I think somewhere we need to converge with NNF and other private providers to make this project technically strong, because currently we have like SBC area is very strong, counseling part is very strong. We also need to bring out the technical component. So we may request some of you to be part of this project. And now this project is being extended to across the Purnia, and starting from 64 more Gram Panchayat. So we have requested district administration to take lead on developing coordination and monitoring mechanism. And now this project will also be submitted for National Innovation Summit, and it will be showcased, and where UNICEF can support. And this project has already got state level award in state level quality conclave, and the team has received the award on behalf of all the team members. In the long term, we can think of including this QI into curriculum of different Ashas and Anganwadis modules, and also integration in pre-service training package. I already talked about it. So these are some of the glimpses of the project. And this was the award that Team Kasba has received from ED State Health Society. It was just in January 2023. And these are the project briefs and process documents. And this is the QR code. If you want to download all the documents related to this project, you can scan it. And with me, I also have Mona Sinha, who is a social and behavior change specialist with UNICEF Bihar. And she has been very instrumental in she was leading basically a newborn survival strategy for Bihar. And we have conducted many community consultation as well. Maybe if you can give 2-3 minutes for her to speak about her perspective on this particular project. Mona ji.
So before we introduce the next speaker, the next speaker is Dr. Mona Sinha. She is a behavioral consultant from the UNICEF. And as we all know, the most difficult part is the behavior change communication and the change of a community behavior. So we have a specialist to talk on the subject. So welcome, Dr. Mona.
Thank you so much. I'm not a doctor. I'm Miss Mona Sinha, and leading the behavior change discipline in UNICEF. But thank you so much for your introduction. Is it an issue if I speak both in English and Hindi mixed karke? Because I'm more conversant in Hindi because I talk with communities more often. So as you saw this, what Dr. Reddy presented and Dr. Sarita presented, this project that we initiated in Purnia has given us a lot of hope and a lot of new ideas also on how we can take this forward and scale it up. And as you know, community, we have to take the community along if we want to improve health indicators. And the first thing that comes to my mind for this is increasing ownership of the community. What do I mean by increasing ownership of the community? Instill confidence in the community that they are capable enough of taking forward health related behaviors themselves. क्योंकि community में भी एक ऐसा एक अप्रोच होता है कि दिस इज बियॉन्ड मी, ये तो भगवान के भरोसे है, डॉक्टर साहब जब तक नहीं बताएंगे तब तक हम कुछ नहीं कर सकते हैं. सो फॉर मी, आई एम लुकिंग एट यू डॉक्टर्स as the biggest influencer to influence community behaviors. If you are not there, community health is not there. So you are the biggest influencers, and that is why I have grasped this opportunity to address you. Because if we look at public health, we look at health indicators, you are the biggest stakeholders here. And Dr. Saab ne abhi bataya 69,000 newborn deaths are still happening in Bihar. That is the average you're looking. You know what? As a behavior change person, I really don't care how many thousands are dying. One newborn death, one maternal death, the cost is too high. It is simply too high, especially if a newborn is dying out of preventable causes. Means the child could have lived, but has not been able to live because of some decisions or actions at the family level, जो कि भगवान भरोसे नहीं था, परिवार के भरोसे था, फिर भी हमने उसके बारे में कुछ नहीं किया. So it is very important for you doctors to look at this and actually instill confidence in the families who are coming to you. I know you are overburdened, there are too many things that you have to do, too many patients lined up, आप एक patient को उतना time नहीं दे सकते हैं. But even then, try to instill confidence, try to counsel them कि कुछ चीजें हैं जो आप घर पे कर सकते हैं और बहुत अच्छे से कर सकते हैं. आपको बार बार डॉक्टर के पास दौड़ने की जरूरत नहीं है. और जब हम लोगों ने ये सामाजिक और व्यवहार परिवर्तन रणनीति बनाई, न्यूबॉर्न सर्वाइवल स्ट्रैटेजी, we went and consulted communities all across Bihar, in many districts of Bihar, and we found some extremely illuminating myths and misconceptions that they had. कि जैसे जब बच्चा जन्म लेता है तो जो प्रोटेक्टिव कवरिंग है उसको जावर कहते हैं, जावर हटा देना होता है, उसको छील के हटा देना होता है. These kind of things. I think you are the people who can really, you know, play a very conclusive role in telling them why it is important not to remove that covering. I don't know what you call it in technical language, but how do you explain in very simple language to the community on what they need to do and why it was given by nature itself to the child to be there? And then another thing that came, ki TTD ka injection and albendazole lead to miscarriage. Garbhat ho jata hai. These kind of things. So it is very important for doctors to be looking at these things, because they are not going to come to you and tell you. They are so in awe of you. You are their Bhagwan. आप उनको 5 मिनट देंगे, वो जो बोलेंगे वो रामबाण समझकर उसको करेंगे. But if they have any conceptions or misconceptions, neither you have the time to take it out from them, nor will they come forward. They don't have the confidence to come forward and tell you, Doctor साहब ये भी है, लेकिन इसके बारे में क्या करें, इसके बारे में. They are not going to tell you. So how do we build that easy communication channel with the community whom you are serving day and night? What is it that needs to be done? And here is where the role of the ASHA comes in very, very, plays a very, very critical role. And this is what we found, that in this project of QI for SBC that Dr. Sarita was talking about, we found that even after so many years, we've had this cadre for how long? I don't even remember. This cadre has been around for so long. But even now, there is such a barrier between this cadre and the community. Even now, they don't go and talk to people. Why don't they talk? Because they themselves don't know what to talk about. They do not know. ये क्या कहना है? अगर माँ का पहला गाढ़ा दूध देना है, उसको कैसे कन्विंस करना है? क्यों माँ को देना चाहिए? How do you override the belief at the community कि बच्चा को जन्म के तुरंत शहद डलवा देना, which is so ingrained? How do you overcome that and tell नहीं, शहद के पहले ये देना है, शहद नहीं देना है, और पानी नहीं देना है, सिर्फ दूध पिलाना है? How do you overcome these deeply ingrained social norms जो कि सदियों से चले आ रहे हैं? They do not have those skills. And this is where we work with the FLW, Asha Hui Anganwadi worker, on how to increase their confidence, how to increase their knowledge, to transact that communication to the community, build their skills and build their confidence and self-efficacy, ताकि वो बात जाकर बोल सके community में पूरी confidence के साथ. And नतीजा उसका ये हुआ है कि now the community is coming back to them for advice. Now the community is telling them. In the IFA project, we found there was so much reluctance. IFA नहीं लेना है, गोली नहीं खानी है. Now they are coming. दीदी मेरा IFA खत्म हो गया है, हमको और गोली चाहिए. मेरा 180 नहीं हुआ है, हमको और गोली चाहिए. Now they are coming. Isn't this what we want? We want the people to come. जैसे आपके पास मरीज जब बीमार हो जाता है तब आपके पास आता है. We want healthy people to come to the ASHA जब बीमार नहीं है and seek health seeking behaviors, so that they are in a position to adopt optimal, desirable, practical behaviors. And these are not difficult to do. We just have to set up these systems where these behaviors are able to be inculcated in the family. So poor counseling skills was one big barrier that we found that was actually hampering the whole uptake of healthy newborn care behaviors. And now after this, as we have found, jo respect hai community ka towards the ASHA has also increased. One big influencer group like yourselves, like the doctors in the community, are the rural medical practitioners. And we have found that it is so difficult. They practice such an influence in the community क्योंकि वो उनके घर तक जाते हैं, उनके घर का हालचाल जानते हैं, सब कुछ जानते हैं. तो Why shouldn't the community trust these rural medical practitioners? You tell me. How do you minimize the influence of rural medical practitioners? Should you take them along? Should you build their capacity on giving proper health and nutrition behaviors? Or should you talk to the community not to listen to them? I think the latter is more difficult. I think we need to take along the rural medical practitioners, because in one of the project for institutional delivery, we found that in ghar mein delivery ho rahi thi because the rural medical practitioners are asking them ki ghar mein hi delivery ho. So we have, these are the influences that we need to work around. And I think, you know, as I said, doctors are the biggest influencers. When you're talking to them, I don't know, you may be doing it already, but when you are dealing with a newborn child, looking at their health issues, if you could find the time to also talk about other things, like maybe family planning. ठीक है, अभी ये बच्चा हो गया है, अगला बच्चा के लिए 3 साल तक वेट करना है, ये, if you are able to do that, that will really help. And also we work a lot with religious leaders because they also impact health behaviors. So working with religious leaders is another issue that UNICEF would request support from doctors who could help us to work with religious leaders, and also getting men, involving men in the whole process. अगर आपके पास कोई बीमार बच्चा को लेकर सिर्फ माँ आ रही है, सास आ रही है, उसकी नानी आ रही है, दादी आ रही है, why don't you insist? Where is his father? Where is his grandfather? Insist on getting the man also involved in care and uptake of newborn best practices. Thank you so much. Thank you. Thank you for patiently listening to me.
So thank you, team UNICEF, under leadership of Dr. Reddy here, Dr. Sarita, as well as Ms. Mona. You have chosen a very important topic. Neonatal health cannot be seen in silos. It's closely associated with the mother, and mother is associated with the society and community. So the overall community behavior is so important, and you have done a QI. I believe you are the PDSA cycles you have analyzed, and now you can come out with a bigger cohort, and you can put it at least at a district level. So this will be another story for us in our next meeting. Thank you. Thanks for joining.
So Dr. Sarita told we are not going to do new things, but things better by a new way. And he did this today also. When I entered, he asked me, will you help us in Purnia for neonatal resuscitation? And I agreed. So initially UNICEF was with us in our skill building. Now we as an NNF person, IAP person are with them, and we are going to support him in Purnia project. Thank you, Sarita.
Thank you so much to all the chairpersons and all the UNICEF members. Madam Mona, I know her since I think past 35 years, and the way she delivers is just the same. Thank you so much, Dr. Sarita, Dr. Reddy. The vision that you have shared with us is very true. And what I wish to convey to you, Ms. Mona, is that there are a lot of government programs happening, a lot of trainings being given by medical colleges, and they are trying to bridge the gap between the patients and the doctors. So a lot of programs, FBNCI, MNCI, happening in all medical colleges. So that is just a step, and with the help of UNICEF, we, I'm sure we'll proceed. So now over to the memento presentation by the speakers to the chairpersons. Yes. So now to move on to the next session. The next session is a very, very interesting topic, that is PPHN, or comprehensive approach. And for this, we have none other than Dr. Ashok Mittal. We've had the honor of being with sir yesterday in the workshop as an HFO, and he'll be introduced better by the chairpersons. Dr. Professor JPN Badmal sir, who has also headed the Department of Pediatrics once. Dr. R.K. Sinha sir from Bhagalpur. And we have Dr. Jayant Prakash sir. Dr. Jayant Prakash sir, who's the HOD, IGIMS. So may I please request the chairpersons to come up on the dais and introduce the speaker, Dr. Ashok Mittal sir. Is Dr. Ghazi Sharik here present? Dr. Ghazi Sharik from Katihar. Sir, if you are here, you can join the dais, sir.
Good morning,
Sorry,
everybody.
Is Dr. Shambhu from Katihar present here? Dr. Shambhu, sir? Sir, if you are here, please join as chairperson on the dais.
Right at the outset, I'll first congratulate doctors involved with this organization, because NNF is being rejuvenated, especially boss is here. So congratulations, sir, for bringing. Presently, I'll go the other way around. Dr. Ashok Mittal is presently the director and HOD of Cloud9 Hospital at Gurgaon. So you must be familiar with Cloud9 Group, and they are there in all major cities and metros. And he did his MD from KGMC Lucknow and was a PG teacher at LNJP Hospital, Delhi. He started NICU at Apollo Gleneagles, and he's also trained from sick kids at Toronto, Canada. He has been awarded with Best Original Research Award in 2008. And I think many of us have been exposed to his acumen yesterday in the workshop. So with the permission of Banwal sir and Sinha sir, I think over to the speaker. Okay.
The theme is intact newborn survival. We heard 69,000 deaths of the newborn per year in Bihar. We heard neonatal mortality 21 per 1,000 in Bihar. The first speaker, what he said, inborn errors with the metabolism. In between came neonatal sepsis. And what we find, that these are the unavoidable, or most of them preventable disease of the newborn. And the third is now PPHN. So let us see how we can prevent the newborn deaths due to these diseases. Thank you. Dr. Mittal, you can.
Thank you very much, the organizers of the Neocon 23, for such a nice talk. Actually, this PPHN is a misdiagnosis. In our day-to-day practice, when patients are referred to us, I think 95% of the doctors among us miss it, PPHN. And that leads to death of the neonates, because the appropriate treatment is not awarded. So I think Ashok Mittal will tell the clinical clues and how to prevent and diagnose it the earliest stage. Thank you very much.
Sure, sir. Thank you. Before we start, can we expect people at the back to kindly not speak and come and sit down, please? People at the back. So thank you, Chairman, and the organizing committee for giving me this opportunity to talk upon this topic, which is very dear to me. And this is one thing that I learned maximally in Western world, how to manage a very, very severe PPHN. And these are very rewarding cases, because these are some of those situations where a neonatologist feels very gratified since the
the response to the technologies that we have, especially ventilation, high frequency oscillation and nitric oxide, gives you very immediate effect. And the gratification is very quick, to the extent that if nitric oxide doesn't work in 2-3 hours, we stop it. It has to work. If it is the right diagnosis and the right treatment, it has to work. So just to take you into the PPHN very, very slowly and gradually, and I expected that a lot of postgraduates will be there who would benefit from this because seniors already know it. They are here. So yeah, thank you. So approach to the patient does not, unfortunately, मरीज दिमाग पे diagnosis लिखा के नहीं आता. If that was the case, it was much easier. So what you will get is a blue baby, right? Who is not able to maintain saturation. Most of these referrals actually, happen to us as what? Suspected cardiac malformation, congenital heart disease. And trust me, out of 100 congenital cyanotic heart disease referrals that we get on such babies, only 1% or 0.1% will actually turn out to be a cyanotic congenital heart disease. Most are either bad parenchymal disease, a missed out pulmonary leak syndrome, an pneumothorax or something, or PPHN. So we thought we will take an approach to a hypoxic baby and slowly take you to the lane of PPHN. So whenever a child is hypoxic in a refractory way, I'm not talking about giving some oxygen and child improving, hypoxic in a refractory way, not improving, then we think of lung, heart, and PPHN as the cause. So तीन ही तो प्रॉब्लम हो सकती है. लंग्स की हो सकती है प्रॉब्लम, सो लंग्स में आपके TTNB, निमोनिया, मेकोनियम, एटसेट्रा, या लंग हाइपोप्लेजिया as seen in congenital diaphragmatic hernia, or air leak syndrome. Don't forget the pleural cavity. Air leak syndromes are also very, very common. The other thing which we are very, very afraid of, we pediatricians and neonatologists are very afraid of congenital cyanotic heart disease. कि ये हो गया तो क्या होगा? So if that be the case, duct-dependent right-sided lesions will present as severe hypoxia, whereas duct-dependent left-sided lesions will present as shock. And they are alive at that point in time only because the PDA is alive. If the PDA gets closed, then you're finished. Either you will die of hypoxia or you will die of shock. So the first thing is to keep the PDA open by starting prostaglandin. So I always tell, if you're not sure and you do not have the facility of pediatric echo on bedside, you better start prostaglandin. So that if it is cardiac, the child will be saved so that the PD is open. Even if it is PPHN, prostaglandin infusion will not harm. It has got some pulmonary vasodilator property. So a postgraduate must understand that if you're running an NICU, your NICU fridge must have a dose of alprostadil, a dose of surfactant, and all other things that you carry, right? So starting a prostaglandin is permissible by a fresh resident. Not able to start it is a crime. Third is PPHN, which is the core area of topic today, which basically means that the pulmonary vascular resistance or the pulmonary arterial pressures that were very high in utero have not been able to fall. That is supposed to be the normal case scenario. After birth, we are supposed to have our PVR. So we will use these terms very frequently from here forth. PVR stands for pulmonary vascular resistance and SVR stands for systemic venous resistance. So if the PVR is very high in utero, it is supposed to fall down soon after birth. Now, how soon is very difficult. Typically, traditionally, by book teaching, you take 10 to 15 minutes for transition of circulation to happen. But we have seen children taking 1 hour, 2 hours. That's okay. So we get very afraid because in utero, the fetus saturation is only 65% and the PaO2 is only 35. But while the child comes out, we expect the PaO2 to be more than 60 and SpO2 more than 95%. So how a 65% SpO2 survived the baby from few nanograms to 3 kilo, and outside you get freaked out as a pediatrician when the saturation is 80. Don't get freaked out. In the initial transitional circulation, there may be a situation where your saturations are little low, and that's completely okay. But beyond 10 to 15 minutes, it may become a problem. So we will see. So how do we differentiate between the three categories? So one is your lungs are bad, Lungs starts from here, for me, airway. So from nose to airway obstruction to lungs to pleural cavity. So the entire thing has to be understood. So wherever there is problem, your child may have choanal atresia and maybe having breathing problem, it's blue. And the only way the child is going to survive is by crying, but because they are obligatory nasal breathers, they don't know how to breathe from mouth. They will cry in response to hypoxia, and that cry will make the air ingested or inhaled, and hence the child will be alive. If you seal the child's mouth or stick something into his mouth and he's not able to cry, trust me, he will die. So your airway starts from nose, so something like choanal atresia or a severe Pierre-Robin malformation, which leads to falling of the tongue and severe airway blockage, and then ultimately, various kind of other laryngeal webs and stuff like that. And down below, RDS, meconium, pneumonia, etc. And lastly, the pneumothorax should not be missed at any given time. So the entire thing has to be kept in mind. Cardiac has to be kept in mind. If everything is ruled out, PPHN can be a diagnosis. So we differentiate clinically. Now, we will not do echo just now. First, we want a clinical approach to this hypoxic infant. And one of the most important things, just by looking at the baby on the cot, that is the baby in distress or not. So distress is not just tachypnea, we know it. So it has to be tachypnea with intercostal, subcostal retractions, use of axillary muscles, nasal pharynx, stuff like that. So if the baby is comfortably breathing, but is just tachypnic, it could be cardiac. It is never pulmonary parenchymal or pulmonary cavity. The lability to saturation. So you touch the baby or you put a cannula or do some procedure, suctioning of the mouth or nose, and the lability, meaning the kind of fluctuation that you see in the saturation, is way more in PPHN. All right. That is because when we give a painful stimulus, we stimulate the sympathetic pathway, and sympathetic pathway has a negative effect on pulmonary. So it causes pulmonary constriction and not dilatation. So hence the desaturation will be too much. You must all be knowing that a child with PPHN, when you do the suctioning and everything, a stabilized patient from 95% saturation will come down to 65 and will take half an hour to reach back to 95. That's how difficult it is. Differential saturation. So preductal and postductal, I would encourage all postgraduates to inculcate this habit of looking at preductal, postductal saturation in all newborns, not even those who are, admitted in ICU. For sure, you will do that. But even nowadays, it is a compulsory mandate that you do preductal, postductal saturation in all newborns, even if it's normal, no breathing efforts problem or any oxygenation issues. Even in those, this is one of the simplest tool to screen patients with congenital cyanotic heart disease. Response to supplemental oxygen. If oxygen is given and the child improves, it has to be either a pulmonary parenchymal or a PPHN. It cannot be cardiac. The cardiac problem, because of mixing of blood or aberrant placement of arteries and veins, will not respond to supplemental oxygen. Air entry, transillumination, do not forget the teachings of that we got as a resident. Hyperoxia test, we don't do it, but then that's the hallmark. Chest X-ray, ECG, and echo. So these are the ways you can differentiate. In the X-ray, lungs, so suppose you got to know that it's a lung cause and you know the treatment. I don't need to teach you. In RDS, you need some pressures in the form of CPAP, non-invasive ventilation, plus minus surfactant if need be. In the cardiac cases, you would require a pediatric cardiologist, and based on the diagnosis, you will have your treatment line decided. In PPHN, also, we need first a confirmation by echo, and then we can look after the first things first. So first thing first means TABC, temperature, airway, breathing, circulation. So you look after those. And as I said, PGE1 infusion comes very handy and should be used unless you are waiting for your pediatric echo assessment bedside done. Do not let the child go hypoxic thinking that it is not cardiac. One of the biggest mistake I've seen some of the residents do is that, sir, there is no murmur. Presence of murmur or any cardiac sign is not something that rules out congenital heart disease. Most bad problems or congenital lesions are actually silent. they don't produce any murmur. Let's focus on the PPHN. So we'll go through the definition, fetal circulation, pathophysiology and stuff. So how I define normally is disruption of the normal postnatal fall in PVR, resulting in sustained high PVR and severe hypoxemia. The incidence may not look to you very, very big. It's 0.1 to 0.2%. But then depending on the kind of an ICU that you deal with, if you get referral patients, then in our centers, like when I used to work in Calcutta, we were the referral center for PPHN cases. It used to be 10%, 5 to 10%, because the kind of cases that we get. Mortality is quite significant, 4 to 33%, depending again on the type of an ICU you have and the facilities you have. Most common in the term or post-term infants or late preterms even. We all know about the fetal circulation. It's a two different loops. And after birth, you expect the PVR to fall and SVR, systemic venous resistance, to rise. Of note here, it's a very interesting finding. If you see at the bottom, so as the weeks of the gestation progress, your SVR increases, your PVR increases also, is at peak at around birth. So there is a sudden increase in PVR in late preterm and term patients. And that is why PPHN is more common in late preterm and term infants. So we always wondered why. We also wondered why cesarean cases have got more chances of, temporary elevated PAH, and that's there. So if you see, the PVR takes time to fall in cesarean delivery compared to vaginal delivery. So it's all related to the kind of catecholamines you release and stuff. So this is an important diagram. We know the biology of pulmonary vasculature, and that has got the known vasoconstrictions and vasodilators. So among the vasoconstrictors, I want you to focus on hypoxia. So low oxygen. Oxygen is one of the best pulmonary vasodilator. You just keep the baby well saturated for 24 hours. If the baby is not having severe PPHN, less than 5 OI, will get better just with some oxygen. Don't disturb. Don't screw up the case further. Endothelin 1, thromboxane and leukotrienes are vasoconstrictors. Among vasodilators, we have prostaglandins, prostacyclin, nitric oxide, cyclic GMP, cyclic AMP, and oxygen again. So this is my favorite diagram from physiology. So up above is the endothelial cell. So the lumen is absolutely at the top. So vascular lumen, the endothelium, and this is the muscle cell, the smooth muscle cell. And you can see the three basically pathways. There are three pathways that work to keep a balance between pulmonary vasodilator and pulmonary vasoconstrictor. One is the nitric oxide path, the other is the prostacyclin path, and third one is the endothelin part. So these three paths, if you know, you will know the management of PPHN right here. So if you can see, do we have a pointer here? Sorry, no. So so if you see, this depicts the entire pathophysiology, the treatment line of PPHN. This is where the lumen of the vessel is, pulmonary vessel. Firstly, you will get the endothelium cell, and then you have the muscle. Now, the nitric oxide is produced internally. It is endogenous nitric oxide. We are not talking about nitric oxide given from outside, which is exogenous. So in utero, we do produce nitric oxide. Nature has kept every system in place. It's just that sometimes the babies are unlucky to have some messing up, or sometimes we mess up. But then nitric oxide is synthesized by nitric oxide synthetase, which is derived from endothelium, hence ENOS. And that's, makes nitric oxide and releases and takes it to the smooth muscle cell, where there is a mechanism of, guanylate cyclase, which forms cyclic GMP. So in short, cyclic GMP and cyclic AMP are vasodilators. So more cyclic AMP and more cyclic GMP in the muscle, it will relax. There are two enzymes, phosphodiesterase 5 inhibitor and phosphodiesterase 3 inhibitor. These two tend to destroy cyclic AMP and GMP. So जैसे हम बोलते हैं दुश्मन का दुश्मन दोस्त होता है. So if this is our enemy, इसका enemy is sildenafil and इसका enemy is milrinone. So PGE5 inhibitor, PGE3 inhibitor, and over here you have prostacyclin path, nitric oxide, endothelin is another chemical that is released by the endothelium, and this has also got some properties regarding vasodilatation. So in here you will get all kinds of treatment. So you have bosentan, you have prostacyclin, alprostadil, which is PGE1 I was telling you about, and milrinone and sildenafil, and oxygen nitric oxide. So all the black boxes are your treatment, and this is it. This in itself tells you the pathophysiology, the treatment, and all in one diagrammatic presentation. We'll skip some of the slides. So PPHN has to happen by three mechanisms. One is endogenous vasodilators are less, nitric oxide or PGI2, or more vasoconstrictors can be there. Or sometimes, rarely, there can be abnormal remodeling of pulmonary vasculature. And these are the cases where whatever you do, come what you do, like alveolar capillary dysplasia, ACDs. I was lucky to see a couple of cases in Canada. And when we did post-mortem biopsy of the lungs, then we could confirm the diagnosis of ACD. And we tried everything, prostacyclin infusion, everything, nitric to pehle hi ho jata hai wahan pe use. We could not save. And those are the situations which are non-responders. Failure to achieve severe hypoxemia. Don't forget, so we'll quickly go through the etiologies, and because of short, so top three causes in ICU. You have meconium aspiration, pneumonia, and third is idiopathic. We don't know the cause. There are two more causes. RDS very seldom does it, and there may be other causes. But remember, meconium, pneumonia, and idiopathic, when to suspect, I told you, cyanosis, presence of risk factors, labile saturation, and disproportionate hypoxemia. Now, this is important. In maternal history, you do take history of intake of antidepressants, SSRIs in mother, NSAID. Suppose the mother is having rheumatoid arthritis, has been on NSAID for a prolonged period of time. You need to know that, because you will be able to prepare yourself for a child who can potentially have problems with saturation. If the mother was smoking, which is very common now in India also, in Western world, though it is very common. Obesity is another thing which is very common. Asthma, its association is not conclusive yet. And last but not the least, LSCS delivery. So this is something that I hope our obstetric colleagues would have taken a note of that. In neonatal black people, late preterm and term more than preterm, and I told you why. And SGA more than LGA, and which is more than AGA. Now, diagnosis, we have already discussed pulse oximetry, more than 10% of gradient between pre and post-ductal. So pre-ductal is always the right hand, and any of the limbs is post-ductal. Left hand can be pre-ductal, post-ductal. So we don't believe left hand. We believe right hand, which is always pre-ductal. So I expect postgraduates to inculcate this habit of checking the right hand and the right leg. And in the ABG, if there is a difference between 5-15%. So pre-ductal, post-ductal differentiation of 10% and PaO2 differentiation of 15% suggests PPHN. But then these are applicable to cases where there is a shunting at the level of duct. If there is a shunting at the level of atria, then this will not be seen. Hyperoxia, although is told to be gold standard, but we don't do, because if the child is not requiring so much of oxygen, why will we keep the child on 100% oxygen for 10 minutes? What if a child is given 10 minutes 100% oxygen and the PO2 is 350, and then we are guilty of giving so much of oxygen at the end? Just for the diagnosis purpose, we will not harm the child. So the best is to do an echo bedside. Sir. Thank you, sir. So differential diagnosis, as I said, in such hypoxic baby would be cardiac and severe PPHN. Yes, murmur can be a sign, but then you need weak pulses, cardiomegaly, pulse differential. So we talked about saturation differential, but there is a pulse difference between the two, upper limb and lower limb, and BP difference. Then there could be a possibility of having a cardiac problem. How does X-ray help? X-ray will help about the parenchymal disease and also the size of heart and many things you can see on the X-ray as well. Sometimes it will give you a clue to the primary cause. Like you have a diaphragmatic hernia, and you can see on the X-ray that tells you that sometimes it can lead to. You have RDS, you have meconium aspiration, and all those things. So these are X-rays where you can see the typical black lung PPHN, which is absolutely black lungs. Lungs are perfectly fine. Still you have PPHN. So which means it's idiopathic. This is typical mass. Then you have CDH, where you can see the left side of cavity is occupied by loops, bowel loops. And this is TTNB, which is pretty simple and recovers. So point of care echo is very important. That's a gold standard. Echo is gold standard just not to diagnose PPH, but also to rule out congenital cyanotic heart disease. It tells you about the shunt. It tells you about the RA and RV condition, flattening of IVA septum to the left side is a bad sign, because when the RV, the only chamber out of 4 chambers which is in distress in PPHN is actually the right ventricle. And so what will happen? Gradually it will be flat, and then it will bow towards left cavity. And the problem with left cavity is that if you have a chink like left cavity, left ventricle, I mean, your cardiac output will decrease. So, and then you will have shock on and over and above severe hypoxemia. And that's a bad combination. You don't want that. One of the philosophy that we follow in treatment of PPHN is to keep the left ventricle well inflated by bolus, by saline, by volume. And also some people use inotropes to keep the left ventricular function intact. Otherwise, if the left ventricle fails, right to वैसे भी fail किया हुआ है, is failing. Let not the left fail. Okay? So that's the very important message. Echocardiography assesses the kind of pressures that you have. Oxygen index is something that we calculated bedside, and this decides us to start nitric oxide. And this is the formula: MAP times FiO2 divided by PO2 times 100. So typically, if the OI is more than 5, we call pulmonary hypertension. More than 10 is moderate. More than 15 is severe. Some people start nitric oxide at 15 or 20, but typically book teaching or the right approach is to consider nitric oxide only when your oxygen index is more than 25. That is something I also follow. So prevention and anticipation of such cases. I told you the maternal history. And if those are the case, you prepare yourself mentally, you prepare the team, guide the team what to do and what to expect. Let's have a bed which is ventilator equipped, be ready, surfactant be ready, prostaglandin infusion be ready, and all those things. Hemodynamic support is very important because often what happens is we tend to focus so much on the ventilatory management and oxygen management, we tend to forget the hemodynamics. And the hemodynamics will actually ultimately kill the patient. So you have to focus on hemodynamics as well the general care of the case, like bundling of care, minimizing precipitating or aggravating factors, general supportive care like your calcium, sodium, potassium, glucose. Your pH should be good. Your managing and your pH is 7.1 is a difficult proposition. General supportive care is very important. And if there is evidence of sepsis, you start antibiotics. If there is evidence of RDS, you can give surfactant. There are studies to do that, which has helped in cases of RDS. Surfactant has helped the control of PPHN in a better way. So supplemental oxygen can be required, but remember oxygen radical injury, and hence you should optimize your oxygen delivery. You must have a blender. You cannot give 100% oxygen to all patients just because they need oxygen, because whether it is hypoxia or hyperoxia, both are dangerous. Similarly, very similar to hypoglycemia and hyperglycemia, both are dangerous. Ventilation. So initial choice is conventional mechanical ventilation. In no way I'm trying to say that HFO should be the first line, but then you can try conventional first. Only as a rescue mode, you can use high frequency oscillation, adequate PEEP, minimum detachment so that we don't de-recruit the lungs. So recruitment is also sometimes difficult in these patients. Suction only when necessary. Don't disturb these children. Surfactant only if necessary. Our target parameters are pH more than 7.25, PO2 50 to 70, and CO2 40 to 50. Usually in only PPHN cases, CO2 is not a problem. CO2s are actually on the lesser side. We have to make sure that CO2s don't go below 40 or 35 for sure. Otherwise, hypocarbia will happen, and that will cause cerebral vasoconstriction and onset of, periventricular decomalacia. So don't do that. And pH, don't aim for a 7.4 pH. Even 7.28, 7.3 is good enough for me. Permissive hypercarbia is allowed. High frequency is used as a rescue strategy and for alveolar recruitment. And if there is no facility for nitric oxide or ECMO, then we can look at alternative pathways. It works best if combined with nitric oxide. Sir, how much time do I have so that I can tailor accordingly? So systemic circulation, optimal cardiac support to maximize tissue oxygenation. Target MAP is 45 to 55. Volume expansion, you may have to use inotropic agents as well, but do not use too much of dopamine or epinephrine because that can increase your PVR. There are selective vasodilators, there are non-selective vasodilators, and selective we have nitric oxide and to some extent sildenafil. In non-selective, we hardly use them. We will skip many slides. Nitric oxide evidence is there. So you postgraduates must be knowing this forest plot chart where the total essence of the study is on the left side, which favors use of nitric oxide to decrease death and need for ECMO. Nitric oxide is something that we start at 20 parts per million, slowly, gradually go down. When to start? At FiO2 requirement of less than so when to start with OI of more than 25 25 of oxygen index, and when you start weaning, almost 30 to 40% may be non-responders. Rest will respond. There are side effects. It is a very expensive medication, but then if you know how to use it, you'll be able to gradually taper it off. Usually it is not required more than 48 hours and definitely not more than 5 days. There are toxicities with nitric oxide. Sildenafil is something that we have been using long term, and IV sildenafil is also available. We'll skip some of the slides very, very quickly. Milrinone is the preferred choice of inotrope if we need in such cases, and not dopamine or dobutamine, because of its unique pulmonary vasodilator effect and also the myocyte relaxation, which is called lucitropic effect. We start with the loading dose and then continue with maintenance dose. There are other pathways also which are targeted therapies. Long-term outcomes have to be followed in neurodevelopmental clinic because they can have neurodevelopment outcome. So the take-home message is failure to achieve normal fall in PVR at birth, resulting in right to left shunting across ductus arteriosus and foramen ovale, can lead to PPHN. Keep a high index of suspicion. Definitely do not start nitric oxide without doing an echocardiography. It remains a gold standard. Do the general care well, use pulmonary vasodilators judiciously, and that's it. Thank you so much. Thank you for the extra time, gentlemen. Would we take questions later? Or?
For your nice talk. Will you give some idea about the steroids in PPHN?
Steroids in PPHN. Sir,
yes.
Use of steroids in PPHN.
Yes.
Use of steroid in PPHN, sir. There is nothing that steroid will give unless you have a situation where the child is not able. It's a refractory shock, catecholamine resistant shock, where as a last resort you can give hydrocortisone C. Otherwise, I'm not aware of any helpful effect of steroid in PPHN.
And anything, your idea about the mixed therapy, the sildenafil and bosentan, over sildenafil alone or bosentan alone?
Sir, bosentan is not something which will act immediately. So sildenafil IV or oral, as the case may be, is good enough, and it acts as an adjuvant to cases which are nitric resistant. Sometimes in mild cases or moderate cases, only sildenafil will do. We don't need to use nitric all the time. Between the OI of 5 to 15, most of the times we use sildenafil only. Good oxygenation, good general care and sildenafil and some amount of ventilation will do. Only when we can't do it, then we add nitric oxide on it. Bosentan is something that I've used on patients who have had prolonged need for some vasodilator, and we discharge them on bosentan as a chronic pulmonary hypertension, not in the acute phase so much.
Before choosing, yes.
Yes, we can. In that case, we can, till the time bosentan's action comes into effect, your sildenafil will cover, because all centers will not have nitric oxide. So as I said, judicious ventilation, not overdo things, avoiding air leaks, good general care, maintain your pH, maintain your BP and sugar, calcium, and then give sildenafil and bosentan if required. If nitric oxide is not there, is good enough.
Is it necessary to do vascular reactivity?
Which test?
The vascular reactivity
Ah.
of the lungs of the neonates. So is it going to help us if we do this vascular
Sir-
reactivity test first, then choosing the drugs later on?
So these tests, so there are various variables that the pediatric cardiologist will look into the echo. But what exactly you mean vascular reactivity test in utero?
Vascular, how the vascular reacts with these drugs.
Oh, okay. With these medicines. So these are, sir, all pulmonary vasodilators. And they will, as I said in the pathophysiology pictorial presentation, that endothelin, so bosentan is an endothelin receptor antagonist. So that will increase the endothelin 1 presence in the smooth muscle. So that's how it induces pulmonary vasodilatation. And your sildenafil is a known PDE5 inhibitor, phosphodiesterase 5 inhibitor, and that's how it helps the regeneration of cyclic GMP in the smooth muscle cell. So cyclic GMP has got pulmonary vasodilatation. So dushman ka dushman dost hai, वैसे ही.
Any question from the audience?
Yeah, because we are running short of time also. Thank you very much.
Thank you so much to the chairpersons and Dr. Ashok Mittal, sir, for the beautiful presentation. And as said by Chairman Reception Committee, Dr. A.K. Jaswal, sir, it would be better if we take the questions in the lunch session. Since there's a huge array of presentations for you, I think we should do them justice. So now moving on to the next presentation, that is Muskan by Dr. Surinder Bisht from Delhi. So the speaker would be Dr. Surinder Bisht, who would be introduced by our chairpersons, ex-HOD PMCA, Chairman Reception Committee, Dr. N.P. Narayan sir, Dr. A.K. Jaswal sir, who was ex-HOD PMCH and Chairman Scientific Committee. And with them, we have Dr. Pankaj Mishra sir from CARE. So now it is over to the chairperson, sir, to introduce our speaker.
हल्का में हम जो नहीं डाली कि खाली
Very good morning to you all, and it's a wonderful moment for me to welcome and introduce Dr. Surinder Singh Bisht, who has been Secretary General of the National Neonatology Forum, Central NNF, right now, and he has been it for 2023 and 24. He has been National Treasurer in 21-22, and he has been a National Executive Board member in 19 and 20. He has been National Convener of Caring both ends of the cord IAP FOXY perinatal module and a member of IAP standard treatment guidelines, a WHO CRO master trainer in quality improvement, a technical advisor in National Quality of Care Network, national member of LAQ Laksh, that is Laksh, MOHFW and NQOCN, North India Zonal Coordinator and Regional Trainer of IAP NRP FGM project, National Trainer, Facility-Based Newborn Care NNF, and National Faculty of ONTOP by WHO SCC, AIMS, and PGIMR Chandigarh. and NNF Neonatology Quiz Master National Coordinator for 17 and 18, and many things which I think will be too much for right now. So thank you, Dr. Surinder Bist, for gracing this occasion, and Dr. AK as well, please.
Thank you, and welcome, Dr. Surinder Singh Bist. In fact, this Muskan, I think some person must not be knowing about this particular project. This is a very flagship program of Government of India, Ministry of Health. That we know that government and especially the National Health Mission is very, serious and very concerned about the quality care should be given to the all babies, right from newborn up to the 12 years of age. And for that, this initiative was started, and this has given a good results. And there has been monitoring, taking the interview of the patient attendant, taking the interview of the staff, and seeing the records and all those things. And finally, the Government of India has given giving the awards regularly for those facility centers where they are performing well. So this is, I think, this is a very, very important. I think it is a very child-friendly or patient-friendly initiative, giving the just to upliftment of the patient care in public sectors. So that's a very, very important topic, I think, and the person here is the right person to talk on this very important subject. And this program has been sponsored by your CARE, and CARE people are also sitting here. So I will request Dr. Bist to please start the deliberation.
Thank you, sir. And first of all, greetings from National Neonatology Forum. And I'm so thankful to Dr. Shravan, Dr. Jaiswal, Dr. Nigam, Dr. Lalan, Amit, Chandramohanji, everybody who has been here, who are making this program such a great success. And from Central NNF, we must congratulate you for organizing such a lavish conference in the heart of the city, and a big congratulations to you, and thanks to you for calling me here. And I must thank Care India for bringing me here for today's program. And as far as I was so happy to listen to Dr. Reddy earlier, Dr. Reddy and their team from UNICEF, who gave a very good insight on what is the status of healthcare in Bihar right now. क्या चल रहा है बिहार में? मैं अभी पिछले बार हम बहुत सारे प्रोग्राम चला रहे हैं देश के अंदर NNF की तरफ से, और मैंने डॉक्टर ललन को भी कहा था कि मेरा फोकस एरिया वुड बी, मेरा 2 साल का जो टेन्योर है 23 और 24, और इसमें मेरा फोकस एरिया शुड बी इन स्टेट्स जहाँ पे कम काम होता है. हम उन्हीं स्टेट, बेंगलोर में क्यों करें सारी ट्रेनिंग, हम दिल्ली में क्यों करें सारी ट्रेनिंग, हम ऐसी जगह क्यों करें जहाँ पे पहले लोगों को आता है. हम उन राज्यों की तरफ क्यों नहीं अपना ध्यान केंद्रित करते, जैसे कि बिहार है, उड़ीसा है, छत्तीसगढ़ है, उत्तराखंड है, हिमाचल है, जो थोड़े से नॉट सो रीच्ड, दे आर स्टिल क्वाइट अनरीच्ड. सो बाकी स्टेट्स के बारे में लोगों की राय, झारखंड में जैसे प्रोग्राम तब भी चल गए हैं, डॉक्टर राजेश हैं, और झारखंड में करें. बिहार के बारे में एक थोड़ी उदासीनता सेंट्रल लेवल पे भी है, और वो उदासीनता का कारण मैंने पूछा भाई क्यों उदासीन है. कहते हैं कि बिहार के लोगों में अभी तक वो अंदर से जागरूकता नहीं कह सकता, मैं कहता हूँ वो नीड नहीं आ रही है. अगर आप लोगों की नीड नहीं आएगी, आई वाज, जब मोना जी बोल रही थी और काफी she was trying to exhort you all and they were trying to invoke compassions and emotions among all of us, I realized कि एक नीड है जो लोकल आनी चाहिए. वो लोकल जब तक नहीं आएगी, people can only help themselves, those who want to help themselves. सो अगर आप जब तक राजी नहीं होंगे कि आप हमसे मिलके, हमारे पास बहुत तरह के प्रोग्राम्स हैं, जैसे क्वालिटी इंप्रूवमेंट प्रोग्राम अभी यूनिसेफ ने जो करा वो NNF का प्रोग्राम है. वो पोकी जो जितने भी रन चार्ट देख रहे थे हमने सारे राज्यों में करे. अब वो गांव में एक छोटे सी जगह पे लोग कर रहे हैं, आप सब लोग उसमें इन्वॉल्व होकर काम करेंगे तो बहुत तेजी से काम होगा. सो दिस इज सेड एंड दिस इज, since this is part of the Muskan quality only, तो क्वालिटी में एक और प्रोग्राम अभी हम NNF चला रहा है जो 5 राज्यों में चल रहा है, और दुर्भाग्यवश बिहार उसमें से नहीं है. तो 5 राज्यों में हम कर रहे हैं न्यूनेटल क्वालिटी इंप्रूवमेंट प्रोग्राम, जिसके अंदर FBNC, SNCU, न्यूमैप, पोकी, ऐसे सारे प्रोग्राम्स का अमालगमेशन करके 6 हफ्ते का ब्लेंडेड प्रोग्राम है। हाइब्रिड, ऑनलाइन स्किल सिखा रहे हैं, सेंटर लाइन डालना सिखा रहे हैं, अम्बिलिकल लाइन सिखा रहे हैं, CPAP दिखा रहे हैं लेटेस्ट सिमुलेशन टेक्नोलॉजी से। ऑल एक्सपर्ट्स फ्रॉम अक्रॉस द कंट्री, बट ओनली 5 राज्यों में कर रहे हैं हम। बिहार उसमें नहीं है, जबकि बिहार होना चाहिए था। ठीक है, तो अगर आप लोग राजी हैं, अगर हम दूसरे चरण में ये काम करें, तो क्या बिहार इसके लिए राजी होगा? क्या बिहार में उस तरह की पार्टिसिपेशन होगा? बिकॉज हम सिर्फ प्रोग्राम बना सकते हैं, प्रोग्राम तो लोगों तक पहुंचाने का काम आपको करना है। और नहीं सर, बिहार सरकार नहीं कर रहे, बाकी 5 राज्यों में भी सरकार नहीं कर रही है, लोग खुद कर रहे हैं। NNF कर रहा है, पांचों राज्यों में भी। सरकारी नहीं है ये, पार्टिसिपेशन करते हैं, पैसा देते हैं और खुद सीख रहे हैं। तो इसी तरह का एक प्रोग्राम है। तो ये मैं आपको NNF की तरफ से कुछ जो संदेश थे वो मैं देना चाह रहा था। एक और संदेश था, आप अपने इतना अच्छा न्योकॉन कर रहे हैं, बिहार से थोड़े मेंबरशिप आप बढ़ा सकते हैं। हमने पेडिकॉन के टाइम पे ऐसा रखा था कि जो पेडिकॉन के टाइम पे मेंबरशिप बनेगा, अगर 8 लोग बन रहे हैं तो 7,500 में बन सकते हैं, 10,000 की बिना पे। और अगर सिंगल मेंबर बनना चाह रहे हैं तो वो 8,500 में बन सकता था पेडिकॉन में। ऐसे ही कुछ होगा अगर नेशनल न्यूकॉन होगा जब, तब भी इस तरह का हम मेंबरशिप ड्राइव शायद निकालेंगे। अभी मैं नहीं कह सकता क्योंकि उसके लिए तो EB से परमिशन लेनी पड़ेगी, बट आई होप वी कैन गेट थ्रू दैट ऑल्सो। सो प्लीज हैव मोर यंगर पार्टिसिपेशन, मोर यंगर दिस। एंड सॉरी, मैं डॉक्टर निगम प्रसाद, अभी तो मैं कह सकता हूं कि मैंने सर के लिए कैंपेनिंग करी थी जब सर प्रेसिडेंट बन रहे थे यहाँ पे, और क्योंकि वो इलेक्शन तो उसका रिजल्ट भी कब का खत्म हो गया, वो प्रेसिडेंट भी खत्म हो गए हैं, वो प्रेसिडेंट भी जा चुके हैं अब। तो अभी तो मैं कह सकता हूं कि मैंने सर के लिए कैंपेनिंग करी थी, और हम चाहते थे कि बिहार से भी NNF का प्रेसिडेंट बने। तो ऐसा एक संभावना आप आने वाले भविष्य में भी देख सकते हैं, अगर ऐसा कोई है जो NNF की बागडोर संभाल सकता है यहाँ से। Good. So with those words, I will just rush through, and I think Jaiswal ji has just said something about Muskan. This is, and I'm happy that some of government of Bihar का एक प्रोग्राम हुआ था पिछले महीने, पिछले से 1-2 महीने पहले, जिसमें मैंने मुस्कान के बारे में बात किया था, और पूरे बिहार के अलग अलग जिलों से डॉक्टर और नर्सेज ने पार्टिसिपेट किया था, और मुस्कान में सर्टिफिकेशन के लिए उन्होंने काम किया था। ये एक क्योंकि अब पब्लिक हेल्थ फैसिलिटीज में सुविधाएं बढ़ रही हैं, उनमें OPD केयर भी बढ़ गई है, उनमें इंडोर जो केयर थी वो भी आप देख सकते हैं कि 2014 के बनस्पत 2017-18 में the public health hospitals even in OPD and for IPD has increased. And out of pocket expenditure, एक गरीब के जेब से अगर पैसा निकलता है, सरकारी व्यवस्था सब कुछ है, और सारे व्यवस्था होने के बावजूद भी अगर मरीज को अपने जेब से पैसा देना पड़ रहा है, तो वो अच्छी बात नहीं है। और आप देख सकते हैं क्योंकि कुछ कार्य किए गए थे, जैसे नेशनल हेल्थ प्रोग्राम बना गए हैं, फ्री ड्रग सर्विसेज हैं, फ्री डायग्नोस्टिक सर्विसेज हैं, नाउ दे आर मोर स्टाफ कंपेयर्ड टू व्हाट दे वर अर्लियर, पोस्टेड इन डिफरेंट डिस्ट्रिक्ट्स, देयर आर HRs एंड आशास which are there, and there is a good 102, 108 अलग अलग राज्यों में अलग से ट्रांसपोर्ट प्रोवाइड कर रही है, रेफरल सर्विसेज है, एंड देयर आर स्पेशल फोकस ऑन improving the quality by certification and accreditation like कायाकल्प, लक्ष्य, एनक्वास। जो मेरा अस्पताल, वैसे यहाँ पे सरकारी अस्पतालों में काम करने वाले डॉक्टर की संख्या कितनी है? अगर मैं नॉट बैड, मेडिकल कॉलेज वाले भी सरकारी होते हैं, वो भी खड़े कर सकते हैं हाथ, ठीक है ठीक है। सो आते हैं, सो गुड। सो एटलीस्ट सरकारी अस्पताल में जो मरीज आए उसकी जेब से तो एक भी पैसा नहीं निकलना चाहिए। तो ये आउट ऑफ पॉकेट एक्सपेंडिचर हैज सर्टेनली डिक्रीज्ड, almost 30% it has decreased over the years, and that is a major intervention which has happened. आपने ये सुन चुके हैं कि देश जब 1990 में था, मैं पूरे देश की बात बता रहा हूं, तो हमारी IMR अंडर 5 ये 126 थी अंडर 5 मोर्टेलिटी, एंड और 93 वाज दी वर्ल्ड की, और अब ऐसा है कि हमारी जो अंडर 5 मोर्टेलिटी रेट है वो 35 है और विश्व की 37 है। तो पहले हम विश्व में सबसे ज्यादा बच्चे जो मरते थे 5 साल से कम, हम उसको कंट्रीब्यूट करते थे। जैसे डॉक्टर चंद्रमोहन इस बात से बड़े नाराज थे कि बिहार अभी भी देश की IMR को, NMR को, अंडर 5 मोर्टेलिटी रेट को नीचे की तरफ ला रहा है, नहीं करने दे रहा है। तो इसी तरह से पहले पूरा भारत यही करता था, बट भारत ने दिखा दिया है कि वी हैव नाउ 72% डिक्लाइन ओवर दीज एरियाज। एंड अभी अगर SRS 2019 की बात देखें तो 8 राज्यों ने, एंड आई होप इन हिंदी इज ओके विद मैनी ऑफ यू, दैट्स फाइन ना, क्योंकि मेरा अंग्रेजी में थोड़ा हाथ तंग है, ठीक है। So 8 states have already attained sustainable developmental goals of under 5 mortality, like Kerala, Tamil Nadu, Delhi. If you can see, Kerala is ये 9 पुराना है, अब 6 के आसपास है, and Tamil Nadu is 16. Delhi has now come down to 9 or something. डॉक्टर लल्लन दिल्ली सरकार में काम करते हैं, और डॉक्टर लल्लन हमें जो बताया लास्ट मीटिंग में आपने कि ये 10 से कम हो चुका है। महाराष्ट्र इज ऑल्सो कमिंग डाउन, and this was certainly 2019 only, and they have already met those, ठीक है। and here जो यूनिसेफ की मैडम थी, प्रीति मैडम थी, जो सेकंड जिन्होंने बोला था, तो she was talking about avertable deaths, preventable deaths. So in India almost 14, you can see 15 lakh deaths can be prevented by doing some public health interventions, whereas these are deaths which are amenable to healthcare. That means if a person or a patient comes to a hospital, then he can be saved. He has to reach to a hospital. ठीक है। So that means तकरीबन आप 25 लाख 24 लाख के करीब ऐसे डेथ्स हैं जो बचाई जा सकती हैं, ठीक है। उनमें से अगर आप देखें पुअर क्वालिटी डेथ्स एंड डेथ ड्यू टू नॉन यूटिलाइजेशन, कई लोग हेल्थ पे आ ही नहीं पाए, वो अस्पताल पहुंच ही नहीं पाए, टाइम से नहीं पहुंचे, घर का रास्ता नहीं मिला, अस्पताल था नहीं, अस्पताल में कोई सर्विसेज नहीं थी। इफ दैट इज द केस, 8 लाख के करीब, 8.5 लाख के करीब डेथ्स हैं, जिसके लिए आपको इंफ्रास्ट्रक्चर डेवलप करना है, जिसके लिए आपको डॉक्टर और नर्सेज पोस्ट करने हैं, जिसके लिए आपको एक सुविधा ट्रांसपोर्ट की प्रोवाइड करनी है, उसके लिए आप 8.5 करेंगे। लुक एट दिस, 16 लाख डेथ, अस्पताल है, डॉक्टर है, नर्स है, सब कुछ है, फिर भी मर रहे हैं। And this is because of poor quality of services provided by at these places. तो क्या हम अपनी जो हमारी क्वालिटी है, ठीक है, उसको हम कैसे बेहतर कर सकते हैं, वो इंपॉर्टेंट है। अभी आप दिस इज ये सारे वैल्यूज आपको एक्चुअली बिहार के संदर्भ में डॉक्टर रेड्डी ने बताई दिए कि कितने आपके पास SNCUs हैं, आपके शायद 43 SNCUs हैं, कितने NBSUs हैं। हमारा टोटल बर्थ कोहॉर्ट इंडिया का 2.7 करोड़ का है, एंड इंडिया में 88 ऑलमोस्ट 90% इंस्टीट्यूशनल डिलीवरीज हो रही हैं, 76% इम्यूनाइजेशन कवरेज। दिस इज समथिंग व्हिच इज आई थिंक वी नो अबाउट इट, एंड डॉक्टर रेड्डी हैज ऑलरेडी सेड सो। Why do you need to have quality of care? And quality is something not which is quality आएगा तो बिहार में क्या क्वालिटी है, ऐसा नहीं होता है, ठीक है। डॉक्टर अशोक भी आ गए, सॉरी नमस्कार। सो बिहार, सो क्वालिटी का मतलब, सब क्वालिटी के चैंपियन डॉक्टर अशोक बैठे हैं सर यहाँ पे। मैंने जैसे क्वालिटी बोला और आप सामने खड़े थे सर, ठीक है। सो क्यों क्वालिटी चाहिए, और क्वालिटी के लिए आपको बहुत बड़ा कुछ नहीं चाहिए, आपको 5 स्टार सुविधाएं नहीं चाहिए, आप जो सुविधाएं हैं उनमें क्या क्वालिटी दे रहे हैं वो इंपॉर्टेंट है, ठीक है। सो एंड पुअर क्वालिटी इज वेरी वेरी कॉमन, एंड वी आर क्वाइट सेटिस्फाइड विद दैट, वी एक्सेप्ट इट, ठीक है। तो हेल्थ सिस्टम शुड मेजर एंड रिपोर्ट व्हाट मैटर्स मोस्ट टू पीपल। स्ट्रक्चरल चेंजेस आर रिक्वायर्ड, आई डोंट से, आई डोंट मीन कि आपको कुछ नहीं, आपको बिल्डिंग टूट रही है, सब कुछ हो रहा है, फिर भी आप क्वालिटी कर लोगे, ऐसा नहीं है। कुछ जो बेसिक एम्यूनिटीज हैं अगर वो हैं, एक स्ट्रक्चर है, डॉक्टर है, नर्स है, कुछ आपके पास दवाइयों की एसेंशियल ड्रग लिस्ट है, एसेंशियल इंफ्रास्ट्रक्चर है, तब आप क्वालिटी क्यों नहीं दे पा रहे हैं, वो इंपॉर्टेंट है। सो मुस्कान इज इंश्योरिंग चाइल्ड फ्रेंडली सर्विसेज इन पब्लिक हेल्थ फैसिलिटीज। तो ये सरकारी तरीका है, और जिन और प्राइवेट के लिए NNF का हमारा एक्रेडिटेशन मेथड है, जहां हम एक्रेडिटेशन करते हैं, विच इज अगेन अ क्वालिटी मेजर्स। तो हम हर लेवल के एक्रेडिटेशन करते थे। जब तक मुस्कान नहीं था, गवर्नमेंट भी सिर्फ NNF का एक्रेडिटेशन क्राइटेरिया को यूज कर रही थी, और यूनिसेफ भी एनएनएफ के जो हमारे एक्रेडिटेशन क्राइटेरिया थे लेवल 1, लेवल 2, लेवल 3 के, उनको इस्तेमाल कर रही थी। अब सरकार ने, भारत सरकार ने अपनी सारी पब्लिक हेल्थ फैसिलिटीज के लिए ये मुस्कान क्राइटेरिया बनाया है, which was launched in 2021. It is a focused approach towards ensuring delivery of quality care to pediatric age group 0 to 12 years at public health facilities. And yes, we want to, जो माला मैडम या सॉरी मोना मैडम यहाँ कह रही थी, जो बच्चा आया है वो एक बच्चा डेथ होती है तो फैमिली को कैसा लगता है? A preventable death is a preventable death, and you need to reduce preventable mortality and morbidity among children less than 12 years of age to enhance quality of care as per ANQUAS. तो आपके अस्पतालों में एनक्वास सर्टिफिकेशन होता है, ज्यादातर डिस्ट्रिक्ट अस्पतालों का एनक्वास चल रहा है। ऐसा मुझे जब हेल्थ वालों ने मीटिंग करी थी पिछले महीने से और सब, तो मुझे पता था कि लोग एनक्वास का फॉर्म भर रहे हैं, एंड दे हैव टू एडहेयर टू एविडेंस बेस्ड प्रैक्टिसेस एंड स्टैंडर्ड ट्रीटमेंट गाइडलाइंस। फॉर्चुनेटली आफ्टर कोविड all these guidelines are easily available to everybody. Standard treatment जो flows हैं वो ICMR ने बना दिए गए हैं, NNF के अपने स्टैंडर्ड ट्रीटमेंट गाइडलाइंस हैं, हमारी क्लिनिकल प्रैक्टिस गाइडलाइंस हैं जो विश्व में सबसे नंबर 1 पे हैं, सबसे अच्छी गाइडलाइंस हैं NNF की, एंड टू प्रोवाइड चाइल्ड फ्रेंडली सर्विसेज टू न्यूबॉर्न एंड चिल्ड्रन। इसके 8 स्तंभ होते हैं, आप 8 पैरामीटर्स होते हैं, ठीक है, और ये सब हिल गया है, जिसमें सर्विसेज, provisions, rights, services, clinical, infection control, quality improvement and outcomes. थोड़ा सा हिल गया है ये स्लाइड, जब एक जगह से जाते हैं तो दूसरी। स्कोप इसका डिस्ट्रिक्ट हॉस्पिटल में भी हर लेवल के हॉस्पिटल में आपको कराना है मुस्कान सर्टिफिकेशन। बस ये है कि डिस्ट्रिक्ट हॉस्पिटल में 4 एरियाज हैं, पीडियाट्रिक ओपीडी का भी करना है, वार्ड का भी करना है, एसएनसीज का करना है और एनआरसी का करना है, न्यूट्रिशन रिहैबिलिटेशन सेंटर का करना है। और जबकि सब डिस्ट्रिक्ट हॉस्पिटल में क्योंकि एनआरसी नहीं होता है तो ओपीडी, वार्ड और एनबीएसयू का, जहां पे एसएनसीयू वहां एसएनसीयू, जहां एनबीएसयू वहां एनबीएसयू, और बाकी जगह पे आपको पीडियाट्रिक ओपीडी और एनबीएसयू, जैसे फंक्शनल सीएचयू जहां पे पीडियाट्रिक वार्ड नहीं है, एफआरयूज के अंदर और कम्युनिटी हेल्थ सेंटर्स के अंदर, वहां पे पीडियाट्रिक ओपीडी और न्यूबॉर्न स्टेबलाइजेशन यूनिट में करना है। Key interventions are certainly it should be friendly to parent and attendant. It should strengthen referral and follow-up services, provision of respectful and dignified care, protocols manage होने चाहिए, and improve indicators होने चाहिए। इनके लेवल ऑफ केयर है, कहाँ से स्टार्ट होता है? देश में सेंट्रल क्वालिटी सुपरवाइजरी कमेटी है, फिर हर राज्य में अपने एक स्टेट क्वालिटी एश्योरेंस कमेटी और यूनिट है, हर जिले के अंदर एक डिस्ट्रिक्ट क्वालिटी एश्योरेंस कमेटी एंड यूनिट बनाई जाएगी, और हर जिले के अंदर जहां पे अस्पताल है वहां पे क्वालिटी टीम और क्वालिटी सर्कल्स होंगे जो इस कार्य को आगे लेके जाएंगे। एक क्वालिटी सर्कल क्या होता है? व्हाट इज अ क्वालिटी सर्कल एंड व्हाट डज अ क्वालिटी सर्कल डू? दे कंडक्ट रेगुलर असेसमेंट। आपके पास एक मुस्कान की चेकलिस्ट है, आप लोगों में से कितनों ने मुस्कान की चेकलिस्ट देखी है? नहीं, आपने तो देखी है डॉक्टर ललन। आप सरकारी अस्पताल, 50% सरकारी अस्पताल के डॉक्टर्स हैं, आप लोगों ने मुस्कान चेकलिस्ट देखी है क्या? मुस्कान करते हैं मुस्कान करते हैं, गुड, दैट इज गुड। सो केयर इंडिया इज हियर एंड आई थिंक विच केयर इज हेल्पिंग गवर्नमेंट ऑफ बिहार इन मुस्कान सर्टिफिकेशन। So I think they have to look into it, that you first need to sensitize people about Muskan, and this is a good opportunity where I am trying to tell you about something about that. इसके अंदर एक मुस्कान चेकलिस्ट है जो 10-15 पन्ने की है, ऐसी या थोड़ी सी मोटी है, कम कर रहे हैं हम उसको भी, और छोटी सी चेकलिस्ट है। उस चेकलिस्ट को आप देखेंगे, उसके हर एरिया में क्या क्या सामान होना चाहिए, क्या क्या प्रोटोकॉल होना चाहिए, बहुत डिटेल में लिखा गया है। आप उसको देखिए, आप उसको जब देखेंगे तो आप उसको भर सकते हैं कि आप यस 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 टिक कर रहे हैं अपना, तो आप उसका असेसमेंट कर सकते हो कि आपके उस चेकलिस्ट में आप कितना आप कर पा रहे हैं कि नहीं कर पा रहे हैं। यू हैव टू कैप्चर मंथली इंडिकेटर्स हैं उसके अंदर, और कुछ टारगेट इंडिकेटर्स है। कुछ भी अगर हम कार्य कर रहे हैं तो हमें पता रहना चाहिए कि हम कार्य क्यों कर रहे हैं और उस कार्य का कुछ फर्क पड़ रहा है कि नहीं पड़ रहा है। सो देयर आर सम की परफॉर्मेंस इंडिकेटर्स which the facility has to collect after each month, and those monthly indicators will be followed up. Okay, and you have some targets. You have to need 80% this, 80% that, 90% that. So you have to have some targets which you need to, which you should aspire to attain, and which every unit can do it. You have to capture and analyze patient satisfaction. मरीज कितने आपसे संतुष्ट हैं. तो ऐसा कुछ करते हैं कई लोग यहाँ पे. पेशेंट सेटिस्फेक्शन का किसी ने भरवाए हैं फॉर्म? पेशेंट सेटिस्फेक्शन सर्वे होता है कि नहीं होता है बिहार के अंदर किसी भी अस्पताल में? नहीं होता है ना सर, बिल्कुल. तो एक और ऐप है. हाँ बिल्कुल सही है, होता है सर, बिल्कुल होता है, हम यही कह रहे हैं. तो पेशेंट सेटिस्फेक्शन सर्वेज हैं जो, हाँ बिल्कुल सही सर, हमें ऊपर ही लेके जाना है. ठीक है. सो मेरा अस्पताल एक ऐप है और मेरा अस्पताल से मरीजों का पूरे देश के सारे सरकारी संस्थाओं में, सारे सरकारी अस्पतालों के अंदर पेशेंट सेटिस्फेक्शन सर्वे और मेरा अस्पताल का आपका फीडबैक अगर 80% 85% है तब आपको एक्स्ट्रा पॉइंट मिलते हैं सर. कायाकल्प का जब आपका सर्वे होता है, कायाकल्प भी होता है यहाँ पे हर जगह, तो जो कायाकल्प का जब सर्वे होता है तब भी मेरा अस्पताल के पॉइंट्स उसमें ऐड करे जाते हैं, तभी आपको अवार्ड मिला जाता है. तो कायाकल्प के अवार्ड भी मिलते हैं यहाँ पे. ठीक है. तो कायाकल्प का सारा चलता है और स्टेट में कायाकल्प चल रहा होता है. सो दिस ऑडिट्स नीड टू बी डन. ये ऑडिट करना चाहिए आप यहाँ पे, और पॉलिसीज एंड एसओपीज बनाना है. ठीक है. तो जो पॉलिसीज एंड एसओपीज संस्थाओं ने बना रखी हैं, सेंट्रल गवर्नमेंट की है, स्टेट गवर्नमेंट की है, हेल्थ डिपार्टमेंट की पहले से पॉलिसीज बनी हुई हैं, वो होते कि नहीं होते आपके अस्पताल में. जब आपने चेकलिस्ट देख ली तो आपको ये देखना है कि आपने गैप आइडेंटिफाई किया कि नहीं किया, और उसमें कुछ क्रिटिकल सवाल हैं जो जिनके लिए जो क्रिटिकल है, जिनके लिए आपको बड़ी टीम चाहिए होगी, बड़ा काम है चाहिए होगा. आई थिंक 4-5 स्लाइड नोट करना. ठीक है. सो एंड आई विल नॉट टेक मोर टाइम सर्टेनली. ठीक है. गुड सर. मुझे सर पूरा ले लीजिए. तो ललन जी हैं सर, हमारे नुमाइंदे यही हैं आज. ठीक है. हाँ. सो नहीं टाल नहीं रहे हम, नहीं टाल रहे हैं हम, बिल्कुल कर रहे हैं. हाँ बिल्कुल सर, देखो हमारा बहुत दिली ख्वाहिश है सर इस बारे में. हाँ ठीक है. ठीक है. सिंपल नॉन क्रिटिकल गैप्स है जो एक कोई भी हॉस्पिटल, कोई भी टीम डिपार्टमेंट, भाई जैसे कि हमने देखा एक जगह पे न्यूबॉर्न जब पैदा हो रहा है तो टॉवल नहीं है या शीट नहीं है, ड्राई क्लोथ जो होना चाहिए वो नहीं था. तो वो उसके लिए बहुत ज्यादा बड़ा सामान की जरूरत है. वो एचओडी भी खरीद सकता है, अस्पताल के फंड से, किसी फंड से आ सकता है. 10-20 हजार 50 हजार रुपए के अंदर क्या सामान है, वो कोई बड़ा चीज नहीं, वो तो आ सकता है. दिस इज समथिंग नॉन क्रिटिकल विच कैन बी डन. एक पानी की सप्लाई है, भाई नल टूटा हुआ था, उसके लिए वो एक गैप जंक्शन है. आपके पास पेशेंट्स के रोल्स एंड रिस्पॉन्सिबिलिटी, राइट्स एंड रिस्पॉन्सिबिलिटी लिखा है नहीं लिखा है, उसके लिए बड़ा काम थोड़ी है. ये नॉन क्रिटिकल सिंपल जंक्शंस हैं जो आप अस्पताल से कर सकते हैं. क्रिटिकल कुछ गैप्स होते हैं जिनके लिए बहुत बड़ा स्ट्रक्चर चाहिए होता है, बड़ा फंडिंग चाहिए होती है. प्रोबब्ली दिस वुड रिक्वायर सम साइंटिफिक अप्रोच की कैसे काम किया जाएगा. एंड इन द एंड हर अस्पताल को जो ये फॉर्म भरेगा उसको अपने मंथली टारगेट्स देखने हैं, मंथली मीटिंग करनी है कि हमारे क्या क्या गैप्स हैं, और उनको गैप्स को बंद करना है, वो गैप्स को क्लोज करना है. एंड देन यू हैव टू गो फॉर मुस्कान सर्टिफिकेशन. फिर आपकी जो मुस्कान की स्टेट लेवल टीम है, वो पहले तो आप अपने अस्पताल में जो आपने टीम बनाई क्वालिटी सर्कल, उसे देख लिया कि भाई हमारे तो इतने नंबर आ रहे हैं, हमें लाने हैं 70%, 70% टू क्वालिफाई. अब आपने सेल्फ असेसमेंट करा, आपके आए हैं 50-60%. यू ट्राई टू क्लोज दोस गैप्स. 100% नहीं हम कह रहे हैं, हम ये नहीं कह रहे कि आप पूरा सब कुछ कर पाएंगे, आप सारे दीवार पोत देंगे, एकदम एसी कर देंगे, ऐसा नहीं कह रहे. वो संभव भी नहीं है. 70% इज गुड, और 70% में बहुत सारे काम हो जाते हैं. हर अस्पताल जो अभी काम कर रहा है वो 60-70% के आसपास ही होगा. ठीक है. मैं मान के चल रहा हूं जो भी अस्पताल, सरकारी अस्पताल काम कर रहा है वो 50 to 70 के बीच में ही काम कर रहा होगा. उसको 70 से जरा सा ऊपर जाना है और वो सर्टिफिकेट के लिए एलिजिबल हो जाएगा. सो यू हैव टू, दिस आई हैव टोल्ड ऑलरेडी, यू हैव टू बेसलाइन इंडिकेटर्स, कीप गैप्स करने हैं, ऑब्जेक्टिव्स करने हैं, एंड यू हैव, जैसे बताया था, यू हैव टू डेवलप द चेंज आइडिया. वो हम बदलाव, वो सुधार कैसे ला सकते हैं, उसके लिए आपको एक चेंज आइडिया चाहिए. उसके लिए आपको जो क्वालिटी इंप्रूवमेंट के लिए है, PDSA, PDCA, यू हैव टू प्लान दैट वर्क. वो इंप्रूवमेंट प्लान, सुधार लाने के लिए आपको क्या करना है, कुछ प्लानिंग करनी है. फिर उसको देख रहे हैं, वो प्लान करने से काम नहीं चलेगा, उसको एक्ट भी करना है, वो करके देखे एक दो बार, फिर देखें वो काम कर रहा है कि नहीं कर रहा है, चेक करना है उसको। ये जो हम सुधार लाने की कोशिश कर रहे हैं, वो काम करा कि नहीं करा। जैसे अभी उन्होंने सुधार लाए थे, दिखाया जो कि इंस्टीट्यूशन जो घर पे डिलीवरी हो रही है उसको कम करने के लिए 80% से उस गांव वालों ने, पंचायत ने काम किया और पंचायत वाले उसको घटा के 0% ले आए।
Dr. Surendra, please, so we are running short of time.
ठीक है, so I think these are all which has already been told, and this is the certification. I think this is the second last only. ठीक है, आपको सर्टिफिकेशन मिलना है ये मुस्कान का, NSHRC उसके साथ, and this will go from institution to state level, from state level to national level, and then you will get this certification. So 70% आपको लाना चाहिए, and at least facility level target 75% होने चाहिए। पेरेंट्स जो सेटिस्फेक्शन लेवल है वो आपका 80% होना चाहिए, मरीज 80% संतुष्ट होना चाहिए। आई थिंक दीज आर द रोल्स एंड रिस्पॉन्सिबिलिटी। डिस्ट्रिक्ट लेवल पे क्या करना है, स्टेट लेवल पे क्या करना है, राज्य लेवल पे क्या करना है, ये आप कर सकते हैं। सो दिस इज हाउ इट विल गो फ्रॉम हियर। कैपेसिटी बिल्डिंग, इंस्टीट्यूशनल बेसलाइन असेसमेंट जो आप खुद करेंगे, गैप क्लोजर करेंगे, रेगुलर रिव्यू करेंगे, एंड देन यू विल गेट दैट सर्टिफिकेट ऑफ मुस्कान सर्टिफिकेशन। थैंक यू।
I thank you, Dr. Surendra, for your discussion on a very, very new initiative by Government of India, that Ministry of Health, and of course, this will definitely going to give result. I think Dr. SBP Singh is there. I want to share one thing, that Begusarai is the one district, and that has got certificate from NQAS, and Dr. SBP Singh from Begusarai only.
Oh, good, sir.
And an NQAS giving 15 lakhs rupees to that hospital, and that way the hospital improvement is further going on.
Very good, sir.
Our colleague from
So Begusarai is our local champion. So sir है और वो local champion, बाकी सबको कैसे फॉर्म भरा, कैसे करा, आप बताएंगे तो 2 मिनट में बन जाएगा सर, 2 मिनट में काम हो जाएगा।
Dr. Mr. Pankaj is here from CARE. I think he wants to say.
Oh, thank you, sir.
Thank you, Dr. Surendra, from bringing the quality issues right now to the health services. I will just like to highlight 1 or 2 points that you particularly brought to the notice of this audience, that the out-of-pocket expenditure has dropped down to 38%. This is a very good, but we have to aim, if a patient is basically visiting a public health facility, the out-of-pocket expenditure should be zero. So this is the aim. The other thing is that this is also to bring to your notice that Bihar is also taking initiative to improve the quality. And
I saw that.
And 16 district hospital is going for the NQAS certification in the next 6 months. And government of Bihar is also working to improve the quality services for the public health facility for the pediatric services, including SNSU, NRC, public pediatric OPD and IPD. And they have initiated the initiative for the 4 district hospital at this moment of time. And I hope that what you brought to our notice, that the 66% of the amenable deaths are basically due to the poor quality service. And I hope that this Muskan initiative and the gap identification is one of the tools that we will bring into the notice of all the pediatricians to improve the quality of the pediatric services. Thank you, sir.
And आपके पास care है यहाँ पे जो आपको care कर रहा है, ठीक है? So there is a Care India which is caring you.
In fact, state quality assurance जो ये है SQAS, इसमें और भी बड़ा लिस्ट है. But national quality NQAS जो है, that have selected some of the districts. So thank you again. Thank you, Dr. Surendra. Okay, thank you very much. So we conclude here. What this is.
Thank you, Dr. Surendra, and thank you, chairpersons, for chairing the session. I request chairperson and speaker to collect memento from the stage. Now for the next session. It is on transfusion practices. So for this we have a young dynamic neonatologist from IMS Patna, Dr. Keshav Kumar. So to chair the session, I request Dr. Professor S.A. Krishna sir, who is former HOD Patna Medical College, to come on dais. I request Dr. Professor Neelam Verma madam, who is ex-HOD Patna Medical College, to please come on dais. I request Dr. S.K. Pansari sir, and I request Dr. Neeraj Mishra, who is DM Neonatology, to please come on dais and chair the session and introduce the speaker, Dr. Keshav Pathak.
Good morning. Good morning, everybody on and off the dais. I'll introduce Dr. Keshav Pathak, a very bright pediatrician and neonatologist. At present, he is posted as Assistant Professor Neonatology in AIMS, Patna. He has done, I'm proud to say that he has done his MD from Patna Medical College when I was HOD, and he was the awarded gold medal for best candidate in the exit examination. After that, he did his DM from RML Medical College, New Delhi, and at present he is doing job for Patna, Bihar, and we are proud to say that he is associated with all of us. A very bright candidate. He is going to speak on current practices and guidelines, evidence on the evidences of practice being done in NICU and neonatal wards. Thank you. I'll hand over the mic to Professor.
Thank you very much. He is going to deliver on the lecture of transfusion practices. What are the new guidelines and things? Transfusion practices, transfusion is very, very important in the neonatal period, and how we will do it, he will explain that. Thank you very much.
Thank you, ma'am, and thank you, sir. Very warm good evening to everyone. First of all, I would like to thank NNF Bihar, who gave me opportunity to share some academic things on this platform, especially in front of my teachers, where I can say I learned ABCD of pediatrics and many things. So today I will discuss the transfusion practices in NICU. So before I proceed, first I will discuss a just brief overview of separation of different blood components from whole blood. That is because nowadays different blood components are being transfused in NICU. So first of all, from whole blood first undergoes slow centrifugation to convert it into packed RBC and platelet-rich plasma. Once whole blood is separated into packed RBC and platelet-rich plasma, it again goes into high-speed centrifugation, where it again divided into 1 units of random donor platelet as well as 1 units of fresh frozen plasma. Again, when you thaw the fresh frozen plasma, it ultimately precipitates the plasma protein, and ultimately cryoprecipitate is generated. So basically, this is overview of separation of different blood components and how blood components are being prepared in the blood bank. The next thing is why we are here discussing the transfusion practices. So basically, when we see the neonates in whom transfusion is being given, the neonates, the group of neonates who are most prone for transfusion are the extreme low birth weight neonate. Why it is so? So basically, first of thing, they have prolonged NICU stay, as well as since they have other associated comorbidities who make them prone for transfusion. So according to one study that was conducted in that is published in Seminar in Fetal and Neonatal Medicine, approximate 50% of ELBW require transfusion during NICU stay. So definitely we are doing transfusion in our NICU, and these transfusions has many benefits. But besides benefits of transfusions, there are several concerns related to transfusions. What are those concerns? Besides benefit, transfusion also prone or put these babies at risk of transfusion related infections, as well as some of the extreme preterms baby in which usually we do transfusions are predisposed to very devastated complications like as graft versus host disease. So later on we will see that definitely transfusion is having benefits, but it is not without any complication. It is not without complications. Babies can have complications during transfusions. So one should have a strict guidelines as well as evidence-based transfusion guidelines. So here first I will discuss the PRBC transfusion. Regarding PRBC transfusions, there are multiple aspects of PRBC transfusions for which evidence-based guidelines must be addressed. So for next 4 to 5 slides, I will discuss what should be the ideal right choice for PRBC. Next is what should be the optimal threshold for PRBC transfusion. That is when we have to transfuse the PRBC, packed red blood cell. Next is what should be the ideal volume for PRBC transfusion. Next is what should be the age of PRBC transfusion, that whether we should transfuse with fresh RBC or the old RBC. Next is what is the role of irradiation and leukoreduction in PRBC transfusion. Then we'll discuss what should be the ideal transfusion rate, and then optimal target hemoglobin, that is during transfusion up to which or what extent we should target the hemoglobin level. So first of all, the PRBC selection, that is right choice of PRBC. Obviously, the PRBC which is being transfused to the baby should be ideally ABO and RH compatible. Basically, units that are ABO compatible with both mother and baby must be selected. If you are going for exchange transfusion or most neonatal top-up transfusion, you can use O negative red cells. Since LBW's babies or preterm babies have multiple needs of transfusion, so it is better to use the pedi packs. That is, from one large pack, you can prepare the 4 to 5 small packs, and each time the baby requires transfusion, you can give the transfusion. What is the advantage? So basically it minimizes donor exposure, which can predispose them to alloimmunization. There are some circumstances or in day-to-day practice when the mother is not accompanying the baby in our NICU. And in that conditions, if the mother's maternal sample is not available, it is acceptable to cross-match antigen negative units against the infant plasma. So again, next is what should be the ideal threshold for neonatal transfusion. That is, it is very necessary to decide who are the babies in which we have to transfuse the PRBC. So definitely we have discussed that definitely PRBC is having benefits. During PRBC transfusion, basically we are increasing the circulatory hemoglobin. And as we know that most of the oxygen is bound to the hemoglobin, which is being transferred, goes to the at cellular level. So basically transfusion improves tissue oxygenation and prevents hypoxia to various organs. As well as by providing transfusion, we reduce cardiac output to maintain the same level of oxygenation, and which provides less stress to neonatal heart. Definitely, these are benefits, but as I have discussed that not all benefits comes without risk. So we have to always weigh the pros and cons of transfusion, and there are also risks associated with transfusion. That is, during transfusion, you are providing blood to the baby, which can have maternal cross-reacting antibodies, and these antibodies can cause various transfusion reactions, as well as the extreme preterms or the preterms baby in which we are giving transfusion. As we know that they have poor immunity and they are susceptible to infection, especially transfusion related infections like a CMV. Next is babies who receive transfusion, especially preterm babies, can have graft versus host disease. That is a immunological complications which occurs when the lymphocytes in the blood goes inside the baby and induce the graft versus host disease. Even babies can require multiple blood transfusions, and due to exposure to multiple donors, they can have alloimmunization risk. So definitely we should have a clear-cut guidelines as well as clear-cut vision that in whom babies we have to transfuse the PRBC. So if you talk about some of the evidence, that is from 2005 to 2020, multiple RCTs have been conducted, and from 2005 and 2006, 2 landmark trials were conducted. That was University of Iowa trial and the PIN trial. Basically, despite conduction of these two trials, which was having also lower sample size, one of the trial was having 100 babies and another was 451 babies. They basically conducted the trials with formation of two groups. One group was called as restrictive transfusion group and another group was called as liberal transfusion group. In restrictive transfusion group, PRBC transfusion was planned at lower hemoglobin threshold, whereas in liberal transfusion group, PRBC transfusion was conducted at higher hemoglobin threshold. And the outcome, according to based on outcomes, definite conclusion was not made because some of the outcomes favored the liberal transfusion groups, whereas some of the remote outcomes favor the restrictive transfusion groups. So again, in year 2020, to solve these issues, again landmark trials, that was ITNOS trial and TOP trial, was published in JAMA 2020 and the NEGM 2020. And definitely this was very well planned RCT. They have large sample size and the outcomes that was studied, that was the death and neurodevelopmental impairment. And in this trial, the conclusion was made that there was no difference in the death or neurodevelopmental impairment between the restrictive group versus the liberal group. Based on this, even NNF as well as British Society of Hematology 2016 both recommends that in preterm neonates, we must follow the restrictive transfusion group, and this is a strong recommendation. Again, British Society of Hematology as well as NNF Clinical Practice Guidelines 2020 also has given threshold for PRBC transfusion in less than 32 weeks of baby. Basically, this transfusion mainly depend upon the postnatal age and the mode of respiratory support, that is whether baby is ventilated, is on non-invasive ventilation or simple O2, or if the baby is without any respiratory supports. So if you want, one can go through these guidelines in babies less than 32 weeks for PRBC transfusion. Next, our question, issues is ideally what should be the volume of PRBC transfusion? Whether we should go for high volume, that is 20 ml per kg, or whether we should go for 10 to 15 ml per kg. Definitely, these are the basic practical scenario that we face day to day, that especially in residency, this is for resident especially, whether you should go for 20 ml per kg versus 10 to 15 ml per kg. Again, a RCT was conducted in 2016 for 10 to 15 ml per kg versus 20 ml per kg, and it found no increased risk of death with low volume transfusion. Even British Society of Hematology also recommends that transfusion volume of 15 ml per kg are generally recommended for non-bleeding neonates. Here, one thing I want to focus, this is for non-bleeding neonates, that is only those neonates who are not having no any bleeding episodes. And side by side, if you go for higher transfusions like as more than 20 ml per kg, basically these are having risk of hypervolemia, and this can put the babies on the risk of volume overload. So again, NNF Clinical Practice Guidelines is having same opinion. It recommends that neonates should have a smaller volume transfusion in the range of 10 to 15 ml per kg. Our next question is, what should be the age of PRBC for neonatal transfusion? Again, this is practical questions, whether we should go for old age RBC or fresh RBC. Basically, based on the time frame of harvesting the PRBC from donor, RBC is categorized as fresh RBC, that is less than 7 days old, or older RBC, that is more than 7 days old. But since two of the trials has been conducted, one trial was called as RAP trials, published in JAMA 2012, and again a systematic review or meta-analysis was conducted by Cochrane 2015, and they found there is no difference between the use of fresh RBC as well as the packed as well as the old RBC for the clinical outcomes. And based on this evidence, even NNF CPG recommends that neonatal units should follow the existing standard practice of blood bank. That is, the blood which was collected late should be issued from the blood bank which was collected previously. That is, older should be the first approach. That blood should be dispatched from the blood bank earlier. Definitely, this is not in the all size does not fit in all. Basically, this scenario is not for the all conditions. There are some situations where you have to use fresh PRBC. These situations are intrauterine transfusion. If you are planning for intrauterine transfusion, in this case, fresh RBC, that is less than 15 days RBC, is preferable. If you are going for large volume transfusion, what is large volume transfusion? Large volume transfusion in neonate is defined as single circulating blood volume, if you are transfusing the single circulating blood volume of neonate, that is usually 80 ml per kg in term neonate and 90 to 100 ml per kg in preterm neonates. Within 24 hours or any time, if you are replacing the 50% of total blood volume in next 3 hours, then it is called as large volume transfusion. In this condition, you have to use fresh RBC, next exchange transfusion. And if the baby is having any transfusion dependent chronic anemia, these are the conditions where the fresh RBC are recommended. Next is role of irradiation. Basically, what is the role of irradiation? During irradiation, lymphocytes are depleted, and it ultimately results in the reduction of incidence of transfusion associated graft versus host disease. But side by side, irradiation also increases potassium leakage from stored RBC and reduces the shelf life of irradiated RBC. What is practical implications? That whenever you are using irradiated blood, just after irradiation, blood should be used immediately, that is preferably within 24 hours, because it reduces the shelf life of PRBC. One thing, one message should go to the audience, that irradiation only prevents from the transfusion associated graft versus host disease. It does not prevent from transfusion transmitted CMV infections. For that, we will see what are the other methods. The most common methods of irradiation is the gamma irradiation with the dose of 20 to 25 gray. So basically, based on these recommendations, even NNF recommends, or British Society of Hematology also recommends, they have strong recommendations that irradiated packed RBC should be given in neonates. And there are certain situations where there is a definite recommendations for irradiated products. Especially, first of all, large transfusion. When you are going for intrauterine transfusion, exchange transfusion, and in transfusion in extreme preterm babies. Again, next thing is use of CMV seronegative and leukoreduction. What is the role of CMV seronegative and leukoreduction? Basically, when you use leukoreduced blood, it reduces the incidence of febrile non-hemolytic transfusion reactions. It reduces HLA illumination, as well as it reduces the incidence of transfusion related acute lung injury. Plus, by depleting the leukocytes, it also prevents the CMV transmission. So, by the use of CMV seronegative blood as well as leukoreduction, one can reduce the incidence of CMV transmission, especially in preterm babies who are more predisposed to these CMV transmitted infections, transfusion transmitted CMV infections. Even based on this, NNF-CPG as well as the British Society for Hematology 2016 recommends use of CMV seronegative component up to 44 weeks PMA. Next is what should be the ideal transfusion protocol, that is up to which age we have to use RBC. So basically one can use RBC up to the end of day 35, that is of 6 weeks. Then what should be the ideal transfusion volume? As you have discussed that usual 10 to 15 ml per kg is recommended, but definitely one can go through the formula. That is first you have to plan the what should be the target hemoglobin. That is up to which hemoglobin you have to target. And based on this, even NNF-CPG recommends that whatever with the transfusion threshold. Suppose a 28 week ka baby hai, or if this baby is having transfusion threshold of 10, then you have to target only 12. There is no so much benefit that if you will target 14, 15. So there is a clear cut recommendation that if the transfusion threshold is 10, you have to just go to maximum up to 2 beyond that transfusion threshold. And that can be calculated by the volume to be transfused. That is desired hemoglobin minus actual hemoglobin into blood volume divided by hematocrit of transfused PRBC. Next is what should be the expected increase after transfusion. So usual expected increase after transfusion is 2 to 3 gram per DL after 10 to 15 ml per kg of volume. What should be the ideal transfusion rate? It should be 5 ml per kg per hour. And what should be the transfusion rate, especially if the baby is at risk of hypervolemia, especially in cardiac failure, then one can go with less than 2 ml per kg per hour. One practical question also comes when you are giving transfusion, that when you have to do PCV, repeat PCV for seeing the hematocrit. Although there is no clear-cut consensus, but 1 or 2 of the studies, basically observational studies, have recommended that post-transfusion PCV should be repeated after 12 hours of initial transfusions. Next practical questions comes during PRBC transfusion is, whether we should use diuretics while transfusing neonates. Basically, this is a routine practice in pediatric population. That is, whenever we are going PRBC transfusion or the blood products transfusion, we use diuretics in mid or in starting of the transfusion. But definitely in neonates, the scenario is different. It has been seen that there is no effect on ventilatory or hemodynamic variables during PRBC transfusion. And since especially we are using PRBC transfusion in preterm neonates, and these preterm neonates are very prone for dyselectrolytemia as well as other side effects of diuretics, that is nephrocalcinosis and ototoxicity. So one has to always take into account the risk associated with diuretics use, and only those babies who are at risk of hypervolemia and at risk of congestive heart failure, only in these babies you can use diuretics. Otherwise, there is no role of routine use of diuretics in PRBC transfusion. Next question is whether these all are practical questions. I am just dealing here only the practical aspects of transfusions. Next question comes whether we should stop enteral feeds for prevention of transfusion associated NEC. So basically, why these questions comes? There are temporal association between the PRBC transfusion and the development of NECs. There are various observational studies who have proven that. What do you mean by temporal association? Basically, when one event is followed by the another event, we say that there is a temporality between the two events. So whenever a baby receives, especially in preterm babies, PRBC transfusion, it has been seen that there are some reported case of transfusion associated NEC with PRBC transfusion. And based on that, multiple observational studies has been conducted on it. And even in 2017, a systematic review was published by the Sanjay Patole, and it was published in Advanced Nutrition Journal. In this systematic review, although it was based on 7 observational studies, it shows there is a decreased incidence of transfusion associated NEC if you withhold feed before transfusion. Definitely, this is systematic review, but it is mainly based on the observational studies. So based on this systematic review, an NF Clinical Practice Guideline 2020 recommends that ideally enteral feed should be withheld 3 hours prior until the end of PRBC transfusion in preterm neonates. But things does not stop here. Again, in 2019, one systematic review and meta-analysis was conducted by the Cochrane, published in Cochrane database. But definitely we are having paucity of RCT on this topic. So only one RCT was included, and there was no cases of NEC was reported in that RCT. So again, Cochrane recommends that stopping feeds during transfusion cannot be recommended at this stage. So definitely we are having inadequate evidence on withholding just for 2 to 3 minutes more. Definitely conclusion is currently we are having inadequate evidence over the stopping of feeds, and in our unit we follow continuation of feeds during transfusion, and no baby has yet developed TANAC, that is transfusion associated NEC. So after all these discussions, the crux is one should always minimize blood transfusion, because blood transfusion does not comes without any risk. Also, one has to always follow the restrictive transfusion guidelines. One has always follow the procedures which can minimize the blood transfusion. That is, one can go for delayed cord clamping for more than equal to 1 minute. It has been shown to reduce the immediate need of transfusion especially in preterm and term neonates. Next is, this is a common practice. That is, the most of the causes of anemia or requirement of blood transfusion in the neonate is mainly due to phlebotomy losses. So you always try to avoid the phlebotomy losses. You can use the point of care devices by the use of capillaries, who uses even microliters of blood. And next, always try to use pedipacks. This reduces the exposure to multiple donors. Just only 2 to 3 slides regarding platelet transfusion and FFP transfusions for just clear-cut message. Just for platelet transfusions, I will only discuss what should be the ideal threshold for platelet transfusion, especially prophylactic platelet transfusions. In our clinical practice, we comes in day-to-day scenario कि baby का platelet 25,000 आ गया, उसे देना है कि नहीं, baby is not bleeding. So for this, in NEGM 2019, a Planet 2 study was conducted, and in that, especially this study, outcome of this study was to see the mortality and the episodes of major bleeding in between the low threshold group versus the high threshold group. एक ग्रुप में उन्होंने 25,000 prophylactic cutoff रखा, और another group में they kept at 50,000 counts, and they saw that even in higher threshold group, that is in those babies in which they have kept the cutoff for 50,000, there was increased death or major bleeding in higher threshold group. So based on that, an NFCPG as well as other governing bodies recommends that definitely lower transfusion threshold are safe, and you have to use only less than 25,000 platelet cutoff in neonates who are not bleeding, just for the prophylactic use. Based on again, British Society for Hematology also given recommendations when to use platelet transfusion in neonates. So prophylactically you have to use when it is less than 25,000. Next is just a few, only 1 or 2 slides. Platelet transfusion in NICU, some of the practical aspects. This is just for practical aspects. You have to always start immediately a platelet transfusion whenever it arrives in the NICU, because platelets has no any, basically the platelet, whenever you store the platelets, it don't have any things which increases the life of platelets. So you have to use always immediately. Next is you have to always use platelets in the volume of 10 ml per kg as compared to 15 to 20 ml per kg, because 10 ml per kg, the expected rise is approximately 50,000 to 1 lakh per cubic mm. And if even you use higher platelet transfusion volume, it is not beneficial, as well as it has not been shown in the study to rise the value so much. Next is just few slides regarding FFP transfusion, when to transfuse and when not to transfuse. So always you have to use FFP transfusion in clinically significant bleeding in neonates, especially prior to invasive procedures when they have abnormal coagulation parameters. You don't have to transfuse FFP in those babies which are having only abnormal coagulation parameters and baby is not bleeding. So this is clear-cut message. Transfuse FFP in those babies who are bleeding and have abnormal parameters, that is more than 1.5 times PT and APTT, and routine use of FFP for volume replacement and prevention of IVH in preterm is not recommended. Just final my slide, that is take home message. Always try to minimize blood transfusion. One should always follow the restrictive transfusion guidelines. Always use leukoreduced and irradiated cellular blood products. Use higher threshold, that is less than 25,000 should be used for prophylactic platelet transfusions. And never use FFP to correct abnormal PT and APTT in non-bleeding neonates. Thank you.
Dr. Keshav, I have 1 or 2 questions for you.
Definitely.
First of all, I would like to clarify, already has told that feeding during blood transfusion is a vital question in neonatology, and evidence are conflicting. But most of the units in India is not stopping feed during blood transfusion, most of the units.
Yes,
second thing, regarding volume, 20 ml per kg transfusion over 4 to 6 hours is quite safe. So always we should try to lower threshold and higher volume so that the antigen exposure can be minimized. I have two questions for you.
Yes, sir.
So in Planet 2 trial, what is the cause of increased mortality, and lower threshold versus liberal, restrictive versus liberal, what are the cutoff for the blood transfusion?
Sir, basically the cutoff for the blood transfusion in restrictive threshold group, basically you are asking regarding restrictive PRBC transfusion or Planet 2 trials. Oh, basically, first of all, regarding Planet 2 trials, the major cause of bleeding was the major intracranial bleeds, the whatever the babies having happening, as well as the sepsis related mortality they were having in Planet 2 trials.
Thank you, Dr. Pathak.
So thank you, Dr. Keshav, for your nice presentation. Thank you, chairpersons. Now, moving to the next session, we know that neonatal sepsis is very common. So we have a panel discussion on neonatal sepsis. So for this, I invite Dr. Kia Ghosh ma'am. She will be the moderator for this panel discussion. Ma'am is Associate Professor and NICU in charge, Institute of Child Health, Kolkata. She was Secretary, West Bengal Association of Pediatrics 2016-2017 and Secretary IAP ID Chapter 2020-21. So I welcome you, ma'am, to moderate this session. And I invite the this panelist. First of all, Dr. Professor N.P. Narayan sir, who is former HOD Patna Medical College. Dr. Professor A.K. Jaiswal sir. Sir was former HOD Patna Medical College. Dr. Shravan sir, He is President NNF Bihar. I welcome you, sir, and Dr. Rajesh, sir, who is the Director, Rani Children Hospital, Ranchi. So I welcome you all for this panel discussion, and I hand over mic to Kia ma'am to moderate the session. Thank you.
Thank you. So thank you. Good afternoon, everybody. At the outset, I would like to thank the organizing committee of the Bihar Neocon for giving me this opportunity. And my special thanks to Dr. Nigam Pinaran sir, Dr. A.K. Jaiswal sir, Dr. Shravan Kumar, and all the seniors. I'm seeing so many seniors. I would like to thank all of them. And so as we know, as everyone was telling, so it is a neonatal sepsis is the most important cause of neonatal mortality in our country. Not only in our country, in all the low and middle income countries. It is a clinical syndrome which is characterized by signs and symptoms of infections. There may be associated positive or negative bacteremia, which we do it by blood culture, which is the gold standard, but we have to remember it has a low sensitivity. So we often have a negative blood culture sepsis, neonatal sepsis, and we will quickly go through this causes for this. And their signs and symptoms may be very non-specific in neonatal sepsis, and these are very subtle and vague, or sometimes they may be specific related to various systems. So as we have a very time constraint, we were given 30 minutes, now it has been reduced to 25 minutes. So I think we will go very fast, and we will go to prototype cases where the panelists will enlighten us about how to go about the cases. So these are the cases which we see routinely. Suppose a 34-weeker with the birth weight of 1995 grams, less than 2 kg, otherwise asymptomatic, was born to a primigravida mother with a history of leaking PV for 30 hours. This is the case scenario which often you get it. The mother had a history of fever of 39 degrees and on 2 occasions immediately prior to delivery. There is no foul-smelling liquor. So with this history, the concerned resident shifts the baby to the NICU. So is it justified? And may I ask, what are the risk factors of sepsis in general and in this case especially? To Dr. A.K. Jaiswal, will you take the case?
Yes, sure. I think after your description of the case, it seems to be a case of early neonatal sepsis.
Yes.
And for that, of course, we know that there are certain risk factors and which are very, very important for giving this thing, developing this early neonatal sepsis. The first one being the low birth weight, less than 2.5 kg, and the prematurity of less than 37 weeks. Second is a febrile illness, the mother of in the degree of 37.8 degree within 2 weeks prior to the delivery of or clinical chorioamnionitis. And third being the very, very important one, that is the fall smelling liquor. And fourth is the rupture of membrane, premature rupture of membrane of duration of more than 24 hours. So these are very, very important things. And other factors are history of more than 3 vaginal examination or single unclean vaginal examination, also very important. And next one is prolonged labor, that is first and second stage of duration lasting for more than 24 hours. And next one is parental asphyxia, Apgar score less than 4 at 1 minute. These are the important factors which gives predisposed for any baby for giving developing this early neonatal sepsis.
So in this index case, we have 3 risk factors. The baby was less than 2 kg, the baby was preterm, the mother had a fever, though there was no foul smelling liquor, but there are more than 3 risk factors. So what is the further action, course of action, and when to start? Will you start antibiotic in this, Dr. Shravan Kumar? So how you would like to go?
Yes, early neonatal sepsis. There is some advancement in this, that the score calculation, and in the.
So we will take the score calculation later, okay, sir. So what you will do, sir?
We will start empiric antibiotic, but we have to do blood culture, lumbar puncture, everything should be taken care of.
So the rule is actually neonatal sepsis guidelines. There are very clear-cut guidelines of NNF and AIMS. So whenever you have 3 risk factors, even if the baby is asymptomatic, especially in a preterm baby, we do start antibiotic.
Or if you have 2 risk factors, you can do a positive septic screen. If the septic screen is positive, you should start. So 2 risk factor with a septic screen or 3 risk factor, you are going to start, especially in preterm. As I said, as an exception to the above rule, if it's a term neonate, you can wait. Some patient will, some doctors will argue that we can wait. We can wait for the onset of symptoms and do. But for preterm neonates, we have to do if you have 3 risk factors or 2 risk factors with a positive sepsis screen. So when to perform lumbar puncture? So Dr. Narayan, if you can highlight.
Yeah, I think it's a very important question. A lumbar puncture is must actually for including the whole septic screening. It is not only the blood culture, but the lumbar puncture also must be done, except in 2 situations where you can skip. That is in asymptomatic babies with maternal risk factors and preterm babies with respiratory distress and no risk factors. But other than that, in almost each and every case, you want to do a complete workup, including the lumbar puncture.
So all these have definite guidelines. Now coming to the advancement in this early onset sepsis. So we have, you have heard of this early onset sepsis calculator. So people all over the world, some of the countries are using. So do we have any role of this early onset sepsis calculator in India? And what are the new biomarkers for this sepsis? Are they more accurate than the conventional ones, Dr. Rajesh?
I would recommend reading the CPG guideline.
Yes.
We had prepared after 2 years of work. It is almost more than 100 pages document from the NNF. It is very, very clear messages there. And there is a synopsis available and there is a whole text is available. There is no role of sepsis calculator in India. We don't have any studies. Whatever studies we have is from the Western countries. And they are the best, they are based on the group B streptococcal predisposition on that group of the babies. So we don't have any role of sepsis calculated in India at all. New biomarkers, CRP we are using procalcitonin for a long time. And
do we use interleukins and others?
Interleukins I never use, and interleukins has got its own problem because it will go up. After some time, after say 48 hours, it will come down. And even if you have sepsis, it will come down. So there is a problem with the interleukin and other biomarkers like CD64. It is very difficult to do it. So all practical purposes is CRP and procalcitonin. And procalcitonin, if you go by recommendations, like if you have CPG guideline, if you have a late onset sepsis, there is no role of any biomarker in late onset sepsis. You have to send a blood culture. Preferably, you can send 2 blood cultures from 2 different sites and start on the antibiotic. But in early onset sepsis, you have a role like like you have maternal risk factor and the term baby is asymptomatic, prolonged risk factor. Then you have to send a like CRP or PCT. Then on that basis, if you have positive biomarkers, send a blood culture, start antibiotic. If you don't have positive blood biomarkers, you don't do anything. So the PCT and coming to procalcitonin over CRP, and the CPG guideline has clearly mentioned the cumulative sensitivity of PCT for blood culture proven sepsis is around 85%.
Yes.
And but CRP is only sub 70%. Sensitivity, but specificity wise, both are almost equal, 80 to 85%. PCT has a role, but still CPG says it doesn't have any role in practical practice.
So very clear cut. So no role of early onset sepsis.
I think
calculator.
CRP is better actually for ruling out the infection. And for ruling in, I don't think,
but
because
still,
there are not many other things.
But sir, like if you go to CPG guideline, it's very, very good.
Yes.
And they say, even if late onset sepsis depends upon your pre-test probability. That means what is the infection of probability in your unit. If you have low infection unit, then the ruling out is important. If you have a pre-test probability of 40%, 50%, then no use.
No use.
Okay. You assume that 40% will have infection. So start antibiotic.
Moreover, I think serial CRP has got more relevance than single observation.
That is for the monitoring. We are talking of the starting of antibiotic. Now coming quickly to a case scenario. which you will often see a 9-day-old neonate who was born at term 3.5 kg, was brought to a hospital with complaints of abdominal pain, distension and poor feeding. The baby was fed on formula on the first day and was discharged. The feeding was not well established. As we are going through this quality control, we know this is a very important. Often the babies are discharged without very good attachment to the breast, or the mothers has not been explained with the exclusive breastfeeding. So the baby was discharged on mixed feeding, and because they thought it was an inadequacy of milk. And so the baby came out with an abdominal distension. So at admission, the neonate was weighing 3.3 kg. So you can see there is a weight loss, but not that significant. But the baby was lethargic with axillary temperature of 37.8. And on further examination, abdomen was distended, but there were no gastric aspirates. So what are we dealing with, sir?
Yeah, I think with the have that first slide, please.
Yeah.
That is the case. Yeah. Yeah. This is a 9-day-old, and in fact, he is being brought up in the community, and he was fed on formula feeds. So he has enough reasons to for us to think about an infection. So I think it is a late onset sepsis.
Okay.
And here you see, can I go for the next question?
What is the most preferred antibiotic?
Yeah, so what is the most preferred antibiotic regimen? I think the most important one is that it always depends on the local organisms, data of the organisms and the antibiogram. But unfortunately, in our country and in remote sources, poor sources, I think we don't have an antibiogram or a data, but we can extrapolate from the data which is already available to us. That is the national data, and this is the BMJ data. It all says you, and you have to know about the organisms. I think for the late onset sepsis, the organisms can be actually put on an acronym, that is ESCAPE. That is, E stands for E. coli, and then you see S for Serratia, then C for Citrobacter, then A for Acinetobacter baumannii, and then P for Pseudomonas, and then E for Enterobacter, or those ones. So I think if you know these escape organisms, we have to focus our antibiotic regime onto those organisms. This must cover. And mind you that most of them are covered by the antibiotics which we use empirically. And in empirical use, I think we still are not convinced now about the ampicillin gentamicin combination or ampicillin amikacin combination. But in our, I think all across the country, now we are using either cefotaxime, amikacin, or else in very few circumstances, it is piperacillin, tazobactam, and amikacin, and very rarely where MRSA we are suspecting. That is MRSA. So there you have to actually add either vancomycin, but normally I think that is fair enough. I think piperacillin, tazobactam, and amikacin, and in community-based, I think it is good for that community-based.
So as Dr. Nigam sir was summarizing, we mostly have gram-negative organisms. Maybe now the scenario is more on the Klebsiella E. coli rather than Serratia and Citrobacter, as you were talking of. And we often get Acinetobacter in hospital-acquired infections. So, but whatever it is 60 to 65% is gram-negative. And the early onset sepsis and the late neonatal sepsis, they often have the same type of organisms. Rarely 30 to 35% may be due to gram-positive, maybe due to fungus, and often we have viral onset of sepsis also. So as I think Dr. Nigam sir was mentioning about this BMG study which came out in 2019 and in BMG, and which shows that we have a huge resistance to common organism use like AMPI, Genta, cefotaxime, ceftazidime in the common or amongst the common organisms like Klebsiella E. coli, Acinetobacter. But please see to it If it is an isolate resistant, this is for hospital setting. In community setting, still we have organisms which may be sensitive to this common organism. So there is a dilemma. The dictum is you have to form your own antibiotic policy. You always review after 6 to 12 months. You see your antibiogram, your first line antibiotic should cover 60 to 65% of the organisms, or 60 to 70%, and your second line should cover 85 to 90%. So that should be, so every unit should have their unit policy. So what factors guide you to choose the antibiotic regimen? So would you, other than the bugs we have talked
actually
about?
most of the things have already been discussed. The decision for choosing the antibiotics, of course, depend upon the what is the sensitivity pattern, what are the antibiograms in your own setup, and all these things. But recent observations have come regarding the cones. Cones is also very important as far as the late onset sepsis is concerned. Correlates your negative.
Staph aureus is the most common gram positive.
So, in the developed world, it is in the tune of 80%, but in our country, some studies have shown that it is around 35 to 40% have cons have come. So that way, we have to go for the either cloxacillin, or maybe in some cases MRSA, we have to go for the vancomycin itself.
So other than the bugs, sir, any other factors?
Other factors, of course, depend upon the any other like your any complication of sepsis or any gestational and birth weight of the babies. All these factors have got their importance, as well as your any immunocompromised babies are there. So all these things have to be taken into consideration for choosing the antibiotic. But still, the fresh case, uncomplicated, late onset sepsis coming to our setup, most of the time it is MP-Genta combination is still good enough. But of course, due to its use of broad spectrum antibiotic, that multi-drug resistant gram-negative bacilli have come a very high percentage, around 50 to 56%. They are coming. So that's why it's not wise to start with MP-Genta. And that Dr. Nigam has already mentioned. Then we go for cephalosporin, the third generation cephalosporin, along with your aminoglycoside. And sometimes we think of staph, we go for cloxacillin, and MRSA, we should go for the vancomycin. And fungal, of course, we have to use the antifungal treatment.
So along with that, we should also look for the site of infection. So if you have a central nervous system, we will go for drugs, which is CNS
that is very important.
And also sometimes for the safety profile, suppose a baby with a septic shock has come with a compromised renal thing. So you have to use drugs accordingly.
So we cannot use nephrotoxic drug in that case. And of course, CNS penetration or even the joint.
Dr. Shravan Kumaria, Dr. Rajesh, would you like to add something?
Yes, I should say that we have to do blood culture. And according to blood culture, if the MP-Genta is effective, we should use because it is not, that broad spectrum is good. Broad spectrum are weak antibiotic, I should say. They are broad they cover more and more bacteria, but they are very weak. If you are getting sensitive to even the ampicillin and gentamicin, you should use that.
So not only if we have started with, suppose we have started with a broader spectrum and the bug comes which is sensitive to ampigenta, we should downgrade. So this is, everyone has the tendency to upgrade, but we don't downgrade. This is very important, though the last point, but this is the most important. Please downgrade as per the sensitivity report.
Yes, I will add because we are discussing so many things, but we often don't do blood cultures. So please do blood cultures, and ideally 2 blood cultures from 2 different sites.
Absolutely.
Without that, all these discussions are futile. Okay.
Exactly. In the first introductory slide, I wrote it. The gold standard is blood culture, though it has a low yield. But in neonate, believe me, it has a very good yield, because in neonate, the bacteria per ml of blood is quite high. So we have a very good yield in blood culture. As contrast to pediatrics, we don't have. So in neonate, always, before starting antibiotic, do a blood culture and do a lumbar puncture.
Dr. K, I mean, conventional blood culture takes time. So regarding this backtake, even the molecular study like PCR from the blood, Nowadays, people are doing the PCR for knowing the organism sensitivity as well. So, what do you think about this?
So definitely, I think we should do the first thing first. So blood culture is, of course, the gold standard, and it is. So if I'm talking of blood, people are not in a habit of doing blood culture. I can't think of those people sending for PCR. So I would rather like to say, first have the habit of having the blood culture, and okay, if you're not getting, then of course you can think of PCR. So at what time you expect an improvement in clinical sign? And Dr. Shravan Kumar, suppose you have given us an antibiotic which is sensitive. So at what time you should think, yes, it's improving?
Your clinical judgment is more important.
Yes,
Not
sir.
like if patient is improving by look, by circulation. If baby is dull, sanos, and if the circulation is improving, baby is sucking is improving, baby is feeding is improving, that is more important.
And so when you will think that in spite of giving a sensitive antibiotic, the baby is not improving. So what are the causes you will think of? So any one of you, Dr. Rakesh, want to?
Yes, you have to wait for 2 or 3 days. Then you can improve, or you
Suppose I have given a sensitive antibiotic as per the sense, but the baby is not improving. So 2 days gone, I've got the antibiotic microbial, more or less the organism I have got, and they have given most likely this is this. So what you will go for?
You are not getting
The baby is not improving.
Blood
So,
culture is also negative.
blood culture is growing something, and you have given that sensitive antibiotic. So in spite of that, it is not growing. Or maybe the other way around, the blood culture is not showing any organism. So would you think of something else?
We have to increase antibiotic. That is empirically, but it is, we have to.
Suppose the blood culture is negative, sir.
You have to improve your blood antibiotic.
Okay, so
Let's
any
see,
other thing?
see, first of all, it may be a pus collection somewhere. That has to be ruled out.
Yes.
That is either you
Source
have
drainage. You mean to say drainage of the source?
drainage of the source.
Yes.
Source reduction is very, very important. That is, if that is quite often mistake.
Yes.
Otherwise, it may not be a sepsis. If your
It-
blood culture is sterile, it may not be a sepsis, and a whole lot of things you have listed. It may be a viral infection. It may be a
inborn error of
inborn error of metabolism.
Absolutely. We had a lovely scenario.
All
in
these things
this.
we can.
And even in this case, it can be a mixed feeding baby. It can be a CMPA also. So coming to abdominal distension with features, because sepsis signs and symptoms are very subtle. So neonates, they behave in a very stereotyped way. They will behave in the same way. So you have to think of other things other than the sepsis. So rule out IEM, CMPA, rule out congenital infection, congenital anomalies, and in some refractory cases also think of HLH. So maybe we are at a tertiary center, so we get a lot of HLH, but I think Dr. Rajesh is also getting a.
And also like immunodeficiency. Baby may be immunodeficient.
Yes.
That's why baby is not responding.
So I will tell all of you to stay back for my interesting cases where I will show all these sepsis mimickers. Okay. So case scenario 3. So we'll quickly go through it. I don't know, the time has been reduced. So it is a 3 kg born term neonate primary gravita delivered by elective LUCS. There was no important antenatal history. At 36 hours, the baby was found to be lethargic with refusal to feed. So with cold extremities, and the investigation shows a CRP of 45 with a count of 20,180, and a CSF was done, which shows 250 cells. It is a frank case of meningitis. I'm just cut-shorting it, okay? But the CSF gram stain also shows some gram-negative bacilli. So how long to give antibiotic? What antibiotic? Comment on the, should we repeat a lumbar puncture at the end, sir, Dr. Nigampina?
Yeah, I think it's a very clear-cut case of neonatal meningitis, and mind you that it is with the early onset sepsis. So the bracketed words like late onset will have meningitis and early onset will have only respiratory is just gone. In India, there is no question of that kind of tight compartment of early and late. They are blurred. So it is very simply neonatal meningitis. Here you have to give an antibiotic which really goes into the CNS. It's not that you will like to give any antibiotic which is not really penetrating the CNS. So I think cefotaxime is the one which is penetrating, and along with micacin you can give it. But of course, if it is community acquired, fine. But if it is not community acquired and you are suspecting something beyond a thing that he has already been given these antibiotics and he has come, then you have to go for a little upgrading the antibiotic. And I think in this situation, meropenem could be a better choice.
So how long? How long?
And the time period for any CNS infection treatment is at least 21 days, mind you, and all IV. There is no question of switch over to IV to IM or oral or whatever. It is all IV and 21 days.
So will you do CNS imaging in every cases?
Well, I think the important one is that the clinical follow-up is also extremely important, as well as the CNS imaging. And in CNS imaging, I think we must understand that we have to look for the ventricles, any ventricular evidence of ventriculitis, and the head size if it is in CNS wise. So we can monitor it gradually during the course of few months. It is not that you will leave the baby after the just treatment of 21 days.
And always always evaluate for the audiology and
So it is very well said, sir. Like whenever you are doing sepsis, we have to do LP because duration is at least 3 weeks. Very often I see they give 7 days antibiotic and later on baby lands up with meningitis and ventriculitis.
So one word about repeat lumbar puncture at the end or in between. So there is lots of controversy regarding this.
Yeah,
so
there is a lot of controversy, but I think if the baby has completely improved, I think we don't really go for the repeat LP. But there is some variation in this opinion.
Then if baby is not improving, we do it. Of course, we have to do it. The baby is improving
so
now.
if not improving, we do. Suppose it's a CSF culture, because there are lots of studies which showing that if the CSF culture was positive, we should do a repeat lumbar puncture.
Exactly. Then
so
you
in
must
that case, though I think there is no clear-cut guidelines regarding this, so it's not always. So very quickly, this is a baby who came on the 14th day with this type of lesions. So what are the organisms? We know the Staph streptopseudomonas. So treating omphalitis, sir, would you like to take? So will you give IV to everyone, or would you like to give?
Yes,
topical?
because this umbilical sepsis or omphalitis, it is a clear case as sepsis, not a sepsis, and because the umbilicus is directly related to the central circulation, so there is a clear-cut neonatal sepsis, and we have to treat like at least 14 days antibiotics should be given. But if
So can we switch to oral in this case if the baby improves?
if even baby improve, we have to do blood culture, and if that blood culture is negative, then we can think. But if I'm saying this picture, there is inflammation all around. There must be a sepsis, so we have to treat at least.
So if you
all IV 14 days.
Okay.
CPG guideline you go through, please. CPG guideline for NNF, go through.
So if you have
it's a very, very
redness,
clear guideline.
if you don't have a induration and redness much, and it is less than 1 centimeter, can we go for topical antibiotics?
No role of topical, no role of oral in units.
So okay. So that, and very quickly, another case. It is a case of I'm not going the case. It's a case of septic arthritis. A very maybe not in every unit, not in SNCUs, but we do get in NICUs. So which antibiotic, how long, and any role of oral antibiotic and role of imaging. So quickly, because we don't have time.
So in the case of septic arthritis in neonates, naturally we know the most common organism being the staph. So in that case, the recommendation is that, and of course some of the cases we do have the gram-negative infection also. So better to cover both. So that way, even cloxacillin with aminoglycoside, or sometimes with straight way going for the vancomycin, and this along with your cefotaxime or
so you mean to say a gram negative and a gram positive?
Yeah.
If you suspect MSSA, give cloxacillin.
Yeah.
If you suspect MRSA, give vancomycin.
Right.
It's very clear. How long, sir?
Say recommendation varies from different places, but it is most of the time they're saying it should be around 6 weeks. But I think 2+2 is also very important. That you give IV medication for 2 weeks and followed by 2 weeks of oral medication, one can switch over.
So if it is septic arthritis alone, you can give for 4 weeks. But if it is septic arthritis along with osteomyelitis, ideally you should give for 6 weeks. And switch over to oral depends upon the clinical response and also on the markers. If the CRP and the markers comes down, we will switch over.
Right.
Any role of imaging, sir? Should we do?
Very important.
Very important. Why, sir?
Yeah, very important because MRI is preferred investigation because what literature says that if you are getting finding on ultrasonography, it means it's too late. And that way the prognosis is going to be very poor. So most of the time, of course, in our office practice, we go for the ultrasonography first and then we diagnose. But of course, when you are getting finding in USG, probably it's too late. So it's better to go if the patient can afford straight way. If you are thinking clinically, of course, it's not very easy to diagnose clinically also sometimes. So we should go for straight way. Then MRI. MRI will give you the inflammatory findings and some effusions and some other changes also. And along with that, we can plan for the drainage of synovial fluid as well.
Absolutely.
So and I will add septic arthritis of hip is a special category. You have to go for arthrotomy. There is no way of
Source reduction is very important.
Knee and all you can wait. Okay, per hip you have to immediately go for arthrotomy.
Yes, and every surgeon will want an MRI to be done.
Drainage should be sent for the pus culture sensitivity, and after that also we can change the antibiotics.
So a last case, a 25-day-old baby who comes with not adequate weight gain. Clinical examination is not that remarkable, but feeding behavior was a little poor. Baby has an indirect hyperbilirubinemia with a thyroid profile was other things were normal and urine routine shows 10 WPCs per HPF. So, sir, what do you think of?
Basically, UTI, clear cut.
Okay, even if the culture becomes negative, you will think of with a neonatal jaundice, not feeding well, not gaining weight. So you think of UTI. So which antibiotic and how long, sir?
Again, mostly gram negative. Either go for, depending on local sensitivity, either peptides or meropenem, I will go. How long? 14 days at least. And depends upon the ultrasound finding. If ultrasound, some complicated UTI is there or pyonephrosis is there, then you have to prolong the antibiotic, maybe for 4 weeks minimum.
And again, the follow-up is important. I think everyone knows the guidelines. I'm just skipping. I would like to end by saying there are very important points to curb antimicrobial resistance in neonatal units. Always take cultures of blood and perhaps CSF and urine as the case may be before starting antibiotic. Please, all of you do this. Number 2, use the narrowest spectrum antibiotic. Though we have talked about giving higher antibiotics, but always start with the narrowest spectrum antibiotic possible according to the unit. The empirical choice should be made based on the maternal risk factor, clinical presentation, and of course, for the local antibiogram. And you should have a strong intention to develop a local antibiotic policies. Every unit should have a policies, and septic screen should be interpreted in relation to clinical status of the unit. Not only jump because the septic screen is positive, we have to give antibiotic. Try not to use antibiotics for long periods. Please follow the given directions. As said by all my panelists, treat sepsis, but not colonization. Very important. We don't have the time to differentiate between contaminant and colonization and the pathogenic bacteria. But please remember this, don't treat colonization. And do your best to prevent nosocomial infection by reinforcing infection control, particularly hand washing, because the sepsis-related neonatal mortality is primarily a preventable thing. So you can prevent it by early recognition, appropriate antibiotic, but the most important thing is by prevention of sepsis itself. So please do that. Thank you. And thanks to my all panelists for a wonderful discussion. The time was running very short, so I have to hurry up. Sorry for that. Sir, इतना जल्दी करना पड़ा वो.
So thank you for a very interesting interactive session. So now moving to next session, we have management of extremely low birth weight babies, and for this we have Dr. Professor Vinod Kumar Singh sir. So to chair the session, I welcome Dr. Vijay Jain sir. He's a very senior pediatrician from Gaya. Sir, please kindly come on dais. Dr. Virendra Kumar Singh sir. Sir, please come on dais. Dr. Pradeep Kumar and Dr. Arvind Ojha sir. So I request all of you to please chair the session. And I request Dr. Professor Vinod Kumar Singh sir to please come. And I request chairperson to introduce Dr. Vinod Kumar Singh sir. And before this, I have an announcement. One car BR01FW7897. It is parked there and obstructing some way. So anyone who is here having this car number, please contact the hotel personnel. Car number BR01FW7897. Please, if someone is having this car number, it is obstructing the path, please contact the hotel personnel. Thank you.
Namaskar. The speaker of this session, Dr. Vinod Kumar Singh, I don't think he needs any introduction. MBBS from Ranchi, MD from Ranchi, gold medalist. The honors each and every subject. Ex-professor and head, Department of Pediatrics, NMCH. Ex-superintendent, NMCH Hospital. The best teacher, a very good orator. And in my opinion, Dr. Vinod Kumar Singh has tips, has Nelson textbook on his tips. The master of critical care, a very good teacher, very good orator, very good postgraduate teacher and undergraduate teacher, a very popular person. And he has been the state president of NNF as well. So the time is very short. And Dr. Virendra, if you want to say something.
Namaskar. Professor Singh is going to discuss very important topic, that is management of extremely low birth weight babies. With the advent of newer techniques and advancement in neonatal care, the survival of extremely low birth weight babies, that is less than 1,000 grams, have improved, and the outcome also has improved because of the better management. He is going to discuss on this topic on various aspects, so we'll be benefited with his discussion. This word, I invite Dr. Professor Singh to say something.
This is the most tough problem for a pediatrician, to increase the weight of child from 800 grams to 2.2 or 2.5 or 2.7. Every day, the attendants come and mother come, Dr. साहब वजन तो 10 ग्राम ही बड़ा है. डॉक्टर सोचता है pediatrician 10 ग्राम तो बड़ा, डॉक्टर का वजन तो कम हो रहा है. बच्चे का तो इतना ही बढ़ेगा भाई. How can you expect that just in 7 days he will become to 1,000 gram to 2.5? So I think that Vinod Kumar Singh, the best person to tell the management of this extremely low birth weight, how they can improve.
Oh, thank you, sir, for the good words. And I must express my sense of gratitude to the NNF Bihar and the organizing committee to give me this topic to interact with our young and elder friends. So to begin with, I must say that there are many young pediatricians, neonatologists, they are doing extremely good in their ICU settings. And many of our extremely low birth weight ELBW babies are being survived by their intensive efforts. To begin with, I must suggest them that once they are making their ICUs, they make one unit of an ICU having totally dedicated to low birth weight babies, means less than 1500 grammars, or if it's possible, less than 1000 grammars should be kept in a cohort in a separate room, and so that a good intensive care may be given to them. Secondly, the ratio of nurses to the nursing staff to the babies should be reduced. So normally you give 1:1 ratio of nursing and newborns in ventilated babies, 4:1 for non-ventilated level 2 care babies. But I will suggest that for the ELBWs, you increase the number of nursing for maybe 2:1 or so. So these babies are physiologically immature, you all know all the things, and the extremely ELBWs, they require some special care, special attention, more intensive management, more delicate management, more human and more soft management, I must say. So this is, there should be a combination of aggression and a smoothness, a delicacy. So that should be there. And so the survival of LBWs, they are increasing day by day, and we have to deliver them the optimal care. Then there are certain prenatal considerations when we are expecting some ELBW babies, and they should be delivered in a facility with a high risk of obstetric service, as well as the hospital must have at least level 3 care of the newborns. So a level 3 NICU must be there. And prenatal administration of steroid is a very, very important. And even if there is no time for the full course of this antenatal steroid to be given, it should be given. Even a single dose that will reduce the risk of RDS and other sequelae of prematurity like NEC, IVH, and bronchopulmonary dysplasia. So you must give it. And this had been shown that antenatal magnesium sulfate, that has got some neuroprotective load. So usually in the pregnant women, once you are expecting delivery from 24 weeks to 32 weeks of gestation, you give 4 grams of magnesium sulfate IV slow over 20 minutes and subsequently 1 gram per kg, 1 gram per hour for next 24 hours, or till delivery is there, whichever is earlier, means you do not give for more than 24 hours. And parental education is very necessary. We have to educate the parents that what tough time the baby and the doctor and the treating team is likely to have in NICU once you are treating a case of ELBW baby, means less than 1000 grammar. So drugs and doses of antenatal corticosteroid, we all know. So Dexa 6 milligram every 12 hours for total 4 doses, and betamethasone. You see the doses, we all know. Then the survival free from neurodevelopmental disability from infants born between 22 to 25 weeks of gestation was dependent not only on the gestational age, but also on the following parameters like sex. So male babies are more in danger. Birth weight, if it is lesser the birth weight, more is the poor is the prognosis. Then exposure to antenatal steroid, we talked that it has got protective role in different complications of ELBWs, and the multiple pregnancies, so that have got poorer prognosis. Then delivery room care of the ELBW is very, very important, and the resuscitation planning should include experienced person, means those who are trained in the neonatal care, those who have been trained in your NRPs, so how to resuscitate a ELBW baby. And here I must say that at the place of bag and mask ventilation, it is always judicious to have a TPC resuscitator for resuscitating the ELBW or premature, because almost all the babies are having some amount of respiratory distress, even if antenatal steroid has been given. And by TPs, you do give PEEP. Okay, so by AMBU, you give 0 PEEP. So at the time of expiration, the lung of the HMD lungs or premature lungs, they fully collapse, and subsequently by giving PIP, you are inflating it. But TP is resuscitator that gives PEEP as well as PIP. So a better device for resuscitation of ELBW baby is a T-piece resuscitator. So I must suggest that we all of us who are practicing neonatology must have a T-piece resuscitator. Then immediately wrapping the baby with even before drying the baby, we should have a plastic wrap, and in that we should wrap the baby so that insensible water loss is prevented. Thirdly, the delivery room temperature should be more than 26 degrees. So usually we keep the temperature of air conditioner at around 27 or 28. So it must be above 26. And delayed cord clamping, already discussed earlier. So normally 30 to 60 seconds, after 30 to 60 seconds, we clamp the cord, but here we will suggest that it should be clamped after 60 seconds so that more and more blood goes to the baby. And because these babies are going to be sampled many times, and there are likelihood of development of this anemia. And resuscitation of such babies. So normally in a term baby, we start with room air resuscitation. But once the baby is premature, we start somewhere between 21 to 30% of the, or around 30% of oxygen we should begin with. And we should not be panic for increasing the oxygen saturation very quickly up to 90% in first 5 minutes of the birth. So that target saturation should be kept in mind, and that should be done. And the target saturation should be between 90 to 95 degree. So I will say 90 to 94 degree only. So once you are more than 94, maybe that hyperoxia the patient is developing, and that should be that this target should be after 10 minutes of birth. So in first few minutes, that right at the time of birth, the saturation of SpO2 of the baby is around 65-70%. Okay, so that is okay. After 2 minutes, maybe 75 to 80% is all right. So we should keep in mind the target saturation at few different minutes of after birth, and our saturation should be more than 90% after 10 minutes. So that should be kept in mind, and don't be in panicky once your baby is cyanosed right at birth. He has to remain cyanosed because of this physiological this thing, hypoxemia. Then this is some sort of this cellophane sheet which prevents convection heat loss and evaporative heat loss from the water from skin surfaces. So we say that the care of an ELBW should be preferably done in incubator. So normally all the incubators have been replaced by the warmers, so open care resuscitation. But it has been seen by different studies that the weight gain is more when we are carrying the ELBW babies in incubators. So you have incubators in one room where the proper distance should be there, proper ratio of the nursing and the baby should be there. And these are the VIPs. As some we arrange a ceremony, some VIP comes, so VIP is given a special seat or a special place. Similarly, the ELBWs should be our VIPs in our NICU, and they should have a special attention and a special place, and a special politeness with a special aggression. So aggression is one thing which is very important. Aggression means immediate action. So not overzealous, but immediate action should be there to make them survive. Then for in NICU care, we should look for respiratory support, and then most of them, they require initial respiratory support. So DR CPAP, so delivery room CPAP, once the baby is born, you see that retraction is there, grunting is there. You start CPAP, means delivery room CPAP, right in the labor room. And subsequently you manage it, whether this CPAP is enough or not. If it is not enough, you give NIV, non-invasive nasal ventilation. And if it is not working, you then lastly you go for invasive ventilation. And before I will say that once your CPAP is not working in ELBWs, means your CPAP is 7, FI2 requirement is more than 30%, you give surfactant to all these babies. So these are the ELBWs, definitely to have HMD. CPAP is not sufficient, then you give surfactant, subsequently NIV, non-invasive nasal ventilation, and if not working, you go for the invasive ventilation. Then the fluid, glucose, blood gases, and electrolytes must be monitored very quickly, and optimum nutrition should be started at birth. So even if there is no contraindication to enteral feeding, I would say that most of the time there is no contraindication to the respiratory distress is not a contraindication for initiating enteral feeding. If you cannot give the full feed, you should start minimal enteral nutrition of 10 to 20 ml per kg divided 4 hourly or so. And so men has to be given. And once you are giving this, so parental nutrition should be initiated as early as possible on day 1 of life. And the monitoring itself may pose increased risk, because each lab test requires significant percentage of baby's blood. So we take out some blood, suppose only 80 ml per kg blood is there in a baby newborn. And if your baby is suppose 1000 grammer, if you are taking even 2 ml of blood, so it is somewhere around 2.5% of the total blood of the baby. So he is having only 80 ml and you have taken out 2.5 ml. So it is, or 2 ml even, so it is around 2.5% of the total volume. So that is there. And they are a tiny vessel, so it is very difficult to negotiate them and to keep them patent. And limited skin integrity increases susceptibility to injury or infection. So many adhesives we are using in our newborn. So once you are using it, peeling it off, it is taking out the upper layer of the skin, and that becomes eroded. So that becomes a source of infection, bacterial as well as fungal. So that we have to take care of. And then in respiratory support, we have talked like CPAP, delivery room CPAP should be given. And the conventional, if it fails or failing, we should consider surfactant therapy. Then NIV, and I will suggest that if your baby is ELBW, start caffeine citrate, because these babies are more than 60% is likely to get this thing, recurrent apnea. So whether to give prophylactic caffeine or not, so this is a debatable one. But at least if your baby is developing few episodes of apnea, we should start caffeine citrate 20 milligram loading, and subsequently 5 to 10 milligram per kg IV once daily. Okay, so and if your baby is not responding well on conventional ventilator, then HFO may be tried. So that is one issue. I am not going in details of that because it is not possible within limited frame of time. And CPAP should be initiated at 6 centimeter of water, increased to 1 centimeter to a maximum of 8 centimeter if oxygen increment increases more than 40%. So you can go up to 8. Try to keep themselves, start with 5 or 6, increase by 1 centimeter if there is no improvement in retraction, increase FiO2 up to 40%. Even this is not sufficient, you give surfactant, then NIV, then conventional ventilation, intubation and ventilation. Then prevention of collapse. This prevents collapse to ensure that CPAP is not interrupted. So CPAP should be a continuous process. So once you will remove the descending pressure, the alveoli are likely to collapse. So you have to be very meticulous on that patient so that it does not get disconnected. And if oxygen requirement rises even after maximal pressure has been reached, or if there is recurrent apnea, I will suggest to give surfactant. And even if there is some requirement, you give non-invasive ventilation and subsequently invasive ventilation. So there are all evidences that CPAP with subsequent surfactant therapy in ELBW reduces the rate of BPD and the death of the newborn. So this should be practiced. So in conventional ventilation, we will suggest to use SIMB with pressure support, and if you can target the volume, that is very good. So volume targeted, this SIMB with pressure support, you can start. So may I request the audience behind, please do not talk. Okay, if you have to talk,
आप लोग पीछे जो खड़े हैं, please keep silence.
The lowest possible tidal volume, we should ventilate such babies at low tidal volume, like 4 to 5 ml per kg. And this inspiratory time should be short, 0.3 to 0.35. We should avoid hyperoxia, because hypoxia, I should say, is less dangerous than hyperoxia, because it liberates a lot of free radicals, and that can lead to damage to the different organs of the body. And we should choose right positive in expiratory pressure. So PEEP should be there. If your lung is not inflated, means if there is a low volume lung, means if you have set a PEEP of suppose 5, PIP of and 20, and I time of suppose 0.3, and you are doing X-ray, and if you are finding that the lung volume is low, means the lung volume is lesser than earth posterior rib, means you have to increase the PEEP, means you go to 6, or if it was 6, you go to 7, or even up to 8, you can give it. And so as Dr. Rajesh was telling yesterday, that once you learn how to set PEEP, you learn how to ventilate a baby. So adjusting PEEP is very important, rather most important in ventilation of the baby. Surfactant therapy is secondary to surfactant deficiency, as we know that it is deficient in ELBWs. And we have talked this thing, how to give and when to give. And high frequency ventilation is required when there is leak syndrome, like pulmonary interstitial emphysema is there, or if your ELBWs, they are having pneumothorax. And some unit, they are using HFO as the primary mode of ventilation. But I would suggest that as beginners, or if you have not done ventilation for more than 5 years, you should not start HFO as a primary mode of ventilation. We need to have more tuning and training to use HFO as a primary mode of ventilation. So you do conventional ventilation for at least 5 years, do some ventilation with HFO as a rescue mode. Once conventional ventilation is failing, there you use HFO, and subsequently you may get tuned for using HFO as a primary mode of ventilation. So there are many hands who are, or units who are using HFO as a primary mode and winning them subsequently on conventional mode. So we should go in other way. So caffeine citrate, early initiation of caffeine, like within 2 hours. So that reduces the incidence of BPD. So reduces the duration of mechanical ventilation, and reduces the frequency of apnea. Then this also facilitates extubation, and this should be stopped after 7 days of time, once the patient is apnea free. and or it can be stopped after 34 weeks of post-menstrual age. So the dosage we all know, we have already discussed about it, and fluid and electrolytes. So should be assessed very frequently, because and there is also renal immaturity in ELBW. So many a times your ELBW baby will be passing a lot of urine. So try to keep the records of the urinary output of the baby, and you try to keep the babies hydrated. Overhydration is always dangerous, because in such babies, PDA is likely to open. Route of administration, usually once we find a ELBW babies, we catheterize, the umbilical vein catheterization should be done almost in all the babies, unless there is no respiratory distress. And if you find that the patient is in shock, and then umbilical artery catheterization is also required. So UVC, the baby is received, RDS, we give it, we insert it and keep it at least for 10 days. So for 10 days at least you have got a IV line, and through which you can give even total parenteral nutrition if you feel it to be given. And the another, we should always protect the antecubital veins. So you say your nursing not to use the antecubital veins, because this should be reserved for the PICC lines. So after 10 days, again, you will be having a lot of problem for negotiating the IV line. So antecubital veins you keep protected, because after a week or so, if you will remove the umbilical line, you have to put the PICC line for your further management. So PICC line should be practiced by all of us, and unless you do it, probably it is very difficult to make revival of the ELBW babies. So this is how much fluid you will give. So lower is the age, more fluid requirement will be there on day one of life. Like if 500 to 600 grammar, 110 to 120 mil, 6 to 800 grammars, 100 to 110 ml, and in 1000 grammar you will be having 100 ml. So in term babies you start only for 60 ml. So lesser is the weight, more fluid is required. So fluid composition is also important. Rather, if ELBW is 5% dextrose, is almost all right, unless it is hypoglycemia, we do not increase it. We can increase up to 7.5 or so. And then hypoosmolar fluid should be usually avoided. And hyperglycemia, if it is there, then it must be treated. So we are ending because of the lack of time. And the dose of this insulin is your 0.05 to 1 unit per kg per hour if the level of blood sugar is more than 200. Nutritional support, I must say that you start TPN from day one, and protein should be started from day one as a full strength, 3 gram per kg per day, and lipid at the rate of 1 gram, and subsequently you increase every day. So protein has to be started full 2 to 3 gram per kg from day one of life, so that there is no catabolism in such babies. Then safe initiation of enteral feeding, I said that it has to be done. And once successful tolerance of feeding is established, means 90 to 100 ml if we are giving, then we can think of starting human milk fortifier. So, and EBM should be given to all such babies. You expressed breast milk, not the top milk, not the dabba milk. So EBM should be given. So try to give EBM, and once you have a 10 days significant, more than 2/3, you will start fortifying them. Cardiovascular support is very important for maintenance of blood pressure. Early hypertension should be detected, and fluid boluses should be very conservative, means one bolus may be sufficient, and subsequently you will start the dopamine. Otherwise, if you will give many boluses, you are likely to open PDA. And you can give the second one once you have done the bedside echocardiogram and you are seeing that the fluid volume is less, the IVC collapsibility is very high, then you can give the second dose. But after first dose of this bolus, you should restrict oneself unless you have got bedside echo and you have judged that you can give second dose.
Dr. Vinodji.
Sir, this is the last, I think. So steroid for catecholamine resistant shock and delayed cord clamping we have talked about. PDA management should be done if it is there by endomethacin, ibuprofen or paracetamol. Here I would say that all the three have got the equal efficacy. So you can give paracetamol even safely 15 milligram per kg every 6 hours for 3 days. And infection control, needless to say, this is the most important part of the ELBW or NICU management. For the success of a film, Bollywood film, what you need? Entertainment, entertainment, and entertainment. So these are the three things which are required for that. Similarly, for the success of your neonatal care, if three things are important, that is infection control, and infection control. Once you control it, you cannot be a successful neonatologist. That I am very sure of it. So, and limit blood drawing and skin punctures, protocol for the central venous lines, and minimize the dwell time. So CVC might be removed after 4 or 5 days. Screen for infection immediately. Send all the babies for blood culture who ELBWs once you are receiving them. Fluconazole prophylaxis should be considered. And of course, we should follow such babies with cranial ultrasound to find out the IVH and other complications. Audiology screening should be done. ROP screening should be done. Vaccination should be preferred, and neurodevelopmental follow-up programs should be done subsequently. Immunization should be given to all such babies at the time of discharge, or even at birth you can give it, but hepatitis B should be delayed up to 30 days of life. So that's there. Thank you very much.
Thank you, Professor Singh, for highlighting the protocols of management of ELW babies in neonate, in NICU and delivery room. I have one question. How percentage of babies who survive have neurological sequelae?
So it all depends upon the center to center. Okay, so poorer is the neonatal care, better is the outcome, or better is the but the incidence of neurological center like periventricular leukomalacia, if there is IVH, so the incidence of neurological sequelae will be very high. If such babies are developing meningitis, so if these complications are there, then likelihood of neurological sequelae is very high. And the amount of care, and this is the most important. So suppose if I have a NICU where I have kept a ELBW with a septic baby, with a diarrhea newborns, okay, so the likelihood of all complications will be extremely high. So if you need to improve the outcome of your NICU, you need to have a dedicated ELBW or at least low birth weight baby unit. Okay, and in that you have ELBW is one side and the other 1,000 to 1,500 grams other side. You should increase the nursing the facilities. You should give more expertise, those residents who are more educated or more skilled in the ELBW unit. So जैसे आप बनाते हैं सर TV unit.
Thank you, Dr. Vinod ji. So one more, Dr. Vinod Singh. One more question, very common question has come in from the house.
Sir.
Dr. Rajesh, Ranchi wale hain kya? Dr. Rajesh, the house wants to know what has been the minimum weight of ELBW which has survived normally with the normal functions in your series.
Dr. Ashok is there from Hajipur. He knows that triplets, 800 grams each. All three are doing very well.
How much?
800 grams each. He knows the family. All three are doing well. And approximately 50% have got a good neurological outcome. 50%.
Thank you.
you, sir. I think sir has, in very short, he has dealt everything about extremely low birth weight baby. Now we have a change of this session. Now I request Dr. Khea Ghosh ma'am to please start her session on interesting cases. And for this, I request Dr. Hemant Verma sir, Dr. Avadh Agarwal sir, Dr. Ashok Talpatra sir, and Dr. Parmeshwar Prasad sir to please kindly come on dais and chair the session and introduce the speaker. Short
introduction I have reduced one slide. It's a good thing.
Good afternoon. Dr. Khea Ghosh, she has already been introduced, I think, but still, just a repetition. She's an associate professor and NICU in charge, Institute of Child Health, Kolkata, a very well-known institute of Calcutta. She was secretary West Bengal Association of Pediatrics in the year 2016 and 2017. She was secretary IAP ID chapter in 2020-2021, and she was also East Zonal Coordinator for IAP NNF Advanced NRP program from 2013 to 2017. And she has already led a panel discussion, and we are all aware of her skills. And she'll be presenting the interesting cases. So I think you can start.
Thank you, Chairperson, sir. And as I'm standing between you and the lunch, so I would like to hurry up my cases. So these are the cases, maybe you will say it may not be interesting to someone, but I would like to say after neonatal sepsis, what is the most common clinical presentation that we come across? It is the respiratory distress in neonate. And whenever we think of respiratory distress, we always think of pneumonia, meconium aspiration syndrome, RDS, pneumothorax, of course. But there are so many other rare causes. With the advent of so many diagnostic modalities, we are now in a better position than our seniors to diagnose such cases. So let's take up this case. This is a 20, may I request the audience to be a little more quiet? So 27 days old female child having respiratory distress since 15 days of life. The baby was born at term. The baby was a post-dated one, cried immediately after birth. There was no significant antenatal history, was admitted in the peripheral nursing homes for 8 days. You can understand, from 15 days to 27 days, treated with oxygen and IV antibiotic, thinking it to be a pneumonia. But as there was no improvement, they did a LAMA and came to our unit. I'm very sorry, they didn't have any of the x-rays before, so I am not sure what was the x-ray like that. So on examination, there was a tachypnea, marked tachypnea, heart rate was tachycardia, there was no grunting, but there was a marked subcostal retraction. On auscultation, even the PGTs could tell us, madam, there was something left on the left side, the air entry was diminished. So there was a respiratory acidosis. We started with the CPAP. Chest X-ray was done, sepsis screen was negative, and echo was normal. In the middle of night, they sent the X-ray, and this was the X-ray. So you can see, this is not a typical like pneumonia. You have multiple cystic lesions in the chest X-ray. So what can it be? The common DDs are, of course, diaphragmatic hernia. So, and of course, you can think of CPAP and other cystic lesions. So though the baby was in CPAP, we tell the resident to take an appointment for the CT scan, and we did this. And this is as you can see, there are large cystic lesions. And also I would like to say, and focus was also done, which also revealed large cystic lesions. So these are the cystic lesions in the lung. So the CT was suggestive of CPAP, which is a multiple large septic cystic lesions. And this is the type 1 of CPAP, where you get large cystic. On the next day, a left-sided thoracotomy was done. Lower lobe was found to be normal. You will see the CPAM is usually unilateral and it affects the one of the lobe. So it was involving the upper lobe. So lower lobe was found to be normal. After excision of the dilated upper lobe and part of the lingual was done, and there was a very improved expansion of the rest of the lower lobe. So this you can see the post-surgical chest X-ray. So this was on the day of admission, and this was on day 3 after operation. So CPAM, though seems to be a very uncommon disease, may occur in 1 to 4 in 1 lakh babies, and it was previously known as CCAM, now known as CPAM. And type 1 is the most common, where you get this big cystic lesions, which cysts are usually more than 2 centimeter, and it has a very favorable outcome. So I would like to highlight on this. It has a very favorable outcome. In contrast, if you have microcystic variety like type 0, type 3, and type 2, they are associated, they are very lethal. Type 0 and 3 has very poor prognosis, almost not compatible with life. Where type 2 microcystic, if it is associated with congenital anomalies, with renal, cardiac, and diaphragmatic hernia, it has a poorer prognosis, whereas the others may have a better prognosis. Type 4 can present later. So this is the flow chart. I will, due to lack of constraint, I will not go. It can be the important why I like to highlight. This case could have been picked up by an alternatal ultrasound. This case could have been picked up by an X-ray, where unnecessarily treating this baby with an IV antibiotic and oxygen, thinking it to be a case of neonatal pneumonia, was not justified. So there is an antenatal, even if you can diagnose it antenatally, you can go, if it is not associated with lethal malformation, you can continue the pregnancy. In a single dominant cyst, now you can do a thoracoamniotic shunt and you can salvage the baby. And if there are multiple cysts, of course, and the age of gestation is more than 32, you should delivery early, followed by resections. So to conclude, CPAM can present with features of persistent and recurrent pneumonia. It may be confused with diaphragmatic hernia and also pulmonary sequestration. CT scan should be done for accurate diagnosis. Surgery should be done even in asymptomatic. This is again, I would like to highlight, because this baby was symptomatic. Even in asymptomatic babies, you can delay it a little bit till the age of 1 year. Why? Because sometimes it shows resolution of the cyst. So you can delay, but never delay it before, after 1 year, because sarcomatous and carcinomatous degenerations are common. And for type 1 CPAM, pleuropulmonary blastoma is a radiological differential. So you should go for it and to confirm that there is no malignancy. And very, very important, I've marked it in red, prenatal diagnosis of CPAM is possible. So we should encourage your obstetric colleague to go for a fetal anomaly scans. So I will just leave this development of lungs. This occurs if there is an insult in the pseudoglandular stage. And in the canalicular stage, if you have an insult, you have features like this. This is again a baby which was just born 1 month back. The mother came with a ultrasound of oligohydramnios with kidney anomalies, but the mother was not willing to deliver the baby at that time, was wandering from obstetrician to obstetrician, got delivered in our unit, cried immediately after birth, developed severe marked respiratory distress soon after birth. And you can see we intubated, and this was a case of pulmonary hyperplasia. So now case to a very, very interesting case. A male baby, term baby, which was born with respiratory distress soon after birth. The antenatal history was uneventful. History of second-degree consanguinity was present among the parents. So there was a history of second-degree consanguinity, but baby was otherwise given moist oxygen through nasal cannula, not maintaining, so referred to our unit. Baby was tachycardic, tachypneic. There was no palacyanosis. There was marked subcostal retraction. Cardiovascular and other examinations were unremarkable. So this was the initial blood counts. As you can see, total count was 15,200 with a CRP of 3.2. The gas shows a respiratory acidosis. So, and this was the chest X-ray. So what you will think of? Though there was no risk factor for sepsis, you will think of of course, you will think of pneumonia, and the baby was started with CPAP, put on CPAP, first line antibiotics started, IV fluid started. But after 24 hours, due to clinical deterioration, the baby was put onto ventilator and the antibiotics were upgraded. And the repeat chest X-ray, as you can see, there is a marked increase in the opacity on the right side. So initial backtake was negative, urine culture and culture was also negative, and the repeat blood counts on day 4, because the baby was not improving, showed a rise in the total count and CRP. So 19,300 and CRP was 93. So we upgraded the antibiotic, and as the baby was not improving and was also on ventilator, so another chest X-ray was done. Surprisingly, this time, as you can see, the pneumonia which was here, this side improved and there was a marked collapse consolidation on the left side. So this is just 1.5 months back, I'm saying. So we did a bronchoalveolar lavas thinking some bad infection. It came out to be enterococcus, and the baby was, ticoplanin was added according to the sensitivity. So we thought, okay, we have won the battle. But baby was kept in left up position because left-sided is and chest physiotherapy was continued. So after 48 hours, there was no improvement. And when we did the third X-ray, as you can see, the left side was there in the second. Now again, it's on the right side. So there is a changing in the opacity. So had it been an older child, we could have think of foreign body aspiration, and so on. It's a newborn with a respiratory distress from day 1. So echocardiography was normal, ultrasound whole abdomen was normal, repeat backtake was also negative. So what are we dealing with? So we thought it could be a case of suspicion of a mucociliary clearance defect or cystic fibrosis, because whenever we're putting the child on that side is getting collapse or calcification. So it was, this was reinforced by the thing that there was a second degree consanguinity amongst the parents, and there was a family history of cardiac disease. The father's cousin had died due to some cardiac disease, which was long back. So we sent for whole exome sequencing because we thought, so this is the beauty of sending early diagnosis, if of course there is feasibility. Though it's a very costly investigation, in our institute, because it's a charitable one, we can do it in a much lesser cost. And we always, because the job of the neonatologist or pediatrician is not only to treat this baby. If there is some genetic disorder, you have to counsel the whole family. So we did send, and this came out to be a case of primary ciliary dyskinesia with a mutation in the hydrin gene, which is responsible for encoding the radial spoke at the central apparatus of the protein of cilia. And hence, the baby was continued with ticoplanin, postural change was done. The mother was made to learn about the chest physiotherapy. And as you can see, the repeat chest X-ray was like this. Gradually, there was clinical improvement, full feed established, baby discharge, proper counseling for the genetic and also for the monitoring guidelines, because these are the babies which require frequent monitorings, and it was done. So to conclude, genetic testing is now one of the most important investigation. If you are thinking of an inherited disorder with genetic mutation, PCD is not a very rare entity. Its estimated frequency is 1 in 12,000 to 1 in 20,000. Previously, we never used to diagnose because we didn't have the access to this genetic sequencing so easily. Should be thought in any unexplained respiratory distress in term neonate. So a term neonate without any risk factor, if you're thinking there is respiratory distress and you are not able to treat it clinically by antibiotics, especially if it is associated with situs inversus. In this case, there was no situs inversus. Had it been a situs inversus, the diagnosis could have been much easier. And heterotaxis syndrome and congenital heart disease. So all these things should be excluded. Some of the reports are there. It may be associated with neonatal hydrocephalus. As you know, the ependymal linings are also lined by the ciliated epithelium. So if the ciliated epitheliums are at fault, you might have hydrocephalus also. So prognosis better than cystic fibrosis. This is very important, which you can have a positive feedback to the parents. It is better than the cystic fibrosis, but it needs stringent monitoring. So another case of respiratory distress, this time a 5-day-old baby with lethargic feeding difficulties and respiratory distress. There was a history of decreased fetal movement, and for that cesarean section was done. And there was a history of meconium stent liquor. So we thought it to be a meconium aspiration, but unfortunately the chest X-ray was very, very clear. Very important clinical findings. The heart rate was tachycardy, but the baby always used to have a very lack of tone, like a frog-like posture. There was high arch palate and undescended testes. So all these point out towards something else other than pneumonia and HI. So initial blood gas, so respiratory acidosis, put on CPAP, routine things were done. It's not moving. Now the investigations were also very normal. As you can see, the X-rays was unremarkable. There was nothing. We thought of some slender ribs also because the muscles were also weak. So this is hypotonia, respiratory distress with a normal X-ray with feeding difficulties. So your antenna should think of, it's a floppy infant. So it's a floppy infant. So it may be central nervous system and the peripheral nervous system. So CNS causes were ruled out by investigation. As you can see, we have ruled out sepsis meningitis. We have ruled out HIE and structural brain disorders by brain imaging. We also thought of IEM because IEM is a very important DD in this case. We sent plasma lactate ammonia, which was normal. IEM panel was sent, which came out later, but it was normal. So there was no obvious dysmorphism, which will point towards the chromosomal disorders. Moreover, we excluded CNS cause because there was no seizure episodes, there was no fisting, there was no, and there was alertness was improving. So we thought of the peripheral causes of hypotonia. Again, I would like to highlight, it's very, very difficult to diagnose SMA by seeing tongue fasciculation in neonate. So other things like hereditary motor-sensory neuropathy is very difficult to diagnose. Congenital myasthenia, the mother didn't have any history like that. So we were left with the muscle disorders. And what is the so what we have to do to clench the diagnosis? We send the serum creatinine kinase and genetic tested. Again, as you can see, we got this nemaline myopathy and there was NEB gene mutations. So NEB gene mutation is very, very common mutation in nemaline myopathy, which is the commonest myopathy. And the classical thing is in this mutation, you will have more of bulbal weakness and axial weakness rather than peripheral. And that is the reason why we got confused in this case. So there's no specific treatment, only supportive, was on CPAP. And this is the child who is on follow-up. The baby was discharged. Mother was taught with OG-tube feeding. This is not NG, I'm sorry. This was OG-tube feeding. And OG-tube was removed by at the age of 3 months. Regularly comes for follow-up. This baby is now 4-month-old. The baby has typical dolichocephalic appearance like a muscle disorder and slender muscle mass. So as I said, nemaline myopathy is the commonest myopathy, that is 20%. So always suspect if you have a generalized hypotonia with respiratory distress, and NEB-related nemaline myopathy is the most common, which has a more axial and bulbal weakness. That explains the axial hypotonia and the feeding difficulties in this child rather than limb weakness. So to conclude, in a floppy baby with respiratory distress, of course, rule out sepsis, HIE, but also think of congenital myopathy, and genetic study is very important. So I would like to end with another very interesting case, though this case, all the three were very recent. This was a little older case in 2022 and June, July, I think. 28 days female baby with a birth weight of 3.59. Came with at the age of 28 days with a weight of 3.59. So weight gain is good. And the birth weight was 2.72. The child cried at birth. There was a respiratory distress since day 25 of life. There was a poor feeding effort. There was marked tachycardia, marked tachypnea. So this is the X-ray. As you can see in the others, we were focusing either there was nothing in the X-ray or maybe some cystic lesion. But here you can see marked cardiomegaly. So the cardiothoracic ratio was around 0.65. So, and there is a progressively increase in tachypnea, initially with nasal moist oxygen, but required CPAP therapy. So this was the initial counts. As you can see, the CRP was less than 1. And we did an ECG, so which shows there is a ST depression in the V5, V6. So you can see there is a way. So we thought it to be a myocarditis or LV strain pattern or evolving infarct. And the echo was done. So echo shows dilated dysfunctional left ventricle with a mild MR and TR, and the LV ejection fraction was around 40%. So we thought it to be a myocarditis. So this is the time, this is July 2022, where there was storm was going off around neonatal MISC and neonatal Kawasaki. So we also did this ferritin, NT-pro, BNP, interleukin 6, which all were high. And the COVID IgG was also positive. So we thought it to be a case of neonatal MISC, and we treated accordingly. IVIG, methylprednisolone, anticongestive therapy, but there was no clinical improvement. So a repeat echo was done. In fact, a cardiologist was called from outside. And as you can see, this is the aorta and this is the pulmonary artery. And if I'm playing it again, you can see the origin of the left coronary artery was from the pulmonary artery. So showing LCA originating from the pulmonary artery. And also there was papillary muscle scarring and LV dysfunction, as you can see in this echo. So diagnosis of Al-Kappa syndrome was made. So why it was missed in the first echocardiography? See, there was this echo also shows there was a moderate pulmonary arterial hypertension. Now what happens in Al-Kappa, when the pulmonary arterial hypertension is high, the left coronary artery, though it's originating from the pulmonary artery, due to the high pressure of the pulmonary artery, there is no retrograde flow. So once the pulmonary arterial hypertension decreases, then you can have the retrograde flow from the left coronary artery to the pulmonary artery, which can be easily picked up by the Doppler. But if you have a high pulmonary arterial hypertension, this is often missed, and sometimes Al-Kappa may be missed. So this was diagnosed as Al-Kappa syndrome, and cardiac central referral was done, and Al-Kappa repair was done. So this is as you can see, this is the normal heart, coronary originating from the aorta. Now coronary is originating from the pulmonary artery. So if you have a if you're very sure this is not matching with your clinical results, always go for a second help and do it. So medical management alone carries a very high mortality, and so you have to go for a repair. So lesson learned, Al-Kappa may not be reliably diagnosed in neonate by echo if there is associated pulmonary arterial hypertension. On the other hand, early diagnosis is important to prevent significant myocardial infarction, because if you do a late diagnosis, already there will be damage, then heart transplantation is the only options for that. So we, as the motto of Bihar Neocon is intact survival. So we should always target for early diagnosis and early management. So I think we should, so don't hesitate to investigate further or repeat if whenever in doubt. So case 5, I will just show the slide. This is a case of arrhythmia, very uncommon case. Only 8 cases has been reported till far. And this is admitted to NICU, and there was, we did the CT reconstructive, and we could found that only 8 cases reported of arrhythmia. This baby came with severe respiratory distress. And these are the differential diagnosis. Again, we took the help of whole exome sequencing, and we got a variety of coronal atresia with lymphedema. And not only this, very important is supportive, aggressive supportive treatment. What we did, and we did took the help of the ENT surgeon of outside hospital, and a nasal reconstructive surgery was done. This is the index case after stage 1 nasal reconstruction surgery, and all well, that ends well. And this is the baby at 10 months. You can see one-sided nasal reconstruct surgery has been done, and the baby is doing fine. So I would like to end with this. Be gentle. Of course, you have to be gentle if you are a neonatologist, but be very passionate to treat neonate. Pick up clinical clues. If you have a strong suspicion of rare disease, don't hesitate for doing investigation if you have the feasibility. And always work as a team. Not only we should work with the paramedics, but we should work with other things like ENT, especially neurologists, to save these babies so that we can have an intact survival of these newborns. Thank you. Thank you.
Thank you, madam, for presenting the rare cases.
So thank you, ma'am. So may I have your attention, please, because we are running short of time. So I request those who want to take their lunch, they can take their lunch without making noise, and we will continue the session. So for the next session, we have Dr. Rajesh sir on oxygen therapy. So to chair the session, I request Dr. Professor N.P. Narayan sir to kindly come on dais. Dr. Arvind Singh sir, please come on dais and chair the session. Dr. Mahesh Kumar and Dr. Muhammad Noise.
As we are running much behind the schedule, I'll request Dr. Rajesh, who needs no introduction. He is an icon of neonatology for the whole country, I must tell you. He has the most populous nursing home of neonates across the country. So I will not waste your time by further introduction. I will request him to start the talk immediately.
Okay,
Dr. Rajesh,
thank you, sir. We all are alive because of mitochondria. It produces ATP, and it produces ATP with the help of oxygen. And if you see the baby, when baby is in the womb, yeah, PaO2 is hardly 25. Hardly 25. When it comes out, the PaO2 goes almost 50 to 70. So a lot of oxygen stress on the baby, and newborns, especially the premature newborns, they have got a very, very inefficient antioxidant system. And so there are a lot of hyperoxia damage is there, especially if PaO2 crosses 100. And we have damage to the eyes in the ROP. We have damage to the lung, BPD, damage to the brain in case of PVLs. So oxygen therapy is double-edged sword. If you don't give oxygen, they will die of hypoxia. If you give too much of oxygen, they will survive, but they will survive with morbidity. So it is like a drug. It should be prescribed at the proper dose with the proper delivery device, and it should always be monitored. And indication of oxygen therapy is very simple. We all know if your baby is desaturating, we give oxygen. That is, everybody knows. But other two things, like if baby is a term baby having a tachypnea, rate of 60, 70, retraction, even if baby is maintaining saturation, you have to give oxygen to decrease the work of breathing. That is very, very important. It's quite often people don't do it because certain maintain kar raha hai, kyun oxygen dena. But if you have respiratory distress and baby is still maintaining oxygen, give oxygen to decrease the work of breathing. Same goes for shock. Even if shock, baby is maintaining saturation, the baby is maintaining saturation because heart is working hard. So you have to support the heart by giving oxygen, so that delivery of oxygen to the tissues will be much better. And also we know that baby in the diseases we have, baby desaturate because they have right to left shunt in the lung. It can be because of your collapsed alveoli. It may be because of blood is not going, like PPHN, or maybe because there is a pulmonary edema and a diffusion is not happening. So there is right to left shunt in the case of hypoxia. And this, so if you have little less, like 10% of right to left shunt, if you give oxygen, 60%, 80%, 100% is there. If you give 60% oxygen, if you increase to 100% oxygen, the rise in PaO2 will be very high, almost double, more than double, 250 to 500. If shunt is say mild to moderate, to say 25 to 30%, if you give 60% to increase from 60 to 80, there will be little increase in the PaO2. But if your shunt is high, more than 50%, like any case of moderate to severe RDS, severe Meconium-Asper syndrome, severe pneumonia, all will have right to left shunt, which is more than 50%. And in that case, if you increase from 60 to 80 to 100, it is not going to help. This is a very important concept. Even if you give 100% oxygen, we are giving 60% oxygen, you have increased to 100% oxygen, but it is not going to help because shunt is very large. Right to left shunt is more than 50%. So if you have more than 50% shunt, which is quite often in severe pneumonia, severe lung diseases, no need of just increasing the oxygen. You have to do something else. Like you may have to give HFNC, you may have to give CPAP, you may have to mechanically ventilate the baby. So, oxygen we start in the labor room, and we all know like 35 weeks or more babies should be resuscitated with the room air. Less than 35 weeks, you start with 21 to 30% oxygen, and the oxygen, the saturation should be targeted. And it's not like the baby is cynosed and you start giving oxygen immediately. You have to measure the SpO2. And I have seen the people trying to put the probe on the right hand or legs. You cannot put because there's a lot of fluid is there, wet surface is there. So better to put on the wrist. Put it on the wrist. It's very, very easy to put the probe on the wrist and just measure the oxygen. And you have to target. And it's better practice that on the resuscitation warmer, you stick this. You get a printout of this and just put it there. So then you don't have to memorize what it is. And if baby is having respiratory distress in the labor room, and if baby is more than 34 weeks, if it is more than 2 kg, how to go about it? You have to start the oxygen by nasal cannula. Maybe we may start with 0.5 to 1 liter. If baby is requiring more than 1 liter of oxygen, you have to switch over to the CPAP or high flow. Okay. If baby is maintaining oxygen say 0.5 liter per kg, per 0.5 liter per minute, you watch it. If baby is maintaining saturation, you wean off. If baby is maintaining, you monitor the oxygen. If baby is deteriorating, baby is starting to have requirement more than 1 liter, then again you have to start on CPAP, HFNC or ventilation. This is a very important concept. Never use more than 1 liter of oxygen by nasal cannula, especially if the baby is smaller. In term babies, for a brief period, you can go up to 2 liters of oxygen, up to 2 liters, not more than that. Up to, for brief period means 10 minutes, 15 minutes, half an hour, not more than that. The baby is still not improving, please switch over to the CPAP, HFNC or any other positive respiratory support. We all know this Laplace law. Okay, smaller the radius, more the surface tension. So smaller the baby, smaller the radius. So it is also the pressure which is required to keep the alveoli open depends upon the surface tension. It is very easy to keep the alveoli open rather than trying to open up the closed alveoli. So start CPAP early, don't hesitate. And sir has told already DR CPAP, delivery room CPAP. Whenever you are in doubt, baby is a small baby, 1.5, 1.6 kg, or the bigger babies, you are giving more than 1 liter of oxygen, baby is not maintaining saturation. Start the CPAP from the labor room itself. If you start it early, it will be successful. Otherwise, you will end up having PPHN and whatever Mithal has taught, you will be doing all those things. So start early, it is very easy to treat. And for that, we have very good algorithm now, smaller babies who are less than 34 weeks, less than 2 kg. Anyway, we have to know that these babies should not be given only oxygen. If a smaller babies less than 2 kg, less than 34 weeks, if they are having respiratory distress in the labor room, please don't give only oxygen. You have to start some other modality. Ideally, with delivery room CPAP most commonly. Otherwise, if you have a bigger baby, means more than 1.5, more than 32 weeks, mother had received antenatal steroid, no infections are not there, then you can try HFNC. So more than 1.5, more than 32 weeks, no risk factors for failures of HFNC. You may start HFNC, so HFNC and CPAP is the choice. If you have 1 to 1.5 kg babies, DR CPAP, no. You have to start delivery room CPAP. Smaller babies, less than 1 kg. less than 1 kg, less than 28 weeks. Again, DR CPAP, what we have? Choice of NIPPV, nasal intermittent positive pressure ventilation is less than 1 kg. And especially we have a risk factor for failures, like infections are there, mother has not received antenatal corticosteroid, baby is 900 grams, is many of the unit practice, they start nasal ventilation straight away. How to give oxygen? You have a head box, you have a mask, you have free flow, you have nasal cannula, nasal catheter, or nasopharyngeal catheter. There are so many modalities are there. And nowadays, universally, people have agreed. Our CPG guideline also, what we had written is that nasal cannula is the preferred mode of oxygen. Don't use head box. WHO has gone to that extent. They said head box should not be used in neonates. And nasal cannula is preferred mode, and oxygen flow rate is 0.5 to 1 liter, as I told you. And the FiO2 delivery, how much baby is getting FiO2 by 1 liter of oxygen? It depends upon the size of the baby. The smaller the baby, more the saturation. Depends upon the rate of respiratory rate of the baby. So you can see, if it is if you are giving 1 liter of oxygen, if it is 1.5 kg, baby gets 74% FiO2. But it is 3 kg, it gets only 45%. So a smaller babies less than 1.5 never go more than 1 liter. Okay. A bigger baby, 2.53, you may go for up to 2 liters for a brief period of time. And also, like, we all use this bubble humidifier, but nowadays there are enough evidence that our baby's natural humidification mechanism is good enough to humidify. So you don't have to use water in your chamber. Okay, no water if oxygen is required less than 1 liter. No water. Studies have shown it creates infection. It causes more infection in the babies. So even our CPG guideline, we have clearly written water is not required in your humidifier chamber, bubble humidifier chamber. If you have to use more than 1 liter, you have to use HFNC, because that is to properly humidify the oxygen by HFNC. If you have to use more than 1 liter, less than 1 liter, please don't use water. It will cause more harm than good. And there are studies these are the adult studies, and they have clearly shown that cold bubble humidification of almost 4 liters per minute did not produce any effect on nasal mucosa and did not attenuate any oxidative state on caused by the oxygen. It is for the adult study for 4 liter. They up to 4-5 liter in adult also need not put the water in the bottle. Okay. Oxygen by hood, because I have seen the people are putting oxygen with say 1 liter of oxygen by hood on the baby. That should not be done. It requires higher flow. 2 to 3 liters per kg per minute is the flow which is required. Lesser flow can cause CO2 accumulation and your hypercarbia. So if you want to use head box, you have to use blender always, because then only you can give this much of flow, and by titrating your oxygen concentration. So minimum flow is 2 to 3 liters. If you want to use head box, use it with blender. Okay. Like if you have a 3 kg baby, you have to give almost 6 to 9 liters of blended air. Then you can control the FiO2. Okay. And monitoring of saturation, we all know alarm settings should be around 90 to 95, target is 91 to 95. And what is important is to set up the alarm limit. In NICU, jo basta rehta, tee ta po po basta rehta alarm. And what happens is the sisters get fatigued. This is called alarm fatigue. When the real alarm comes, they will not respond. So NICU, no alarm should be coming. If alarm is coming, it causes alarm fatigue in the nurses. And when real your time is there to respond, they will not respond. So if you have, that's why the alarm setting should be 90 to 95. Alarm should flash when saturation is lower is 89, upper is 96. In PPHN, we keep slightly higher range. Alarm limit is 90 to 95. Alarm flash is 89 to 100. But on room air, if baby is room air, that's where the people do mistakes. And upper limit, they don't put it off. Baby is on room air, 99 saturation is coming, and a monitor is giving alarm. So that is bad because that also causes alarm fatigue. That should be avoided. If baby is on room air, you should put off the alarm, upper limit. Upper limit alarm should be off. Which type of pulse oximeter? We have a pulse oximeter nowadays with the signal extraction technology. That should be used. That is little costly than other thing, but that should be used. And we have nowadays this advanced oxygen monitoring like oxy-CRG and histograms. This oxy-CRG is nothing but oxy-respirogram. Whenever apnea will happen or any bradycardia will happen, like any episode, ABD events, apnea, bradycardia, desaturation events, it will record everything. Of how was the bradycardia, how much was the bradycardia, how much the lowest saturation, how much was the apnea duration. All this are available in the market. We have all these monitors with us. These are not very costly monitors. They are very helpful. Even this you have SpO2 histograms in many of the many of the monitors. You can see this at 24 hours, last 24 hours, how much time baby was in your the target zone, like say 91 to 95. And you can ask the nurses, and by showing this, you can show the nurses that you are not careful. Then you can do the teaching for nurses, and the better outcome will be there. So these two are very important: SpO2 histogram analysis in the everyday round, and oxy-CRG monitoring to pick up the bad events. And nowadays we have this automated FiO2 controls. Nowadays ventilators, they are giving. Say, well, see, in this baby, oxygen saturation is 83%, baby is on FiO2 23. You don't have to do anything. Ventilator will automatically increase. So it will 35%, SpO2 will increase. So if you have automated FiO2 control, it is much better. They will ask you maybe 1 to 1.5 lakhs extra for the ventilator, but it is always better for the tight control of the oxygen. So how to prescribe oxygen? The typical will be like 0.5 liter per minute by nasal prongs, write in the case sheet, maintain SpO2 91 to 95, and write also if oxygen requirement is more than 1 liter, please inform the doctor on duty. It should not be like sister oxygen shuru kar do, start oxygen. It should not be right like this. You have to write like a drug. 0.5 liter per minute by nasal prong, maintain saturation 91 to 95. If oxygen requirement will be more than 1 liter, please inform the doctor on duty. He will take the corrective action. Otherwise, what happens? The night time system will keep on increasing. 1 liter, 2 liter, 3 liter, 4 liter increase kar denge, then ultimately baby will be bad. I think that is the last slide. Thank you.
Thank you very much, Dr. Rajesh. In fact, oxygen is a drug, and I think it should be used as judiciously as he was mentioning. And he has shown his merit again. He is not tackling with all big ventilators, but this oxygen therapy through other methods, how it should be judiciously given, he has explained pretty well. And I was impressed with the automated ones. Automated ones have come today.
Yeah, they are available in the market, sir.
Yeah,
Indian market.
That's wonderful. It is something new to me. So I think you will have some comments. Dr. Arvind, please.
No doubt. Thank you, Dr. Rajesh Kumar, a very brilliant neurologist. Undoubtedly, we have today benefited from your speech on the oxygen therapy. And it is really, oxygen therapy is very essential and very important for the prevention of sequelae and complication also. It should be given judiciously, as said, and also you have also mentioned oxygen therapy important. So undoubtedly we should be careful in the NICU, and if doctor are careful, then nurses will be also be careful. If we relax, they will relax 4 times more. So it is really very
शुद्ध भी जुनून जो कहते हैं कि मैं जो बच्चे का लाइफ बचाना, एक न्यू बॉर्न बेबी खास करके, तो जुडिशली यूज होना चाहिए। हाइपर ऑक्सीजन भी हार्मफुल है और हाइपो ऑक्सीजन भी, अंडर ऑक्सीजन भी हार्मफुल है, जो बहुत सारे सिक्वली से बचता है। और जितना जल्द हो उतना जल्द जरूर स्टार्ट करना चाहिए, देना चाहिए। जो ऑक्सीजन का एक लाइफ लॉन्ग उसका इम्पैक्ट पड़ता है, आगे भी एक बर्डन बेबी नहीं हो। हमारे क्लिनिक में एक बच्चा आया 3 साल का, उसको सीवियर आजमेटिक अटैक, वो हाजीपुर हमारा अशोक जी के साथ हम लोग, तो वह स्टार्ट ट्रीटमेंट किया हाजीपुर, और फिर कुछ दिन के बाद मेरे पास आया। तो बच्चा का देखे हम भाई ये क्यों इस तरह का, बच्चा भर्ती हुआ था क्या शीशा हुआ में, तो ना से 3 साल तक बहुत अच्छा था, तो इसको अचानक सीवियर आजमा हुआ, और पता नहीं ऑक्सीजन की कमी के चलते, बाद में हम लोग पता चला कि ऑक्सीजन की कमी के चलते वो सिक्विली में चला गया। बच्चा जो मेंटल रिटार्ड, ओवरवेट है, वो यहाँ न्यूरोफिजिशियन को हम दिखलाए पटना, फिर निमांस, जयपुर, जहाँ जहाँ न्यूरोफिजिशियन फोटो से, माने एक बर्डन बन गया वो बच्चा। आज वो आता है, मेरे आराम नाम है उसका, हम फीस आधा लौटा देते हैं, फिर भी देख करके भीतर से लगता है कि यार नेग्लिजेंस हुआ, जो ऑक्सीजन नहीं दिया बच्चे, पेरेंट्स का कोई गलती नहीं, वो बेचारा एक ओनली सन है, और तो लड़की ठीक है। तो जब भी आता है मेरे भीतर से लगता है कि यार ऑक्सीजन वही या तो पल्स ऑक्सीमीटर से नहीं देखा हो, या लाइटली लिया, जो आपने बोला कि बर्डन ओवर ब्रीदिंग हो उसमें भी देना चाहिए, सेप्सिस में देना चाहिए, जो आपने जो मेंशन किया, ये बहुत माइन्यूट चीज है जो बच्चे को लाइफ के लिए, आगे के लिए बहुत ही हेल्पफुल है, और बर्डन नहीं बनेगा। सबसे पहले कि फैमिली के लिए बर्डन नहीं बनेगा। तो थैंक यू राजेश जी, आप रियली यू आर ब्रिलियंट।
Okay, thank you, sir. Thank you.
Okay, we close. अब सबको अलार्म सेटिंग में स्कूल सेटिंग हो गया।
So we break for lunch only for 15 minutes, and we reassemble after that. Yeah, thank you.
यहाँ आगे से ना यार, पीछे से ले रही है, बंद है माइक। यहाँ यहाँ लो नहीं, नहीं अच्छा है।
So welcome back after lunch. I request those who have finished their lunch, please take their seat. So we will start the next topic. This is on osteopenia of prematurity. And speaker is Dr. Binay Ranjan. And to chair the session, I request Dr. SBP Singh sir, Dr. Akhilesh Kumar, Dr. Hemant Kumar sir, and Dr. Satyanarayan Chaudhary sir to please come on dais and chair the session. Bihar. Amit, 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 Hemant sir. कितना हुआ?
48 हो गया,
आधा घंटा लेट चल रहा है, 2:10 से
हम 5 मिनट और फटाफट कर लेंगे।
हाँ
ठीक है।
So next session is on osteopenia of prematurity. I request Dr. SBP Singh sir to please come on dais. I request Dr. Hemant sir to please come on dais. आप अपना शुरू करें.
ये वो ले लेगा वहां से ना लोग स्क्रीन। चेयरपर्सन के लिए पहले बोलेंगे नहीं पता होगा, बता दीजिए। लगा दिए, खाली बोल दीजिए, दे देगा।
Now there is a good educative session. Dr. Vinay Kumar from Basal Hospital, Patna. Subject is very interesting. So all of you should learn something. That is the osteopenia in prematurity. Now I request Dr. Vinay to start your session.
Thank you, sir. I am welcome all of you. Today is a good session about the approach to a metabolic bone disease, also known as the apnea of osteopenia, neonatal osteopenia or neonatal rickets. Neonatal osteopenia is the important area of interest for all the neonates due to the continue increasing the survival of the neonates. During the hospital stay in NICU, they are treated with most of the drugs like diuretic, corticosteroid. These all are contributing factor for the metabolic bone disease. The definition wise, it is best defined as a reduction in the bone mineral content relative to the expected level of mineralization for an infant. The metabolic bone disease formerly known as rickets or the osteopenia prematurity. Now it's a new term, metabolic bone disease. Metabolic bone disease can be occur in the isolation with only biochemical changes without coexisting osteopenia on radiograph. So we can we have to wait for the radiological appearance. We can say about the biochemical parameter also. The incidence, we talk about the incidence of the metabolic bone disease, the categorized in the weight wise. Most of the cases are seen the extreme preterm neonates. If you talk about the prematurity, the neonates who are less than 600 grams, the chances are being osteopenia is around the 67%. Around the 1 kg preterm, the chances around the 60%. These are the various risk factors for the developing metabolic bone disease. Some are the prenatal, some are the postnatal. We talk about the prenatal, the prematurity comes first because it is due to the prematurity, there is a decrease in the utero calcium and phosphorus acceleration. Also, there is a decrease in the maternal vitamin D deficiency leads to the metabolic bone disease. Placental deficiency, which is seen in the case of IVGR babies, and the genetics, the male genetics also contribute the high risk of metabolic bone disease. If you talk about the postnatal risk factor, that is limited calcium and phosphorus delivery by the TPN. If you use TPN more than 4 weeks, there is a more chances of less supply of calcium and phosphorus, vitamin D deficiency, immobility, and drugs. As we talk, diuretics, steroid, and caffeine also contribute the postnatal factor for developing metabolic bone disease. The risk factor for metabolic bone disease, the chronic lung disease, because in chronic lung disease, we use most of the drugs like glucosteroid, methylxanthine, and lip diuretic, all leads to the increased chances of metabolic bone disease. NEC, in case of NEC, we have prolonged period of prenatal, parental nutrition, NPO, poor gut function, all leads to the metabolic bone disease. And excess phosphate supplementation, they leads to the secondary hypothyroidism and bone reabsorption. The pathophysiology of phosphogenic metabolic bone disease is low dietary intake of phosphate, increased urinary excretion of phosphate, that is decreased serum phosphate, and no compensatory mechanism to mobilize the phosphate from the bone through PTH, the normal calcium, normal PTH level. These are the clinical scenarios and factors we can diagnose the metabolic bone disease appear because these appear late in the phase 4 to 6 weeks after the birth. The biochemical changes, clinical signs and symptoms, failure, because most of the preterm babies have to go into the NICU stay more than a month in case of extreme preterm. So there is chances of failure to wean from the ventilation, respiratory disorder, in X-ray, accidental finding of the fracture, X-ray of osteopenia. If you talk about the investigation part, there is no single parameters we can define the metabolic bone disease, but some factors like first come with the alkaline phosphate, mostly wide use marker for the metabolic bone disease. There is no agreed cutoff value for the LP, but LP is increased because the LP increases over the first week, 3 weeks. 90% is a bone origin and it reflects bone turnover. These are the study which are done in the cutoff value for LP. There is 3 scenarios, the Backstorm, Abdullah, and Michel, which have a different cutoff value for LP. If we talk about the Backstorm, there is if LP is more than 900 and Michel 800 units. But according to American Academy of Pediatrics, the LP value more than 800 and is suggestive of the metabolic bone disease. If the LP value lies more than 500, this leads to the impaired bone hemostasis and more than 700 associated with the bone demineralization. Phosphate level, serum phosphate level that is less than 5.6 the IAP cutoff value is less than 4. So diagnosis ALP more than 900 and phosphate less than 1.8 millimole. That's the diagnosis of metabolic bone disease. Another value, the biochemical marker PTH level, the crucial for both the screening and diagnosis. There is an early rise of the PTH in the calcipenic metabolic disease, and the cutoff value is more than 100 picogram per liter. Tubular reabsorption phosphate, that the normal value is 75 to 85%. Increased PTH level with decreased TRP in the setting of low phosphorus calcium deficiency. Normal PTH level with increased TRP and low phosphorus phosphate, that's leading to phosphate deficiency. The another less reliable biomarkers are osteocalcin. The radiological marker for bone metabolic bone disease is X-ray. Not reliable in early age because the bone mineralization must be reduced by 20 to 40%. There is a Q-score for the radiological severity of metabolic bone disease. These are the X-ray of normal, grade 1, grade 2, and grade 3. In normal X-ray, we can see the white line. In the grade 1, we see the absence of white line with thinning of the cortex. Whereas in case of grade 2, there is a white line absence, thinning of the cortex, and the flare metaphysis. Grade 3, that's lead to the pathological fracture. Dual energy X-ray absorption, that is DEXA, is a gold standard technique for assess the BMD, the bone mineral content, that is BMC, and the bone mineral density. About DEXA, it is expressed the bone calcium content as a gram of hydroxyfolate per centimeter square. Normative data are available. Preferred target region is lumbar region, forearm, and the calcaneum. But there is a limitation of the DEXA scan because this is expensive, not portable. Movement artifacts are absorbed in the DEXA. Radiation exposure are more. Limitations of normative data. Another markers we can diagnose, it is quantitative ultrasonography, which measures both BMC and organic matrix. The parameters we can use is the speed of the sound and the bone transmission time. The quantitative ultrasonography is usually performed in the tibia. SOS increase and BTT decrease, then increase in the BMC and strength of the bone. The quantitative ultrasonography is another way to diagnose. The advantage are this is a portable, inexpensive, non-iodizing. The limitations are a small window for result, uncertain relationship between SOS, sorry, not widely available. A screening of BMD. Why routine screening is required? Thank you. Why routine screening is required? Clinically present with poor extra-uterine growth, increased ventilator dependency, not winning from the ventilation, have prolonged respiratory disorder, accidental finding of fracture. These are the screening tools. In addition, metabolic bone disease has a long-term consequences, including short stature, osteopenia in the young adult. In a recent prospective study, that is 30% of the extremely low birth babies develop metabolic bone disease, out of which 1/3 develop fractures. Cases with metabolic bone disease have 3 times higher mortality and longer hospital stay. That is observed in the respective study. The another question is arise whom to screen. There is another guidelines with American Academy of Pediatric, UK guidelines, and CHOP study. All have a general consensus of less than 1500 grams to be screened. Gestational age have a variation around less than 28 weeks. TPN all have the same consensus, or who have given taken more than 4 weeks of TPN have to assess. And when and how frequently to be screened. The age first to be screened is 4 to 6 weeks, and the monitoring should be weekly. These are the flow charts, how to screen. If two parameters, alkaline phosphatate more than 900, phosphate less than 5.6, then you have to screen for the secondary PTH, TRP, and vitamin D level. Elevated PTH more than 100 and low phosphate. So calcium, vitamin D deficiency, supplement calcium. If the vitamin less than 20 nanogram, we have to supplement with vitamin D. Repeat calcium phosphate and ALP and PTH in 1 to 2 weeks and adjust the dose of calcium and phosphate accordingly. Prevention and treatment of metabolic bone disease, early enteral feeding. So you have to practice where if there is no contraindication of feeding, we start with the enteral feeding, at least that should we start with MEN. Fortification of breast milk should be in our aim to optimize the calcium and phosphorus, minimize duration of TPN, at should be less than 4 weeks. Avoid prolonged use of bone active medication like diuretics, corticosteroid, caffeine, all leads to the chances of metabolic bone disease. Mechanical stimulation, frequent change of position. What should be the calcium and phosphorus intake? And there is another guidelines of academic pediatric, SPAGAN, WHO, and CFS, all according average 150 to 220 milligram of calcium per day and 75 to 140 gram of phosphorus milligram per kg per day, and vitamin D 400 to 800 unit per day. Why do add supplement in the preterm breast milk? Because the human milk contains less of calcium and the absorption is also 60%. So you have to fortify with HMF or infant formula. Supplementation with calcium and phosphorus when further increase cannot be made by the fortification. The starting dose is 20 and maximum dose is 70 to 80, and about phosphorus half 10 to 20, and the maximum should be 40 to 50. The another modality is the treatment of metabolic bone disease. In the phosphating metabolic bone disease, concurrent calcium can be given along with phosphate to ensure calcium phosphorus between 1.5 to 1 or 1.7 to 1. On TPN, optimize phosphorus phosphate level. High dose of vitamin D supplemented only when the vitamin D is less than 20. There is no role of adding vitamin D if the level is more than 20. Role of active vitamin D, no role of protein management, only indicated presence of kidney disease, liver failure, and genetic defect in vitamin D pathway. There is another Cochrane collaboration study which is done for the metabolic bone disease, which shows the physical activity program for promoting the bone mineralization and growth in preterm infant. And the result was the data is inadequate to allow assessment of the harm and long-term effect. The current variant does not support the routine use of physical activity program especially in the case of preterm infant. Post-discharge follow-up. In exclusive breastfeed, very low birth weight infant, the measurement of ALP is suggested 2 to 4 weeks. Post-discharge and ALP is more than 800 to 1000. The mineral supplementation is needed. The guidelines for transitional high mineral containing product, the decreased mineral intake, either by the less human milk, fortified or formula should be given at a body weight of around 2000 grams. Delaying the switch till 300 grams. Infant on fluid restriction, especially less than 150 milligram per kg per day. For infant with a prolonged course of parental nutrition, persistent elevation of serum APA more than 800. These are the guidelines to transition high mineral content product. To summarize the metabolic disease in few words, screening of metabolic bone disease in premature infant is largely driven by risk factor. It is most commonly associated with deficiency of calcium and phosphorus and opposed by the vitamin D. Due to lack of normative data and clinical trials, there is no one established screening practice for metabolic bone disease in premature infants. The most common biochemical screening are the alkaline phosphate, and calcium level, but each test has their own limitations. TRP and PTS level are also important. In lab tests, the concerned radiological X-ray should be considered. However, the metabolic bone disease is not detected on X-ray in the early stage of the life. DEXA scan has some role, but there is a not widely available, very expensive, and more chances of radiation exposure are there. The TBL quantitative ultrasound shows promises, but remain primarily as a research tool, not for routine use. Common practice of universal phosphate supplementation for all neonates with metabolic bone disease should be discouraged without prior PTH measurement. These are all about the metabolic bone disease.
Thank you for excellent detailing of the common complications of prematurity. First, the clear-cut message should be that we are already supplementing the vitamin D routinely. But for the susceptible child, premature babies, we must go for a follow-on at about 2 to 4 weeks. By doing these investigations, alkaline phosphatase, vitamin D, calcium, phosphorus, and if possible, the DEXA scan of the lumbar spine. This would be the message, because in susceptible prematures, particularly on corticosteroids having neuromuscular problem because of low physical activity, vitamin D metabolism is less. So the message should be, though we are not only administering the vitamin D, but these susceptible children must be followed up at about 4 weeks of life for these investigations. Thank you. Thanks a lot.
Thank you, sir.
Thank you. Thank you, Dr. Vinay. You have timely finished. And thank you, chairpersons, for chairing the session. Now, moving to next session, which is on very important topic, enteral feeding in preterm babies, infants. So for this, our speaker is Dr. Ashok Mittal, sir. And to chair the session, I request Dr. Shiv Bachan Singh, sir, Dr. S.D. Agarwal, sir, Dr. Rupesh Kumar, and Dr. Nishant Kumar to kindly come on dais and chair the session and introduce the speaker. And I welcome Dr. Ashok Mittal, sir.
Good afternoon, everybody. I think this is the second talk of Dr. Ashok Mittal. So he has been already introduced to the audience. In short, he is Director of Pediatrics and Neonatology at Cloud9 Hospital, Gurgaon. And I request him to straightway start his talk on enteral feeding of preterm infants. Thank you.
शुक्रिया सर, बहुत बहुत शुक्रिया सर। पिछली बार थोड़ा ज्यादा टाइम ले लिया तो इस बार मैं थोड़ा सा मुद्दे की बात करूंगा। तो जब भी हम न्यूट्रिशन के बारे में बात करते हैं तो अगेन न्यूट्रिशन इज आल्सो an important area when it comes to a concept of survival which is intact neurologically, so which means intact survival. Now intact survival में अगर आपको विश्वास है तो आपको न्यूट्रिशन में विश्वास जरूर होना चाहिए। क्यों, हम पता करते हैं। So sir, survival की जहां से बात आती है कि earlier days when we were resident or senior resident, we were very excited with ventilation and hemodynamics. एंड पहले हम वेंटिलेशन पे बहुत एक्साइटेड थे, फिर हम थोड़ा सा हमने हेमोडायनामिक्स को इंपॉर्टेंस दिया, फिर न्यूट्रिशन कहीं पीछे रह गया है। कहाँ पर हम जब लखनऊ में हम काम करते थे, रात रात में 3-3 बार एक्सचेंज ट्रांसफ्यूजन, एक मैंने 3 एक्सचेंज ट्रांसफ्यूजन करते थे, तो न्यूट्रिशन कहाँ बैक स्टेज ले लेता था। तो न्यूट्रिशन बहुत इंपॉर्टेंट है। वो क्यों है, उसके लिए काफी स्टडीज हैं अब। तो वेंटिलेशन, परफ्यूजन, इन्फेक्शन प्रिवेंशन और न्यूट्रिशन, उनको इंटैक्ट करने के लिए आपको वेंटिलेशन को जेंटल करना पड़ेगा, परफ्यूजन को जुडिशियसली यूज करना पड़ेगा, हर डक्ट को बंद करने की जरूरत नहीं है दवाओं से। एसेप्सिस इज मोर इम्पोर्टेंट, इन्फेक्शन कंट्रोल इन एंटीबायोटिक स्टुवर्डशिप इज मोर इम्पोर्टेंट, इफ रिक्वायर्ड जुडिशियल यूज ऑफ एंटीबायोटिक। अभी भी मेरी यूनिट में एम्पिसिन, जेंटामाइसिन इज द फर्स्ट लाइन मेडिकेशन। तो ये है जो हम फॉलो करते हैं। सेफोटैक्सिन, थर्ड जनरेशन सेफलोस्पोरिन कभी भी फर्स्ट लाइन नहीं है हमारे यहाँ। न्यूट्रिशन में प्रिवेंशन ऑफ ईयूजीआर, सो आईयूजीआर अगर बच्चा पैदा होता है या लो बर्थ वेट, वेरी लो बर्थ वेट, वी विल फोकस ऑन वेरी लो बर्थ वेट 1.5 एंड लेस। सो उसमें प्रिवेंशन ऑफ ईयूजीआर मतलब एक्स्ट्रा यूट्राइन ग्रोथ रिटार्डेशन इज आवर प्रायोरिटी। ओवरऑल इफेक्ट इज नो लेस देन वेंटिलेशन एंड परफ्यूजन मैनेजमेंट सर, क्योंकि इसमें ब्रेन डेवलपमेंट से लेकर रेटिनोपैथी, इम्यूनोमॉड्यूलेशन, हेल्दी गट, reducing incidence of necrotizing enterocolitis, protein growth, osteopenia of prematurity, BPD, PPHN, PN, postnatal cholestasis, ये पेरेंटल न्यूट्रिशन एसोसिएटेड कोलिस्टेसिस, ये सारा का सारा प्रिवेंशन हो जाएगा इफ यू टेक केयर ऑफ न्यूट्रिशन वेल. सो आई कॉल VLBW, लोग VLBW जानते हैं लेस देन 1500 grams. मैं बोलता हूं इट्स अ न्यूट्रिशनल इमरजेंसी. सो एवरी VLBW may not require ventilator or cardiac assistance, right? You may have a 1250 grams which is absolutely fine. ना उसको ऑक्सीजन की जरूरत है, ना CPAP की है, ना आइनोट्रोप की है, ना फ्लूइड बोलस. But nutritional emergency is always there, because let us look at a premature baby or an VLBW baby as a baby who has come out prematurely or in debilitated state, but his or her requirement has not stopped. So the moment you cut the placenta, the requirement is ending. But then if you now put the child only on 10% dextrose and not give any protein, it is difficult for the baby to cope up with it. So it's almost like आपको मैं 4 दिन उपवास में सिर्फ चीनी पानी ग्लूकोन डी मिला के पिलाऊं, तो जो आपको फील होगा 4 दिन बाद में, वही बच्चे को भी फील होता है. It's just that he or she can't say. So goal is to achieve growth rate and body composition of a normal fetus at the same post-menstrual age. मतलब जैसा अंदर में वैसा बाहर, वो संभव तो नहीं है पूरी तरह से, लेकिन जितना क्लोज हम जा सके वही हमारी उम्मीद है. इससे प्रीमेच्योर बच्चे हम सबसे ज्यादा कंट्रीब्यूट करते हैं पूरी दुनिया में. वी आर नंबर 1 इन मेनी थिंग्स एंड दिस इज आल्सो वन ऑफ देम. वी कंट्रीब्यूट ऑलमोस्ट 23% ऑफ वर्ल्ड प्रीमेच्योर बेबीज. एंड इतने बच्चों को देने के लिए हमारे पास चैलेंजेस भी उतनी ही हैं. यहाँ पर ये देश ऐसा है जितना हेट्रोजिनस है कि इसमें मैलनरिश मदर विथ लो वेट, एनीमिया, good poor antenatal care guidance, ये सब की वजह से the challenges become even more, because the start is bad, the antenatal care nutrition is bad, and now the baby is born prematurely with low birth weight. Then the problem is very, very bigger. It looks much bigger. So better nutrition. Why is nutrition so important? It does not only relate to immediate outcome like growth, sepsis prevention, neck prevention, BPD prevention, but also long-term health and quality of life. It also ensures integrity of GI tract. इसीलिए हम early enteral nutrition करना चाहते हैं. And there has been association shown between weight gain and long-term neurodevelopmental outcome. Studies are there. I will not go into details. The presentation will be saved here. Anybody can take. Infants in the lower quartile of in hospital, जिन बच्चों का weight gain lower quartiles में हुआ था compared to higher quartile weight gain, उनमें बेलीज जब किया गया डेवलपमेंटल स्कोर, तो वो स्कोर्स वेर मच लेस देन द वंस जिनमें हायर स्कोर मोर देन 21. सो 12 ग्राम पर किलो पर डे की जगह अगर 21 ग्राम पर किलो पर डे में आप कंपेयर करें तो न्यूरो डेवलपमेंट आउटकम 21 वाले में ज्यादा अच्छा था. हम कौन सा दूध चाहते हैं? माँ का दूध, ह्यूमन मिल्क, मॉम्स ओन मिल्क, MOM. क्यों? शॉर्ट टर्म बेनिफिट्स काफी सारे, लॉन्ग टर्म बेनिफिट्स अब आ रहे हैं. Reduce incidence of obesity in future, reduce incidence of diabetes, asthma, allergic disorders, and so on and so forth. और भी बहुत आएंगे उम्मीद करता हूँ. शॉर्ट टर्म तो आप सबको पता ही है, जिसमें ह्यूमन मिल्क ओलिगोसैकेराइड is taking a very prominent space, probably because of commercial infant formula, because they want to come up with one new thing each time. So this time HMO is in the wake, and I have to go and talk in various platforms for HMO. Also, HMO is important, was always there. It is just that it has taken the spotlight. माँ के दूध में HMO तो पहले भी था, ये नहीं कि अभी आया है. तो ये प्रमोट करता है healthy gut colonization को. So this is one of the prebiotic. So the concept of prebiotic, probiotic and postbiotic. Prebiotic gives rise to all these things. And उस तरह का एक prebiotic का नाम है human milk oligosaccharide, जिसका example है 2FL या इस तरह की चीजें. फ्लुकोजिलेटेड लैक्टोज होते हैं ये. लैक्टोफेरिन, एपिडर्मल बोल रहा हूँ, एपिथेलियल ग्रोथ फैक्टर, हेल्दियर इंटेस्टिनल माइक्रोबायोटा. In fact, a baby who is born with normal delivery will have a different microbiome compared to that which is born by cesarean, and especially with relation to bacteroids, which is very protective. So the kind of flora that you have inside you is very different when you have good maternal nutrition, antenatal, safe natural delivery, exclusive breastfeeding for first 6 months, complementary feeding introduction at 6 months of age, and continued breastfeeding till 2 years of age. That's by WHO. So उसी में 1000 days concept आ जाता है वगैरह वगैरह. So nutrition की importance जताना मतलब एक it's not a 1-day task or 1-hour task. MRI brain also showed region specific effects of human milk on growth of thalamus, basal ganglia, hippocampus, cerebellum, and also white matter connectivity and neurosynaptic connections. So ye thalamus, basal ganglia, hypothalamus, these are all areas which are related to emotions, not cognition just. So cognition se bhi hai, lekin emotion hai. So emotional growth and social growth is also good if the child is breastfed. बहुत सारे और रिसर्च है, मुझे थोड़ा स्किप करना पड़ेगा. The other alternative in case there is not enough milk is PDHM. What is PDHM? PDHM is pasteurized donor human milk. So coming from government medical colleges where we didn't have other opportunities, other available options like pasteurized donor human milk commercially available. So we used to have that milk only, and उस समय तो pasteurized भी नहीं होता था. हम लोगों ने तो उस वक्त अपना ब्लड भी दिया हुआ है यूनिट के अंदर सर. जब बच्चे को चाहिए होता है इमीडिएटली, कोई स्क्रीनिंग नहीं, कुछ नहीं. मौलाना साहब में वो सब भी हो चुका है. So those days are different, but आज की neonatology is very, very different. We can't even think of doing anything like that. We'll be behind court in the bar, court of law standing. So it doesn't guarantee total destruction. So अब जब हम पास्चुराइज करते हैं तो कुछ एडवांटेजेस है, कुछ डिसएडवांटेज. इट डिस्ट्रॉयज द वेजिटेटिव फॉर्म ऑफ बैक्टीरिया एंड वायरसेस, डजंट गारंटी टोटल डिस्ट्रक्शन ऑफ spore forming organism. So spore forming organism still can remain there. The disadvantage is microbiota is totally inactivated by the act of pasteurization. However, HMO, lactose, glucose, LC-PUFA, epithelial growth factor are preserved, and lactoferrin growth factors, lysozyme, immunoglobulins are destroyed. So there are various pros and cons of doing this thing. There are some absolute contraindication to enteral feeding in a VLBW, major GI malformation, refractory shock, critical congenital cyanotic heart disease, neck, suspected IEM in first 24 hours after severe asphyxia. So feed initiation is one thing. Say, suppose there is a sick child in the unit, say 1100 grams on ventilator, on inotrope, has PD on 3rd day, being treated with indomethacin or ibuprofen, whichever, has central lines in place. So generally residents will be very apprehensive in starting enteral feeding. But then there are different researches, and I've combined everything, that the presence of well-placed line, if the lines are well-placed, so suppose you have a umbilical artery catheter which is blocking the splanchnic circulation, then you have a problem. But that's not because you fed, because the line is a problem and is at an area where the vascular supply for the intestine will come out from. So you can't block that area, right? If your umbilical artery catheter is well placed, either high or low, then you have no risk of continuing with enteral feeding. So enteral feeding aap jaldi start kijiye. Children who are born with less than 1.5 kilo, they can receive the entire amount of enteral feeding, 60 or 80 ml per kilo, from day one if they are mechanically and hemodynamically stable. All these presence of umbilical catheter, need for ventilation, inotropes are no longer contraindications to initiate enteral feeding, especially if human milk is available. If you want to start formula milk for some reason, you may have to think twice, and that's your call. So importance of minimal enteral nutrition or trophic feeding, जिसको हम पहले कहते थे, is important because we know that अगर हमने दूध नहीं पिलाया तो venous atrophy हो जाएगी, and prolonged enteral fasting can lead up to 50% of loss of mucosal mass, cryptus, and enterocyte apoptosis. It was proven in the neonatal pig studies that within 8 to 12 hours of starvation, portal superior mesenteric artery blood flow reduced by 50%, epithelial cell apoptosis or programmed cell death started, and venous atrophy was also there. So these are things that we need to keep in mind. And the advantages are of minimal enteral feeding is it enhances resistance to neck, it promotes interstitial peristalsis, it promotes enzymatic activity, blood flow, barrier function, and also improves the microbiome, which reduces infection. Now, in this picture, you can see the picture above is a well-fed child, which is enterally fed from day one. And you can see the nice structure of the villi, they're long, slender, villi which are equally formed, and that increases the surface area, subsorptive surface area, and absorption is better. However, the one below does not have a well-formed villi. How do we progress feeds? Progression of feeds also has been a topic of debate. And if we go by the recent, there was one study by Dr. Sushma Nangia, which was published in 2019, where early total enteral feeding versus early partial enteral feeding. So suppose the child is 1200 grams and you want to start, and the baby is stable otherwise, like no tummy upsets, no refractory shock, maintaining oxygenation well, even on ventilator. We normally start the entire feeding on one day. So day 1 पे 60 ml per feed calculate करके वही enteral feed हम OG feed करके देते हैं. So this was done, and it was published by Dr. Nangia that early total enteral feeding in a stable baby, which is less than 1.5 kilo, within the first 24 to 48 hours, reduces the time to full enteral feeding, the time taken to reach full enteral feeding, the need for IV access, parenteral nutrition, risk of late onset sepsis, and faster regain of birth weight. ये तो सभी जानते हैं कि हम जल्दी शुरू करेंगे तो हम जल्दी निकलेंगे, तो कॉस्ट ऑफ केयर सब कुछ कम होता है. डर कहाँ है? डर है नेक का, necrotizing enterocolitis. तो वो क्या होता है वो देखिए. A meta-analysis published in 2020 summarized existing randomized control trial comparing early total enteral feeding to early rapid family feeding progression and showed no increase in feed tolerance or neck. So if your other hemodynamic parameters are not doing wrong, you can give the entire milk feeds in children less than 1.5. This is, do not extrapolate the data to ELBWs. I'm not saying less than 1 kilo, but less 1 kilo to 1.5 kilo, we can start. Progression. There are two types of progression. So one is slow and the other is fast. 15 to 20 cc or 30 to 40 cc. दोनों को compare किया गया. Again, late onset sepsis के risk कम होते हैं. Time needed to reach enteral feed, stay और postnatal cholestasis, ये सब कम होगा. Neck बढ़ा कि नहीं? There was no risk of increased risk of neck, feed intolerance और mortality. तो ये भी हो गया कि भाई slow या fast? Fast is the answer. Speed of increasing feed trial भी हुआ था, जिसको SIFT trial कहते हैं, उसका भी results काफी कुछ इसी से था, मिलता जुलता. Indian trial जो मैं बोल रहा हूँ, ये भी फिर सिद्धार्थ रामजी सर ने कराया था, and this was published in I think इसका year मुझे याद नहीं है, early aggressive feeding था. So even in 750 grams onwards, they tried to do slow versus fast feed, and the results concluded that neonates with aggressive regimen have fewer days on IV fluids and reach full feeds enteral. Incidence of neck was comparable. It was not high. So जहां भी population में 1 किलो के ऊपर definitely आप full enteral feeding पहले दिन से शुरू कर सकते हैं. जब मैं इंग्लैंड में काम करता था 2003 और 4 में, तो वहां पे जिस यूनिट में काम करता था, they used to stop feeding and keep the baby fasting for first 5 days in cases of reverse endosteric flow in umbilical artery. तो absent या reverse endosteric flow, abnormal Dopplers में, and I was wondering why. And then a few years later, the research came, ADAPT trial, the data came that they randomized कि 24 घंटे में देंगे versus 120 घंटे में, मतलब 5 दिन बाद देंगे, and there was no difference in the incidence of neck. So अब वो चला गया कि ADAPT मतलब endosteric flow abnormal है या reversed है, तो हम feeding नहीं देंगे, उसको fasting रखेंगे 5 दिन. These are gone things. So if you do it, it's a problem. And these are recommendations. If somebody deviates from the recommendations and doctor is pulled to the court of law, remember, these will be cited, these trials will be cited. Why fortification? Fortification is important. And we start fortification. पहले हमें बताया जाता था अगर 160 फीड है तो हम 120 पे शुरू करते थे. 120 ml per kilo जब एंट्रली टॉलरेट कर लिया. अब फिर 100 पे आए, फिर 80 पे आ गए. अभी तो लोग 50 पे भी कर रहे हैं. बट टेक्निकली 50 में थोड़ा अनकंफर्टेबल मैं फील करता हूं एक 1200 ग्राम के बच्चे में. सो आई जनरली डू इट एट 100 cc per kilo, which is 2/3 of total enteral feeding. Once that is reached, I am happy to do fortification. These are nutritional requirement. अगर आप देखें तो जैसे जैसे बच्चा फुल फीड पे आएगा लगभग 10-12 दिन में, वैसे वैसे प्रोटीन का कंटेंट आपके माँ के दूध में कम होता जाता है. कोलोस्ट्रम में शुरू में ज्यादा होता है। अब उस वक्त फोर्टिफिकेशन अगर हम नहीं करते हैं तो बच्चे का ग्रोथ ठीक नहीं होगा। So recent Cochrane also 14 randomized controlled trial, a total of over 1,000 infants were enrolled, and no increase in neck, and obviously early feeding, good weight gain, and all those positive effects on the development outcomes were seen. We use human milk fortifier, and we've gotten good results with that. Thankfully, our patients can afford it. For those who can't afford, it's a problem, and there are other options as well which you can look into. Monitoring of such children should be ongoing. There is a confusion about orogastric and nasogastric tube, but then in the RCT that compared determining the effect of an oral versus a nasal gastric tube for enteral feeding on episodes of hypoxemia or bradycardia in infants with apnea or prematurity, the trials did not confirm an advantage of one over the other. The routine dictum that we follow is if there is a child who has got some kind of respiratory assistance requirement, HFNC, CPAP, कुछ भी, उनमें हम oral gastric tube डालते हैं, और जिनमें ओरोग्रेस और कोई रेजिस्टेंस रेस्पिरेटरी सपोर्ट नहीं लग रहा है जिसको, उसको हम नेजल ट्यूब डालते हैं. सो बिकॉज ओरोगैस्ट्रिक ट्यूब में एक वेगल नर्व स्टिमुलेशन होने का चांस रहता है, और दूसरा रहता है कि चाइल्ड परसीव्स अ ट्यूब एज अ कंस्टेंट फेनोमेनन, एंड व्हेन इट इज टाइम फॉर हिम टू डू सकिंग एंड एनएनएस एंड एनएस, देयर इज अ कंफ्यूजन. Too early feed or 3 early feed, again, won't go into the details. One study, the meta-analysis of 4 trials has shown that there is no difference in any stage of neck, feed intolerance, time to reach full enteral feeding. Either आप 2 hourly दें या 3 hourly, but typically 2 किलो के ऊपर 3 hourly और 2 किलो के नीचे 2 hourly is a good this thing. Feed intolerance is something that I really want to touch upon, and this is more for postgraduates because they are the ones who will be resident and senior resident and will actually stop the feeds overnight. They are the ones to do it. Usually consultants will not even come to know if one feed was stopped. Feed intolerance is actually very, very subjective phenomenon. It is very subjective. It lacks evidence and is inconsistently applied internationally, not just in India, but internationally also. There is a tendency, depending on the doctor on duty, कि उसको क्या लगता है, पेट थोड़ा सा बढ़ गया है, नॉन इन्वेजिव वेंटिलेशन पे है, बंद कर दो फीड, ओवरनाइट बंद करो, एक फीड बंद करो, वो एक उल्टी कर दिया, 5 ml गैस्ट्रिक रेसिडुअल वॉल्यूम निकल गया, they stop. So this has to be given more importance. Otherwise, sir, 5 minutes or less. Otherwise, there will be problems and child will take more time to reach full feeds. The problem is not the stay. The problem is that to maintain the delay in reaching full feeds, you will have to depend either on a central line, which will lead to collapsi, infection of the central line, or if you're not giving central line, if you're giving everything through peripheral line, then there is a scope of or risk of having bad extravasation injury. So in दोनों को prevent करने के लिए, it's good that we use the enteral route and we go fast because science is in our favor. If something happens, the panel is going to favor you. So there are usually 2 ways by which we. Why is it not moving? Sorry. No. So there are traditionally 2 ways by which we tolerate feed intolerance. One is gastric residual volume, जो हम aspirate करते हैं, और दूसरा है abdominal circumference. Gastric residual volume is a very tricky thing because up to 3-4 ml of gastric juice is always there. So you can take it out. One, you will be confused and you will stop feeding. Second problem is that you are continuously taking the acid out. So that will cause slowly electrolyte imbalance. Abdominal circumference का ऐसा है कि जो रेजिडेंट लेगा उसका भी वेरिएशन देखा गया कि कितना वेरिएशन हो सकता है. 1 सेंटीमीटर 2 सेंटीमीटर नहीं, 3.5 सेंटीमीटर तक का वेरिएशन देखा गया बिटवीन रेजिडेंट्स, बिटवीन यूनिट टू यूनिट. बिकॉज पेट तो सर पूरा पेट है, आप कहाँ ले रहे हैं, फीता कहाँ से कहाँ ले रहे हैं, ये बहुत वेरिएशन है. सो और जनरली ये बोला जाता है कि एब्डोमिनल सर्कम्फ्रेंस जब 2 सेंटीमीटर से ज्यादा बढ़ जाए तो आप नर्स को बोलिए गैस्ट्रिक रेसिडुअल वॉल्यूम देखेगी, एस्पिरेट करेगी. अदरवाइज रूटीन एस्पिरेशन इज अ थिंग ऑफ पास्ट. जितना पास्ट वो हो चुका है ना, बच्चे को उल्टा लटका के धप 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 करना, उतना ही पास ये हो चुका है कि हर 2 घंटे में फीड के पहले आप एस्पिरेट करें, ठीक है? क्योंकि गैस्ट्रिक रेसिडुअल वॉल्यूम आप फॉलो करेंगे फीड इंटॉलरेंस के लिए, तो आपका जूनियर डॉक्टर बार बार बंद करेगा फीडिंग और आप कभी भी नहीं पहुंच पाएंगे फुल फीड्स पे। तो आप यूनिट का प्रोटोकॉल कर दीजिए कि गैस्ट्रिक रेसिडुअल फीड बंद कर दिया जाए, अनलेस इट इज बाइल, अनलेस इट इज ब्लड, दोज आर डिफरेंट सिचुएशन. I'm talking about just the simple secretions that come out.
Dr. Mittal, we are running short of time. So
Sir, we are done.
Fast.
Sir, we are done. So ESPGHAN guidelines and our own proposed protocol, choice of milk is mother's own milk, followed by pasteurized donor human milk, and last is preterm formula. Fortified DHM is conditionally recommended over preterm formula in preterm infant less than 32 weeks or less than 1.5 kilo. Typically, time to reach full enteral feeding is 7 days in VLBWs and 2 weeks in ELBWs. Trophic feed should be started and kept for at least 72 hours in less than ELBW and for 24 hours in VLBW. Contraindications are mentioned: 2-hour feeding in ELBW and 3-hourly feeding above 1250 grams. Progression could be fast, increased by 20 cc per kilo per day, 45 at 80 cc per kilo per day, and NNS should be started at 32 weeks. KMC should be started. Feed intolerance के लिए आप लोग जरूर से प्रोटोकॉल बना ले यूनिट के, and that's about it. Thank you so much.
Thank you, Dr. Mittal, for such a nice talk and such an important topic of enteral feeding in preterm. I hand over to Dr. Rupesh for any comment.
Thank you. We learned so many. Thank you, sir, for the nice presentation, and we have learned so many things. And we have to take home message. We should start feed. If baby reached, what is my experience and not experience by the study. If baby weight reached 1 kg in 4 digit, so we should not have fear to start feed. We can start feed 60 to 80 ml per kg. Rapidly we can progress feed. So there are 2-3 indications. If baby have any congenital malformation, in nutshell, if baby have any GI malformation, major GI malformation or CHD, in that case we have to delay the feed, and otherwise we can feed. So there are so many advantages. And which feed to start? We have to say mother milk, because the milk bank should be available. So mother milk, what exactly we are facing problem, mother milk is not easily available in the unit, and we don't have milk bank all across unit, because so many units are there, and there is, as I don't know how many milk bank is not present here, sir. So we are facing problem in giving feed. So that is the one we can
all over India. I think there are 20 to 25 milk bank, but that is required just for a population of 1 lakh. And we are a population of 140 crores.
Sir, sorry, but sir, actually what I remember, 53 milk bank was there in 2019, sir.
Okay, so that must be the recent. But even that is very, very less. Very less. And like when I was in Calcutta, SSKM had one, but they would not give the milk to us in private sector, as if though there is a continuous tiff between government and private. अरे बच्चा तो बच्चा है, किसी बच्चे की जान बचेगी. Thank you so much. Thank you so much.
As a shortage of time, so no questions.
So thank you, sir. So thank you, chairpersons. Now we have an online session. Dr. Girish Gupta, he will be talking on artificial intelligence in neonates and its application. And to chair the session, I request Dr. Shravan Kumar sir to kindly come on dais. Dr. Anil sir, HOD Pediatrics, Vidya Medical College. Sir, please come on dais. Dr. Pankaj Kashyap, who is Assistant Professor, Department of Pediatrics, Patna Medical College, and Dr. Muhammad Israel. Sir, and I request chairperson to introduce the chair speaker, and then we'll start the session.
Firstly, is my screen visible? Am I audible? Hello? 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 Hello.
Now we are starting a very new topic, artificial intelligence in neonatology. And I should say that we are proud that he is Dr. Girish Gupta earlier was about to come here, but in the last moment, DM inspection was there in his institution, so he couldn't come. And I will like to introduce him. His HOD neonatology in Himalayan Institute of Medical Science, Dehradun, and is a retired admiral and Army Medical and HOD of Armed Force Medical College, Pune. And we should say that he is the commenced first DM neonatology of India, and he has more than 45 innovation, and he is the author of 4 books. And Protocol of Neonatology Fellowship, he has done 1 year, Neonatal Nursing Fellowship 1 year, Neonatal Transport Certificate course 3 months. Near future, he is doing his institution DM neonatology, neonatal nutrition and core interest is the clinical neonatology, teaching, learning, and HR development and technology. And I should say that this artificial intelligence is now in the future we have to adapt, and by this way the neonatology will be very easy. So without taking much time, I am inviting Dr. Girish Gupta to present his deliberation.
Thank you, Dr. Shravan Kumar. Am I audible and visible?
Yes, sir.
Is my slide visible? Is my screen visible? Hello?
Yes.
Okay, fine. Okay. So good afternoon, everyone, and heartiest congratulations to the... Hello?
Please wait, sir.
Achha, all right. Okay.
Yes, now you can.
Okay. Good afternoon, and my heartfelt congratulations and gratitude to the Bihar neonatology team. I'm really indebted to Dr. Shravan and Dr. BK Singh. Because of them, whatever neonatology I know, they have been my co-partners in common learning program in the country. So thank you very much for giving me this opportunity. I really wish to be present in person because such talks need both verbal and non-verbal expressions to make them effective. But whatever is best possible now, we are trying to do it. Now, I, for one, always believed in our original words. And Indian in particular, and in India, the people from Bihar in very specific. It's a genius group of doctors in Bihar. And you do whatever you do most meticulously in great depth. And therefore, when I was asked that what I should talk in the Bihar Neocon, I just thought of 2 topics. One was artificial intelligence and other was of communication skills in neonatology. Both are way apart, but I thought I would talk on a topic where Bihar takes lead and shows the country that how it can be used most efficiently. And right at the outset, I feel very happy when I was analyzing the neonatology setup in Bihar. I found one of the smart NICU in the country in the city of Patna, and that is Dr. Shravan's unit. So congratulations, Dr. Shravan, and I would like to have more smart NICUs in Bihar in the country. Now, I'm basically a naive, I have no experience in artificial intelligence, except that I started exploring it for some time and trying to use in my domain of work. But my aim today would be to create timely awareness of AI and to emphasize how important it is in the coming future. So I would say that either embrace it today or just be a follower of others. Choice is ours. So let us embrace it today. Now, it is important to understand that whatever we practice, we are practicing for our neonate, and we must understand him. And here, neonate is telling us, then don't disturb me, leave me alone. I want intact survival. I want a developmentally supportive care. And if we have to give that, we must use artificial intelligence most optimally and to the hilt. A time is coming when more application of this will leave our babies more and more intact. Now, it's a question that, is human intelligence enough? Answer is both yes and no. And why I'm saying yes, because we are saving babies and they're doing wonderfully well. But then there are problems with us today that our neonatal survival rates are not improving beyond certain range. We lose babies. We do investigations either ineffectively or don't analyze them. The treatment is not most optimal. We don't do adequate counseling. And then there are many more flaws in the management practice. Now, we all are sincere, but still not being able to do all this. Can we take help of something? Yes. Therefore, we need to be supplemented today. And this supplementation would come by machine intelligence. It's a time that all of us use our intelligence most effectively, but whenever there is a scope, get the machine intelligence into place and see how a win-win situation would be created, both working together. And that is why I always say that if you have to do very strong neonatology, take industry on board. So when there is a doctor, neonatologist, and local manufacturer together, we'll have the best equipment and best care. Likewise, today, it is our intelligence and machine intelligence should come together for the most optimal outcome of our patients. Let me discuss the scope of artificial intelligence. And why I showed this slide is just to show that every system, every organ, every tissue, every cell, either in particular or body in general. For example, in case of SIRS, infection related, all organs are getting affected. So you have a scope of its utility. I call it as an omni cell for every cell. It has its utility in all levels of prevention, be it primary prevention, secondary prevention, or tertiary prevention. Monitoring, treatment, follow-up, counseling. Counseling is one domain where we are still very suboptimal. And that is why all the problems occur when it comes to patient-doctor relationship and subsequent developments. Though I shall be touching tomorrow on this topic when I talk of communication. It could also be adequately explored in the domains of training, research, trans-specialty work. We should also develop collaborations. It could be used for a unit, for a case, for a state or a country. When it comes to beneficiaries, it could be neonate, mother, father, and public. And this list can go on and on. It is just left for our imagination. Therefore, if we have such a tool available, which helps us in all the domains, why not to embrace it at the earliest? A bit about machine intelligence. It's a technical component. I do not want to discuss at length, but suffices to say that we want to generate large amount of data. And this data should go into the various machine programs. So data collection, data analysis, and it should be massive data. Whatever data you can collect from unit, please collect from whichever source, historical, monitors, therapeutic units, sideline investigation, everything. collect that data. And once data is collected, massive data, we'll have some outputs coming by using various algorithms, models, associations, analysis. And then these outcomes will be converting into certain useful outcomes. And they could be in terms of giving us a better diagnosis, better predictions, writing guidelines, writing various standard practices, discussing on the counseling, future planning, and so on and so forth. And therefore, it is important that we must generate our data. It starts from there. Because we are excellent clinicians. But when we talk on objectivity, we become very subjective. Our case was like this, but when we ask how many cases, what happened, though we are changing very fast, but still there is a need to generate data most effectively. And once we generate this data, we will be able to use that data in terms of artificial intelligence. Now, I want to give you a little caution and make you a little worried person, in the sense that AI is fast changing. It is encroaching every walk of everyone's life. And so much so today that the concept of digital twin is coming, which means that we will create a human being whose all responses through sensors, DNA sequencing, other analysis would be done. And all even trials can be done on that particular so-called artificial human being, which is a digital twin. So which drug, how much drug, which procedure, and to this level, things are going to take place. Therefore, it is very important that we must start embracing it. Hence, at times we feel that is our role going to be replaced? Maybe yes, if we don't awaken ourselves. Therefore, it is important that in addition to a clinician, let's become a health informatics specialist. Start generating that information, start relating with them. So let's be a combination, let's be a hybrid person. So we are clinicians, but we should have some information about health data and certain processes related to it. That would make ourselves a very secure professional of tomorrow. Otherwise, there is a possibility that your job could be questioned. When I sit in my institution here, whatever things I used to make as a progressive plan for the institution, and which used to take me months, I'm being able to do in 5 minutes, which states that it is not only me who can do it, anyone who knows it can do it, and hence I could be replaced. So therefore, it's high time that we should be one up on AI and use it most effectively. It is the people who are with the time, they grow. Those who are not with the time, they are only subservient. We Indians have been subservient so far. Now the time coming that we should take timely action, and we should quote our studies, our data analysis to the Western world. Otherwise, we'll only quote England and US, but not India. The time that we must talk first. Last year, I was starting one of the online training program. It was an inaugural session. And there were people from 10 countries sitting in my inauguration session. And my talk was on AI somehow that time as well. And what remark was made by the Western world, Dr. Gupta, it seems that rather than Indians coming to our countries, we have to send our people to India. That is how, if we are with the time or ahead of time, we would do immensely well. And I have no doubt about our IQs, our sincerity and hard work. Let's embrace it today. I put some chat platforms. It's just a list. There could be many lists, so don't worry about the slides or whatever I have written. Just wanted to show you there are many chat platforms available. And if you have access to this, you just put a search word in that chat platform. It will give you a much longer list. Essentially, we are using OpenAI chat platform and Microsoft, which is Edge based platform that's being commonly used. I'll speak a bit about them so that you are more aware of it. And you can explore then any number of platforms which are customized to medical profession. You can have AI platform medical imaging, you can have AI platform a medical podcast. You can have AI platforms for neonatology in times to come. So there'll be enough lists. So you don't worry about these numbers. But what I'm trying to say is be conscious that you can probably retrieve them and use them. As I used to talk about apps on smartphones long back from, say, late 90s. And now there's a flooding of apps on smartphones which are related to your area of interest. Likewise, we must become comfortable with AI related to our area of work. So be on the lookout. About 6 months back, when I was just analyzing AI in PubMed-related publications in neonatology, I had just some 20, 25 publications. But when I analyze today, I find the AI-based publications on PubMed, even they are in hundreds, crossing maybe close to 1,000. And even Cochrane has started analyzing AI-based activity. So soon we'll have start getting meta-analysis more and more AI and neonatology. Be the lead person, not the follower. Embrace it. Now coming to the application of AI in different levels of NICU, this is just a small depiction, but just suffices to say that you can use it for organ diagnosis, organ support, organ monitoring, image analysis, predictions, electromedical records, decision support, counseling, QI, miscellaneous. And this miscellaneous is a hugely important. Means you can have anything and everything in addition. So this is for NICU 3, level 3. Likewise for NICU 2, you can again use it. So it's not that only a level 3 can use it. You have your any areas of interest. It will provide you. In fact, I can simultaneously open another laptop of mine and go to my AI platform, and I can generate information on all of these. Even Manu is a mother and neonatal unit. It's a diet unit, even for that. Here I am just putting at PHC level, some areas I've just mentioned. So suffices to say that my 4 or 5 slides have stated that there is no restriction for AI use, that it is only level 3 can use. It is for each and everyone, even in the OPD practice of newborn care, you can use AI. Now, I would like to mention once again about smart NICU. As our country is becoming smart, as our cities are becoming smart, so the NICUs also must become smart. And whatever I have shown here, these are just some of the things which a smart NICU can have. Sooner we have it, more comfortable practice we'll have, most optimal outcomes we will have, more controlled regulation we have, and more quality of work which we have. So please integrate everything. A smart NICU will have a better services, better research, better training, better monitoring, better counseling, so on and so forth. It's a time when we must practice teleneonatology. And I must tell you that way back in 1996, I gave a first talk nationally on teleneonatology. So many decades have passed, but still, in true sense, we are not using it, except for some of our units. It's a high time that we must practice at all levels teleneonatology to its hilt if we want to have a safe practice. The time again that we are working on neonatal transport services, which we are developing. I'm very happy to share just 15 days back, we have developed one of the advanced neonatal transport ambulance. And again, when you are transporting a baby, the huge role of teleneonatology. COVID has taught us telemedicine. So the teleneonatology we should all embrace. And I would be very happy to mention again, when I was searching on the net, it was a newborn care center of Patna, which came up. So congratulations, Dr. Shravan. I am sure many other senior colleagues of ours also must be practicing in the state of Bihar. Now, my experience with ChatGPT, just few weeks or months back, I thought, let me experience it. I found it to be very exciting, highly beneficial, but cautious. Need to double check. It has a great future. And if you want to fully exploit it, maybe you can have a paid version. You have to have some premium registration. There is some amount. It costs you something about $26, $27 a month. But those who can exploit it, it is no money. The amount of facility it provides. Now, I want to give a little comparison that at the moment, two which are most commonly used by us are, or which I use in my 2 laptops simultaneously to build up my interest areas. One is Chat GPT, which is 3.5, is a paid one. Another one is a Microsoft Edge Bing. Now, both are very, very useful. But something only basics I'm going to tell you that Microsoft Edge Bing is essentially a search engine, but it gives you a very fast, specific searches. While Chat GPT is a real intelligence, you give him question to Chat GPT, if it will generate answers, customize as if a human being is going to customize and give you answers. So my request would be explored. The other thing is that Microsoft Edge is free, while Chat GPT 3.5 is a paid version. Maybe next one will come shortly, which will be again a paid version. Google is trying to come up strongly, but it is not yet giving its platform in India at present. Maybe soon we'll have this as well. So Microsoft Edge is free, useful to be explored, maybe more precise, and it also gives a facility for image creation. Now, Chat GPT, I'm just re-mentioning that it would enhance patient care, teach better, do research, innovation, publishing, mentoring, leadership, network, and miscellaneous. I give you example. Now, you just write in Chat GPT, say, for example, any counseling for that matter. Counseling of a baby for whose ELBW, whatever has been just talked, all these bullets will come. Or when feeding of a low birth weight baby, all these bullets will come, which you would like to spend time with parents to explain. Or if you want to teach somebody and you want to say, okay, I would like to talk on nutraceuticals or micronutrients, these will come. So use it. And you will explore that it is very, very exciting and very, very helpful to each one of us. Though it's very important that we must know pros, but at the same time cons also. Don't take it as a foolproof. It's a gospel truth. There could be errors, and errors could be even at the algorithmic level. Even decision making can become wrong. Therefore, we must have an oversight for everything. Like, for example, I just wrote few chapters, and my chapters got written maybe less than a minute, but all references were not appropriate. Or if you suppose write a prescription which has 10 points, well, maybe all 10 could be correct, but maybe 8 could be correct. So these artificial intelligence cannot replace human beings, and do not trust them 100%. Which you don't trust anybody in an ICU because you always double check. Ethical considerations. Patients' privacy security should be taken care. There should be informed consent. Equity should be taken care. Access to care is a question, and many more. Plagiarism. Again, whatever is coming in the AI is again put to check for plagiarism because they have taken from somewhere. Please keep it a note for. Now, ChatGPT live experience is worthwhile. Since I'm at an online session, I may not be in a position to show you, and because also the time limitation, but it may be a good idea that please go to ChatGPT, have your own experience. The future is for scientific attitude, not a doctor. I call each doctor a medical scientist. Enjoy a profession as a science. Generate data, do a rigorous data capturing, analyze it, have friendship with the people who are professionals in the computer data related issues, customize with the help of them all the data with a targeted outcome for your setup, and you'll find you will do wonders for your patient care. But my bottom line here comes is that nothing must replace you being as a staunch clinician. That's the last word. AIs, technology, whatever it is, cannot replace you. And hence, you should behave in a manner, you should develop in a manner that whatever somebody says, I will check with my own hand. So that will give you the best answer. Therefore, to conclude, I could have written many points, but deliberately I deleted all of them. And I wrote that I embrace AI today, watchfully. There are many avenues which are coming in the domain of AI every day is the future. But again, be watchful for them and embrace carefully. Thank you very much for your time. I dedicate my talk to Swami Vivekananda. From him, I get a lot of aspirations, and people sitting in front, you are my source of energy. And thank you everyone for giving me this chance and giving me time. Thank you.
Hi, my friend, Dr. Nigam here.
Hello, Dr. Nigam, sir. How are you?
Wonderful talk. And you are still so, modern. You are getting The in-depth of AI, I'm really impressed.
Thank you, sir. It's your greatness.
Thank you, sir. This is a artificial intelligence. Everyone is using that. Google is also using, and many all the business is using artificial intelligence. And you are opening our eye that we should be also ready to accept artificial intelligence in our domain also. Yes, it is a time to be ready for that. Yes. Thank you, sir.
Thank you very much. Grateful.
Anyone can ask. Thank you.
Thank you, sir.
Thank you
I think this was a very session. Thank you, chairpersons. Please have memento there on the. Now, moving further. Now, next session is management of neonatal seizure, and for this, speaker is Dr. Professor Ashok Kumar sir. So I request him to kindly come on dais, and to chair the session, we have Dr. Kumar Shambhunath sir. He is Professor Katihar Medical College. Sir, please come on dais. Dr. Mohammad Athar sir, he is Associate Professor at Nalanda Medical College. Dr. Richa Dalai and Assistant Professor AIMS Patna. So I request you all to please come, and Dr. A.K. Sahu sir, sorry, Dr. A.K. Sahu sir. So I request everyone to please come on dais and introduce the speaker, and we will start the session.
Or you can call Jayant Prakash also. Jayant Prakash is sitting here. Jayant Prakash. Professor Jayant. That's okay. That's okay. Can I have water? Yeah. Pani ho gaya. Pani ek piche rakha humne. Okay. That's good. So, Bidhi, can I start with the permission of chairpersons or?
Great time when a student introduces his teacher. So Dr. Ashok Kumar, he is Dean Research Institute of Medical Science, BHU, and he is professor in charge, NICU in Banaras Hindu University. He was former head of the department in pediatrics in Banaras Hindu University. He has done Commonwealth Fellowship in Neonatology from UK, ICMR International Fellowship from the Norway, and he got INSC Senior Scientist Award from the Germany and Hungary. He has around 100 national and 100 international publications, and he was president and secretary UPNNF. At present, he is also a president in Varanasi branch of Indian Academy of Pediatrics. So, sir, great time you are here. We will again learn from a very common topic, neonatal seizure, and we all know the common topics sometimes make it very, very difficult.
Okay.
So, sir, please start.
So, thank you, chairpersons, for your kind words. So, good afternoon. I bring you greetings from Banaras Hindu University and the holy city Varanasi and the holy river Ganges. At the outset, I am thankful to the organizers for giving me an invitation to talk on this very important topic. So I shift the gears from artificial intelligence to the seat of human intelligence, a real intelligence, that is the human brain. And one of its very common disorders, that is neonatal seizures. This is one of the most common problem in newborn babies. Approximately 1 to 5 newborns per 1,000 live births, they develop seizures. In contrast to older children or adults, most of the seizures in newborn babies are acutely provoked, but we used to call acutely symptomatic seizures. That means there is underlying brain injury or there is underlying cause. So we should always be looking for the cause, and we may have a treatable causes. One of the major problems in newborn babies and neonatal seizures is the clinical diagnosis. Seizures are both overdiagnosed and underdiagnosed, generally overdiagnosed. Paroxysmal events are quite common in newborn babies. These may be non-epileptic abnormal movements, but people will treat them as seizures with, of course, a lot of issues to the baby and a long-term outcome. If you look at the incidence of seizures across lifespan, there are two peaks. It is said that the neonatal period is the phase of highest incidence of seizures in life. But there's also second peak around 8th or 9th decade of life. Why newborn babies are more prone to seizures? Broadly speaking, we have excitatory and inhibitory pathways or systems. And in newborn babies, because of immaturity, the excitatory system is, it's more developed compared to inhibitory system. So overall, of course, there's a complex biology behind it. I will not go into it, but there is net, the result is the excitation is more compared to inhibition. So the newborn babies have more likely to have seizures. If you look at the etiology of seizures, so look at the size of these bubbles. HIE is the most common cause. 50 to 60% cases, you have HIE. This is also the most common cause of seizures on day 1 of age. The other causes are perinatal stroke, which remains unrecognized. In fact, this is the second most common cause of seizures in newborn babies. There could be brain malformations. Infections constitute around 5 to 20%. In our setup, probably the role of infection is more. And with the advances in medical science and more of genomics and TMS investigations, we have more of inborn errors of metabolism being diagnosed in the neonatal period, which can present as neonatal seizures. So as I mentioned, the clinical diagnosis of neonatal seizures is difficult. There's both overdiagnosis and underdiagnosis. This is a very interesting study. In this study, they showed 20 video clips of paroxysmal events. So to 137 physicians, mostly they were NICU physicians, and they were asked whether these are seizures or non-seizures. The average of correctly identified events was only 50%. So just flip of the coin. So now you can understand both. So normal events were labeled as seizures and the seizures were labeled as normal events. So now you can understand the difficulty in making diagnosis clinically of neonatal seizures. Personally, I feel that this was a Western data and probably we are more good at identifying the clinical events as seizures, but this needs to be validated. I'm not very sure of it. Now, if you look at the classification of neonatal seizures, this classification is provided by International League Against Epilepsy. So starts with any suspicion of seizure or any critical sick newborn. So this classification emphasizes the role of EEG, which is the gold standard of our diagnosis, because the clinically, as I said, both overdiagnosis and underdiagnosis. So continuous EEG monitoring is the gold standard. If that is not available, then probably amplitude integrated EEG will do, but it has its own limitations. So this will define the EEG whether the seizure or non-seizure. If it is a seizure, look at the clinical manifestations. Can I have an arrow here? Yes. So it could be electroclinical. That means there is an EEG correlate and there is a clinical manifestation. Or sometimes, in fact, in newborn babies, there could be only electrographic seizures. That means there's an easy evidence of seizure, but there is no clinical correlate. And in HIE, in most babies would have electrographic seizures. There may not be clinical manifestations. And if there are electroclinical seizures, this could be further. Okay. So it could be motor, non-motor, sequential, or unclassified.
In contrast to older children or adults, where we say these are focal seizures or generalized seizures, and newborn babies, the seizures are considered to be focal in onset. So the division into focal and generalized is not necessary in newborn babies, except barring few neonatal epilepsies or myoclonic seizures. Almost all neonatal seizures are focal in origin. So there are some management issues. The neonatal seizures, they frequently fail to respond to the most commonly used drugs like phenobarbital and phenytoin. 50 to 60% is the response rate. And both these drugs have acute side effects. And the phenobarbital also has long-term effects on the cognition. And in animal studies, both phenobarbital and phenytoin, they cause neuronal apoptosis, especially in the immature or developing brain. So this gives you a glimpse of how the anti-seizure medications have evolved or developed over a period of time. So if you look at this, the first anti-seizure medication was bromide. And this was, discovered in 1857, the time of first Indian revolt for independence. The second was phenobarbital. So what we use in newborn babies today is the oldest or second oldest anti-seizure medication. So you can understand. Lot of new compounds have come up. Your levetiracetam is the third generation, but still the drug of choice, of course, with many limitations remains phenobarbital. So what is your choice? You have a postgraduate students and practitioners here. What do you use for treating neonatal seizures? Anyone for phenytoin or levetiracetam? So there are few people, right? So there is a controversy, of course. People have used phenobarbital, phenytoin, and levetiracetam and other compounds. So let's see. Levetiracetam is a good, attractive choice because it's a good efficacy. The safety profile is good. And most data shows that this drug, in contrast to phenytoin or phenobarbital, does not cause neuronal apoptosis. In fact, it may have some neuroprotective effects, but this is yet to be confirmed or validated. But theoretically, it looks like this. So because of the, and this is also available in both IV and oral formulation. So many people started using levetiracetam for the treatment of neonatal seizures. So this is an important study which compared levetiracetam with the phenobarbital for neonatal seizures. It goes by the name of NeoLab-2 trial. In this study, the diagnosis, they use a gold standard for making diagnosis on neonatal seizures, that is continuous EEG monitoring, and not the clinical, the diagnosis. The sample size are pretty small, 106 babies, not large. One would have expected, let's say in the sport trial, there were 3,000 babies or 2,000 babies. Only 106 babies, 83 were analyzed for efficacy analysis. Briefly, the levetiracetam group, they started with 40. Seizures were not controlled. Then they gave 20 milligram, no response. They switched over to phenobarbital. In a phenobarbital group, they started with 20, no response, again 20, and then they switched over to the levetiracetam. Okay. So what was the result? So the efficacy, which was defined as cessation of seizures in 24 hours, again EEG wise, not clinically, was 80% in a phenobarbital group and only 28% in the levetiracetam group. So this was a huge shocker to the investigators. They didn't expect it. If there would be such a huge difference, but this was there. Of course, the sample size was small. They did observe higher rates of side effects with phenobarbital, which is well known: respiratory depression, cardiovascular instability, and other issues. So this is one management protocol for the neonatal seizures. You start with phenobarbital with 20 milligram. No response, you can give 10 to 20 milligram more. If there is no response, you can go either for levetiracetam or phenytoin. We go for levetiracetam. If there is no response, as a third line, we use midazolam. Some people, especially in the Europe, have used lidocaine as a third line agent. And if the seizures are still not controlled, then you send the patient to anesthetist. They will induce coma in the patient. So we follow this pathway. Phenobarbital, usually 20, then 10 plus 10, rather than giving only 20 milligram. I mean, there is no consensus. Some people would say 20, then 5, 5, 5, and 5. Total of 40 milligram. But we do 20, 10, and levetiracetam, and then midazolam. By and large, 90 to 95% of cases, the seizures will be controlled. So how long to continue anti-seizure medications? What's your idea? Postgraduates, what do you think? Would you give it for months or years or weeks or days? Can I have feedback? Bolo. Yes. Lot of silence. Why we should bother it? I mean, older child, you will give it for 1.5 to 2 years. Adults, you continue for a long time. So why we are concerned about the duration of anti-seizure medications in a developing brain or immature brain? Because there are consequences. And these drugs, especially phenytoin, phenobarbital, are not very safe. The brain is growing actively. So there's a possibility that we can cause more harm than good. That's why we are concerned about the duration. So there is a very interesting study which appeared last year, I think 2021. They compared two groups of babies. There the anti-seizure medications were discontinued at hospital discharge, 109, again a small sample, or they were continued. At the age of 2 years, they assessed these kids for neurodevelopment or epilepsy. And they did not find any difference. So the conclusion of this study was most newborns should not continue anti-seizure medications after hospital discharge, by and large. Not that every newborn baby you have to stop this seizure by the time of hospital discharge. If it requires 2 or 3 anti-seizure medications, baby is neurologically bad, EEG is terrible, MRI shows a lot of bad things in the brain, you might consider to continue anti-seizure medications. But by and large, as a policy, when the baby goes home after 1 or 2 weeks or 3 weeks, the baby should be off anti-seizure medications. So that is the message I want to give. The reason being, see, the people have used phenobarbital for the prophylaxis of febrile convulsions in the past. And there are studies that for each 10 milligram per kg of phenobarbital, there is a loss of 3 IQ points. So there are cognitive abnormalities, there are behavioral abnormalities. So we should not be careless in prolonging the duration of anti-seizure medications in neonatal seizures. So when do you suspect neurometabolic disorder? Around 1 to 2% cases, they will present with intractable seizures. There may be positive family history of seizures. And if you don't find any other cause, and I would present this case, this was an odd-born male baby with history of perinatal asphyxia. He had a complaints of feeding difficulty, seizures, hypotonia, and brisk knee jerks. Baby was already on 3 anti-seizure medications, but seizures were not controlled. Family history was interesting. This was a twin 1. The twin 2 died on day 7 due to sepsis. Elder sister, 9-year-old, was healthy. The eldest one, I happened to see her around 20 years ago. She died at the age of 8 years. At that time, we made diagnosis of developmental delay with seizures. MRI brain was done. It showed cystic encephalomalacia. We did not do molecular genetic testing that time, around 20 years back. In this baby, we did MRI brain. So what did you find? Do you find it? So there are a lot of cystic areas, multicystic encephalomalacia. Well, could happen in perinatal asphyxia. But you must understand, there are mimickers of perinatal asphyxia. Those disorders can present like baby can have the delayed, the transition, Baby may require resuscitation at birth, and there were too many cysts. So when we showed this MRI was done outside, we showed it to our radiologist. His first possibility was asphyxia, but at the same time, he also thought of it could be some metabolic disorder. There was family history, and there was no other obvious cause. So we did this exome sequencing, and it turned out to be sulfite oxide deficiency, which is a mimicker of perinatal asphyxia. So baby will require resuscitation at birth. There will be positive family history. Of course, there is no treatment. So one should consider if their seizures are intractable, and then the baby is getting multiple anticonvulsants. So I would conclude that seizures are common in newborn babies. The gold standard for diagnosis or neonatal seizure, the NICUs, it is not available. It should be point of care testing in NICU, not in neurology department. And despite its effects, phenobarbital continues to be the drug of choice for neonatal seizures, but it's only a matter of time before this drug is put into the dustbin of history. I tell you, the drug is toxic, causes neuronal damage. Since we don't have any other alternative, so we keep on using it. If we use it in older children or adults, the neurologist will be horrified. What are you doing? आप कर क्या रहे हैं कि phenobarbital दे रहे हैं बंदे को जाकर के. But in newborn babies, we don't have any other choice. In most cases, these anti-seizure medications should be discontinued before discharge, regardless of MRI or EEG findings. Barring few cases, you might have to continue. And suspect neurometabolic disorder if the seizures are intractable. So thank you very much. I will be happy to respond to any questions.
Hello, everyone.
So Shambhu, you have to ask me a question. Shambhu is my student. I think Shambhu, you passed out from PHU in 2009. So this is an opportunity for you to take revenge. Jayant is also my student, but very, very senior, 2 years junior to me. But of course, my senior is sitting there, Dr. Anil Jaspal. He was 4 years senior to me in BHU. Chalo. Sir. Okay, good. Yes, Jayant. Okay. Why? Because, I mean, we don't have any other choice. I mean, we thought levetiracetam would be a wonderful drug. And people started using it. But that led to the trial, NeoLab trial, which showed the mother, despite it was more effective, but Jan, trying to understand a point. As a physician, as a neonatologist, our idea is not only to control those jerks. We should always be looking at the long-term developmental outcomes. So what will happen to the baby at the age of 2 years or 5 years, that is equally important. So the babies who are exposed to phenobarbital, they would have a poor, the cognitive functions. So we need a new drug basically. As on today, no, but maybe next 5 or 10 years. I fully agree with you. There is no need to stop every single twitch. So if the baby is seizing and if it's infrequent, don't panic. The treatment choice is just stand there and observe the baby. In fact, not every seizure needs to be treated. Some of the babies may not require anti-seizure medications if they are frequent. Now, don't ask him what the definition of frequency. That becomes now a little bit more controversial kind of thing, right? But if it is causing cardiac or respiratory embarrassment kind of thing, or very frequent, then I would be a little bit upset, and then I will use phenobarbital. We were previously using levetiracetam off and on, but now the efficacy is there. We have to use it. But keep in mind the long-term outcome. That's the most important thing. If you keep that thing in mind, probably you will not be that much enthusiastic. despite knowing the fact that as on today, this is a first line drug. So the search continues for a better drug. Thank you for asking this question.
Sir, the question is,
so yeah,
you have talked about the electrographic seizures that is more common in the HIE, in
Yes.
which we are not getting any clinical features of seizure, but we are getting some changes in the screen.
Yeah.
So how will you treat this type of seizures?
Question is excellent. Answer is difficult. But I tell you, 80% of the babies with HI would have electrographic seizures, and there is no clinical correlate. Since most of our NICUs do not have that continuous EEG monitoring, so we are not aware of it. But let's say you are working in a very good NICU, you have that facility. Would you treat? People started treating because seizures per se can cause more harm. They can damage the brain. But recently there was a very interesting study again published in JAMA. So they compared two groups of babies, electrographic seizures plus versus electroclinical seizures. So, and they did not treat electrographic seizures. And at the age of 2 years, the neurodevelopmental outcome was same. So probably I would say if there are infrequent electrographic seizures, it's all theoretical. Don't treat it. If they are very frequent, you may be compelled to treat it. Many neonatologists who are doing neurology, they will say, look at the seizure burden. Seizure burden means if the seizures last more than for 14 minutes in 1 hour, if you're doing continuous EEG monitoring, 1 घंटे में 14 minutes तक that electrographic seizure is there, probably there's a higher risk of brain damage and you will tend to treat it. Or more than 40 minutes total seizure burden, not per hour. So more than 14 minutes in 1 hour, I'm talking of electrographic EEG seizure, or more than 40 minutes, then you will treat it. Otherwise not. So it's a difficult, the question is far from settled. I think we have to wait for the more data to come. Interesting question. Thank you. But don't overtreat. No. That's a ठीक है. But don't overtreat because this drug can cause more problem than good.
You see, I'm also practicing neonatology for last 33 years. Okay, now, but today we all have changed this phenobarbital to levetiracetam to begin with. You have used the phenobarbital. Most of the tests are still telling to use phenobarbital as the first line drug. I do differ, and we start levetiracetam as the first line drug. And if it fails, of course, then you switch on to phenobarb or phenytoin. As a neonatologist, I use fosphenytoin as the second line drug. And if not, it is working, then we use phenobarbital as a third line drug or so. So phenobarbital, particularly those NICUs who are having only level 2 facilities, means if you do not have ventilatory facilities, I would suggest that do not use 40 milligram of phenobarbital as the first line anticonvulsant drug. You try to give levetiracetam. It is more safe, less of respiratory depression. And of course, if it fails, you better use fosphenytoin. Even if this fails, then I will say that you should use phenobarbital, because a high dose of phenobarbital is associated with a lot of respiratory depression, particularly in prematures. HI's babies, they tolerate phenobarbital in a better way. So, and term HI's, if it is pre-term, so please try to use less of phenobarbital. As sir has already told that this produces more apoptosis and the neuronal damage, the learning disabilities. So all these things are concerned so far as phenobarbital is concerned. So yes, exam dena ho, aap bolo phenobarbital is the first line drug. But in the clinic, if you have to use some drug, you must have your support system also available. आपके पास केवल वो level 2 care है, केवल CPAP है, आप 40 milligram phenobarbital दे रहे हो.
Okay.
And once you have given it,
right.
And if there is apnea,
so point is well taken. I think.
Yeah.
So that means there's a controversy basically. Had there been no controversy, then we would not have discussed this thing. So the point is well taken, but I agree with you. We go by the published evidence. Ultimately, you have to go by what is published there, and sometimes our experience may be right, may not be right. I'm not undermining experience. Experience is important. We have been oxygen too much. We had retinopathy of prematurity. We use ventilation very aggressively. We had that chronic lung disease. So many things. So we have to maintain a fine balance between the benefit and harm. So if we understand that difference, that's a fine. Doctor, yes, Nigam sir.
Yes, my partner, we were faculty at many places.
So many places. Yes,
I have a question. Yes, I have a question.
Sir.
If a baby if is ventilated, as actually in the UK, sometimes it happened that they used to desaturate every few hours. And because they were on morphine, it was difficult to actually get the idea of a seizure, whether it is having or not. Then we used phenobarbital and it really worked. So do you think that those desaturations were seizure activities?
Well, episodic changes in autonomic nervous system like tachycardia, hypertension, or desaturation could be a manifestation. But if the baby is on ventilator and desaturating, my most common cause would be lung-related or ventilator-related issue rather than seizure, unless I am doing continuous EEG monitoring. That's why there is a place for this continuous EEG monitoring.
Yeah, that's true, but that they were momentary events, you see.
Yeah, could be there, but I will still think ventilation, I'm a lung problem, the baby is on ventilator and desaturating, tube, ventilator settings, lungs, lung pathology, all those issues.
Excluding everything.
Yeah, right. But I can't really answer it. Give phenobarbital. I would not add on this platform. I would not advocate it. But it could manifest as desaturation. Seizures can manifest as desaturation, tachycardia, and related things.
Okay, thank you.
Thank you. Interesting question. Yes.
One more question, sir.
Oh, please go ahead.
Sir.
Shambhu, this is the last time.
Sir, this is not the direct question. Just want to learn something. I have seen at least 3 cases in which there are so many anticonvulsant drugs that are all not effective and finally responded to pyridoxine that was given intramuscular injections.
In fact, because of time constraints, I could not do it. Yes, sir, but okay. So my last line is, in any intractable seizure, give 100 milligram of intravenous pyridoxine slowly. In any case of intractable seizures, because pyridoxine deficiency or dependency, whatever the case, right? Could be one of the. So thank you very much.
Thank you, sir. That was a very interesting and enlightening session. And we can take home 2-3 golden points. One is that seizures in neonates can be undertreated as well as overtreated. And we always need an EEG correlate in order to treat that. And as sir rightly pointed out, that seizure burden is very important. So we should not treat all electrographic seizures, but if the seizure burden is there, then definitely they should be treated. And we should always try that the anti-epileptic drugs, they should be discontinued as soon as possible. So these were the main points. Thank you, sir, for the nice session.
Thank you.
So thank you, sir. Good to see. Good to see interactive session.
Having great deal of mortality and morbidity, and it cleared all other points also that arise in the audience also. Thank you very much. Thank you, sir.
So thank you, sir. And thank you, chairperson. It's good to see so many questions, but because of time, we are limiting this interaction. So moving to next topic, it is on cholestatic jaundice, and speaker is Dr. Lalan Bharti, sir. And to chair the session, I request Dr. Bhupender Narayan, sir, who is head of department, pediatrics department, Patna Medical College. Dr. Ken Mishra, sir, Professor Ken Mishra, sir, Dr. Akhilesh Mohan, and Dr. N.P. Gupta, sir, to kindly come on dais and chair the session and introduce our speaker, Dr. Lalan Bharti. And there is a small announcement that this poster presentation, posters are there. It will be evaluated tomorrow. So those who have are there, so they have to be there tomorrow. Thank you.
आ गया आ गया ना सर आ गया सर आ गया सर डिस्प्ले दे दीजिए डिस्प्ले दे दीजिए पीपीटी खोलिएगा इसको चेक करना
Good afternoon, everybody. This session of cholestatic jaundice will deal by son of the soil, Dr. Lalan Bharti, who is fellow Afro-Advac, South Africa, executive body member, Central IAP Delhi in 2022 and 2023, President IAP East Delhi, National Coordinator IAP, President NNF Delhi 2022. He is Head of Department Pediatric JPC Hospital Delhi, and presently he is Executive Editor of Journal of Neonatology. And the topic is very important, cholestatic jaundice. So I request Dr. Lalan Bharti to start because we are running short of time.
Yes. Okay.
Thank you very much, sir. At the outset, I would like to congratulate the organizing team, Dr. Swan sir, Dr. Nigam sir, Dr. sir, and for giving me, I thanks from the bottom of my heart to all the organizing team, Dr. Jaiswal sir especially for having me here. यहाँ आना लगता है कि घर को आए, अगर कोई भी प्रोग्राम पटना में होता है तो आना बहुत ही अच्छा लगता है. तो थैंक यू वेरी मच एंड मैं उम्मीद करूंगा कि हमारे टीचर है भूपेंद्र सर, तो थैंक यू फॉर द काइंड इंट्रोडक्शन एंड आई हैव बीन गिवन द टॉपिक अबाउट द अप्रोच टू neonatal cholestatic jaundice. We all know that neonatal jaundice is a very common and important clinical condition during the neonatal period, occurring in around 60 to 80% of preterm and term neonate, and usually it is physiological and resolved by 2 weeks. Jaundice persisting beyond 2 weeks in term formula fade or more than 3 weeks in preterm breastfeed baby is called prolonged jaundice. And any infants with jaundice beyond the age of 3 weeks or 2 weeks must be investigated to rule out the causes which can be treated easily. So I'll be discussing the definition, etiology, investigation, approach to neonatal cholestasis, few case scenario, and eventually the conclusions. And all this will be discussed in respect to clinical guidelines, evidence, and practices. So what is the neonatal cholestasis? Neonatal cholestasis is defined as conjugated hyperbilirubinemia more than 1 milligram per dl in newborn or infant with the passage of high colored urine with and without clay stool. So you can, so for labeling cholestasis, we should have jaundice, dark urine staining the diaper, and clay color urine. Conventionally, the cholestasis has been defined as direct bilirubin more than 1 milligram if the total serum bilirubin is less than 5 milligram per dl, or direct bilirubin fraction is more than 20% if the total serum bilirubin is more than 5 milligram. However, as per the recent American Academy of Pediatric guideline, the direct bilirubin concentration more than 20 of the total is no longer regarded as necessary for diagnosis of cholestasis. So any value of the bilirubin, direct bilirubin in excess of 1 milligram per dl, irrespective of the level of total serum bilirubin, should be considered as cholestasis. So is it possible to identify that the baby is cholestatic jaundice without doing the total or direct serum bilirubin? So the answer is yes, as the urine stain clothes in the conjugated hyperbilirubinemia. Direct observation of urine and most importantly the stool is necessary component of assessment of jaundiced infant. Acolic stool and dark urine staining of the diaper often indicates presence of cholestasis and conjugated hyperbilirubinemia. So this inspection of stool is very, very important to establish the clinical diagnosis of biliary atresia. However, studies have shown only 63% of the healthcare professional can identify cholestatic stool correctly. A stool color chart may be very helpful to identify the stool color correctly. In Taiwan, use of a stool color chart has proved to be very effective with sensitivity of more than 95% to identify the pale stool. So this can be used and this can be kept in every clinic. So for PG, are the direct and conjugated bilirubin same? The answer is no. Direct and conjugated bilirubin is not the same. Direct bilirubin, which is usually measured by Dijo or Van den Waals method, that includes both conjugated as well as delta bilirubin. Then what is delta bilirubin? Delta bilirubin is conjugated bilirubin covalently bound to albumin. So direct bilirubin concentration are higher and more variable than the conjugated one. Now coming to the causes of neonatal cholestasis. There are various causes of neonatal cholestasis, and among them hepatocellulars are the most common, followed by obstruction of the biliary tract, then endocrinal and genetic diseases, and this spasticity of the biliary tract. In hepatocellular diseases, neonatal hepatitis, which includes the idiopathic giant cell hepatitis, other infection and toxic agent like torch, UTI, sepsis, parasitic infection like malaria, toxoplasmosis, and or other viral viral infection, and TPN. If the baby is preterm and on TPN for more than 2 weeks, then toxin, mostly this soya lipid, can cause the cholestasis in that. Other causes, metabolic causes include this galactosemia, PFHI, tyrosinemia, fructosemia, hematochromosis, and inborn error of metabolism. The endocrine cause include PFIC, bile acid disorder, neonatal hemochromatosis, and paucity of biliary duct include the Alagille syndrome. So Indian data published by Yacha et al. Showed etiology of neonatal cholestasis in India. This picture depicts the major chunk is contributed by hepatocellular, accounting around 53%, followed by obstructive cause, which is about 38% of the total etiology. So if we have leveled that this is a case of neonatal cholestasis, examine the stool. This stool could be equally called fluctuating. Then think of the biliary atresia. And other causes include Alagille syndrome, TPN associated cholestasis, and inspissated bile syndrome, CDC, etc. And if the stool color is pigmented, then we have to see whether child is sick or not sick. In well child, think of hypothyroidism, PFIC, CME, and if the child is sick, then it could be because of the sepsis or UTI. The other possibility in sick-looking child with pigmented stool can be underlying genetic or metabolic disorder like galactosemia, tyrosemia, and that can lead to the compensated liver failure. So now, how to approach a child with cholestatic jaundice? So for hepatocellular disorder, in hepatocellular disorder, the most of the baby is clinically sick looking. The stool color will be intermittently clay, and there would be increased SGPT or SGOT and prolonged PT, APTT, and which is not corrected. If you give the vitamin K, this will be the same. It will not correct it. In case of biliary obstruction, the baby will be clinically well looking. This is the main difference. In biliary obstruction, the baby will be clinically well looking, and persistently stool color will be clay. And so we have to see the color of a stool for 3 times. We cannot rely on the attendant. Clinician must see the stool color himself. And in this condition, biliary obstruction, there will be elevated AP and GTT. Now, how to investigate this baby? In hepatocellular cases, for infection, we have to do the septic screen. CBC, CRP, IT ratio, ESR, and blood culture. In the morning, we were thinking about the culture, septic screen. Nigam sir was saying that the septic screen is not to in the baby. This is just to exclude the baby. If you have done the septic screen in first time and baby is clinically sick, then you start the antibiotic, you can repeat the septic screen after 12 hours. If that is also negative, then definitely you can say that this baby is not having sepsis. So we can send the blood culture, and if sepsis is also ruled out, then we can send the torch infection and other viral marker If this torch infection and other viral marker is also negative, then look for the malaria, particularly if the baby is having fever. If sepsis and torch infection is also not there, then you just send the routine urine and routine culture. UTI also causes cholestasis. So you have ruled out all these things, then we have to look for the metabolic causes. In metabolic causes, send the urine for non-glucose reducing substance. That is Benedict's test. If non-glucose reducing substance is positive, then get the reduced erythrocyte galactose 1-phosphate uridyl transfer GALT enzyme activity analysis, and this is the confirmation for the galactosemia. If galactosemia is not there, then send serum ferritin and urine for succinyl acetone. If serum ferritin is elevated, that means it is hemochromatosis. If succinyl acetone is elevated, that is tyrosinemia. If there is history of sucrose or fructose juice given to the infant, that is not very common, then always assess for the aldolase B enzyme in liver biopsy, and that clinches the diagnosis of hereditary fructose intolerance. So if there is no evidence of infection, metabolic or endocrinic, all we have ruled out, then, and the baby is having intense pruritus and GGT is low or normal, then think of PFIC, progressive familial intrahepatic cholestasis, and which can be diagnosed by genotyping mutation. So if there is no evidence of infection, metabolic or endocrine, then think of the genetic causes, or this here it is written this TSH and all these things, but nowadays most of the center and most of the government hospital, they are doing a screening. In Delhi, we are also under this NEEP program. We have been doing this screening, all the 6 diseases. So TSH comes in the first tier, though here it is mentioned on the second tier. So we have to do all these things in the first tier. If baby is having hypoglycemia, feature of shock or micropenis or midline defect dysplasia, then we have to send morning cortisol or brain MRI to confirm the hypopituitary. If there is dysmorphic feature and multi-system involvement, in that condition, we need to do the karyotyping to rule out trisomy 21 or trisomy 18. If there is very high elevation of the GTT, say more than 20 times than the normal value, then think of Alagille syndrome, and that should be confirmed by the genetic assay. So if we have ruled out all these things, then we have to think of the liver biopsy. And the feature of giant cell transformation, diffuse changes, and cannulate color cholestasis is suggestive of idiopathic giant cell neutral hepatitis. So last one is the biliary atresia. So in biliary atresia, AP is elevated, GTT is elevated very much, that is more than 3000 international unit. And ultrasound should be done first after 4 hours of fasting, and the feature of ultrasound is absent or small gallbladder, and there is a characteristic feature of the triangular cord sign. And HIDA, so HIDA has very low specificity. We are not usually doing this HIDA. There is a chance for this HIDA we need to give 5 days courses of phenobarbital, and specificity is also very low. So usually we don't do this HIDA. And this is the liver biopsy. There will be the bile duct proliferation, bile duct plug, and peribiliary fibrosis. But the gold standard of the biliary atresia is intraoperative cholangiograph. That is the gold standard. So that has to be done before Kasai operation. So with this discussion, now coming to the 1 or 2 case scenario. So this is the 52 days old female child presented with on and off pale stool, which was progressive dark color of urine, started from the 8th day of life. There is no history of fever, lethargy, refusal of feed, anemia. So we have ruled out all these things, insufficient bile or TPN use. There is also no growth failure. And the most important in this is the bleeding manifestation responsive to the injection vitamin K. This is the color of urine, which matches with the abnormal color on the stool color chart. So on examination, there is significant jaundice and hepatosplenomegaly. So key points of this case: dark urine with diaper staining. So definitely this is a conjugated hyperbilirubinemia. Acholic stool in well child. That means there is some obstruction. Child is well and there is acholic stools. And vitamin K responsive bleeding. So that means there is some obstruction. There is no perinatal event, TPN uses, anemia. So that rules out TPN associated cholestasis or insufficient bile syndrome. Liver hepatosplenomegaly, so that points towards the portal hypertension. So every case of NEC, we must examine stool for 3 times. We should look for the dysmorphic feature, which will point towards the genetic causes. Eye examination should be done just to rule out cataract, vitamin A deficiency, or other this fundus for cherry red spot. The skin should be examined for pruritus or CLD stigma, and genitalia for the hypogonadism. So this was the investigation of this child. This investigation should mark conjugated hyperbilirubinemia with deranged liver enzyme. And the most important is the INR is corrected with vitamin K injection. So then we did the ultrasonography, liver 7.5 centimeter, coarse ecotexture, gallbladder not visualized, CBD not visualized, a spleen 8 centimeter, and there is no ascites. Again, is HIDA needed? We didn't do HIDA in this patient. So HIDA doesn't provide any extra information beyond what is provided by acholic stools. Having very low specificity and delayed the diagnosis and surgery, as this test need 5 days of phenobarbital. So HIDA has limited indication in modern day practice where liver biopsy is not available, or equivocal changes in biopsy, or the color of stool is not, we cannot make out the exact color of the stool. So role of liver biopsy. Liver biopsy remains the cornerstone of the diagnostic workup with cholestatic jaundice. It provides accurate diagnosis in 90 to 95% of the patient. And in addition to the diagnosis, it also prognosticates depending upon the fibrosis. So this is the picture of the liver biopsy. The classical histological feature of the biliary obstruction are bile duct proliferation, bile duct plug, portal and periportal fibrosis, edema with preservation of basic hepatic lobular architecture. So intraoperative cholangiogram is the gold standard for diagnosis of biliary atresia and may be followed by Kasai operation depending upon the diagnosis. In this patient, there was no proximal or distal potency. So this baby underwent KPA at 57 days of life. So this Kasai operation should be done as early as possible and ideally before 2 months of the age. We can see from these different studies that the several several studies that show that there is gradually significantly and gradual decrease in the mortality if we increase the age of operation. So ideally it should be done before 2 months. So fourth big post-op, this is the investigation. Stool started pigmented. And the final diagnosis was biliary atresia and post-Kasai operation was successful. So coming to the second case.
Time is over.
No, just 2-3 minutes. Sir. The second case, this is a 3.5 months old male child, breastfed, presented with jaundice since day 10, along with the progressive abdominal distension and failure to thrive. No history of bleeding, seizure or sensorium is altered, vomiting or extrahepatic involvement. Family history is significant with 1 abortion and 1 SIB death in 3rd week of life. Antenatal and postnatal is uneventful. On examination, child is lethargic, having jaundice, anemia, and bilateral cataract. Abnormal facies and per abdominal examination shows hepatosplenomegaly with ascites. To summarize the case, neonatal cholestasis with pigmented stool is sick child with decompensated, that is ascites, sepsis with failure to thrive. Besides anemia and hyperbilirubinemia, unlike previous cases, here INR is not responsive to vitamin K therapy. So sick infant with pigmented stool, with ascites, with hypoalbuminemia, with coagulopathy. There was recurrent abortion, SIB death, consanguinity, diarrhea, vomiting. Think of metabolic liver disease. These are the certain red flag signs of the liver disease, metabolic liver disease. So evaluation of the sick child with NCC. This has already been discussed that first we have to do the fasting blood sugar, then the urine for non-reducing substance. This is the Benedict test we did. Then second line is definitive for GALT assay and urinary succinyl choline. GALT stay before, and GALT assay should be done before giving PRVC. And the final is exon and this thing. So urine on routine, there was no sugar. Urine for reducing substance was positive. And GALT level was 5 unit per gram of HB. The normal value is more than 15. And this child was managed on so the diagnosis was galactosemia. And this child was managed on the lactose-free diet, and at 4-month follow-up, jaundice resolved and there was normal growth of the baby and the cataract is still present. To conclude with, jaundice in newborn beyond first 2 weeks of life is like total, we should evaluate the total and direct bilirubin. Neonatal cholestasis is direct bilirubin more than 1 milligram per DL. classify the cause based on the stool color and decompensation, to rule out treatable cause like sepsis, UTI, hypothyroidism, galactosemia. A stepwise workup after detailed history and examination is the key. Identify whether the patient is sick or non-sick. Sick, in fact, indicates infection, sepsis, and metabolic causes. Non-sick infant thriving well looks for the stool color. Equalic and fluctuating color stool points toward biliary atresia. And pigmented stool points toward FPC and CMB and Alagille syndrome. Ultrasound is the first screening test to be done fasting to evaluate gallbladder and bile duct. Liver biopsy is the most informative in experienced hand. And HIDA scan has low specificity. Intraoperative cholangiogram is gold standard for biliary atresia. And early referral is the key factor for better prognosis. So thank you very much.
Thank you, sir, for your detailed and nice presentation. We have learned so many things from you. Question wanted from audience.
No question. And all teachers are sitting here, so I don't think I expect any question from them. उन्होंने पहले ही पढ़ा दिया, पहले ही क्वेश्चन पूछा दिया.
Early to diagnose and early to refer. But this is the final comment. 6 साल में 6 गो
हम लोग डेवलप करें ना इसके लिए कि
आप डीएमसी में कर ही सकते हैं. आप प्रिंसिपल हैं, आप डीएमसी में कर ही सकते हैं.
बताया कि वायरल मार्कर को एक्सक्लूड करना है, हमारे यहाँ वही नहीं हो पाता. क्या एक्सक्लूड करेंगे हम? एक बहुत से टॉर्च करवा लेते हैं, बहुत हो गया. पोस्ट पर रहने से होगा. आप लोग कैपिटल में बैठे हुए हैं, आप लोग कर सकते हैं.
Just simply seeing the stool color and serum bilirubin. अगर हमें पता चल गया कि ये जो cholestatic jaundice है और early अगर we can send, so we can save the child, particularly the mortality and morbidity. Time is very, very critical. So thank you very much.
So thank you, sir. Thank you, chairpersons. Now, since we are running short of time, we have a fixed inauguration time. Many people have to connect online. So it's my humble request to the chairpersons to please be on time. We have last 2 sessions. I want to get it finished by 5:40. So please, I request everyone to maintain the time. Thank you. So next session is on genetic approach to congenital anomaly and perinatal deaths. For this, the speaker is Dr. Chaitanya Datar. So I welcome you, sir. And to chair the session, I welcome Dr. Professor Alka Singh, madam. She is HOD in Nalanda Medical College. Dr. Ashok Kumar, sir, from Hajipur. Dr. Mohan Kejriwal and Dr. Vibhash Ranjan. So I request all of you to please chair the session. I request Dr. Suman Mishra, ma'am, to please come and chair the session, and Dr. Prabhat. Sir.
Good afternoon. Good afternoon. It is my pleasure to chair this session on the genetic basis of malformations and syndromes. For this, we have a very noted speaker, Dr. Chaitanya Datar. He is MD in medical genetics, clinical and metabolic geneticist, program director of Sujanan Clinic. And he has held many Key posts, he has been executive member, Indian Society for Inborn Errors of Metabolism, chairperson genetics, sub-chapter Indian Academy of Pediatrics, in charge of fellowship program in genetics at Bharati Hospital and Research Center. He has 22 publications, 3 book chapters to his credit, and he has given over 70 lectures in Indian and international conferences.
Thank you, madam.
Thank you.
At the outset, let me thank the organizers for the second talk. Can I see my presentation, please? Switch. So I'll be talking on genetic approach to congenital anomalies and perinatal deaths. It will be more of a pictorial presentation just to initiate you all towards how the congenital anomalies are picked up and diagnosed. So essentially, when we're talking about a congenital anomaly, it is essentially an abnormality which can lead to structural or functional deficits which cause morbidity and mortality. These are actually visible structural defects that we would see, like CTEV or a congenital heart defect or some renal. So it can either be observed grossly or on systemic examination. So these are different types of ear anomalies that you can see. So various types of dysmorphisms is what we'll come across when we are evaluating a child. So you can see a ear pit, small ears, large ears, ear tags, elfine ears, and sometimes microtia. So similarly in hands also, you have numerous types of dysmorphism based on which we can diagnose various syndromes. So common congenital anomalies in through the antenatal period are typically neural tube defects, craniofacial abnormalities, skeletal problems, syndromic presentation, renal, cardiac issues, etc. So if you look at the commonest anomaly that is seen, nowadays the incidence has reduced because of improved ultrasound, but cleft lip, cleft palate is the commonest anomaly that you will come across, followed by a congenital heart disorder. Also, you'll find a lot of atresias, intestinal atrias and stenosis, which will be common. Now, overall, when we are looking at the incidence of birth defects, a single minor defect may be present in about 14% cases, single major in 3%, while about 0.7% will have multiple defects. So what is a minor defect? Essentially, a minor defect is a one which is not only of cosmetic significance. It's not going to have any major, functional consequences like a ear tag or an epicanthic fold, polysyndactyly. These are only essentially they're going to cause only cosmetic issues, not functional issues. While major defects are like cleft lip, cleft palate, or renal anomalies or cardiac anomalies, which are going to cause significant deficits. Various factors can affect form. One of them is genes, but a lot of antenatal factors like antenatal nutrition, supplementation, exposures, viruses, etc. can lead to problems. A genetic cause is responsible for almost 60 to 70% of congenital anomalies, while environmental to about 10%. 20 to 30% causes are yet unknown. Now, when we are evaluating the child postnatally, what we are evaluating is for visible abnormalities. So visible is features like dysmorphism, etc. For invisible abnormalities, you're using 2D echo, you're using MRI, you're using ultrasound to diagnose the internal defect. A very important aspect in genetics is a form, the structure of the individual. So once a patient walks to our OPD, we know the features and based on which we can diagnose various syndromes. So that is what is called GESTOT. GESTOT diagnosis is a physical diagnosis. Like for example, in this case, a neural tube defect, which can be isolated in the upper frame, while if you're looking at a neural tube defect, which is associated with a meningocele, associated with a cystic renal change, that is what is a syndromic neural tube defect. Sometimes CTEV as an isolated entity can just be because of some in utero influences like oligoamnios. Sometimes teratogenicity plays a major role, like fetal warfarin syndrome, fetal alcohol syndrome, congenital rubella syndromes, or fetal valproate syndrome. So these are exposures in utero which cause major anomalies. Now, abnormalities can be at various levels. So when we are evaluating a chromosomal abnormality, we are looking at the chromosomal as a whole through karyotype. If you want to look at any deletion syndromes like microarray, you're opening up the chromosome and looking at the chromosomal segments. While if you open up the chromosome to the rung of the ladder and you're looking at ATGC, that's when you're doing your sequencing. Commonest syndrome, Down syndrome, physical features along with a lot of anomalies diagnosable by karyotype. Patau syndrome, wherein you're going to get a cleft lip, cleft palate with a congenital heart defect, again diagnosable by karyotype, trisomy 13. Edwards syndrome will come with a clenched fist. Any neonate with a clenched fist, with a rocker bottom foot, always think of Edward and always do a karyotype in these children. Turner syndrome doesn't have a phenotype, but if you see that kind of a swollen feet, pedal edema in a neonate who's otherwise well, you can think of a Turner syndrome. Do a karyotype, it will show up as monosomy X in some cases. Look at the skin always. So if the skin is showing hyper and hypopigmented streaks, abnormal skin pigmentation, you should do a karyotype because you'll find mosaicism in the skin, which is here, it is in between chromosomes X and 7. Now, sometimes you're going to have multiple dysmorphic features. See this neonate with hypertelorism. You can see the abnormal ears, a severe microretrognathia, a significant sandal gap, which is noted. Now, this child had seizures along with dysmorphism. So all this put together, based on the dysmorphic features, we did a microarray. Microarray is going deeper than the chromosome, and it identified a 9q24 microdeletion. So when I'm doing a chromosome or karyotype, I'm looking at the book from outside and keeping it back. When I'm doing a microarray, I'm going to the chapter level. And when I'm doing an exome sequencing, I'm going to the page level and reading each page letter by letter. So till now, what we have seen is a chromosome level as well as a microarray. Now, when I'm doing an exome sequencing, I'm opening each page and reading each page letter by letter. When I'm reading a single line or a single page, I'm doing a Sanger sequencing. But when I'm opening multiple pages at a time, I'm doing an exome sequencing. Like this particular baby, you can identify based on a gross phenotype. You can see the second, third toe syndactyly with a single palmar crease and synorphis and the dysmorphic features. This is a case of Cornelia de Lange syndrome. Multiple genes are, could be one of the mutation maybe in one of these genes. So you're using an exome sequencing to diagnose this. See the combination. Always pattern recognition is very crucial in dysmorphology. Here you have a child with facial dysmorphism, tongue frenulae, a polysyndactyly, and the brain showing a molar tooth sign. So that gives us a clue that this is a case of orofaciodigital syndrome or Joubert syndrome. Then you have facial dysmorphic features like in this particular case, a Tricher-Collins syndrome on the left, when you have significant microretrognathia and underdeveloped jaw. While in the other case, what you're finding is this child has retinitis pigmentosa with obesity and a postaxial polydactyly. And this is a case of what is called Bardet Biedl. Now, all these are single gene syndromes wherein you need exome sequencing for a diagnosis. But here you are seeing a neonate who is overgrowth, has neonatal hypoglycemia, developmental delay. So essentially, this child has a very large tongue, and based on this, we know it's a case of Beckwith-Weidman. Beckwith-Weidman cannot be diagnosed by exome sequencing. It requires a methylation study for diagnosis. So we have to be aware that certain conditions cannot be diagnosed by exome sequencing, and it's not an answer to all the genetic syndromes. Then you're going to get overgrowth, a child with a unilateral limb overgrowth, like for example, a Proteus syndrome, or here you can see an abnormal pigmentation only on the half side. Now, these conditions are typically somatic mosaic conditions. If you do a blood karyotype or blood exome sequencing, it will lead to no answers. You need a tissue sample, a skin biopsy for a diagnosis. So not all cases, we must remember, can give answers on exome. So you have to filter down the cases properly and to reach a conclusive diagnosis. Like here, sometimes even the crying, this child, if he's not crying, it will not give you a clue. But once he cries, you know that this is a craniofacial macrosomia syndrome, and you know the genes which to look for. While a child with microcephaly, numerous genes are responsible, for which we need to do a whole exome sequencing to really diagnose these conditions. Then there could be some ophthalmic phenotypes, like children with cataracts. We have different differentials, corneal opacities. It could be torch or other conditions. There could be colobomas, which may be associated with other genetic conditions, or anophthalmia, microphthalmia, which may be noted in single gene conditions. Then the other phenotype that we come across, or anomaly, would be at the level of genitals. So always when we're evaluating, open up the genitals and look at the baby. Here it could be an excessive virilized female. So in the case of congenital adrenal hyperplasia, or under-virilized male, that also has genetic basis. And we have many genes which nowadays are known to cause a disorder of sexual development. So here you have a bifid scrotum, reduced rugosities, and it was an NR5A1 related DSD. Then you have skeletal phenotypes that would come across, like ranging from achondroplasia, where there's severe shortening, to hypochondroplasia, where you have short family members. So when we're evaluating family members, sometimes you get to know that what we are dealing with is a hypochondroplasia. Achondroplasia will have significant shortening. Then bone mineralization. So sometimes we need some X-rays and additional investigations to come to a diagnosis. On the left frame, you have osteogenesis imperfecta, under mineralized bones. While on the right frame, you have an infant with over mineralized. So there is significant dense bones along with a liver involvement and severe spasticity. So this is a case of neuronopathic osteopetrosis. Then skin also gives us a lot of clues. So looking at only the isolated, you can see identify the picture on the left. It's an ectodermal dysplasia, but sometimes the features can be very subtle, like very you can call it oligodontia with significantly wide spaced teeth and affected nails. So this is a case of Rapp-Hodgkin's ectodermal dysplasia. So based on the phenotype, you can come to a conclusion. Both are cases of ichthyosis. The one on the left is a harlequin ichthyosis, okay, and the one on the right is what is called as a congenital, the ARCI, that is congenital ichthyosis, and the genes for these are different. Ultimately, the diagnosis will be based on exome sequencing only. Now, we saw some cases of cholestasis earlier. So when arthrogryposis with renal dysfunction with cholestasis, you know the syndrome could be an ARC syndrome. So a pattern recognition is very, very crucial in genetics, while sometimes lesions would evolve over time. A neonate with the kind of vesicular lesions will evolve into a neonate with verrucous lesions and hyperpigmentation, which runs as streaks. This is a case of incontinentia pigmenta. So if you're looking at the child early, that is, at that point, you will find the vesicular lesions. But if you're looking at the child a little later, you will find the typical hyperpigmented streaks on the body. And this is an IP case. Then sometimes you will find phenotype of storage disorders being presenting, like non-immune hydrops. Lot many, like Gaucher disease, can present as a non-immune hydrops or with a severe hepatosplenomegaly postnatally. The only MPS type which can present earlier with a major dysmorphism is mucolipidosis. So it's a disorder of enzyme transport, and that can present much earlier. The other classical MPS types will come to presentation much later than that. So we have to be aware of these metabolic phenotypes also. Now, how do you really come to a conclusion, especially for students and those who are interested in evaluating for dysmorphology? You need to collect all the symptoms. So here what we have, there is some facial dysmorphism with a post-axial polydactyly, and there you can find a duplicated hallux. You can see the two thumbs there, and here you have absent corpus callosum. So you're putting this in OMIM. OMIM is Online Mendelian Inheritance in Man. It's a free website which is available, where you can put the dysmorphic features, put "and" as a handle in between, and that will lead to a syndrome. In this case, it's an acrocallosal syndrome if you're putting all these handles properly. Then, as we discussed earlier about artificial intelligence, here we do have AI in genetics as well, and this is something called Face2 Gene app. This app is freely downloadable, and you can download this app and you give the correct images, and that will help you in diagnosing the syndrome based on the heat maps. So here in this particular case, it's a case of Hutchison-Gilford syndrome. So once you put a proper pictures and you put proper dysmorphology handles, that will give us the answer that this is a case of Hutchison-Gilford syndrome. Cardiac causes for essentially, they are multiple and they can lead to sudden death. So usually syndromic cardiac causes may be noted in about 25% cases. In about 3 to 25% cases, you will identify a definitive genetic cause for the cardiac cause. So essentially, there are numerous, among which the VSDs are the common, the AVSDs are also fairly common. So essentially what we are dealing with, there are multiple cardiac anomalies which could have a genetic basis, but the yield of genetic testing in a isolated cardiac disease is much less. It may vary only about 3 to 10% if it's isolated, but to about 25% if it is syndromic. We have discussed about mortality in the morning. So mortality in the context of genetic disease is what I'll quickly discuss, and it's very crucial for you all to understand this. So when we are talking about any IUD or neonatal death, that is between 22 weeks of gestation in the pregnancy to 1 month postnatally, that is when we call it as a perinatal mortality. Though we agree that prematurity, sepsis, other complications do account for a significant percentage, what we now know is the large amount of asphyxias now can be attributed to a genetic cause. About 20 to 30% of unexplained IUDs may have a genetic cause which can be responsible for. These are the cases which must be carefully investigated. So perinatal deaths can occur because of inborn errors of metabolism. There could be neuromuscular issues, like a very severe SMA can also present, or congenital myopathies can present as an IUD or neonatal death. They could have neurological issues, etc. So 20 to 30% of unexplained deaths as such in the perinatal period could be genetic in nature. So just to give a few case-based examples, The previous child had a similar presentation. So at this particular baby at 24 weeks had presented with a subdural hygroma, with pleural effusion, with restricted limb movements and CTEV. Poor prognosis was explained, and this pregnancy was ultimately continued. The baby delivered. Now, what was crucial at that time, this baby was not going to survive. But what was important here, they've already lost one baby. So we collected our residents took pictures. They collected the blood sample immediately and stored the DNA. Patient was not affording, but they stored the DNA and took the pictures. Now that helped us. When the patient came back for counseling, we could study that DNA and identify that this was a condition of fetal akinesia deformation sequence or Pina-Choquet syndrome. So similarly, these kind of IUDs, when they occur, most of the times doctors, they're not very comfortable dealing with these situations, but it is very important to have proper documentation in place where you take proper pictures. If blood sample is not available, you can take a small piece of cord, a small 4 to 5 centimeters of cord, you just put it in saline and gentamicin and have a DNA stored out of it. DNA storage is not expensive at all, but that helps in giving out a diagnosis. Now, this particular fetus had significant, at 30 weeks, had edema, brain parenchyma had shown abnormalities. We suspected a lysosomal storage disorder, and it came out to be this complex condition called fetal akinesia with respiratory insufficiency, with microcephaly, polymicrogyria, etc. So when you're approaching an IUD or neonatal death, always take a good history and document it properly. Whatever dysmorphism you see, you can document it. Secondly, take photographs of the baby, because these notes are very, very crucial in reverse phenotyping when we do a genetic study. If possible, get an autopsy done if it is available at your local place. DNA storage banking is most important. You store DNA that can be utilized later for testing and try to investigate. Now, this particular fetus, I was called to the NICU to evaluate this because the baby was found to be dysmorphic. So all would agree that this baby has significant dysmorphism and contractures. Now, when I saw the father, he was also dysmorphic. Now, this turned out, once we did the investigation, it turned out to be a case of Freeman-Sheldon syndrome. Now, the risk of recurrence in the future pregnancy is almost 50%. So, you have to be very careful in giving a diagnosis because they have very high risk of recurrence. And if you ignore this, the poor family will again land up with an issue like this. So now sometimes in this case, you have clues like there is significant skin laxity, it's cutis laxa, there are hypoplastic lungs, hydronephrosis, etc. A case of cutis laxa type 1C. Now, in these cases like these, you have a very good clinical diagnosis at hand. Now, this baby, again, a second born, has dysmorphism, contractures, a congenital heart disease, MRI showing pachygyria, nodular heterotopias are noted, liver is showing calcifications. We know that this is a case of Zellweger. We have done a biochemical investigation also to confirm it's a Zellweger. But do we stop at that? Because just based on Zellweger, we cannot offer a prenatal for the subsequent pregnancy because the outcomes in this case are poor. So ultimately, what we did is we stored the DNA, lost the baby, but we could give a diagnosis to the baby later on and then offer a prenatal diagnosis for the couple's next pregnancy. As we have already discussed this about molybdenum cofactor deficiency. In cases of sudden deaths, it could be neonatal deaths, which are very sudden. There could be metabolic causes like a biotinidase or a MOCO or a fatty acid oxidation or urea cycle defect. In these cases also, always counsel the family to store the DNA and reach a conclusive genetic diagnosis, because we know a lot of cardiac channelopathies also can present as SIDS. So we have to be aware that essentially these cases can be recurrent in the future pregnancies. So we have to be very alert in diagnosing these. Now, a couple of cases here. Now, 2 babies. The first baby had died postnatally, had cardiomegaly, hepatosplenonephromegaly, they had hazy cornea, corneal ulcers, viral case. So a picture presenting like a torch group of infection. So the pregnancy essentially was, the baby died. Eventually they planned the next pregnancy, but ultimately the baby also had similar features and it turned out to be what is called pseudotorch syndrome. So wherever you're even suspecting infection, sometimes you are reaching a genetic diagnosis. So this was a case of Aicardi-Gouttiere. Doing some investigations, some extra investigation sometimes helps in reaching a diagnosis. Again, a 37-weeker C-section did not cry at birth. So usually a good birth weight baby not crying at birth is always should be, it should ring a bell that we are dealing with something which is not correct. And we shifted to the NICU, had seizures. Somebody was, in the NICU, they did an MRI and you can see the brain stem. It's so thin. The cerebellum is almost like a dragonfly. So that itself gives a diagnosis that it was a complex cortical dysplasia with brain malformation. So the baby did not cry because that the baby was weak or something of that sort, but it was because of the genetic disorder. Similarly, in this case, the second case, the first baby had similar presentation, a good birth weight baby, dying with seizures, lethargy, poor feeding, and altered sensorium. Again, the second baby had a similar course. Again, an MRI was done and it showed classical hypoxic changes in the brain. But here what we found is it is very unusual to have two good birth weight babies dying of hypoxia. So again, in this particular case, we could reach a diagnosis of hyperhomocystinemia, wherein the brain vessels were being thrombosed in the antenatal period, causing asphyxia. So always store the samples properly, collect 2 ml EDTA blood for DNA storage, or a cord piece, or if you have this should ideally be done pre-transfusion, because what we find, sometimes the babies are transfused and that leads to problems. This is just my last case that will come up. Okay, this is the last thing. So now sometimes how you can save babies, from the death. The first, I had shown this case in the morning. Essentially, the first child is a known case of VLCAT deficiency, my patient. Second, they did not consider prenatal diagnosis. Baby had a neonatal death at that time. And they came for a third pregnancy, and the baby was affected with the same deficiency. But the mother wanted to continue the pregnancy, so we started her carnitine and MCT. The baby was affected on newborn screening, but clinically well. So we could save a neonatal death if you do certain antenatal measures. Now he's almost 1.2 years old and he's doing absolutely well. So always have a good proper approach. So take home message would be, approach to congenital anomaly should be on a case-to-case basis. The genetic aberration can be at various levels. It's not only at a karyotype level or at an exome level, which will give all answers. So you have to filter each case properly. If an IUD occurs, you have to have a proper documentation, photographs, and storage of DNA. That is, DNA banking is crucial, and further genetic investigations have to be planned meticulously. Thank you.
Thank you, Dr. Datar, for this very interesting presentation. First of all, the clinical diagnosis is important, so everyone should be aware, or if they are not aware, they can now search online. And of course, because it provides a basis of genetic testing. And once genetic testing is done, you can offer counseling to the parents and tell them about the reproductive risk in the later pregnancy. So they can decide for themselves what to in the future pregnancies. And you have said that whenever we suspect a case, the samples should be stored and DNA analysis and other karyotyping, etc. So that was very interesting. I don't think there is much time, but
thank you, sir. Thank you. It's a nice talk, and you're a good orator, I think. Any question from audience, sir? No.
Which type of test we have got?
See, when we have
Down syndrome, we go for karyotyping.
Yeah.
Which we have to order and how you have
A simple way to understand is if there's dysmorphism,
phenotypes are not clear.
Dysmorphism, developmental delay, intellectual disability, autism. In the background of no consanguinity, you can opt for microarray as a first line.
Which type of testing?
As a microarray as a first line. So essentially, if it is dysmorphism associated with intellectual disability, autism, and no consanguinity in the family, you can opt for microarray as a first line. Otherwise, it should be a whole exome sequencing. We do not do whole genome sequencing. Whole genome is done currently only on academic research basis. Whole exome is opening up the coding region of 20 to 25,000 genes. That is a test of choice, whole exome sequencing. Clinical exome is a smaller version of the whole exome, which screens for 8,000 genes. It's like 8,000 pages you're reading at a time is whole, when you're doing a clinical exome. When you're reading about 25,000 pages at one time, that's a whole exome. So whole exome should be ideally done in cases when there is consanguinity, seizures, or you can fix it up to a gene level. Okay, so simple way to go about dysmorphic features, intellectual disability, autism, developmental delay, and no consanguinity. Go for microarray first before an exome, because microarray is opening up the book and looking at the chapter. When I'm doing an exome, I'm opening up each page and reading each page letter by letter. Okay. Yeah, microarray will not detect larger deletion duplication. It will detect very large ones. You know, for single gene deletion duplication, you require MLP. Karyotyping is very limited nowadays, only to Down syndrome.
No, not 100% Down syndrome. I mean, karyotyping negative does not exclude Down syndrome, because in mosaicism, karyotype will be negative also.
Usually, you will find karyotype is gold standard, so you will not miss anything on a karyotype if it is down.
Even in mosaicism.
Yeah, absolutely. Karyotyping is gold standard for Down syndrome.
I want to correct myself. In your slide, it mentioned the cardiac heart defect is in the lower side. I think CSD is the most common of congenital anomalies. And again, the most neonatal death of congenital heart defect.
Yeah, certainly. Congenital heart defects are most common. Major congenital anomalies are nowadays screened antenatally and they are discontinued. Those which continue, they are minor defects usually. So sometimes some of which may be symptomatic, some non-symptomatic.
It was very good, sir. And one thing just I want to say, say to the audience that especially in the recurrent fetal loss, it's very important that we should have a genetics counseling for the parents, because we know that tuberculosis is another category of the illnesses we can exclude. But if we screen for genetic screening, it will be very helpful for the parents and the family members.
That's true.
Thank you,
Dr. Chetan. You have elaborated very nicely the most untouched portion of the neonatology. Briefly told us about the verbal autopsy, AI, importance of AI in the diagnosis of so many syndromes, which we are in a search from the UG to PG. And thank you so much.
Thank you, sir, and thank you, chairpersons. So moving to the last session of the day, it is on clinical approach to respiratory distress in newborn. For this, we have Dr. K.K. Divakar, sir. So I welcome you, sir. And to chair the session, I request Dr. C.B. Kumar, sir, from Muzaffarpur, Dr. Akhilesh Kumar, NMCH, Dr. Ajay Kumar Singh, Dr. Rakesh Kumar, and Dr. Priti Kashyap, ma'am. So I request for you all to come on dais. Dr. Amit, please chair the session.
Good afternoon, everybody. Or I think it's evening. At the outset, let me thank Dr. Shravan for inviting me here and seeing so many friends. When I walked in my kurta, I found Dr. Shravan so well dressed. So I went and put on a tie. And I came back and realized Dr. Ashok Kumar is so relaxed and speaking. I feel I should have just come and spoken like this. Thank you. It's been wonderful being with all of you. As we have very little time, we won't waste much time and go ahead. The session that I've been asked to do here is something which is perhaps the largest number of conditions for which a neonate is admitted to the neonatal intensive care unit or any special care unit. These are basically my ideas. I may be wrong. So we'll brush through many things, and over tea, probably we can discuss if there are any queries. Definition is a very standard thing which we teach to all undergraduates, but this is not without its own problems, because I've had occasions where at Manipal and other centers, when I work there, I get a phone call and I walk into the ICU and I find a baby doing like that. And I asked, why did you not call me? He said, rate to 60 se kam tha. So it doesn't work. You should have something called common sense. Every time this definition of grunt and rate does not work, we must evaluate that there is some problem if the baby is breathing. Etiology is always a very important thing for us. And every distress is not pulmonary. This is also important because this is one of the photographs that I had personally taken. And I can assure you at this time, I was extremely tachypnic. And if I had one of my DM trainees there, they would have intubated me immediately. So one needs to know a lot of physical things produce tachypnea and distress. We have hypothermia, and pain. It is not uncommon to have a preterm baby coming to a unit with a grunt, only to know the temperature is 35 degrees. So before you start blowing around, just see what's happening. So while you're putting the baby on CPAP, etc., you may probably realize that this is not really an RDS that you're dealing with. It's purely just hypothermia. And you will sort it out and probably save the parents about 12,000 rupees. Pain is another important factor. Obviously, if you have an IV site that is extravasated, you will find a baby being tachypnic, and you'll be running all over the place to wonder how the baby is tachypnic, but saturation is very good, and you don't know what is happening. All you look at is a swollen IV, just take it out, babies are comfortable. There are many systems that will produce tachypnea. Of course, cardiovascular, we know, things like TAPVs are normal. Anything that produces acidosis will produce tachypnea. So we have to know, are we dealing with a metabolic disorder, whether it be any infection or so on and so forth, before we jump across and say, okay, let's get the ventilator ready, because ventilators are the most easily available. We forget that there's a person standing behind the ventilator that is more important than the equipment. Pulmonary causes are very standard. We have certain prototypes. We always say respiratory distress and meconium aspiration, two extremes. And of course, we have the late preterm infants. We have all these conglomerations that come together. Unlike in adults, in newborn, unfortunately, we have to keep on changing our goalposts. We cannot just wait and get a confirmatory diagnosis, take an X-ray, come back after 1 hour and then see. So we must always evaluate, diagnose, and our management has to be fortified and changed according to how we feel the changes are occurring. As soon as the patient comes, obviously you're taking care, you're taking the history, certain standard things. Are you dealing with a term baby, a preterm baby, or late preterm? So this is a simple thing that we had already discussed earlier. In history, simple things like, are you dealing with oligohydramnios? Or was it polyhydramnios? Was a person given antenatal steroids? You have oligohydramnios, the lung might not have developed properly. They will come with stiff lung because of various physiological problems that are there. What are the intrapartum situation? Was the baby resuscitated at all? How was the postnatal program? Was the patient all right postnatally? When did this respiratory distress start? If a distress is started after 24 hours in a preterm baby, you can be assured it is not classical RDS. It can be anything else but that. Clinical examination, again, we have various scores. Of course, general examination is always done. And we have down scores, Silverman score, etc. Pulse oximetry is extremely important in this case. And I'll be commenting a couple of things on the next couple of slides. And transformation has become a part and parcel of neonatal examination. Mind you, how much time we take to stabilize a baby from the time it comes into your NICU is the credibility. We can confuse the parents with a lot of gimmick, but within 20 minutes of the baby coming in, you should come to a diagnosis. What am I treating? What am I dealing with? Otherwise, it'll be just left to lectures that we'll be giving everybody. Investigation standard, X-ray and a blood gas. And now the new baby around the corner is ultrasonography. We'll comment a little bit about ultrasonography. Thanks to Dr. Pradeep Suryavanshi, who has given me all these slides and who tries to teach me and realizes that along with my hair, my brain is also decayed off. I'm not able to understand many things, but some things are interesting. It's basically a reflection that we are seeing with the 12 hertz linear probe that we see. We have some rib shadows that come up, and we see the A lines that are horizontal lines come up and the B lines that are present there with a gap between. This variation, the B line pattern, is what is actually deciding the pulmonary problem of lung, because we do not want to expose patients or babies to more and more X-rays. So probably lung ultrasonography will be the investigation for the future. And I think we should all be familiarizing ourselves with it. You have confluent B lines where you find that, yes, the A lines have disappeared, but you have still the rib shadow that is coming in between. Or you have what is called alveolar interstitial syndrome, where there are more than 3 confluent B lines, but still you notice that the rib shadows are seen here. Or you have a situation where rib shadow disappeared and these are compact B lines. All this tells you that there is some gap going on. There's a lot of fluid happening. And based on these things, some wizards like Pradeep come up with fantastic diagnosis, which I'm still trying to learn. I think maybe another 3-4 years, I should also be able to make some diagnosis. There are certain things in our management which we should know. Most important is avoiding hypoxia, avoid hyperoxia, avoid hyper and hypocarbia and acidosis, avoid progression of disease. This is important for us when we are dealing, and please avoid delay in referral. Treatments are very simple. Neonatology, very simple subject. Nothing to be very complicated. Give some oxygen, give some respiratory support, do good monitoring, and most of the time the babies recover by themselves. Monitoring is obviously the sheet anchor. We come for a specific and supportive care. Supportive care is another factor which people tend to forget. It is not antibiotics or surfactant that makes a baby survive, because then any baby would have survived anywhere, because both these things are available on the shelf. We forget the fact that the baby who is hypothermic, a baby who is hypoglycemic, who's hypotensive, they deteriorate much more. And this support is equally important for us. And obviously for managing complications. Monitoring is the sheet anchor of handling babies. How do we monitor? All of us put on a pulse oximeter and see. But what is important for us to know are the waveforms coming properly, because there is selective choice. If it is a night, then we are happy with saturation of 93 and 92. If it is daytime, we will change, because we have to see where the waveform is coming. If there's no waveform, your pulse oximeter inaccurate. So when we buy pulse oximeters, I always say, please spend a little bit more money and go for something with a waveform. We all monitor babies on a ventilator with arterial lines. Most people prefer umbilical lines. In our unit, we go for peripheral most of the time. Waveform of the arterial line is extremely important to be seen. Otherwise, very soon this line will go off, because nurses will put the hand in a funny position or umbilical catheter in a funny position to get the wave. But if the wave starts disappearing, within an hour or two, you're going to lose the line. And never flush an umbilical line if your waveform is going off, because you're pushing up an embolus straight up. Well, many lines which we normally put posterior tibial, but when we put the posterior tibial line, we have to know that when you're fixing, the toe must be very clear cut, because if the toe becomes wide, the line has to come out. No baby has ever died because it never had an arterial line, but many a limb has been lost because the doctor's ego or the hesitation prevents the line from being pulled out. Dorsalis speed is again a fairly good line if you can get it. It lasts for very long with no complications. Here also the toe is something very important one has to sort out. Avoiding hypoxia. This we are all very familiar with, and we do it very quickly. We give oxygen. And it's not at all uncommon for people to say that now the baby was requiring half a liter of oxygen, is now like 1 liter. Abhi 4 liter ho gaye, abhi mujhe refer karna hai. Please understand, flow is not equal to FiO2 when you are using non-blended oxygen. Because babies are obligate nasal breathers. So if you put something near the baby's nostril, it's half a liter of 100% oxygen. And babies are going to breathe that much. So your increasing flow is just fooling yourself, unless you're using a blender. And I think we should all go for using blenders. Indian blenders are available now. Then all your flows, etc., make some difference. Otherwise, putting a baby, unless you're in a hood, because in a hood, if you put 5 liters, it makes a difference. And you do not run anything less than 5 liters. This itself is a full-term lecture. I think we are having a session on oxygen therapy, so I won't interfere on that. Pulmonary causes are very straightforward. Structural abnormalities, I'm sure with Dr. Dattaria, he would have picked up some syndromes which I could never pick up. But this baby will come tachypneic, and I assure you, first thing we'll be telling is ventilate and intubate the baby. Be very hesitant to do that, because ultimately we have to send this baby home. You cannot send a baby home on a ventilator. So we have to think of alternative, and these are structural problems that are there. Or we have to detect some of the issue when the baby comes out, baby cries, stops crying, it becomes blue. It again cries, baby is all right, then suddenly it becomes blue. All we need to know is, are we missing out a bilateral choanal atresia? You just need a simple airway. And once you put the airway in, baby is comfortable. Subsequently, post-surgery, it has to be trained. This itself is a different session, probably in a workshop. We can discuss this. Glossoptosis is another important thing. The baby may be born with tachypnea or distress. I'm sure with the genetist sitting there, he'll again say, oh, I know what syndrome this is. But for us, that's not the concern. For us, the mother asks, can you send this baby home? Can I breastfeed this baby? So we need to realize that this positioning is more than important. You position the baby properly. You don't have to put the baby on a ventilator. You don't intubate the baby. Please make out the problem. Tracheal fistula, simple history of, did you have polyhydramnios? Was there a large tummy? We tell us many things. And babies may be born to gestational diabetic mothers. We get missed out. Many times a tube is put and baby is fed. And baby aspirates. And then you genuinely have to intubate the baby because we have missed out a tracheal fistula. Simple X-ray is more than enough. You can see the coiled up tube in the esophagus, even esophageal atresia, very often associated with tracheal fistula. Congenital diaphragmatic hernia, we always say that beware of a dextrocardia in a baby with tachypnea. do not worry about it, because if there is a dextrocardia and there's nothing you can do about it. But if the diaphragmatic hernia, if you start bagging, you'll end up in trouble. There may be a lot of antenatally diagnosed things, but I can assure you the TIFA scan which is being done, sometimes it may miss. And this is why you'll find there will be a disclaimer written underneath. This is not always a complete scan or something like that, because we have had issues in which TIFA has been done and the baby was born with a very frank diaphragmatic hernia, and it left us all red-faced because they're done by a very senior professor. And we had to, poor neonatologist has to lie through his nose. We always do that in asphyxia also. Kabhi to kabhi ho jata hai. Now he has given me an excuse that I can say it can be a genetic reason also for asphyxia. Hyaline membrane disease. Again, nothing much to talk about this, except if you have a distress that is coming after 24 hours, it is not classical hyaline membrane disease. And this hyaline membrane is an oxymoron. There's no hyaline or membrane in this. It's a lung alveoli that are collapsed, and the transudative picture is getting eosinophilically stained. So it looked like some hyaline, so people started calling hyaline membrane disease. So we still use that terminology, though it's not actually correct. This is a very beautiful disease. Just stabilize it for the first 24 to 72 hours, and baby improves out to 7 to 96 hours. It becomes worse. The problem starts, how are you going to do it? Very easily said and done. Prevent prematurity. That is going to be impossible. Give antenatal steroids. Again, we do not have the betamethasone, what is being recommended. We don't have phosphate acetate, but we give dexamethasone. In other words, it is better that we are giving dexamethasone, because it has been found that phosphate acetate has got a much longer action, which much more deteriorating effect on the fetus as well as a mother. It lasts in the baby for a much longer time. And now we know that it is better what we are doing with DEXA is much better, or the lesser effective betamethasone that we are doing today. So by default, we have been very lucky. X-ray granular pattern. Everybody says, you might have noticed when the registrar comes the morning after half an hour, why did you give surfactant if you're given the freedom? X-ray was looking like RDS. This is the most meaningless thing which I've ever heard, because any baby which does not cry properly or there's no good aeration, it'll look like this. So please do not jump to a conclusion about RDS. If the baby is having good saturations and the X-ray is looking hazy, it is not RDS. If the baby cries very well and the lung is well expanded, the granular pattern may develop after 6 to 12 hours or 24 hours. So it all depends on how good your aeration has been. If you resuscitate the baby very well, the lung will be well expanded, the classical pattern will come later. If you're not resuscitated, it will manifest much earlier. Again, ultrasonography is coming up here. Simple, because we know that peripherally there is no expansion that is present. So it looks like a consolidation. And this will tell us, okay, by RDS can be made out by ultrasonography, classical pictures. Management is again straightforward. I'm going a bit fast because I don't want to lose my time here. I'm open to questions whenever you want. Surfactant replacement, everybody's been talking about it. Important is delay in any treatment worsens the outcome of hyaline membrane disease or RDS. So please start CPAP as early as possible. And if you find the CPAP is unnecessary, take it off. And then decide on a surfactant, because it is a very expensive drug and you don't want to lose on it. Respiratory care, one of our earliest papers way back in 1993, we had started giving surfactant. But now better methods have come, Ensure, LISA, less invasive surfactant administration, minimally invasive. This itself is a different session. But idea being that LISA and MIST, you are on CPAP, you're allowing the baby to breathe. And when you're giving LISA, please give it very, very, very slowly. Do not panic. Let there be more oxygen. Give more oxygen to nostril. Give it slowly. Don't try to push it in and regurgitate the whole thing and say we are giving LISA. It'll take time. It'll trickle in. With each spontaneous respiration of the baby, the distribution becomes better and better. We are not very confident in giving LISA for babies less than 1,000 grams, but more than 1,250, we are very confident. 1,000 to 1,250, depending on who's a consultant on duty. Meconium aspiration syndrome, very simple and straightforward. It's basically purely mechanical factors that is happening here. You have a ball valve mechanism that is coming in. It can produce an emphysema. If you're not careful about it, this emphysema may progress, and that can produce a pneumothorax, and you get an X-ray which is straightforward. Or you have a situation where you have a total block that is happening, and it can come with a collapse, straightforward X-ray again here. Further again, in the next part, in which meconium pneumonitis, this takes time. It may take 6 to 12 hours. So there is no difference between thin meconium and thick meconium in developing meconium pneumonitis. So that is why if you have a meconium stained amniotic fluid, please observe that baby for first 6 to 12 hours. or at least keep a down score in the ward if you don't want to admit to the ICU. We do this, and this is a picture that you may get. All the pictures, all the features that we have discussed is seen here. Again, ultrasonography has come up for diagnosing meconium aspiration syndrome. I could not make out how Pradeep makes out this. Basically, he says a very confusing picture, but this I tried to do it, but I was thoroughly confused, I must confess. But he says you can make out meconium very well. Only thing I could make out is one part of the lung looks pretty normal, where the other looks really grotesque and bad. But I guess we all have to start learning this. Management is very straightforward. Avoid hypoxia, hypercarbon acidosis. Treatment is again standard. Antibiotics are not warranted in meconium aspiration syndrome. This is what we need to know. Pure meconium aspiration, do not give justification, because tomorrow lectures on NEC, I will get some time to discuss about early antibiotics, which is more scientific with some data. This is more for a very light discussion we have had. Complications are sequelae, air leak, VQ mismatch. We have a very detailed discussion on personal pulmonary hypertension for newborn coming, and you can go for that. Reduce crying in a baby with meconium aspiration syndrome. This is very important. What we do is we feed the baby, give 40 ml per kg, give the baby tube feed. Baby just keeps quiet, because first few hours the stomach size is very small. A little bit of feed is enough to keep it quiet. I do not want this baby to cry, inhale a lot of air, and produce a ball valve mechanism creating trouble. We do not lose meconium aspiration syndromes in our unit. I've been confident about that. So feed the baby. Treatment is very simple. If you go to this stage, aim in MAS is not to go to this stage. Prevent it. It is 100% preventable, and monitoring it. Pneumothorax, again, we do only a downscore monitoring in a meconium aspiration. If the downs become worse, only then we start investigation X-ray and things like that. Pneumothorax, I show that this is a very favorite X-ray of mine, because this I picked up in Australia 30 years back. It happens in the Western country also. It is not only in India. Okay, horrible baby with pneumothorax missed out. They could not even diagnose it. Anyway, you transluminate the baby. This is a different baby. It'll be transluminating like a cherry light. So please invest in a fiber optic transluminator. Very useful for you. Once you put the drain, it clears off. Once the drain has been put, again, sonology, they say that you can make out a pneumothorax also by a sonology. There is something called a lung point, where one point is absolutely normal, and beyond which you will find patch. Most interestingly, you will find that the A lines are coming with a gap, and that comes below because of the air shadow that is present. Put an ICD. Mother can breastfeed the baby comfortably. When I shot this film at Manipal, the mother was very angry with me. She was really upset because she said she was going to smile and I didn't take the photograph. So to make her happy, I show this always, because she was so proud that this baby who came so sick, she's breastfeeding the baby. Others are basic, simple pneumonia. I will not discuss too much on that. And transient tachypnea newborn is always a diagnosis of exclusion. TTNB, the interesting part is you have one part of the lung which is perfectly normal. This is called the double lung point. This is very easy to make out. Even I can make this out. Lower lung looks perfectly, will be looking affected with the compact type of B lines, whereas upper lung fields will look absolutely normal. So in conclusion, I would like to say that, okay, the ABCDE of respiratory problem is first confirm the etiology, have a basic and specific care, which must be very, very clear-cut. Clinical evaluation for progress and complications must be taken care of. Deterioration and detection must be detected very early, and seek for early expert assistance. Continue treating or seek second opinion is a big dilemma which we all have, but I think there should be no dilemma, because we should always understand that when we are doing together, it is always a baby that is improving. Thank you very much. I'm sorry for hurrying up. Please be free to ask me questions. Thanks.
Thank you, sir, for such a wonderful and lucid presentation. The tagline for me was that think something different from RDS. If a preterm develops, respiratory distress after 24 hours, and keep your basics right, do good monitoring, and things should be fine. And I agree with you, sir. Now government is also saying that use dexamethasone instead of betamethasone.
Thank you, sir. Very detailed knowledge in very short time.
Thank you very much. Thanks.
Thank you, sir. Really, it was a very excellent presentation. Thank you, Chairperson. So with this, we end today's session. I'm really thankful to all of you for patience listening. And just after a few minutes, we will have inaugural session, and from 7 p.m. onward, we have cultural program and followed by dinner. So I welcome you all to the cultural program and dinner. So thank you very much. And today we will meet here sharply at 9. We will start tomorrow's session. Thank you very much. So we will start our inaugural session. Yeah. So everybody requested to be please be seated here. Within few minutes, we will start the inaugural session.
Good evening, everybody. In a short while, we'll be beginning with the inaugural ceremony. I request all present here to please take a seat. And may I request Dr. Amit and Dr. Sushil to call all those who are inside to be present here for the inauguration ceremony. We would commence in 2 to 3 minutes. So that much time should be enough. A very good evening to all of you. On behalf of the entire organizing team of Bihar Neocon 2023, I extend a very warm welcome to all delegates, our esteemed faculty who have walked that extra mile to be with us here today, enriching us with the wide array of the knowledge. All of us have already witnessed the flow of knowledge on day one of this conference and the pre-conference workshops, and I'm sure we will be better equipped and closer to the theme, which is intact newborn survival, a better future. The aim of any conference is to exchange views and to approach knowledge in a different and a varied form with new updates. And on behalf of the entire organizing team, I wish to voice their zealous efforts that they have put together in weaving this tapestry together. And from all of them and all of us present here, I welcome you all once again from the core of my heart. To get the evening rolling, we proceed further. And at the outset, let me share with you that today's inauguration would be slightly different because we are choosing to go hybrid today. Reason being, two very important and very eminent guests who were unable to come here physically, but their mere presence is extremely, extremely important for us. Despite the busy schedules, our chief guest and guest of honor have agreed to be here today with us on this hybrid mode. And with this, I would like to welcome our chief guest, none other than Dr. Vinod Kumar Paul, sir. Dr. Vinod Kumar, I would request you to please connect. Yeah. A very good evening to Dr. Paul, sir. He is a globally recognized pediatrician and scientist, and he has headed the Department of Pediatrics at AIIMS, New Delhi for more than 1.5 decades, 1925 to 2000. Sir, an active member of Niti Aayog, which is the think tank of the government, has helped a lot with all the child and maternal health programs. Sir has led the country to a victorious position with his outstanding work in the COVID era. Once again, I welcome you, sir. I am honored to get this opportunity to call upon Chief of Health UNICEF India, Mr. Luchidi Anquino. Sir would be here as guest of honor with us today. I welcome you, sir. Sir advocates the rights to life. Sir advocates the right to life and to health and development of every single Indian child. Prior to joining UNICEF in India, Sir has worked in the Liverpool School of Tropical Medicine. He's worked with UNICEF and many other organizations as Save the Children. It is really a pleasure to have you here, sir. Now, coming to the physical presence on our dais, for this, I am overwhelmed to welcome Madam Nafisa Binte Shafiq, Madam, the Chief Field Officer from UNICEF Bihar. May I request Dr. Sushil to escort Madam, please. Ms. Shafiq, who hails from Bangladesh, has a huge experience of working in humanitarian and development sectors. She has almost 24 years of experience in working with many organizations, Save the Children being one of them. Madam has been serving UNICEF for approximately 20 years, and her service extends from places like Bhutan, Syria, Sudan, and so many others. Madam has expertise in adolescent development and participation, HIV, AIDS, and others. And today, we are really proud to have you here in Bihar, Neocon, Madam. And I'm sure neonates and our theme for today, that is intact newborn survival. So once we have an intact newborn, we will move towards a healthy adolescent as well. So today we rope in. So being in UNICEF, of course, you are committed to all that, but Bihar Neocon today gives you a start for that too. Thank you so much, ma'am. This is my honor to invite Chairman Organizing Committee, Dr. Vinod Kumar Singh, sir, on the dais. Sir, a rare blend of academic achievements and humanitarian sensibilities has made his mark by his outstanding managerial skills in the COVID era when he served as superintendent in MCH, which was the first hospital in the dreaded COVID situation. He has held almost all the presidential posts of the state bodies like IAP, NNF, and has been representative as EB also from Bihar. An apt organizing chairman, we also must have palpated his vigor and his personal interest in every activity of the two-day conference. I thank you so much, sir, for your contributions. May I request Dr. Nigam Prakash Narayan, sir, Chairman Reception Committee, to bless us with his presence on the dais. Sir, who served as Vice President, East Zone Central IAP, also surprises us with his energy, and he so smoothly glides through all the posts of Vice President Infectious Disease Chapter, be it the examiner of prestigious Royal College of Child Health, and also apex presidentships of the state. Still, when it comes to working with juniors like us, we always find him leading the squad from the ground level. A sportsman, literally. I would like to repeat, a literal sportsman and true to the nature. Sir effortlessly moves ahead, taking journals, conferences, and all events to completion with his guardianship. I welcome you, sir. It gives me immense pleasure to call upon ex-HOD Pediatrics, Dr. A.K. Jaswal, sir, as Chairman Scientific Committee. Sir, one of the most popular HODs in the history of Department of Pediatrics, PMCH, is known for his meticulous management of patients, of the institute, of students, of faculties. He is so popular with his students, which we have just witnessed during the farewell ceremony that he received recently. Sir has headed the state IAP NNF and represented our state all over the country as examiner expert, MCI inspector. He has been honored with so many awards that I really can't enfold them together to share with you. But of course, one of the very important ones which I had witnessed was the Purvanchal Shishu Visheshagya Shiromani Award that was conferred upon him in Silchar, Assam. My honor to request you to be here, sir. Now to welcome the man of the match, our organizing secretary, Dr. Shravan Kumar, sir. Sir is and always remain young at heart, with his heart lying in all innovative ideas in serving the community as well as the newborns. He has been the founder of neonatal services in Bihar and opened up the first private setup of neonatology. Sir is President NNF and National Accreditor for NICU also. Our gratitude to you, sir, for being there behind the event, pouring in every inputs and taking it all in your stride. To complete the galaxy of luminaries on the dais, may I request NNF Secretary, Dr. Anil Kumar, sir, who's HOD Betia, to please lend his presence to the dais. Sir, a very amicable person, is presently heading the Department of Pediatrics at Betia. A very academic person, he is always willing to lend a helping hand to all events. So now with our chief guest, guest of honor, and all the other dignitaries on the dais, we move on. And we could never miss this opportunity to express our joy and gratitude with a small token. What could that token be today? Saplings. Why? Because green symbolizes life and a promising, clean and pure world ahead, akin to our newborns. Well, neonates also, when treated well, when dealt with well, they lead to a better, a purer and a happier future. So with this, I would request to move on to the bouquet presentation, sir, for which I request Dr. Sushil Pathak, who's Assistant Professor NMCH, to please come and present a bouquet to our guest of honor, Ms. Nafisa. Sir, Dr. V.K. Paul, sir, would be the first recipient of the bouquet. But since you are there with us online, sir, I think the honors are being done by Nafisa, madam. So she would be representing you and she would be representing UNICEF Chief, Mr. Lichidi and Quino, sir. Okay. May I request Dr. Deepa to present a bouquet of appreciation to Chairman Organizing Committee, Dr. Vinod Kumar Singh, sir. May I request Dr. Priya to do the honors and present the bouquet to Chairman Reception Committee, Dr. N.P. Narayan, sir. May I request Dr. Shruti, a postgraduate student from PMCH, to present the bouquet of appreciation to Dr. A.K. Jaiswal, sir. I'm sure you must be thrilled because you are missing, sir. I know that. May I request Dr. Sushil to present a bouquet to our organizing secretary, Dr. Shravan Kumar, sir. Dr. Deepa to NNF Secretary, Dr. Anil Kumar, sir. our chief guest, Dr. Paul sir, and UNICEF chief, and Kuno sir. My apologies that I could not reach the bouquet to you directly. Welcome address. Welcome address. There would be a slight shift in the events due to the paucity of time of our chief guest and guest of honor who are there with us online, but we really can't miss the welcome address by Chairman Organizing Committee. So I request Vinod sir to please come and address the August gathering.
Thank you very much, Dr. Rasmi Agrawal, for inviting me to give this welcome address to the people on the dash and off the dash. I am very much thrilled to welcome Professor V.K. Paul sir, who had been the professor and head of neonatology at AIIMS Patna, AIIMS Delhi, and we have learned a lot from you. You see, I had not been your routine teacher, and myself and Dr. Sravan used to go to the AIIMS CME very regularly for 4 or 5 years, and still we find that we are a student of neonatology, and we are very much indebted to you by I always see you as our teacher, and you are a torch bearer not only in the field of neonatology but also in the field of pediatrics, and we are very much proud of you, and I feel a lot of happiness in welcoming you on this occasion. And we the people of Bihar, the neonatologists and pediatricians of Bihar, we all are thankful to you, sir. Next, we welcome Dr. Luigi D. Evino, who is the chief of UNICEF Health India. And UNICEF has really helped this, not only this country, but the world in the field of child care. And a lot of work and support has been given by UNICEF. We remember that when we were teacher at Nalanda Medical College or even at Patna Medical College, UNICEF was the first agency to support our SNCU, and we received 24 warmers for the first time in our institution, not from the government, but by the UNICEF. And in many districts and almost all the medical colleges of Bihar has received the instrument and devices for neonatal care in Bihar. So we always feel grateful to the UNICEF people and UNICEF. I welcome you, sir, on behalf of NNF Bihar. Then Mrs. Nafisa Binte, who is sitting here in front of us, is CFO UNICEF Bihar. A lot of help and contribution by UNICEF in Bihar, I have already talked. And we further, whenever we need any support from UNICEF, Dr. Reddy is sitting in front of us in audience. You all have been very much helpful to us, and a lot of cooperation from UNICEF in whether it is pediatrics or neonatology, community neonatology or community pediatrics. A lot of support is being given by you, and we pediatricians of Bihar, we are indebted to it. Then our chairman reception committee, Professor N.P. Narayan sir, who had been our national vice president of IAP and our teacher as well. So we learned a lot even today from him, not only the science, but art of living as well. And he's my teacher, but I look older than him. So this is some thing which we have to learn from him, that he should not only teach us neonatology and pediatrics, but also the way of living and how to remain happy and healthy. Then we welcome you, sir, and Professor A.K. Jaiswal, sir, who has been always loved us, particularly me. I feel Lakshman in front of him. He is my Ram, and I feel that I am his Lakshman. And he has showered his love not only to me, but all the juniors, students, and the people of this pediatrician and neonatologists of Bihar. So you deserve a lot of respect and honor from all of us. And my friend, Dr. Shravan Kumar, he is a milestone in the field of neonatology in Bihar. I always say that in private sector, he started neonatology for the first time. So it was a matter of great courage. At that time, CARE or UNICEF or other supports were not there. We started neonatology from ABCD, and I got inspiration from him only and courage from him only to start neonatology as a second man in Bihar. But I give full credit to him that he gave me inspiration and courage, and I still feel blessed in his company. Or Dr. Girish Gupta always say Ram and Syam. Okay, so when in conference, if he sees Dr. Shravan Kumar, where is your Ram and Syam? Okay, so we move together, and most of the time we are very happy with each other. So you are the part of this conference, but still I, as a chairman, I welcome you, sir. Dr. Anil Kumar, who is head of the Department of Pediatrics at Bethia Medical College. He is the secretary of NNF, and he is doing excellent work, and a lot of affection and love from him. We all get, and he is one of my sir. I always say that you are my sir. So a lot of work is being done. Whatever we say him, he always tries to complete it. So Anil Babu, we welcome you on this occasion. And the people of the dais, particularly our faculties, Dr. Ashok sir. So we had been as an examiner there at PHU, a lot of, we thank you very much to become the part of our academic session here. We enjoy a lot in your company, not only academically, but also as in a friendly environment. Professor K.K. Divakar sir, you are the people from whom we have learned pediatrics and neonatology. Neonatology, we have for last 25 years, we are attending the conferences of neonatology, and myself and Dr. Shravan used to be eager to attend your deliberation, and I used to reach in the hall in the previous lecture only, so that we should not miss you. So thank you very much. The other faculties who are not here, but still Dr. Girish Gupta is one of the person from whom we have learned a lot, and we welcome you, sir. And there are some people who have left also. So we are very much indebted and thankful to you to become the part of our conference. In the audience, our elder brother, Dr. Bijay Jain sir, who has been a source of inspiration, a source of encouragement to all of us. And he is one person who is, I see that pillar of IAP and NNF in Bihar. So he always attends as a faculty, as a chairperson, as a very pivotal person in the field of neonatology and pediatrics. Dr. S.B. Singh sir, and our elderly brother, who is the part of this conference. We welcome you, sir. Dr. S.A. Krishna sir, our teacher, our guardian, and you are always there to help and motivate us, sir. And our other the faculties and delegates who are attending the conference, Dr. Om Prakash sir, Dr. JP sir, Dr. Ruchi, Dr. Vijay, Dr. Tiwari sir, Dr. Lalan Bharti, who is the product of this soil only and is representing the national at national level. The EMS Patna, head of the department, sir, Dr. Chandra Mohan. We are very happy to find you here, and you are the part of this conference. A lot of participation from EMS people. We are very much we welcome you, sir, and other members of the media and the hotel people who have supported us and to make this conference a success. Dr. Om Prakash from Darbhanga, he is a very dynamic and taking part in most of the activities of NNF. My friend Dr. K.N. Tiwari sir, principal of DMCS and professor and head. Yes, K.N. Mishra sir, who is the professor and head of pediatrics and principal at DMCS. So thank you very much to become this part of. We welcome you, sir, in the audience. So with these words, I conclude, and I welcome all of you again and again. Thank you very much.
Thank you so much to Chairman Organizing Committee. And now it would really be a crime if we keep our chief guest, Dr. Vinod K. Paul sir, waiting. We are all very eager to hear you, sir. And may I request you to shower your blessings on us and guidelines also, sir. Over to Dr. Paul, sir.
Good evening. Thank you very much. Are you able to hear me well? Thank you. Thank you very much. Thank you and good evening. Namaste.
We could have,
am I
sir,
audible? Can you confirm that I'm audible? Yes. Okay.
Yes.
Sure. So my friend, Dr. Luigi, distinguished dignitaries on the dais, Dr. Nafisa, my friend and role model, Dr. Jaiswal Saab, Dr. Nigam Narayanji, Dr. Shravan Kumar, Dr. Anil. I understand that in the audience we have Dr. Divakar, Dr. Lalan Bharti ji. I can see Dr. Girish Gupta online, and many, many other friends with whom I have had great association for many, many years. Namaste and good evening. And indeed also the faculty of this important session, distinguished participants, dear students, dear friends, and dear colleagues from Bihar and beyond. I'm really grateful that you gave me an opportunity to reach out to the participants of this meeting. The leaders of Bihar neonatology are here. Indeed, leaders of national leadership of neonatology is here. Very grateful. So पहले तो मैं सबको आपका धन्यवाद करता हूँ कि आपने मुझे मौका दिया, और जब आपने मौका दिया है, I can recall many visits that I have made to Patna, several things that we did together, going back to the good old days of neonatal resuscitation program, good old days of NNF meeting we had in Patna long back, very memorable. And I also like to say hello to Dr. Srivastav Sahab. I believe he's in the audience. My namaste to you, sir. So many memories are coming back because Bihar has been such a strong team of newborn health in the country in those days when newborn health was relatively invisible. We were learning to walk, learning to toddle, and we were having NNF as a as an association which was still in childhood. National Neonatology Forum has now matured. We are vibrant. We are well recognized. We are respected for all the good work that the members and the leadership of Neonatology Forum has done over many, many years. So thank you once again. Thank you indeed. And I miss being physically present in the wonderful city of Patna. Very, very wonderful, ancient city. I particularly also recall my visit to the Holy Gurudwara in one of the meetings when I came. So friends, we have moved on in many ways in advocating newborn health, building the blocks of neonatal care in the country, and implementing the national programs in newborn care, as well as in promoting high quality education for the home care, for community care, for specialty care, but also on the high-end side, we all have worked together to take neonatology where it stands today. I would like us to now think how, given the context of our nation now, we refashion ourselves going forward. Let me say where we are. Firstly, we are at a point where we are proud to have achieved the Millennium Development Goals for maternal health and for child health. We are proud that we have done much, much better than the rest of the world in general. And we're very proud that we did it through policy changes, to scale up of interventions, working with partners, and also with the key role having been played by professional bodies, in particular the Indian Academy of Pediatrics, in our own very special way, the neonatal care. But the fact remains that the agenda for neonatal health care, neonatal survival is not over. We are committed to reach neonatal mortality rate of less than 10 by a certain date, by 2030 to be precise, if not earlier than that, indeed. Because when we are below NMR of 10, then we are in the company of developed nations. And that's why this target was put. So we are moving toward a Viksit Bharat, and Viksit Bharat has to have indicators of Viksit world. And Viksit world indicators in neonatal mortality, we should remember, is an NMR of well below 10, 9, 7, and so on. We must also not forget that simultaneously we need to make improvements in the sphere of stillbirths. Both indeed go hand in hand. A stillborn baby whom you and I failed to resuscitate, maybe at 40 minutes ago was a live baby. We cannot forget this is a continuum. And therefore, going below 10, the single-digit stillbirth rate is also our agenda in partnership with stakeholders of maternal health and the professionals who deal more with maternal health in their own way. So the agenda is unfinished. So friends, whether we are in Patna or in Delhi, our agenda is still unfinished. We take things which worked to an extent, and we are proud to be there where we are today, which is an NMR of around 20. Having said that, in this journey of many years, we have learned to do things in a gentle, positive, sensible, humane way. We have learned not to disturb the babies. We have learned not to overdo with our ventilation strategies. We are talking about gentle care. We are talking about touch to the newborn babies, talking about kangaroo mother care. We are talking about essentially breastfed babies. We have learned from that time in particular, when there was a little more aggression in neonatal care, which was damaging the babies, one system or the other, at the cost of survival, we have learned to be gentle. In the course of this, we have learned how to prevent ROP. all across the country. ROP is a problem that's on a decline, and now essentially at those levels where we are just about comfortable, but more needs to be done. We have learned how not to produce too much of BPD, chronic lung disease. We have learned it. We have learned to handle it with love and care. But let me say that in the sphere of what things that we have not been able to do, and we must address them, are the following. One, our nutritional outcomes of small babies are suboptimal. Study after study, they show that when we have babies below 1500 surviving, and very often now they are much more intact survivor than they were in the past. We are very proud. We have reduced intraventricular hemorrhage of the severe kind to very minimal levels. Those are good things. But when you look at the growth of such babies, let's say at 5 months corrected age or uncorrected age for that matter, they are below the trajectory where they should be. It's a serious issue. In a study which was done at AIMS some 7 years ago and published in the Lancet, we tried everything during the care in the hospital and beyond to ensure optimum nutrition with great amount of counseling, emphasis on breastfeeding, etc., and also micronutrient. But we found, and this is published, this is Suchita Gupta's work, as you might know, we are not achieving very optimum macronutritional status. These babies are underweight. These babies are not necessarily optimally reaching their linear growth, and they look wasted. I want us to think how to optimize nutrition. I want us to think how we can ensure the current level of best practices, scientific-based information to be used for nutrition. Please think about nutrition, because suboptimal nutrition in the presence of a very fast-growing brain would surely have consequences. It may not be a visible microcephaly, but it might mean 30 IQ points for all you know, or an opportunity for the baby to do music or to do great maths. We need to think like it. So I want us to focus on nutrition, the macro, as well as micro, the problem of anemia, and so on and so forth. So there's one area that I would like us to really focus on. The second area where we have done collective good work is the area of developmental stimulation. I'm very proud to say that these things emerge in many of our nurseries. I like us to ensure that that aspect is not only practiced optimally in the neonatal nursery settings, but also in the earliest phase of life, practiced by our families, the children's family, the baby's families, the mother not alone, but everybody else in the family, systematically. Today, we have an additional opportunity of doing so because we have the cell phone, we have the mobile. We can educate, we can message, we can connect with them, spending relatively small amount of quality time with the family. So I want us to remember that the outcomes are not only survival, not only absence of traumatic developmental delay or absence of ROP, but optimum nutrition and optimum development. Not just absence of disability, but optimum development of sensory pathways, connections, cognition, and so on and so forth. So I like to urge that these are the areas which should now get your kind attention. Let me also move to now a more system level discussion with you very briefly. I'm mindful of the time. I'd like you to note that we have 3 very important programs with which you have to connect, and you should connect. We start with the first one. The first one relates to the home-based newborn care. Babies who are discharged are to be followed up in the home setting by the ASHA workers, 6-7 visits to be done. Can you help us understand how this program is doing? ASHA worker, through a simple algorithm and simple training that she has received, is expected to detect illness, to do assessment of feeding, counsel the mother, refer if need be, but she is the agent for ensuring optimum breastfeeding and kangaroo mother care. I'd like to know whether that's happening or not. I'd like to know how you can connect with it. We learned this from the Gadchiroli experiment that a lot can be done, but then a lot can only happen when a quality counseling session takes place. Can you help in enhancing that? Today, again, we have a help. She has difficulty. Can she call one of us, some of us on different days within the government system and outside the formal district system, people like yourselves? How can you get connected with this? Are you available on, let's say, 7th or a Saturday for 30 minutes for these calls? Because why I mentioned that nutritional outcomes are not good. If they're not good in the watch, under the watch of AIMS team, which all the wherewithal of social workers and doctors and everything, surely there are challenges of those who survive our SNCU care and who are looked after at home. So can you strengthen the home-based newborn care and take it to version 2.0? And here I request also UNICEF to help us understand how well we are doing in this regard. Please tell us how we are doing, how we can improve, how we can use technology and the good way, in a now a different way from the fraternity of pediatricians and others in this regard. And indeed, what can be the improved model of home-based newborn care in this decade? The second familiar intervention, health system level intervention, is special care newborn units. Time has come that we look at our outcomes. Time has come, we look at our infection rates. Time has come that we ensure that there is universal kangaroo mother care. And time has come to reposition additional capacity, if that is needed, for public health neonatal care through SNCU at facilities outside and within the medical colleges. Which means I want to ask whether are you happy with the number of SNCU we have? Are you happy with the kind of number of beds that you have? We devised 12 to 20 beds. Are they enough or are they too much? Or are they less? How do we move toward a more comprehensive SNCU model, more comprehensive nursing care in the SNCU model, more tele-ICU kind of a help that we can bring in? Because ultimately, it's survival, but also a good survival and a good care where antimicrobial resistance, for example, is not an issue. And ROP is not an issue. Just as ROP should not be an issue, similarly, we should not be losing out on it, for example. And also, optimum kangaroo mother care and family-centered care in these. So I want you to think overall, what is version 2.0 of our facility-based newborn care, where the UNICEF had a stellar role. And the third and the last one, I want to remind you that the Honorable Prime Minister has instituted very proudly and very lovingly the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. I work in his team and I know how proud the Honorable Prime Minister is about Ayushman Bharat PMJ. It's his flagship scheme. It's a fascinating framework of health insurance. It has taken care of 4.2 crore hospitalizations so far in 4 years, or 4.5 years. And it has saved 80,000 crore rupees of out-of-pocket expense. It covers almost 50% of Indian people, 12 crore families directly under PMJ, and then states are doing more on their own. So we've actually ended up like half of India having health insurance, free, cashless, paperless care and coverage. My sadness is that the newborn care packages, which I personally designed with the help of some of the key leaders, a couple of them are in the room as well, but they're not being utilized. When I look at the packages or the care that's being used for under this, and which is fine, is about stenting, it's about knee replacements, fair enough. It's about cancer, fair enough. It's about some medical packages, no problem. But why the proportion of utilization of care under PMJ for newborn babies, for that matter children, is among the lowest, 3%, 2% of the total package consumption. Why is it so? There is a significant private sector out there and the government sector. PMJ is about partnership of government and the private sector. I like us to see how we can enhance the connect of sick babies through PMJ for that 50% of Indian babies. Technically, 50% of Indian babies should have no out-of-pocket expense. Notwithstanding the fact that supply side may be, I have not heard about supply side issues. I'm worried that the newborn care entities, hospital, nursing home, are not really actively engaging. And I want our international partners to please see it on the ground. What is it that we can do more in this regard? Because I repeat, on principle, the nation has assured private plus public sector, secondary, tertiary care of newborn babies free. Half of the problem, in fact, maybe 2/3 of the problem, because these are the most vulnerable families with more children, has been technically taken care of. But then why that connect is not there, and we are there to modify it, we are there to course correct if there's anything. I don't hear this from the fraternity of Canada, कि आप ज़्यादा करिए, आप ये क्यों नहीं करवा पा? कार्डियोलॉजी वाले रोज आके याद दिलाते रहे कि ये कम है, ये ज्यादा है, और तरह तरह के एंडोस्कोपी वाले आके बताते रहते हैं। न्यूनेटल फ्रेटर्निटी ने भूल ही लिया है कि हमारे पास पीएमजे है, हम एसएनसीयू से पूरी सेवा नहीं दे सकते, क्यों खोला गया प्राइवेट सेक्टर? सो मैं आपसे विनती करूंगा कि आप इसके बारे में सोचिए। और दूसरा, जो भी इस रूम में बैठे हैं उनके हॉस्पिटल अगर पीएमजे में नहीं जुड़े हैं, विल यू प्लीज कम फॉरवर्ड and become part of that system. There's never an ideal, super ideal situation, but this is a system which is, encompassing almost 30,000 hospitals. Why children should not have the best opportunity? So that's my real request to you, that please use, and if there are challenges, let us know. We are there to assist. PMJ has been designed by us. बैठ के बनाया, इसके पैकेजेस हाथ से बनाए हैं इस एरिया में। फॉलो अप का भी पैकेज है, फी विजिट का भी पैकेज है, ट्रीटमेंट इज टेकन केयर ऑफ। व्हाई देन इट हैज नॉट टेकन ऑफ? कैन यू हैव मोर प्राइवेट सेक्टर newborn units which are aligned to the cost structure that PMJ can afford, and which is generous, by the way. So I want expansion of the private sector newborn care. I want the private sector to be connected to PMJ. I want the public sector also connect through PMJ. But please remember what I'm saying. Technically, neonatal care through public plus private has been taken care of in a cashless manner. I want us to think about similarly. Can you please also help, my last point out of this, help the ESI system, the railways system. ESI covers 13 crore, 130 million individuals. These are 30 million approximately families with their babies. Can you help? Because they're also protected. Their cost is already borne because the employees in the employees' social insurance system are making their contribution, their own. Can we expand facilities there? Because this would take care of, if you look after ESI families, 14 crore population ke bache, babies, newborn children, adults of 14 crore families, 14 crore population, which is a population of UK plus France put together. अब देखिए कितना है। So आप थोड़ा इधर रीच आउट करिए, अपनी ESI फ्रेटर्निटी को देखिए, उनका प्राइमरी केयर भी देखिए, उनका होम बेस्ड न्यूबॉर्न केयर का मॉडल बनाइए। तो मैं I like us to think now in a little bit more specific manner and work with these three wonderful opportunities that this nation has to get the best out of it. I think we are missing on the PMJ advantage, which we all have. I admire the good work that's being done. And on the last point, truly an additional point that I like to make now from cell system to another point, and that is, I like us to be liberal with starting neonatal DM courses. During the course of chairperson, as a chairperson of Board of Governors at Medical Council of India, now NMC, we have made norms that are liberal. sensible. We want neonatology as a specialty, subspecialty to also flourish. So please think about where all you can start DM courses, where all you can work together to support DM courses. And last but not the least, and that's my last message, wherever there's a DNB neonatology course and pediatrics neonatology, pediatrics DNB course, please help. They are also specialty trainings of our nation. They're also getting the right license. Medical college, PG training, and this PG training through DNB system in medical college or in district hospitals or in private, it's the same. The trained doctor will contribute to the nation's babies. So these silos should break. I call upon the academia to hold new neonatology sessions, theory sessions, practical sessions, remotely or in person, in cities together, where you also invite the DNB students to come and take part. Because everybody can improve if we have a larger set of people training. And NNF, as an organization, and Girish, you're listening, think about how you can support webinar-based newborn care grand rounds. Can you have a national NNF grand round every Saturday at 7 p.m. where we discuss cases? You will do once, I will do once from another location. What is the difficulty? Let medical college PGs, DM students, and both DM and PG together, DNB, diploma, and people who are working in the community and in the state district hospital, pediatricians, let them all listen. Use this damn medium. Reach out. जितनी देर में मैंने बोला आधा केस डिस्कस हो गया, इतना तो हम दे ही सकते हैं, मैं भी दूंगा. इसको फैला दीजिए. You become the benchmark of keeping in mind humane care, keeping in mind rational care, evidence-based care, rational use of antibiotics, stimulation, mother-centered, family-centered, KMC-centered. तो इसमें जो नई हमारी opportunities and pathways हैं, kindly let's make use of them. And we need it, and we need it for doctors, specialists. Today I'm talking more about them. And likewise, we need it for nurses. So our capacity, build on that. My message in essence, going reverse now. Build capacity, use novel ways, go toward the high end, both for nurses and the doctors. Second, please invoke PMJ for the best benefit of babies in our nation. Please improve the coverage, quality, and approach to home-based newborn care. Please reach the best outcome through SNCU and tell us what the next version of SNCU should be. That's my second bunch. And the first bunch is really move in the direction of optimizing the nutritional outcomes and developmental outcome. Absence of emaciation and absence of disability is not our goal. Optimum nutrition and optimum cognition is our goal as we move through the Amrit Kal toward Viksit Bharat by the 100th year of our independence, 2047. We now should play a repositioned role, building on what we have done in the past. Thank you very much. Jai Hind.
Thank you so much. It was sheer bliss to hear you, sir. And may I request our organizing secretary, Dr. Shravan Kumar, sir, to.
Thank you, sir. We, from our core of heart, I'll say that we are very much embedded and we are very much thankful that you have said all we are doing, and you will surprised to know our theme of this conference is intact survival, a better future. As you have said that we have to think about the brain, all the cognition, or the development, not only the survival. So we are going on the right way, and we are very much thankful that your blessings, and you are saying that you are so much love and affection for Bihar. We are very much obliged to you and your direction. And you have rightly said that in Ayushman Bharat, all the medical faculty like cardiologists are wanting more and more, but we neonatologists are not asking much from your side, PMO and Ayushman Bharat. That is your concern, and we are really very much concerned. But why we are not asking? Why not we are connecting you, and your direction we will follow, and really we will try to contact you and to develop neonatology in Bihar. And as you said that DNB and everything we will develop. And you, sir, I should say, NNF was made by you, sir. And we are proud to you that we are developing neonatology and we are learning neonatology, and you have so much pain about Bihar. That is we are also very much thankful to you, sir. Yes, we will definitely work hard, and we will reach to you, and we will learn how we can help Bihar, and we will develop. Really, you have said that in NMR, you are concerned with NMR. This MCH is also improved, but NMR is not improving. So really it is much concern, and we Bihar, if we will try to do better, the national level will automatically improve. So thank you, sir.
Thank you so much, sir. Now, if we could please request 2 minutes of your time only, so that we could have the lamp lighting with you. So to proceed with the lamp lighting, I would like to say here that light, synonymous with knowledge, always dispels the darkness of ignorance and opens new vistas of opportunity. Tamso Ma Jyotirgamya has been our prayer since time immemorial. So to keep the lamp a sakshi and to bless us with divinity and clarity to carry our purpose forward. So I'm so happy to have our guest of honor and chief guest, Mr. Antonio, to join in the lamp lighting.
महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा महाकाय सूर्यकोटि समप्रभा निर्विघ्नं.
Thank you so much to all on the dais, and especially those on screen, Dr. Paul sir, Mr. Antonio sir, to be with us today as we light the lamp, as you take it forward with your blessings. Thank you so much to our chief guest, Dr. Paul sir. Sir, if you have other commitments, we could bid you goodbye for today. Thank you so much, sir. May I now request UNICEF Chief of India, Mr. Luigi D'Anquino, sir, respecting your time as well. We have just turned the clock otherwise. So it would be so nice to hear from you, sir. Over to Mr. D'Anquino. Could you please have him on the whole screen, please, the management?
Very good evening. Can you please confirm whether I'm audible to you? Hello?
Yes, sir, you are audible, sir. Thank you.
Very good. So thank you so much. Very good evening to each and every of you there. And let me thank you immensely for organizing such an important conference. Let me apologize for not being able to be there with you today, which I would have very much liked to, but as I used to say, there is an epidemic after the pandemic, and that is a lot of commitments coming day after day, and therefore I needed to be in Delhi. Anyway, grateful and glad to be online. And now you have given me a very, very hard task, I have to say, because coming to share a few thoughts after Dr. Paul has spoken is not the simplest thing to do, but let me try to add a few considerations. I met Dr. Paul a week back in Goa during the G20 working group for health. And a very one consideration that he made to me personal was, you have really seen the worst and the best year in India during your 4 years to date in this country. And that is true. COVID has been what it has been. And amongst the beautiful things, the best, I think, is in many ways how the agenda of newborn health has progressed so quickly, particularly in some areas of the country, and Bihar is definitely one. So my first word is a word of congratulations for a state that has really pushed on the accelerator and made its annual rate of reduction of newborn mortality faster than many other states or of the nation average for that matter. And that speaks to commitment, to leadership, and to motivation to move this agenda forward. So thanks for that. My second thought, as I was listening to Dr. Paul, went to the 3 points that Sir made, which are 3 points that we have been discussing for a while. I think we have all been overwhelmed by a COVID response and the long tail of it. But I want to take this opportunity to reaffirm, at least for what concerns the home-based newborn care, and for what concerns the utilization of PNJY as a scheme for neonatal and child health, that we will definitely work and are working on it. And if we can do it in Bihar, I want to take this opportunity to really stay focused. We can do good study, good evidence generation everywhere, but it would be fantastic. My colleague Nafisa is there sitting. If we could get consensus partnership to start from here and start looking more in depth at some of the data that can help, hopefully, from our small role as UNICEF to address some of your very, very relevant questions. These are questions that speaks to system, to existing big schemes, and that need to be leveraged, and particularly in those states where the journey is still long. And I come to my third point. As much as in my short time here, I've seen the newborn mortality rate in Bihar declining from, I believe, 28 when I arrived 4 years back to now 20, more or less. The journey is still long. The country, and therefore the state as well, need to achieve a single-digit MNMR. So we need to half from where we are, which makes the trajectory much harder from now onwards in terms of how much we need to tackle the big issues. On that, I think I want to bring three main considerations, and then I'll leave those to you. The first is what essentially Dr. Paul was talking of, and I want to make it even broader. I mean, my first point is there are an incredible number of well-thought, well-designed operational schemes for health system strengthening, for RM and CHA in this country. They are there. So the first point is they really need to be utilized at the best, unpacked and used. I can talk of health and wellness centers, I can talk of Laksha, I can talk of digital health schemes, of health insurance, of the SNCUs, everything is in place. So the ingredients are there, and I want to thank, I believe, the country for making it so comprehensive and such a big architecture. But now the first point is to unpack why there are still bottlenecks. When I look at the coverage of antenatal care in Bihar, or when I look at the coverage of early initiation of breastfeeding, or of the coverage of the full package of home newborn care visits, or exclusive breastfeeding for that matter, it's obvious that there is still a trajectory where focused investments need to happen. How? I believe there are data. These data need to be unpacked, analyzed. There will be extra resources. The aspirational blocks initiative will force to work locally more and more and really unpack issues and through bottlenecks analysis, leverage the resources and resolve the basics to start with. So this is one. My second point speaks to the other big pillar of the concept of primary healthcare, and that is the community engagement. So I believe that if we look at newborn health and newborn development as a trajectory of life that starts from preconception and continues for long, there is a lot of education that needs to go in the communities, through the schools, through the adolescents that are a vibrant part of the Indian community, the youth, the PRIs, the private sector that is also vibrant and very active. There needs to be sensitization around what are the key behaviors. Nutrition was one that Dr. Paul was referring to. Environmental health can be another one. Sexual education. There is so many simple messages that speak to prevention, health, well-being, and can influence the health of a newborn that we can't leave that untapped. So on this front, again, please do count on us for the little we can do as UNICEF. But I believe that is the area where we can really try to be a convener of various parts of the society around certain themes and topics. And the topic of child health and well-being, including newborns, could and should be really at the center. We're coming out of a big global emergency. Let's put, again, children back at the center of the agenda, because their development is everybody's future. Third and last point is around partnerships, which is also why we are here. And so be it private sector, be it professional associations, be it, of course, medical college, government institutions, Ministry of Health, Niti Aayog, I think we have learned in the truest sense of the concept during the pandemic to really forget about personalities, divisions, politics, and work together. Why can't we do the same? We should do the same, exactly the same, when it comes to issues like this of newborn survival. So we have learned a lot in that. We have learned how to untap resources from parts of the society we would have not even considered before, connecting dots towards an agenda. And I think this is another important part that needs to continue happening. With this said, let me just perhaps conclude by saying that as we look at the SDGs, and we have many countries coming to India in these months, many global experts, because of the G20 of many other initiatives. Everybody is looking with enthusiasm, interest, willingness to share, but also willingness to learn about what India is devising in terms of its health infrastructure and its vision for primary health care and for health for all. There is no better opportunity now out of a pandemic with this great restart to continue investing on SDGs. And really, somebody said it before me, if we want to move the needle of SDGs, we need Bihar to move. That's a global measurement. I'm not talking of India, I'm talking of the world. Bihar has a role for the achievement of SDGs in the world. So with that, I count on everybody's commitment, and I thank you all again for coming together. I could follow some of the sessions earlier, really interesting. So thank you so much and good continuation to all. Thank you.
Thank you so much, sir, for being with us here today and giving us your vision. To continue the chain forward, may I request UNICEF person from Bihar, Madam Nafisa, to please address the gathering. Madam, you will take forward sir's message for Bihar.
Thank you so much, Dr. Rashmi Agarwal. Good evening, people, and I acknowledge the colleagues on the dais and off the dais. Because of the paucity of time, I will really not repeat the points which has already been mentioned by Dr. Paul and then Luigi, my colleague Luigi. Very, very important point. But first, let me start by congratulating all of you, particularly for organizing this Neocon 2023 Bihar chapter. This is really a fantastic platform and forum where we can discuss, as Dr. Rashmi was mentioning, this is the start of the life. And this is also, Luigi mentioned, this is the future of all of us. It is the future of not only those children who are getting born today, but it is the future of the entire world. So let's make it as safe as possible. And that is all of our responsibility. So we as UNICEF would like to really acknowledge and appreciate the critical role of NNF and IAP, particularly Bihar State Branch, who have been very instrumental in augmenting the efforts of government of Bihar in the improvement of newborn and child health scenario of the state. As Luigi was mentioning, if Bihar moves, not only India, world moves, because 10% of because 10% of young population of the entire country resides in Bihar. So extremely important state for making a progress. And this kind of platform is very important to influence the future of Bihar and of India as well as the world. We know that every 7 minutes, there is one neonate dies in Bihar. This is preventable. It could be because of the lack of care at home, also maybe at the service points, but this is preventable. As I walk into this forum today, I think Dr. Agarwal, Dr. Divakar was making a very interesting presentation where he highlighted how prevention is the best investment that we can make. And I'm repeating what Luigi has just mentioned, that it is so important. Yes, curative measures are important. That's why we need SNCU, NRC, Laksha, all these kind of programs. But I really would like to dream about a situation where there will be no NRC, SNCU, or MA or Laksha programs because we have prevented it well. Now, how do we prevent that? This situation, because as already Dr. Paul and Luigi mentioned, that we have made a very good progress, but still a long way to go in terms of NMR. We are still in 2-digit. We need to really make it 1-digit in a few years only. We have to, this is 2023, we have less than 7 years to make that from 21 to 1-digit NMR for the state. And this is very much in line with the INAP. So I think that it is important that we all gear towards prevention to make the scenario better. Now, we have been supporting SHSB and then also other, state institutions by supporting whether it is Laksha or SNCU, NBSU, MA, IYCF, Suman, everything. But those are all curative measures. So I really would like to pitch for a couple of things in addition to what Luigi has already mentioned. One is use of science and technology. Particularly, this is the era of ICT, and we need to use the best or utilize the best of that platform to reach every mother and every father, every household, to make sure that they know about how to take care of the newborns and also the maternal care at home. Secondly, innovative approach, whether it is community-based, whether it is institution-based, whatever, but we need to come up with innovation. And I think Luigi already mentioned one very important point: to mobilize as young as adolescents, so they are aware of what needs to be done, whether it is for nutrition, maternal health, anything, but they need to get prepared, both girls and boys. The third point I would like to mention about is the evidence generation, where UNICEF can play a critical role and help all of you to come together and generate some evidences which will be critical for us to change, whether it is policy level work or our system strengthening, but we need to really generate evidences and data which will guide us for influencing our future decisions at the policy level, for system strengthening. And also one very, very important component that I want to speak about is social and behavior change, because prevention lies in social and behavior change communication. So they need to know, I am from Bangladesh, not a very different scenario or context from Bihar. Now, a lot of young mothers are being influenced by their families to say that you should eat less and that will make your delivery easier. And that compromises the health of the newborn. So these are the social norms that we need to unpack and address. Child marriage is a critical area that we can really focus on, where it will work as prevention, because a lot of young mothers are actually delivering. I have visited a lot of SNCUs and I have seen that most of the mothers are young mothers who are delivering underweight neonates, and then that is also leading towards something which is not controllable. Secondly, maternal care and practices at home. Thirdly, nutrition, which Dr. Paul already mentioned about. And then lastly, I really would like to mention that it is important to raise awareness. We always think that when it comes to maternal health, neonatal health, it's all about mothers and mother-in-laws and the pregnant women, but that's not the case. We need to engage men and boys in this entire process. So it doesn't remain as only mother's arena. It should be actually husbands, fathers, brothers, everyone should know how to take care of the mothers and neonates. So this is my last point, to mention that not only curative measures, but also prevention, as I was mentioning. Dr. Divakar mentioned it very, very clearly, and many of you also know that extremely important point is prevention. That is key, and bringing everyone together. And that's why I think platforms like Neocon is very, very important, which brings not only experts, but also private sector, media, maybe students and everyone, so we can all come together and see how we can make Bihar, as I said, if Bihar needle moves, everything moves. So how we can really make sure that Bihar is making a progress which is commendable in the entire country. And with all your support and commitment, we can do that. And UNICEF remains there to support all of your innovative ideas. And thanking you all for making this happen today. And congratulations again for such a great program, and wish you all the best for tomorrow as well. Thank you.
Thank you so much, ma'am, for such an expressive and such a clear vision of Bihar that you've painted. We moved with intact newborn survival, and the morning session of UNICEF, Dr. Reddy, Dr. Sarita took us to prevention. And here again, you are talking about it, and more so, you talked about the involvement of men in taking this to preventive level. So we do join hands with you, all of us together, especially the women in pediatrics are with you to realize your vision. Thank you so much, ma'am. And now may I address our Chairman Reception Committee, Dr. N.P. Narayan, sir. And sir, could I just put in a request for brief?
Yeah, we have to be. I think in today's Bihar Neocon's academic mega academic feast, the inaugural session of which we are addressing, the chief guest on virtual mode, Dr. V.K. Paul, sir, and Dr. Luigi Equino, who is the chief of India office of UNICEF, and guest of honor, who is in real mode, Miss Nafisha Binte, and my other colleagues, Dr. Binod Kumar Singh, who is the organizing chairman, and the scientific chairman, Dr. A.K. Jaiswal, organizing secretary, Dr. Shravan Kumar, and Dr. Anil Kumar, and all important faculties who are here from outside the state. I'm seeing here Dr. Ashok, the outside, Dr. Divakar, a good old friend of mine, and lot many whom I'm not able to address right now. But the seniors like Dr. S.A. Krishna, Dr. S.B.P. Singh, Dr. Vijay Jain, Dr. R.K. Sinha, and all the faculties who were present all through the day and who made the whole, you see, conference a great success. Well, it was a great moment for all of us that we were addressed by Dr. V.K. Paul, who is a very active member of the Niti Aayog. And we never imagined that he will give so much of time and such a meticulous way he analyzed the process of newborn care. I'm really impressed, and we are humbled by his approach and the way he put Bihar into real focus. And you see, I mean, how much responsibility we have. Yeah, and the government's effort, what he emphasized, it was actually not being utilized by all of us, like the Ayushman Yojana. The government is doing its best to bring down the whole NMR to single digit. But I think it is our responsibility now to take the baton in hand. And certainly in this effort, you see what he very clear-cut analyzed about the nutrition and the development of the child, then the home-based newborn care, then facility-based newborn care, and then Ayushman, and of course with the kangaroo mother care. I think we have actually formulated the intact survival, which is including everything what he said. But certainly his points were too critical, and actually we are going to address all that. Perhaps we are having one immediate KMC also, KMC, and of course these everything actually has to be practiced and has to be made aware to all of us. And I think for awareness purpose, I think the NGOs also like UNICEF and CARE, they have supported us. And certainly the whole media also they are doing it their best to make the whole news across going across the whole state and country. So I think we have immense responsibility, but the whole academic feast has been a great success, and it is due to participation by one and all. And I'm very, very thankful to UNICEF bodies and certainly Professor V.K. Paul, who has given full time to this Bihar Neocon. And I'm sure that this movement, newborn care movement, is going to take a great leap forward. And I'm sure we were discussing, Dr. Shravan and me, that now we will have a good channel to just pass our ideas across, and we will be in regular touch with the center. And we have got, you see, the Secretary General was here of NNF, the past Secretary General, Dr. Lalan Bharti, who is the son of the soil, he's here. So I think we have many persons who can really give full support to us. I'm sure that Bihar Neocon is going to be going to give a very good guidance towards the good and very improved newborn care in this state. Thank you very much for giving me the honor of being the chairman reception committee of this August gathering. Thank you very much.
Thank you so much, sir. May I request Chairman Scientific Committee? We have all seen his guidance in the 2 days flow. May I request Jaswal sir to please address the gathering.
Thank you, Rashmi. So, good evening to all. And chief guest of today's function, Dr. B.K. Paul, who was online with us, and Mr. Luigi Di Aquino, the country chief of UNICEF, Madam Nafisha, I see the UNICEF chief Bihar, and Dr. Binod Kumar Singh, organizing chairman, and Dr. N.P. Nayan, sir, he is the reception committee chairman, Dr. Shravan, organizing secretary, Dr. Anil, secretary, NNF Bihar, and all the dignitaries sitting off the dais, senior person like Dr. S. Krishna, Dr. S.P.P. Singh, Dr. Vijay Jain, Dr. R.K. Sinha, and all Dr. Tiwari, and all Dr. Ashok from Banaras Hindu University, BHU, and some of the postgraduates sitting here, and all our colleagues, fellow colleagues from NNF, Bihar, as well as the speakers from outside state. So there is it was a wonderful journey that how we thought of having this particular conference. In fact, Dr. Shravan has been the President NNF Bihar since 1.5 years now. And we have been talking that we must have a very good conference of NNF Bihar, and we should make it a real memorable as far as the scientific programs are concerned. And I was given the responsibility as scientific chairman, and I myself, with consultation of Dr. Binod, Professor Dr. Nigam, and Dr. Shravan, Anil, and all senior persons sitting here, we tried to make it very scientific, and we tried to make this program very informative and very motivating as well, I must say, because since morning it has been very hectic scientific activities we have been witnessing here. And as far as the UNICEF people are concerned, we know that a lot of support has been there from UNICEF, because I was the head of the department of Patna Medical College almost 8 years, 7.5 years, and I was head of the department in Nalanda Medical College also. So UNICEF has been supporting us in so many ways. And as far as this NMR is concerned, of course, yesterday also when I was inaugurating the workshop, pre-conference workshop in Patna Medical, because the INAP goal, even the SDG goal, we are lagging behind. So because it's the NMR of our countries should come in single digit, but still national figure, of course, it is a long way to reach. And in Bihar also, that 21 or so, I suppose. And in Kerala, it is just one digit, that is 4. Dr. Divakar is here. So we must learn from Kerala. When Kerala, one of our state of our country, they can reach the 2030 goal of SDG or even INAP, even the National National Health Policy, they all have made a target of getting in single digit neonatal mortality rate. So we have to achieve it. And of course, we know that government with support of UNICEF initially has made it in 3-tier system as far as the neonatal health care is concerned. In public sectors, I must say that your neonatal newborn care centers, NBC at all delivery points, maybe in medical college, main PSC, and labor room, and even in the operation theater where the cesarean is going on, and NBSU and on regional hospital, newborn stabilization unit, and the SNCU in all district hospital all over the country. In our state, all 38 districts have beautifully running that SNCU. And I have been the instructor for this BNC training program, and most of the medical officers and paramedics used to come to Patna Medical College. So I've seen that a lot of things has been done, but still more has to be done as far as the neonatal morbidity and mortality has to be cut down. So that is that should be our motto. And with the very motivating speech of Dr. V.K. Paul, I think we should make it oath. I mean, we should take it a challenge also, that how to cut down the NMR in our state. So I won't take much time, but really with I could see in the morning hours that it was hall was full, and that I'm very happy with and I must congratulate the whole organizing team that they have worked very hard, especially Dr. Shravan. And this conference is real great success. So I hope that tomorrow also we'll have the same crowd and all will be met. Thank you very much.
Thank you so much for encouraging words, sir. May I now request the dais souvenir release? May I request Dr. Sushil Pathak? And could I call Dr. Anil Tiwari, sir, one of the editors of the souvenir that has already been delivered? The editor-in-chief, Dr. Anil Kumar Tiwari, sir. And should I hand the mic to Dr. Sushil to... So Dr. Tiwari, sir, and myself, Dr. Rashmi Agarwal, we were two people in the magazine, and we would really be looking forward to all inputs and all corrections that the seniors would suggest.
Very good designing, very good printing, and very good materials.
Should I request Dr. Sushil to take the other packet to the audience, all our seniors, Dr. Vijay Jain, sir, Dr. Singh, sir. So this was the other copy for release by you there. Thank you so much to the dais and all the seniors present in the audience. And I would like to repeat that we are open to all inputs on all suggestions so that we are able to serve better the next time. Now to take the program forward, may I request NNF Secretary, Dr. Anil sir, to please present the Secretary report.
Thank you, Dr. Rasmi. Our respected, the chief guest of today inaugural session, Dr. B.K. Paul sir, the member of the Niti Aayog, Government of India. Respected Lungi D. Aquino, the chief of UNICEF India. Our guest of honor, respected ma'am, Dr. Nafisha ma'am, the chief field officer of UNICEF Bihar. Our esteemed chairperson of this organizing committee, Dr. Professor Vinod Kumar Singh sir. Our most respected Dr. Nigam Prakash sir, the reception committee chairman. Our extremely respected Dr. A.K. Jaswal sir, the Professor A.K. Jaswal sir, the ex-HOD of the PFCH Patta, and also my mentor also. Our respected organizing secretary, Dr. Sarvan sir. As we know that this is the function of the NNF Bihar State Branch. So on the behalf of NNF Bihar State Branch, as a secretary of NNF Bihar, I welcome all of you. I welcome the chief guest, both the chief guest, the guest of honor, and all the dignitaries on the dais of the dais. The special welcome to our respected Dr. Vijay Jan sir, Dr. Professor S. Krishna sir, Dr. S.P.P. Singh sir, Dr. A.K. Sinha sir, Dr. Reddy, the UNICEF Bihar, Dr. J.P. Naran sir, Dr. Anil Tiwari sir, Dr. Thar, and all other delegates present in the audience. Now my memory goes, perhaps this is the second Neocon that has been organized in the Bihar. The first Neocon has been organized under the leadership of Dr. Sarvan sir, and this also organized under the leadership of Dr. Sarvan sir. Now I have taken the charge of the secretary in the session 2021-22. We know that the 21 was very much terrific. We are passing through a very horrific condition due to the COVID pandemic, and we have not organized much activity in that year. We have organized the activity, or we have organized the online activities. But the year 22 has been remarkable year for the NNF Bihar. So many academic and community activities had been organized by the NNF Bihar under the constant and persistent support of and guidance of Dr. Sarvan Kumar sir, President NNF Bihar State Branch. We have organized so many activities, and I would like to share some of the activities, some of the important activities with the audience. Some of the future important activities that a panel discussion on the surface representative therapy has been organized. A joint CME has been organized with the ISOPARB and INNF. A CME has been organized by Dr. Sarvan sir. A prestigious seminar has been organized on the child development with the catchy title, that's Teeny to Teens. Also, so many workshops and the CME has been organized on the occasion of the World Breastfeeding Week. And also during the newborn care, we have organized so many workshops on the subject of the newborn care. So this is some of the important activities that I have shared with you, and all the other activities have already been given in this secretary report, so you can go through that reports. At this auspicious occasion, I feel indebted to our stalwart and senior members, respected Dr. Vijay Kujan, Dr. Professor A.K. Pandey sir, Dr. Professor Sanjata Rai Chaudhary ma'am, Dr. Professor Nigam Prakash Nayan sir, Dr. Neelam Verma ma'am, Dr. Shubhachan Singh, President IB Bihar, Dr. O.P. Kejriwal sir, Dr. S. Krishna sir, Dr. Kragnan Thakur sir, Dr. Mohan Kejriwal sir, Dr. R.B. Thakur sir, Dr. Bajmohan, Dr. S.P.P. Singh sir, for their continuous support and blessing in my endeavors. I take this opportunity to express my deep sense of gratitude to Dr. Professor A.K. Jaswal sir, Dr. Sarvan Kumar sir, Dr. Professor Vinod Kumar Singh sir, Dr. Professor Alka Singh ma'am, Dr. Bipender Anand sir, Dr. B.P. Jaswal sir, for their valuable guidance, suggestions, and directions in discharging my duties and responsibility as a secretary of Bihar. At last, most humbly, I get full thanks to all the respected members and NNF for their love and affections during this year to help me to achieve these incredible achievements. This is all about the secretary reports. Thank you, sir.
Thank you so much for being so brief, sir. And the NNF secretary report is also printed there in the souvenir that is in your hands. Now, may I request the organizing secretary, Shravan Kumar, sir, to bring the event to an end with his vote of thanks.
Thank you. Really, I'm very much happy. Really, I should say I'm honored and privileged for such a large, although this is not a real, but real was in the morning. Yes. And I'm really happy. My credit, I should say I'm not only, I am the face. All things are this Brahma, Vishnu, Mahesh, I should say. Dr. Vinod Kumar Singh, Dr. Nigam Prakash Nayan, Dr. A.K. Jaswal. Yes. And Anil Agrawal, Anil Kumar. आप अग्रवाल खोजते रहते हैं. अच्छा, sorry. And I'm really happy that everyone, this UNICEF CARE has supported in tremendous way. I'm really thankful. Thankful, man. And I should say that everyone, not only the media and this pharma people, are supported such a nice way. Whatever I should not name much, but I'm not restricting myself that I should name a few name. The Alchem, Aristo, and one and most important work has been done by this Medway Biotech. Really, I'm really thankful. And the whole committee, organizing committee, are very much grateful to them that they have not only given that kit, beautiful kit, but they have supported in, I should say, whatever I say, I don't even ask, but okay, sir, I will do. Yes, it will be done. Everything has been done by him. We are really very thankful. Yes. And one that I will thankful to the guest speaker, like Dr. K.K. Diwakar is coming from Kochi, and from one call he has said, okay, why not? I have come many times in Bihar and Patna, and I should say that I have done earlier one Bihar conference. On that time he also came, and I should say that all that time, those was PG, and now they are practitioner. They were asking you, sir, that please call Dr. K.K. Diwakar. He is very good speaker. And many, I should say that Ashok Mittal, Dr. Ashok Kumar sir, he is a very good speaker. Dr. Lalan Bharti, Dr. Tomorrow, Dr. Kishore Kumar, he is the chairman of this Cloud9. He is coming, and he is very good speaker, and he is very good man also. And we are also happy that they are not only speaking on one topic, they are gladly accepted that they will speak on two topics, and this is the win-win situation in ourselves. So we are getting one in 1 to 3. buy one, get one free. So it is very good for us. So I am really, I should say, and one thing, my dearest friend, he is, that I should say, we are dearest friend, we are not 1 in 1, 2, but we are 1 in 1, 11. And we will work together. We had worked together. We will work together. And just like we said that in Bihar, in neonatology, as Dr. Nigam Prakash also said that in Ayushman Bharat, we in our private setup, we will also work Ayushman Bharat. We will work for the poor, and really we will want to work hard for the whatever your suggestion. And as they said that so much pain our Dr. BK Paul is having with us, with our Bihar. It is very proud for us. So I'm thankful to all of you. I will not take much time, and I am requesting and cordially inviting on the gala dinner, and I will request that please inaugurate that session also. And if, thank you. Musical, gala musical program. Thank you.
Thank you so much to all the delegates, all the members who have lended us the ears and sat so patiently in this hall for the inaugural function. You are all invited for the gala dinner, which would be inaugurated right now. Thank you so much. And with this, we come to the end of the first day.
Madam Nafisa.